Κύριοι συνάδελφοι, καλημέρα σας. Σας καλωσορίζομαι στο παραδοσιακό πια, αλλά καινοτόμο και σημαντικό συνέδριο που οργανώνει το Τμήμα Διακαυτηριακών Βαλβίδων του Ομίλου Υγεία, που ηγείται ασφαλώς ο κύριος Σπάργιας, με συνδιευθυντή του προγράμματος τον κύριο Στρατιπατακό. Ο τίτλος του συνεδρίου είναι Transcatheter Valves Greece 2021. Νομίζω ότι τα τελευταία χρόνια στο χώρο της καινοτομίας και ιδιαίτερα το χώρο της επεμβατικής καρδιολογίας, το συνέδριο αυτό έχει κερδίσει τις εντυπώσεις, έχει ικανοποιήσει και τους πιο δύσκολους ακροατές και οπωσδήποτε προχωράει στις καινοτομίες που η διεθνής πραγματικότητα επιβάλλει. Ο χώρος των διακαυτηριακών βαλβίδων είναι ο χώρος αιχμής για την διεθνή καρδιολογία. Υπάρχουν εντυπωσιακές εξελίξεις. Πέρα από τις διακαυτηριακές τοποθετήσεις αορτικών βαλβίδων, όπως γνωρίζετε, υπάρχουν διακαυτηριακές προσθέσεις στην μητροειδή βαλβίδα και στην τριγλόχυνα βαλβίδα με τα clips. Όλα αυτά τα αντικείμενα είμαστε υπερήφανοι, διότι το Τμήμα Διακαυτηριακών Βαλβίδων του Ομίλου Υγεία τα υπηρετεί στην πιο καινοτόμο έκφρασή τους. Το τμήμα αυτό συνεργάζεται με μεγάλα κέντρα και με την βιομηχανία στο εξωτερικό, ώστε να μπορεί να έχει διαθέσιμα τα νεότερα προϊόντα στην πιο σύντομη δυνατότητα. Έτσι, πολύ συχνά τμήματα της βιομηχανίας είναι παρόντα στον Όμιλο Υγεία για να δώσουν όχι μόνο τα προϊόντα τους, αλλά και την τεχνογνωσία τους σε αυτό το καινοτόμο πεδίο. Αναμφίβολα η καρδιολογία εξελίσσεται. Αναμφίβολα η ευρύτερη καρδιογειακή ιατρική εξελίσσεται. Και οι εξελίξεις είναι τόσο μεγάλες όσο η φαντασία. Τα υλικά βελτιώνονται, η τεχνολογία γίνεται μικρότερη, γιατί οι άνθρωποι, οι ασθενείς θέλουν το μικρό, την miniature. Θέλουν αυτό που δεν αφήνει ουλή, το scarless. Και η επιστήμη του υγεία μπορεί και εξυπηρετεί όλα τα προηγούμενα. Τα αντικείμενα αυτού του συνεδρίου είναι πολλά. Όλα εκείνα τα οποία απασχολούν τους ειδικούς στην καθημερινή τους πρακτική. Δεν θα τα ονοματίσω ένα προς ένα. Απλά θέλω να σας επισημάνω ότι θα είναι εξαιρετικά χρήσιμο για την κλινική σας εμπειρία και όχι για αυτούς μόνο τους ειδικούς, αλλά και ευρύτερα για τους γενικούς καρδιολόγους να παρακολουθήσουν το συνέδριο αυτό. Εμείς, οι συντελεστές και κυρίως ο κύριος Σπάργιας και ο κύριος Στρατιπατακός και ο κύριος Γρηγόρης Πατακός, είναι υπερήφανοι για αυτό το συνέδριο και κυρίως για τις επιτεύξεις τους τα τελευταία 10 χρόνια στο νοσοκομείο Υγεία, στο πεδίο αυτό, το τόσο εντυπωσιακά εξελισσόμενο. Ευχαριστώ πάρα πολύ.
Κυρίες και κύριοι, καλημέρα σας. Χαίρομαι πάρα πολύ που έστω και με αυτόν τον τρόπο βρίσκομαι για άλλη μία φορά κοντά σας, σε αυτή την πραγματικά εξαιρετική ημερίδα, επιστημονική ημερίδα που διαπραγματεύεται ένα πραγματικά τεράστιο θέμα που τα τελευταία χρόνια έχει γίνει πλέον καθημερινότητα. Όταν πριν από πολλά χρόνια μαζί με τον κύριο Σπάρια ξεκινήσαμε στο Υγεία αυτή τη μεγάλη προσπάθεια, δειλά-δειλά εκείνη την εποχή, είχαμε μέσα στο μυαλό μας, όλοι μας, και εκείνος και εγώ και ο κύριος Πατακός, που και εκείνος ενεπλάκη από την αρχή σε αυτή την προσπάθεια, ότι φτιάχνουμε κάτι που στο μέλλον θα είναι πάρα πολύ σημαντικό και πολύ έτσι με μεγάλη συχνότητα χρησιμοποιούμενο. Δεν φανταζόμασταν όμως, εγώ το λέω προσωπικά, παρόλο την πίστη που είχα στην ομάδα, που είναι μια εξαιρετική επιστημονική ομάδα, ότι σήμερα, 11-12 χρόνια μετά από την αρχική μας προσπάθεια, θα είχαμε το ευχάριστο πρόβλημα να αναζητούμε τρόπους και να αυξήσουμε την δυνατότητα να παρέχουμε αυτή την υπηρεσία σε όσο το δυνατόν περισσότερους ασθενείς μας. Οι εκδηλώσεις αυτές τις οποίες, οι επιστημονικές αυτές εκδηλώσεις τις οποίες η ομάδα του Υγεία των διαδερμικών βαλβίδων τις κάνει κάθε χρόνο. Φέτος βέβαια υπάρχει αυτή δυστυχώς η περίεργη κατάσταση που ζούμε και όλοι μας. Ας ελπίσουμε ότι θα είναι η τελευταία φορά και του χρόνου θα επανέλθουμε πάλι στην κανονικότητα, τις διαζώσεις επαφής, που είναι πάρα πολύ σημαντικό για όλους μας. Αλλά θεωρώ ότι και βλέποντας και το πρόγραμμα και τους ομιλητές, που είναι απίστευτα υψηλού επίπεδου αυτή η ημερίδα, ομιλητές από όλο τον κόσμο, πολύ σημαντικοί, που δύσκολα έχουμε τη δυνατότητα στην Ελλάδα και την ευκαιρία στην Ελλάδα να τους δούμε, να τους ακούσουμε και να πάρουμε πολλά και να ανταλλάξουμε και μάλιστα μεταξύ μας τις γνώσεις που έχει ο καθένας, αλλά νομίζω ότι τέτοιες ημερίδες βοηθούν στο να πάμε στην επόμενη μέρα. Γιατί ο καθένας από εσάς, καταθέτοντας την εμπειρία του, τις γνώσεις του και τις δεξιότητες του φυσικά, κάνει αυτές τις προσπάθειες ακόμα πιο εύκολες για το μέλλον. Με αυτά θα ήθελα να δώσω την ευχή από του χρόνου να είμαστε από κοντά, να τα πούμε από κοντά. Είμαι σίγουρος ότι θα στεφθεί από επιτυχία, από απόλυτη επιτυχία, αυτή η σημερινή επιστημονική ημερίδα και νομίζω ότι του χρόνου που θα είμαστε από κοντά τα πράγματα θα είναι πολύ καλύτερα για όλους. Καλή επιτυχία σε όλους και του χρόνου να τα πούμε, όπως είπα, διαζώσεις. Ευχαριστώ πάρα πολύ.
Καλημέρα σας και από μένα και καλώς ήρθατε στο 11ο ετήσιο συνέδριο διαδερμικών θεραπείων καρδιακών βαλβίδων του Τμήματος Διαδερμικών Βαλβίδων του Υγεία. Σας καλωσορίζω εκ μέρους του Συμπροέδρου του Συνεδρίου, του καθηγητού κ. Βάρδα, που είναι συντονιστής στον τομέα καρδιάς του ομίλου, του κ. Στρατή Ποτακού, που είναι διευθυντής της Β' Καρδιοχειρουργικής και συνδιευθυντής του Τμήματος Διαδερμικών Βαλβίδων, του κ. Γρηγόρη Ποτακού, αναπληρωτή διευθυντή της Β' Καρδιοχειρουργικής και του Τμήματος Διαδερμικών Βαλβίδων, και των συνδιοργανωτών, κ. Χρυσοχέρη και Μπούλια, αναπληρωτών διευθυντών του Τμήματος Διαδερμικών Βαλβίδων. Φέτος το συνέδριό μας έχει και την τιμητική αιγίδα του Hill Academy, που είναι ο νέος επιστημονικός, εκπαιδευτικός και ερευνητικός φορέας του Hellenic Healthcare Group, και αυτό είναι μεγάλη τιμή για μας. Η πανδημία μας αναγκάζει να συναντηθούμε μια ακόμα χρονιά διαδικτυακά. Αυτό όμως δεν θα μειώσει καθόλου την εντατικότητα των εικονικών συνεδριάσεων που θα έχουμε αυτό το διάστημα, όπου θα παρουσιαστούν και θα συζητηθούν διεξοδικά όλες τις τελευταίες εξελίξεις στον πεδίο των διαδρομικών θεραπείων των καρδιακών βαλβιδοπαθειών. Ένα πεδίο που γνωρίζει την προσοχή ανάμεσα στην τελευταία δεκαετία και έχει συγκεντρώσει την ανθρώπινα του νεοτερισμού, της ευρετικότητας και τεχνολογίας με σκοπό να βελτιώσει και να απλοποιήσει τη θεραπεία που αισθανόμαστε με καρδιακές βαλβιδοπάθειες, καρδιακές βαλβιδοπάθειες που είναι η δεύτερη συχνότερη καρδιοπάθεια μετά τη στεφανία νόση. Δεν συζητάμε μόνο για διαδρομική θεραπεία της ορθικής βαλβίδας, όπως κάναμε πριν 11 χρόνια στο πρώτο συνέδριό μας, αλλά για θεραπείες όλων των βαλβίδων. Ενδεικτικό είναι ότι η σημερινή πρώτη μέρα του συνεδρίου κεντρώνεται στις διαδρομικές θεραπείες της ορθικής βαλβίδας, ενώ η δεύτερη μέρα κεντρώνεται στην πλοηγή της βιώσιμης βαλβίδας. Η διαδικασία το οποίο όμως διαπιστώσαμε φέτος έχει ξεπεράσει κάθε προηγούμενο, που καλά της πανδημίας είναι πιο εύκολη η online δράση συνεργασία, οι υπηρετές και πρόεδροι είναι 32 κορυφαίους καρδιολόγους και καρδιοχειρουργούς στο χώρο χάρη του εξωτερικού, οι οποίοι είναι líderes, όπως λένε, και φυσικά όλοι οι κορυφαίοι και δυνάμοι Έλληνες καρδιολόγους και καρδιοχειρουργοί. Entonces, yo uso el tipo de productos que pueden muy que no es lo que tú, pero es de normal que los discos que se pueden que los comunidades en el mundo que hay que nos estarían atacando. La presencia de cuanto el día que nos atacamos el día de reclamos y el día que tiene control y posible que se especie de los que los parques para que tengan niveles que se aplican en su modo de desarrollo. Con una forma de combinación de lo que se histología neuroplato. Hay naciones aquí en España, yo tengo beneficio de la serie de España, luego de nosotros tenemos un serio político por la reunión de un partido, tanto como que se tiene que trabajar de todo, que ya como político, pues que primero se puede explicar. So, with this opportunity, I would like to welcome everybody to Transcatheter Heart Series 2021. We're going to be looking at a peek into the upcoming advances in tapping devices. We have mainly the electronic plus the scientific network and others. And with no further ado, to make sure you stay on time, we'll ask the speakers to be around 8 minutes each if possible. We'll start with Dr. Vargas, who will be serving us the Edward portfolio in 8 minutes. So we look forward to hearing from you. Hello, good morning, and thank you, Dr. Patakos, for the introduction of this session. So it's my pleasure to present you the Edward study portfolio. I'm sure you're all very familiar with my disclosures. And we all know that over the past 13 years, we've seen over the operations of the Edwards valve, the stopping valve, and we are now using the fourth generation, the stroking through ultra valve. And you can see here the photographs of the changes that happen over the evolution of this valve. And the something you see, there is a change in the strength alloy, the stem cells, and then the second free valve change again in the stem cells is down, and the addition of the skirt. And now the getting the ultra valve, that there is a change in the skirt fabric and in the skirt. And you see here that the use of this valve over the years is extremely expensive, and about 500,000 implantations all over the world, and more than 25,000 cases have been enrolled in clinical trials and sponsored by Edward. So this is a pretty expensive experience, clinical experience, and trials with this valve. You can see a certain 3-meter fabric is like cotton or sponge texture, and this supposedly helps to reduce prolonged leak. And also you can see, compared to the previous generation, the 3 valve, how the outer skirt is going one step higher to reduce again the prolonged leak. And it's essential to know the dimensions of the valve we're using, and especially the secondary and certain feature that the cell and the cells that the cells are exactly the same, the stem design is exactly the same, so we have the frame height for the various sizes of the valve, so 16.5 to the more than the 20 millimeter valve, up to 22.5 to the larger diameter 29 millimeter valves. And then the inner skirt height and the outer skirt height that in the new ultra valve are exactly the same.
And certainly over the years, we've seen how the clinical outcomes, the 30-day offloading out and the 30-day observing a stroke have been improving with the use of device in randomized clinical trials. And part of this improvement is to become to the lower risk of the patients included in these randomized trials. But as you can see, part of this improvement can be attributed to the improvement in the valve. As you can see here, the higher patients, these are both higher patients, and you can see better results with the mirrors and the motion valve. And the same can be seen in this intermediate risk patients, and same conclusions can be withdrawn from the 30-day with stroke results. And now for the valve we're using currently, the ultravalve, we have experience of 2 years, 5 studies, and almost 2,000 patients included. And you can see what we can achieve with the valve in the clinical trial. We have 9 paravalvular routes in less than 10% of patients and moderate in less than 1% of patients. These are amazing results, one of the best in this field. And then again, we have the single-digit numbers for needs for new pacemaker, as you can see here. These were the outcome because the also recommended strategy was used in this instance study. One thing that is under other development is this is a study in non-cancer aortic valve disease, non-cancer aortic valve disease affects up to 2% of the population. And they are convinced of some developmental complications, including autostatic patients. And as we are moving to lower risk and younger patients, bypass aortic disease much more frequent. And as you can see, approximately half of the patients going to surgery at the age below 80 can bypass aortic valve disease. So if we are to expand to this younger patients, we need to have a very good valve and to render very good results in these patients. And we do have the experience from the CVT registry with a total of 3 valves, and you see here a direct comparison between bicuspid and tricuspid valves, approximately 6,000 patients, and you see the outcome of one mortality or stroke is the same, no significant difference between bicuspid and tricuspid. And as you can see, each group of patients were very well marked. And here's an example of a typical bicuspid case. You can see the distribution expression in the 2 leaflets, and you can see the CT scan the appearance of the 2 leaflets. Here is the axial imaging, and where you can appreciate the exact anatomy. There is a calcified rough. You search very carefully, and the dimensions are 26 millimeter tapping valve. You can also appreciate the bending here beside as possible of the face, and you can see also the unfolded aorta with the multiple angulations, which is also horizontal aorta with 63 degrees of angulation there. So this is the valve we did use in this patient. Severe aortic stenosis, you can see the hemodynamic gradient. And here is the aortography with appearance of this valve. This is the valvuloplasty, and this valve with a 20mm balloon. We use the simultaneous aortography, and we took a 20mm balloon offering complete healing in this valve. So we don't go to the 26th valve, initially prescribed from the sizing tables, but we're using the 23 valve. And you see how we multiply horizontally this valve using the flexing feature of the catheter of the commander. And here's the first rapid pacing and the inflation of this valve. And this is how we went nowadays to position these valves like 80% above or 90% above the annulus, just a little below the annulus, as it is down here with the excellent result. So we have these publications from many about calcifications, and actually, in all of these registries, the majority of the valves used, and these registries were studying 3 valves, and you can see the results there, pretty much impressive, 20 to 25% mild paravalvular vegetation, and a very low percentage of moderate vegetation. And what we consider as important in stopping valve is the circularity that offers, and this allows us to promote constitutive function and function. And we can see here from this study that the circularity is preserved in the bicuspid valve. You can see the elasticity index of the annulus actually compared to the second valve is more or less the same between tricuspid and bicuspid valve. And the future of this patient is usually younger starts at their first study, because more than likely they're going to use they're going to need a second study. And then we need to consider about the anatomy that will be the result in the second study in these patients, and also access to the coronary. And then when we go to younger patients, as we see here, comparing the typical to what we use today, and the patient having 3 layers of trial, we see that those patients in this younger patient with a trial community disease intervention will be expected to increase dramatically over the following years. That's why it's very important to have good coronary access. And when we use the second 3 value, we have, as you see in this study, 100% successful access to the coronary in the follow-up. This is another study that examined from the CT scan and the features of concerning the coronary function and the coronary osteum. And we see here is below the scale the risk of concerning the function when we use the evolute and above was 20% for the left coronary artery and 4% when we use the second valve. And if we count the cholesterol points on these valves, then the risk is the concluded in parallel is that 35% not to have a good access to the coronary when we use the evolute, and only 15% when we use the sapling. And this is to be expected because the height of the cage in a sapling valve is much shorter than the other valve, or it's even higher than the leader target in the actual neo valve. So this is an implication when we do TAVI and TAVI, and from the study they found that the risk of convert coronary access is extremely high in the 2 supraangular valves, and then lower with lower supportive one and with 0% with saving valve. And this is another model-based study with computer tomography that found the risk of coronary obstruction due to sinus sequestration when we do TAVI, and you see that the risk for running both coronary arteries when we do TAVI with evolute flow is 45%, and only 2% when we do the study. And with this, I would like to thank you. Thank you very much, Dr. Spartus, for this wonderful talk. You can stay at home. We're going to move to the next presentation quickly and to hear from PD Church, who's going to be showing us the Medtronic data. We're just a little bit behind time, so we're going to ask everybody to be as quick as possible and to get to 10 minutes. Okay, Dr. Tolchak, we can have this talk if we're ready. Our Medicare Director, please begin with Dr. Tolchak.
Latest Medtronic TAVI portfolio and study updates. These are my disclosure. So let's start with the portfolio. So the platform we are talking about is the Evolute platform with the self-expanding 19-hole stent frame design with 3 levels. So the outflow portion that is meant for achieving coaxiality, the constrained portion that houses a triliflate porcine pericardial valve with a 2 goal design. The first one being to have a an adequate and maximize leaflet coaptation, and the second to be being to achieve low gradients with single-digit mean gradients. And then we have the inflow portion aiming at anchoring and sealing the aortic annulus, and we're going to see that in the most recent iteration we have a wrap aiming at mitigating perivalvular regurgitation. But if we jump into the past and start with the first iteration to better understand what the platform that we have, it all started with the core valve. The core valve already had that self-expanding 19-hole stent frame with a free level, a free configuration design. And it also already housed a 3-leaflet porcine pericardial valve with a supraannular function, but it wasn't repositionable. Deployment was kind of tricky in some patients. So we had the third iteration that was the Evolut R, aiming at providing a device that was repositionable, recapturable, so to target perfect implants suited to every single patient. So the stent frame was redesigned, particularly at the level of the inflow portion for a more consistent radial force all across valve sizes. And then we moved to the second iteration, that was the Evolut Pro. That was the same as the Evolut R with an external wrap aiming at mitigating PV leak for the 23, 26, and 29, but at the cost of an increase in the sheath profile that moved from 14 to 16 French. So now we have the Evolut Pro Plus platform. The Evolut Pro Plus combines all the features of the Evolut R with the 14 French sheath design for the 23, 26, 29, and of the Evolut Pro with the wrap for all 4 valve sizes, 23, 26, 29, and 34. And this is definitely aiming at being able to treat patients with an annular range from 18 to 30 millimeters with the same outcome in terms of repositionability, accuracy of deployment, and PV leak reduction. So if we have a close look at the Evolut Pro platform, the sheath size now for the 23 to 29 enables to treat patients with vessel sizes of 5 millimeters. So definitely we're going to be able to treat more patients. More patients will be suitable for a transfemoral approach with that platform. With the advanced sealing for all 4 valve sizes, we're going to have more predictable final procedural outcomes in terms of PV leak reduction, even in larger anatomies that were more challenging to treat before we had the Evolut Pro Plus. So definitely an improvement. What's coming next? Next step is the Evolut FX. So the design goal of the Evolut FX will be first to improve vessel access with a more flexible device, a small sheath profile, and to make sure that trackability is enhanced with, once again, that flexibility allowing to tackle even more tortuous anatomies. And even in these more challenging and complex situations, the design will aim at increased deployment stability, to have something that is even more stable than it is today, to maximize the outcomes for the patient. The visualization of the implant depth will also be enhanced to make sure that we achieve a perfect implant for every single patient. Apart from the Evolut FX, the next gen will have additional goals. The first one will being to simplify coronary access, because this can be tricky in some patients, and achieving an appropriate commissural alignment spontaneously, automatically, will be one of the design goals of this next generation, apart from, once again, even more predictable deployment. And at last, TAVI-wise, device-wise, the future technology will focus on valve lifetime management, addressing younger patients with several procedures, conduction management, and PV leak reduction. And beside that, we will have some TAVI accessories that are going to be deployed, whether it be, for example, a temporary pacemaker or a more appropriate TAVI wire. Let's focus now on more recent clinical data. Before discussing the more recent data, we need to understand what allowed us to, what led to the approval of the Evolut platform for all the risk spectrum. We've started with the extreme risk study in 2011, 10 years ago. And then we moved to the high-risk patients with that superiority of the core valve platform as compared to surgery. And then the intermediate risk patients with the SURTAVI trial. And very lately, the Evolute low-risk trial that demonstrated the non-inferiority of TAVI as compared to surgery in low-risk patients with even lower numbers of events in the TAVI arm. And one of the most recent indications for that platform is bicuspid, and this has been obtained through several registries. Some of them are going to be detailed afterwards. So let's start with the Optimize Pro. The Optimize Pro is probably one of the most important study that has been very recently presented. So the primary objective was to collect clinical evidence on valve performance and procedural outcomes associated with an optimized pathway, optimized pre- and post-procedural TAVI care pathway, focusing on the cusp overlap technique to deploy the Evolute platform. What is the cusp overlap technique? It's the fact to overlap the right and the left coronary cusp, most of the time in the RAO caudal projection, to isolate the non-coronary cusp, aiming at elongating the left ventricular outflow tract, erasing, withdrawing any foreshortening of the left ventricular outflow tract, and making sure that we have both in plane, the annulus and the catheter marker band, and this is going to be obtained in the cusp overlap view. The cusp in which we have a better appreciation, estimation of the interaction with the conduction system and the membranous septum, and another projection that allows an appropriate commissural alignment. So only benefits of this cusp overlap technique. So the Optimize, here is the design of the Optimize Pro. The interim analysis focused on 171 patients among the 600 that are meant to be enrolled. Enrollment is still ongoing. So the patients will be treated with the Evolute Pro and Pro Plus platforms, and two arms are going to be analyzed. The first arm, patients with no AV conduction disturbance, are going to follow an optimized post-procedural care pathway aiming at achieving early discharge. And on the other arm, AV conduction disturbance patients will have an optimized conduction disturbance management pathway, just to make sure that unnecessary pacemakers are not implanted in these patients. So the primary endpoint will be all-cause mortality and stroke at 30 days, and the patients are going to be followed for 1 year. So here is a summary of the interim analysis focusing on 171 patients at 30 days. The Evolute, the Optimize Pro study demonstrated no deaths, no disabling stroke, a pacemaker rate of 8.8%. And so this was expectable in terms of PV-leak because of the design of the platform as we've seen before. So a lot of patients, most of the patients were treated with a Pro Plus platform. So extremely low rates of total aortic regurgitation, and excellent hemodynamics with a mean gradient of 8.1. And most importantly, when we consider the cusp overlap technique, no pop-outs. So with an appropriate technique, high implants can be achieved without pop-outs of the valve. The median left on stay was 1 day, so many patients were discharged 1 day after the procedure, thanks to this optimized post-procedural care pathway. And so this strongly encourages us to use the cusp overlap technique, and we need to wait for the results of the overall cohort, but already these outcomes are impressive. So the investigator concluded that the cusp overlap technique and care pathways are associated with low rates of permanent pacemaker placement, low rates of residual aortic regurgitation, and expedited discharge in patients undergoing Evolute Pro Plus TAVI for symptomatic severe aortic stenosis. So this is only the interim analysis. We need to wait first for the 600 patients and second for a longer follow-up. So the Evolute X is one of the study I was in charge, and this was one of the first prospective cohort of patients treated for a bicuspid anatomy with the Evolute Pro platform. 151 patients were included. it was a 50-50% distribution between annular and combined sizing. And in terms of clinical outcomes at 30 days, you can see so very low death rate, 3.3% at 30 days, a very low stroke rate, and very a pacemaker implantation rate that was close to 19%. So we need to understand why, and we need potentially with the added value of the cusp overlap technique, potentially there is something that we can improve also in that population. What was impressive were the hemodynamics with very large EOAs in bicuspid patients, 2.1 centimeter square, very low mean gradient, 7.3 millimeter of mercury, and no patients had moderate or severe regurgitation. So excellent hemodynamics and PVD prevention with the PRO platform in bicuspid patients. The Evolute low-risk bicuspid study was another study focusing on bicuspid. Here is a summary. In these low-risk bicuspid patients, extremely high device success rate, low mortality and stroke at 30 days, 1.3% in that low-risk population, and consistent hemodynamics with, once again, large EOAs, 2.3 centimeters square in bicuspid patients, and mean gradient below 8 millimeters of mercury, and no patients with moderate or severe aortic regurgitation, and patient prosthesis mismatch severe in only 5.3% of the cases. So when we let's focus now for the last part of that lecture on durability, and more precisely on structural valve deterioration. We had the Notion trial. You know that the Notion trial was a trial that randomized low-risk patients between TAVI with the core valve platform and surgery. And we've seen that at 1 year and up to 5 years, the outcomes were excellent. But when with now this 8-year follow-up, we can summarize the findings of the Notion trial as follows. First, the core valve hemodynamics were statistically better as compared to surgery out to 8 years. Second, the structural valve deterioration rate was lower with the core valve platform than surgery out to 8 years. And at last, there was the same rate of all-cause mortality and stroke between patients undergoing TAVI with the core valve or surgery. So definitely in terms of durability and structural valve deterioration, that study is extremely encouraging and confirms all the interest and the potential positive impact of TAVI for our patients, even in low risk. And this is the last study that I wanted to present that explored the relationship of hemodynamic valve deterioration and led clinical outcomes after TAVI with a self-expanding platform and surgery. That poster was recently presented at ACC 21. And so the objectives were to assess the incidence of hemodynamic valve deterioration after TAVI with the core valve Evolute platforms and surgery, and to evaluate the impact of that hemodynamic valve deterioration on clinical events, and to try to find out the predictors for hemodynamic valve deterioration. So that our pool from all the studies that were presented before, the core valve US pivotal high-risk randomized trial, the US pivotal extreme risk, and the continued access registries and the CERTAVI. So you see that for more than 4,000 TAVI patients were compared to more than 1,000 surgery patients. And the definition of hemodynamic valve deterioration was defined as an increase in mean gradient over greater or equal to 10 millimeters of mercury from discharge to the last available echo of valve reintervention for stenosis more than 30 days post-procedure. Similar baseline clinical characteristics between TAVI and surgery. And what you can see at 5 years, less structural, less hemodynamic valve deterioration in the TAVI patients as compared to the surgical patients in the randomized trials. In multivariate analysis, the predictors were younger age, surgery, no prior CABG, high residual gradient post-procedure, low post-procedure DVI, and effective orifice area. and severe PPM. So these were the predictors of hemodynamic valve deterioration observed in that study. Thank you very much. And this is open for discussion now. Thank you very much. And this is open for discussion now.
We thank Dr. Cece for his talk. I think that what we're seeing is that all of the companies are increasing their technology, and the benefit is that this is going to lead to better outcomes for all of our patients. We are ready to go on now to the next talk, which will be Dr. Katsimaglis, who will be showing us the Boston Scientific portfolio. Dr. Katsimaglis, thank you very much for being here with us today, and we look forward to your talk.
Dear Presidents, I'd like to thank the organizing committee at Boston Scientific for the kind invitation to participate with this very interesting conference, the Cardiac Advances in TAVI Devices, the Boston Scientific portfolio. These are my disclosures. During 2020, two events have taken place for Boston Scientific in TAVI field. The final withdrawal of lotus valve and the presentation of Accurate Neo 2 as an evolution of its predecessor Accurate Neo. Which are the advantages of Accurate Neo? This is a self-expanding supraannular valve. As a result, it has bigger effective orifice area with top-down implantation, so to have better alignment.
I'm sorry to interrupt, but we don't see your screen. We don't see your screen. If we can do a share screen, we don't see your PowerPoint.
Sorry, yes.
No problem. I'll tell you once we have your slides up.
Okay.
Okay, we see it, and just go to a full screen if you can now.
Yes.
You can continue where we were because we heard what you said, but okay, let's go now. Good.
Okay.
Perfect.
With top-down implantation, so as to have better axial alignment and stabilization, with very good coronary access because of the short size of the stent valve, and with low rate of pacemaker implantation, but also with low radial strength. So the pre-dilatation is necessary with two markers of low radiopacity and annulus height. As a result, bigger amount of contrast with small height of skirt. As a result, higher rates of PBL and taking only from 21 to 27 millimeters. In the scope 1, and my trial, non-periodic factor Neo to supplementary valve movement. Because mainly from cases with acute kidney injury, moderate regurgitation. So this PBL may decrease probability for post-dilatation, allow to shorten procedures with less contrast and potentially longer the rate of acute kidney injury. In scope 2, as we all know, the pacemaker implantation was very low, and this results. We have seen also the same results in Morena in a multi-center trial with head-to-head comparison with the balloon expandable transcatheter valves. As we see here, the pacemaker implantation is very low in comparison with the Sapien 3. Also, in RBBB trial, it is a trial in 7 centers in general in Germany and Switzerland. As we see here, the pacemaker implantation in this here we have a retrospective study from Finland, 250 patients approximately. It was similar another thing that we eliminated after a cardiac implantation. In 2020, we see here a trial from Barbandi. They have seen the feasibility of coronary artery embolization after target, the potential predictors of coronary access to impairment. And we see here the best coronary embolization with also scientific accurate mirror, not accurate mirror to the condition. The predictor, the main predictor for substantial coronary embolization was the ratio between transcatheter aortic valve with the tension of Valsalva and the field of aortic valve and the depth of transcatheter aortic valve implantation. Now, the last mirror must be valid. So the evolution was the accurate mirror 2. With the accurate mirror 2, we try to maintain the function from accurate mirror and to add some new features. These new features will enhance out the state and the driver that matter in the human system. So we expect reduction in PBS, so as to have less hospitalization, less shorter procedures, less contrast group, and so lower risk of acute kidney injury. This is the new design of accurate mirror 2 with the stabilization axis, with the upper bound, and the PBL and the new scale for the PBL. And this is an animation to understand that it's phase as we see here, the bound and the side space here. So we can see that the coronary axis is free. Some clinical data, this is study, it concerns 130 patients. It was a prospective study of multi-cell study at 9 European sites. The final point was the 30-day mortality, the all-cause mortality of 30 days, and these are the key secondary endpoints. Here we see the baseline characteristics, and these are the procedural characteristics that we try to be on top of the presentation. Here are the results as we see here with the new accurate mirror. We have less cases with PBL, moderate and severe, and less cases with acute kidney injury. We see here the high pacemaker implantation, but there were a lot of patients with RBBP. It runs now in United States and Canada, accurate IDE. This is a prospective multi-center, multi-cohort randomized trial with randomization 1-to-1 with the Evolut and the Sapien 3 valve. And now some data from the PCR 2021, just 2 days ago, the ITAL NEO registry. It is a registry from 9 centers in Italy with 95 patients. The primary point was the device success with accurate NEO 2. There was a percentage of 35% with coronary artery disease, 98 approximately device success, but the procedural lengths and the fluoroscopy times were higher than previous studies because of the high percentage of concomitant procedures because there was a coronary artery disease. So the main clue was that there was only a percentage of 3.1% of moderate and severe PBL. Data from the NEO2 registry. It is from Karolinska University. It is a trial with 5,554 patients from September to 2020 to March 2021.
Dr. Katsimaglis, I'm sorry to interrupt. We have 1 minute remaining.
Okay, I'm going to finish. These are the procedural characteristics, the primary outcomes. with only 1.3 paravalvular leak and only 6.0 pacemaker implantation. This was 230 patients from this sample were compared to accurate neo, so as to compare the mean regurgitation fraction between accurate neo and accurate neo 2. The accurate neo 2 was associated with less regurgitation. These are our data from Naval Hospital from accurate neo and accurate neo 2. I'm going further. So in conclusion, accurate neo 2 has features good enough for young patients with easy coronary access, with a lower pacemaker rate, perhaps the lowest, a low rate of PVL, but without data for bicuspid and valve-in-valve, mainly because of the low radial strength. This is the only trial with bicuspid valve. These are the future design goals for Boston Scientific. The accurate prime with increased size range to 29 for annulus, and the accurate NG with bigger radial force. This is the accessory technologies from Boston. As we know, Boston has the Sentinel. As we all know, stroke remains an issue in contemporary TAVI trials. Going further, the majority of stroke is related to the procedure. And the first week after TAVI, here is how an animation, how the Sentinel filters the 90% of blood flow to brain. The number needed to treat is 22 patients to reduce 1 stroke or death with cerebral embolic protection. And 2 trials are going to be with Sentinel, the protected TAVI, which is going to be completed July 1st of 2022, and the British Protect TAVI with 7,700 patients approximately from June 2020 for 6 years. And here is our first implantation in Naval Hospital with accurate neo 2. Thank you very much. I'll try to be very fast.
Thank you, Dr. Katzimaklis, for your comprehensive presentation. And now we're very happy to have with us Professor Hadzek from the Medical University of Warsaw, the Department of Cardiology, and he's going to present the Abbott portfolio on TAVI for us. Thank you, Professor Hadzek.
Thank you very much for the introduction. Without further ado, I will share my screen for the presentation. Can you see my slides?
Yes, perfectly well.
Okay. So I know we are behind time, so I will try to be as fast as possible. So it's my privilege to present on behalf of Abbott its portfolio. These are my conflicts of interest. So we all know, probably most of us are familiar with the current prosthesis of Abbott, which is Portico. Prosthesis, it is of course self-expanding intra-annular mounted leaflets prosthesis with a characteristic large open cells design. All of these features allow for flexible delivery, and during the deployment, which is important for the operator, we have early valve functionality. Of course, it is recapturable and repositionable, and it covers the annulus from 19 millimeters up to 27 millimeters. The presence on the market of Portico valve is mandated by the CE Mark study and Portico 1 study published in 2017 and 18 with a good clinical result, as you can appreciate here on the slide, and with excellent hemodynamics, actually comparable to Medtronic device with a single-digit gradients and a big effective orifice area. And the pacemaker rate was ranging from 15 to up to almost 19%. Then in 2019, the new delivery system was introduced. It is so-called FlexNav, which is mostly characterized by integrated sheath with 14 French internal diameter delivery profile. It is nicely hydrophilically coated, so that really reduces the friction. It is easy to introduce into the femoral artery. Thanks to the large cell framework of the Portico valve, it's also easy to maneuver in tortuous anatomy. Then there is a stability layer which improves the accuracy of the positioning of the valve, and there is a major change also in the ergonomics of the handle. And for me, the most important change is that the deployment knob, really every turn in the deployment knob is translated into the deployment of the valve, not as it was with the previous system. As I mentioned, hemodynamics with Portico is really remarkable. It is compared in terms of effective orifice area and gradient with Evolut R-Evolut Pro, and it seems to be better than with balloon expanding devices. This translates subsequently into low numbers of patient prosthesis mismatch with Portico, with only 3.5% of severe PPM. Very briefly, some examples of what we do in our cath lab in Warsaw. This is like our workhorse valve. So we, of course, use it in a normal tricuspid anatomy, but we also not shy away from a severely calcified valve with this prosthesis, with a good pre-dilatation. We can achieve a very good result. We use it also there are patients coming for TAVI and TAVI. This is a degenerated Sapien XT that we implanted in 2012 and was treated with a good result with a Portico. This is demonstration of easy coronary access thanks to the large open cell design and the need for PCI of the left circumflex after implantation. Flexibility, an example of passage through in a difficult patient with stent grafts in abdominal aorta and iliac arteries. Also, this is not a CE-marked valve for be done with a good result, also with a horizontal anatomy. Now, the major advance in the Abbott portfolio for TAVI is the introduction of the new prosthesis, as it's called Navitor. It was just this week, it was awarded a CE mark. As you can see, the characteristics of the design retains all the good features of the Portico valve, but additionally, there is some change in the stent design at the upper part. There are some curved aortic cells, as you can appreciate here, and the major change is the outer PVL feature. It's an active anti-PVL cuff. As you can see here, it's inside and outside, inner and outer cuff. Especially the outer cuff is interesting as it acts actively, and it is supposed to increase the sealing zone. The annulus range is the same. As you can see in this animation, how it should work. It should actually inflate during the diastole and prevent from a bigger PVL. Of course, Portico and Navitor is an intra-annually mounted leaflet self-expanding valve. This is the bench demonstration that even with elliptical shape at the base of the leaflets, leakage of the valve. So, summarize, Navy Seal active cuff fills in diastole to actively manage PVL. It molds to the surrounding anatomy, and also it is believed that it recruits tissue and growth for a permanent seal. The outer cuff, the active seal, does not increase the insertion profile. As you can appreciate, it is still 14 French for the two lower sizes and 15 French for the two bigger sizes of the valve. And the CE mark was granted on the basis of the Navitor valve study that was just presented at the EuroPCR. It was performed in European, American, and the Australian centers. The PI for Europe was Lars Sondergaard. It presented the NG study results. You can appreciate that the valve hemodynamics on the left-hand side was as excellent as with Portico, with single-digit 30-day gradients and 2 centimeter square EOR. And there were no cases of moderate or severe paravalvular leakage. It all compares nicely to the competitors in terms of hemodynamics, in terms of PVL, in terms of MACE also. But the rate of permanent pacemaker implantation, as you can see, stayed at 15%. However, 13 of the 16 subjects that had to be implanted had pre-existing conduction abnormalities. It was mentioned in previous talks that a coronary access is of utmost importance now with TAVI. You can appreciate the comparison between Navitor 29 and 29 Evolut Pro. You can appreciate that the design of large open cells is probably favorable for, it should be favorable for future coronary access. The coronary access, of course, is important when you implant the first valve. What it was also mentioned by the previous presenters, it will be of even greater importance when we move to the younger population, when we have to do TAVI in TAVI. And in this scenario, given the commissural alignment, Portico and Navitor could perform also well. For 2022, also a bigger design of the Navitor is expected.
Dr. Husek, I'm very sorry to interrupt, but we have one minute remaining. So if we can slowly conclude. So sorry to interrupt you.
It's my last slide, actually. Yeah, of course. So the Navitor Valve Plus is going to be for 2022. It should cover annulus up to 30 millimeters and 95 millimeters per meter. And this is my summary slide. Portico Navitor with flex nav delivery system is easy to deliver. It has a very good prosthesis and patient stability during deployment. It provides excellent hemodynamics. Large open cell design will provide easy coronary access, and the active sealing that I just showed you with the Navitor seem to reduce PVL. Thank you very much.
Thank you, Dr. Hadzek, for presenting all the Abbott portfolio and especially the Navitor valve. And for the sake of time, we'll move forward to the next presentation, who is with Dr. Smith from Morrison Hospital, Swansea University, the UK, and he's going to present us the Allegra valve of biosensors. Dr. Smith.
Hello, my name is Professor Dave Smith. I'm a cardiologist in Swansea in the UK, and I'm going to talk to you about the Allegra TAVI valve, which is a new TAVI valve system with uncompromised hemodynamics. The stent frame itself is a short, self-expandable nitinol stent, and it has 6 radiopaque gold markers that allow for excellent visibility and therefore accurate implantation. There's a squeeze to release mechanism to deploy the valve, and the valve itself is actually unsheathed before deployment, so-called the permaflow deployment, which allows flow around the valve during positioning and implantation, allowing for a stable procedure in terms of hemodynamic stability throughout the procedure. The stent frame is connected to the delivery system with 3 T-bars, allowing safe anchoring and easy release from the delivery system. And there's differential radial force throughout the stent frame to minimize leaflet stress and therefore hopefully allow for long-term durability of the valve leaflets. As mentioned, the stent itself has 6 radiopaque markers that are visible throughout the implantation process, both when the valve is crimped inside the delivery sheath and also when the valve is fully expanded in the aortic annulus. The markers demarcate the location of the leaflets above the gold markers and a 12mm sealing zone below the leaflets to try and minimize the risk of paravalvular leak. The leaflets themselves are made of bovine pericardium, and they're in a supraannular location, allowing for low gradient and high effective orifice areas. And as already mentioned, there's a sealing zone below the leaflets to try to minimize the risk of paravalvular leak. In terms of sizing, availability and the size matrix for the valve, there are 3 valve sizes currently available: 23, 27 and 31 millimeters in diameter, and this allows for implantation in native annuli between 19 and 28 millimeters in diameter. The valve implantation is quite straightforward, and I'll go through this in the following slides with a pictorial on the left and the live angiographic images on the right. So as mentioned before, the valve is completely unsheathed before delivery, and as you can see on the right, this is the valve delivery system being, delivery catheter being withdrawn to unsheath the valve, and you can see the gold markers as previously described. Next, we, after aortography, start to position the valve and start to release the valve ready for full implantation. This is the so-called squeeze to release mechanism, and you'll see it's a very rapid and quick release of the valve in the annulus. After aortography and hopeful accurate positioning, we will then begin to release the valve frame from the delivery system. And again, that's very simple, quick and easy using the squeeze to release mechanism as shown on the right in the live moving angiogram. And you can see the release of the T-bars from the delivery system at the top of the stent frame. And then, as with any TAVI valve, we assess the final result with a combination of hemodynamic assessment, aortography, and echocardiography. And in this case, you can see an echocardiogram confirming a good final result of the implantation of the Allegra valve. Now, in terms of data, and I'm going to show you some published data from the Allegra valve through different series. This is some Spanish and Swiss data, and you will see in a high-risk populations, mean 78 years, mean STS score of 5.2. And we can see that early device success was good, with 95% of cases successfully undertaken, low rates of all-cause mortality at 30 days, no strokes, no life-threatening bleeding, a low rate of vascular complications, and approximately just over 1/3 of patients requiring a post-dilatation to optimize the valve result. In terms of 30-day outcomes, we've seen low rates of all-cause mortality, and again, low rates of other complications, with 13.5% of people having a new pacemaker implanted following their Allegra TAVI valve procedure, no patients with repeat hospitalization, and low rates of patients remaining in high NYHA symptomatic classes. In terms of hemodynamics, we can see very effective low single-digit mean gradients, mean of 7.2 millimeters of mercury, high effective orifice areas, and only 3.4% of patients are having more than mild PVL at 30 days. On the right of this slide, you'll also see excellent symptomatic improvement, as one would expect with a contemporary TAVI system, with at 30 days only 3.9% of all the patients being in NYHA class 3. The Allegra valve has also been studied because of its hemodynamic performance in valve procedures, and this is the first study, the VIVAL study from Germany, looking at 30 patients who already had degenerate bioprosthesis in place. And you can see here that the striking thing about this subject population was that 80% of the surgical valves that were degenerate had an inner diameter of less than or equal to 21 millimeters, and almost a quarter of the valves were actually less than 19 millimeters. Mean age, as you can see there, and a reasonably high STS score as well. In terms of the procedural outcomes, you can see here that all but one patient had an Allegra valve successfully implanted, one patient being converted to another TAVI device. And again, low mean gradients considering the size of the valves, 11.6 millimeters of mercury, with the majority of the valves, 90% of the valves being a size 23 millimeter valve, a small TAVI valve, and only 10% of the valves being a 27 millimeter, i.e. larger TAVI Allegra valve. And again, you'll see that in this cohort, just over half the patients received post-dilatation to optimize the result. In terms of 30-day outcomes, these are also excellent. No deaths, strokes, or major bleeding, and a low rate of vascular complications, with only one patient out of the 30 suffering a vascular complication, and no new pacemakers post Allegra TAVI valve implantation. And again, on the right, you'll see their NYHA symptom classification, and pleasingly significant reductions in their symptom burden, especially considering the small size of the majority of these degenerate bioprostheses. In terms of 30-day outcomes, hemodynamically, you can see again, we've got very low mean gradients, 14.7 mean, considering the size of the bioprostheses, with very good effective orifice areas, considering the majority of these were 23mm valves. And in terms of paravalvular leak, no patients at 30 days had any evidence of paravalvular leakage. In terms of 1-year outcomes, pleasingly, the mean gradients have reduced yet further, and the orifice areas have further increased as well, which is, I think, excellent results and testimony to the hemodynamic performance of this valve. Again, no PVL at a year and 90% survival at a year with no cardiovascular mortality. We've also seen published last month a study from Spain, the SAVIV study, again in 29 patients with degenerate surgical bioprostheses. And what's quite striking, is shown on the right side of this slide at the bottom there, is the size of these bioprostheses, even smaller than the VIVAL population, so an even more challenging population in terms of hemodynamic performance following TAVI valve implantation. And again, as you'll see here, very good clinical outcomes on the right, no deaths, only one patient suffered a stroke, only 8.7% of patients had a new pacemaker implanted following the Allegra TAVI valve procedure, and only one patient had a vascular complication. Striking note on the procedural details on the left of this slide is that only 1 in 5 of these patients actually needed post-dilatation to optimize their hemodynamics following their Allegra TAVI valve implantation. And as you can see on the left side of this slide, again, a striking reduction in terms of mean gradient. So the mean gradient post-procedure was 8.4 millimeters of mercury, which is, I think, is remarkable given the size of the bioprostheses and the size of the TAVI valves that were being implanted inside these bioprostheses. And also on the right, you will see the rates of paravalvular regurgitation, with most patients having no AR and at worst only mild paravalvular AR following the TAVI valve procedure. In terms of my own data, these are the cases I'm going to show you from the first 26 patients that I've implanted, a high-risk population, mean age of 86, Euroscore 2 of 2.9%. The majority of patients were for degenerate aortic stenosis, and there's one valve-in-valve case implanted. Similarly, again, we've had excellent procedural outcomes, no mortality, no stroke, no major vascular complications. And also, again, whilst the majority of patients have been pre-dilated, only approximately 1 in 5 of my patients have required a post-dilatation to optimize their TAVI result. Low levels of contrast use, and again, the majority of patients that I've implanted have been implanted with either a 23 or a 27 millimeter Allegra valve. And again, we've seen excellent hemodynamic results, mean gradient of 6 millimeters of mercury, and only one patient had more than mild paravalvular leakage at discharge, and that was gone at 30 days, so that no patients had more than mild paravalvular leakage. 3.8, or 1 out of the 26 patients of mine, have required a new pacemaker, and no mortality at 30 days. So in conclusion, the Allegra TAVI system is a new TAVI valve that's been designed for optimal hemodynamic performance, and this has been confirmed by clinical experience. The valve produces excellent hemodynamic results with low gradients and minimal paravalvular leakage, despite low rates of post-dilatation to optimize valve results post-implantation. And whilst the Allegra valve, I think, is an excellent workhorse valve, it also seems to have added benefit in patients with either small native annuli or degenerated surgical bioprostheses. I thank you for your attention.
Fantastic. We thank Dr. Smith very much for that wonderful talk. And because we're a little bit beyond time, we're going to go straight to the next session, which is TAVI planning and device selection. We're going to have Drs. Dardas, Mastrokostopoulos, and Voudris moderating the session, and we're honored to have them with us. And we're going to be having talks by Dr. Chrysoheris, Dr. Spargias, and Dr. Toutouzas, who are clearly some of the biggest names in transcatheter valves in Greece. So without further ado, Dr. Dardas, Dr. Mastrokostopoulos, and Dr. Voudris, let's please be very brief with our introduction so we can get to the talk and respect the time that we have allotted for our speakers. Thank you very much.
Astonishing results we've seen from nearly all the valves is to see some talks regarding the practical tips and tricks, and I'm going to introduce Dr. Chrysoheris, who is well known to everybody, and he's going to speak to us about TAVI access, sheaths, vessel puncture, and vessel preparation. Mihaly.
So good morning to everybody, and welcome to the 11th THV conference. I will be addressing in the next 8 to 10 minutes issues relating to access selection, sheaths, vessel puncture, pre-closure, and pre-preparation for a successful procedure. You can see my slides. Let me move on. The Heart Team at EA Hospital. So TAVI is by default a transfemoral procedure because it's the least invasive access. It requires no surgical preparation. It can be done, we can do the whole procedure under local anesthesia. There's decreased morbidity and mortality and definitely fewer hospital days and reduced cost. Other alternative procedures in patients who cannot go transfemoral are multiple and depend on the expertise of each center. In our institutions, for instance, we use direct aortic or transapical. For the evaluation of transfemoral access, the use of multi-detector CT is mandatory. The three main elements that we're looking for is vessel size and diameter, tortuosity, and calcification. Vessel size can be measured very accurately using multiplanar reconstructions. Tortuosity can be a problem during transcatheter procedures, especially when it's like this, over 180 degrees. However, when it's a soft tortuosity without calcium in the wall, these can probably be easily straightened out with a stiff wire. It's more difficult when we have tortuosity along with significant calcification, like in this case, a patient here, whom we wanted to do a transfemoral TAVI from the left side, but we had significant calcification and tortuosity on the left side. It was impossible to advance a sheath, so we went from the other side and ended up with a successful result. The last part, obviously, is calcification, especially if it's a concentric calcification of the artery, or if it's protruding into the vessel lumen. So the three problems would be small diameter, tortuosity with calcification, and circular calcification with borderline diameter. So in moving on to accessing the femoral artery, the three main modalities are fluoroscopy, angiography with roadmap, and ultrasound. Especially for ultrasound, we can very nicely highlight with ultrasound the bifurcation of the common femoral artery, and then we can point to the front wall of the femoral artery, the common femoral artery, and safely puncture without inadvertently puncturing the branches or the vein. We, in combination, especially with crossover technique and roadmap angiography, we use ultrasonography, and especially in patients like these where the presence of a prosthesis may obstruct the view of the artery, the combination with ultrasound is very useful. From the beginning of the procedures, we look for our strategy in terms of how are we going to close, because we're going to be doing a large bore arteriotomy of about 14 French minimum. So the main two modalities that we're using is the ProGlide, which is a very standard technique. We use 2 ProGlides, which essentially it's a percutaneous surgical repair type of modality with a preformed knot. We can easily upsize or downsize our sheaths, especially if procedures become complicated. And it's indicated for closure of vessels from 5 to 21 French. Traditionally, we use 2 ProGlides oriented, one in the 10 o'clock position and the second one in the 2 o'clock position for our closure. And with that, we can do the whole procedure transfemorally without issues. The other major player for closure devices is the Manta device, which has 2 sizes, 14 and 18 French. It's a collagen plug, essentially, positioned at the end of the procedure. We don't do pre-closure with this, obviously, and it's been shown to be highly effective in terms of technical success with a very short time to hemostasis and a low rate of vascular complications. There was also a study that compared ProGlides to Manta with results favoring Manta in terms of risk of major bleeding and red cell transfusion, and in addition, faster discharge from the hospital. Whereas for vascular complications, we had maybe some more pseudoaneurysms and hematoma with ProGlides, but wasn't statistically significant. This is a patient here who underwent transfemoral TAVI with use of ProGlide sutures. However, he was obese and very difficult hemostasis. So at the end, we had to use a balloon to occlude the external iliac in order to facilitate hemostasis, which was done successfully. The third closure device is the AngioSeal, which is used usually for the second device. It's for the secondary access that we use. It's a collagen plug as well in 6 and 8 French size. And it's not prohibited to go back and repuncture the artery if need be for future access. It's doable. We just have to go 1 centimeter above the previous puncture. Coming along with the sheath that we use, the Edwards E-sheath is a very fantastic device for use. We've had very tremendous success with using it. It's very gradual in its insertion. It's 14 and 16 French for depending on the size of the valves to be used. The Evolute R and Evolute Pro platforms utilize the inline sheath, which again, for the Evolute R, has a 14 French diameter. But for the Evolute Pro system, it's a 16 French, which is about to change with the Evolute Pro Plus system coming along soon. Similar with the E-sheath, we have for Accurate has the I-sleeve, which is also 14 French across all sizes of the Accurate platform. And the Portico valve has the FlexNav TAVI system, which has integrated sheath, which is 14 French for most sizes and 15 French for the large size. Now, coming along to the when we have hostile iliofemoral access, which means a femoral artery that's less than 5 millimeters with severe calcification and so on, we could still try advancing a sheath or doing some maneuvers. And if the sheath goes up, fine. If it doesn't, we can consider doing angioplasty, atherectomy, or lithotripsy. Here's an example of a patient with difficult peripheral access, so lots of calcification. In this patient, we used an E-sheath, 14 French E-sheath from the right side, which was successful and was with an uneventful procedure done. For other patients, though, with very calcified stenotic vessels, we often have to utilize balloon angioplasty of the peripheral arteries. In this patient, we couldn't really go transaortic because of the presence of bypass grafts. So in this case, we accessed from the right side, and we had to do balloon inflations with a armada of 7x40 and 8x40 prior to advancing the sheath and the proceeding with the TAVI device. At the end, we had to do also angioplasty of the contralateral common iliac because of plaque shift. The shockwave lithotripsy is a device that promises to facilitate access for very calcified vessels. It produces acoustic waves which fracture both the intimal and medial calcium on the wall. This is an example of a patient with severely calcified common iliacs, in which lithotripsy was effective in being able to make more pliable the artery wall and be able to advance and complete the procedure. Lithotripsy has been studied in this study, which 42 patients with severe aortic stenosis are all deemed ineligible for peripheral access because of severe calcified occlusive disease. We can see the characteristics here. With the use of lithotripsy, they were able to have 100% success rate in advancing the valve with zero, essentially, complications, and with closure device being used, being mostly suture closure devices. Another important aspect of access is the use of a secondary access, because 1 in 4 complications, vascular complications after TAVI occur in the secondary access. And this study compared the standard, in an observational manner, the standard secondary access, which is the contralateral femoral, to the radial access, and showed that the vascular complications decreased significantly, major life-threatening bleeding was down significantly, as well as events that we wouldn't anticipate, like 30-day stroke, acute kidney injury, and mortality were all much better at 30 days. Now, obviously, this was an observational study, but it makes you wonder whether we should be shifting to the radial access for secondary access. And indeed, radial access is important, especially we see it, we use it when patients have the need for left main protection, like in this case, a low-lying coronary osteo, we had to position a stent across the left main to be ready just in case there was an occlusion. So here we have 3 axes for this, one being the radial. This patient here who had a renal transplant in the pelvis, so we couldn't use the one-sided iliac, so we had to go from the radial for secondary access with a successful result. Some other issues we encountered in clinical practice is, for instance, this calcified borderline size iliofemoral. With an unsuccessful attempt, we had to switch over to a transaortic access. Not every peripheral access is feasible. Here we have a patient with aortoiliac stent grafts. Here we have to be very careful. The size was very good. We advance the E-sheath all the way up to the abdominal aorta, and we externalize the valve when we are outside of the graft stent, so to ensure there's no interaction, and a successful deployment of the device soon after. Finally here, another patient with iliac stents, a very difficult case that required balloon. We tried to go with the E-sheath to begin with, but eventually we did multiple dilatations with peripheral angioplasty balloons prior to successful advancing through the iliac stents and deploying an Evolut R34. In summary, for access, MDCT is the fundamental tool that we're using for planning TAVI procedures and defining the original strategy for access. Ultrasound guidance and roadmap angiography allow for safe and accurate puncture and sheath insertion for primary transfemoral access. Choice of secondary access, what's called contralateral, femoral, or radial, is evolving based on newer data on safety and complications. Closure devices are essential for hemostasis and TAVI excellent outcomes, and novel technologies like lithotripsy may help expand transfemoral access for patients with severe peripheral arterial disease. And with that, I would like to thank you for your attention.
Ευχαριστούμε πάρα πολύ τον κύριο Χρυσοχέρη. Well, that was a fantastic talk, solving all the issues of peripheral access. There is the question from the chat regarding TAVI cases in cirrhotic patients. I don't know whether you've got any concern about that, and whether you want to say something about that.
I mean, definitely these are patients, it's a bit irrelevant obviously, but cirrhotic patients are a particular group of high-risk surgical patients, and in those patients, transfemoral TAVI would be the way to go if access is available.
Right. Okay. Now, just a question from me. How often do you use the ultrasound guided, and are there any steps that we need to know before we use it, and are there any pitfalls of this ultrasound puncture?
Well, ultrasound is very useful, but the main thing is that it has a learning curve to it. You need to be proficient in using it. So you need at least 10, 15 cases, maybe also in conjunction with your radiologist to be able to understand the anatomy and be able to become fluent in using it. Again, we usually use it in conjunction with roadmap angiography. Right.
I mean, this is a very useful technique because, to our experience, we've lessened the complications, the complication rate a lot by using this technique. And thank you very much. Just a final remark about the IVL. It's a very good technique, but it's costly. So one has to bear this in mind, that it costs a lot.
It's better than going transaortic or transapical.
Sure. Okay. Thank you, Michalis, very much. Now I'm passing over to Dr. Mastrokostopoulos to introduce Dr. Sparias.
Hello, dear colleagues. Good morning. It is my great pleasure to present our next speaker, Dr. Sparias, who is the director of the Transcatheter Heart Valve Department at the EA Hospital. He has extensive experience both for the procedures in the mitral, the tricuspid, and the aortic valve, and I'm really eager to hear his presentation concerning about the aortic root anatomy, sizing, and how we can choose the correct valve for our patients. Dr. Sparias.
Okay, thank you, Dr. Mastrokostopoulos. Can you hear me now?
Yes, we can hear you.
Perfect. So in the next 10 or 12 minutes, I will try to address the issue of the anatomy beyond the aortic valve annulus and the implication of this anatomy for the procedure outcome and the device selection. So when we talk about aortic root anatomy and sizing, we mean to talk about small sizes of the anatomy that can lead to coronary occlusion or sinus-valve obliteration and thrombosis, horizontal aorta with a difficult procedure in general and increased risk of complication, TAVI in SAVR or TAVI and the impact on coronary ostia, future coronary access for diagnostic or therapeutic procedures, asymmetric calcium distribution of the leaflets, and calcified STJ. And when we all, what we all scare and we are afraid about is when we have this outcome, when we get coronary obstruction either immediately after the procedure or later on, and this can have two mechanisms, either from a displaced leaflet from a previous bioprosthetic valve or from the sealing skirt of our device. And we can also have this complication occurring lately, as you can see in these two cases. And fortunately, the late coronary obstruction, which the very few things you can do to save the patients, is very scarce. And it's, as you can see, just 0.36% in self-expandable valve and just 0.11 in balloon expandable valves, and a little higher, just below 1% in valve-in-valve procedures. Other things we don't want to see in our aortic anatomy above the annulus is to have malpositioning and need for a second valve, or when we have extremely calcifications and we're doing ballooning, to have the aortic dissection. Before we talk in detail, we need to know in detail our devices. This is very, very important to know the exact dimensions and design of our devices. So here is the Evolut valve, the Evolut Pro valve, and you can see the waist diameter, which is very important, and we should know it's from 20 to 24 millimeters, and the commissural height, which is 26 millimeters. When we talk the commissural height, we talk about the top of the commissural post, and the skirt height, which is the bottom of the leaflet, which is 13 millimeters. And for the Sapien valve, respective numbers are here, and we should be very familiar with these dimensions. Factors that are impacting the coronary access after TAVI are the anatomy and the device in general. So the anatomy is generally the sizing of the aortic root, but except the sizing of the aortic root, it's also important the leaflet length and the bulkiness, how calcified and thick they are, and the coronary height. So the coronary height is the one we usually comment upon before the procedure, but as you can see, it's just one of 5 anatomical features. We should have a look in all of them. And finally, the device design is very important, but also the valve implant depth. So if you take a supraannular device and you do a deep implantation, then you change the design of this valve and you get a different risk of coronary access. So again, we need to know the exact design of our valve. So if we get a coronary artery somewhere here, which is at the deepening of the leaflet, then we can have access to this clearly. But if we have a coronary ostia just in front of this post, the commissural post at exactly the same height as previously, then obviously it's extremely difficult or even impossible to reach that coronary ostia. And what is the risk? The risk can be calculated from CT examinations before or after the procedure. And in this study, recent study, they found that the risk of unfavorable coronary access of the coronary ostia when we use the Evolut valve at below the skirt is 12% for the left coronary artery and 3% for the right coronary artery. And for the shorter Sapien valve, that is also annular, not supraannular, with a shorter skirt, the risk is lower. As you can see, 4% for the left main, 0% for the right coronary. And if we add to that the posts, the commissural posts that go very high in the Evolut valve, but are very lower in the Sapien valve, then the total risk of unfavorable access is 35% for the left main with core valve and 15% for the left main with Sapien. So these are things we should remember before selecting a device. And this is a difficult access. In a previous Evolut 23 valve, as you can see, it was impossible to reach the right coronary artery, which was fortunately small, and there was no problem there, so there was no need for intervention. But we were able to reach the left main. You can see the C-tab of the valve here in the inner curve, which is a good sign that the alignment of this valve was good. So we're able to get there, and we found there was a lesion in the circumflex artery that we went on to balloon and then stent in this patient with a very good result. So it may be difficult, it may be impossible, but it may very well be feasible, and we can do even difficult coronary angioplasties. Actually, once we get our guide catheter into the ostia, then the valve offers some extra support in most of the cases to do our intervention. So it's very important to consider the alignment of the posts of the prosthetic valve to the posts of the native valve, because if we get this wrong at the implantation, then we add some difficulty. And here you see the posts of the native valve in the coronary angiography, and the posts, how they change, they rotate after the positioning of the valve. And if we get a post in front of the left main, like here, or very close, then it may be difficult to get it. So is it easy, or is it possible to predict where the posts go with the Sapien valve? This was an experiment. They tried the Sapien valve in various rotations, and they found no effect at all on the risk of coronary overlap. So it's impossible to crimp the sapien valve in a way that you will prevent or improve your access to the coronaries. Can you do that with Evolut? Yes, you can do, because you have the C-tab, as you can see here, the pin here, and it's by default in this device that the C-tab goes opposite to the heart marker. This is the heart marker that is always on opposite of the C-tab. So if the C-tab is up here, this is the heart marker. It should be like this, not like this or like this. And when we have the heart marker at the outer curve, when we implant the valve, then we know that we have the C-tab, which is a commissural tab in the inner curve, and this prevents the standing of this commissural tab in front of the left main. And in the same experiment that they found that when we have the outer curve, the marker heart, then the risk of coronary access obstruction is extremely lower compared with the other position. So that's why we should always insert the system with the flashing port, not at 12 o'clock as we used to do in the past, but at 3 o'clock, because when we do that, we get the marker heart at the outer curve, so we avoid problems with reaching the left main. What happens when we have valve in valve? Then the game is completely different, because the leaflets of the first valve go outside of the second valve, and they create a cage there. So this cage may prevent reaching the coronaries through the cells, the open cells of the valves. And here is why it's important to have a valve that is smaller and lower compared to a supra-annular that creates a cage that is very high compared to the cage that we have with an annular valve. And here is exactly what I mean. You see the cage of the sapien valve, it stays down here, and the cage of the Evolut valve that is higher. But the design of the valve is just one component of the risk of TAVI. The other is the anatomy, because if you have a huge anatomy, you don't really care about this cage. There is huge space around this anatomy to get perfusion in the coronaries. And the other, of course, is the depth of implantation, because you can get a supraannular valve deeper and make it look like an annular valve. And just to remind you again, the heights of the leaflets in the various valves we're using today, with sapien having the lower height and the accurate having the higher height. And what we're looking for to predict the risk of coronary occlusion is the virtual TAVI to coronary distance, the VTC, this is how we measure it. We simulate the valve and circle within the anatomy in front of the ostia, the coronary ostia, and we measure the distance from the valve to the coronary ostia. And in this case, it is just 2 millimeters for the left main, and it's 9 millimeters for, in this case, larger. And we should always calculate the thickness of the native valve that will go outside of our prosthetic valve, and we should add this thickness to the VTC, because the native valve will also occupy a space there. That's why generally we don't accept a VTC less than 4 millimeters, and this may be higher when we have a very thick leaflet at the level of the ostia. And of course, CD modeling today is a big thing, and for predicting the coronary obstruction risk. We talk about the height of the valves, and this is a CT scan investigation that they predicted the risk of coronary obstruction and impaired coronary access when we do TAVI in TAVI. With core valve, the risk was 44%, with Symetis accurate 61%, Lotus 35%, Portico 20%, and Sapien 0%. And this is a more recent study, again, to predict the sinus sequestration and obstruction of the coronary ostia when we do redo TAVI. And with the Evolut valves, it was 39% for the left main, and 45% the risk of sinus sequestration. And on the opposite side, it was just 2% for the sapien valve. And what happens if we just, the first implantation is evolute? Is it better if we implant a sapien for TAVI-TAVI? The answer is no, as you can see here, because we have to implant the sapien at the height of the leaflets. So our gates, again, is going higher, and so it doesn't really matter if we use one or the other valve. And one might say, okay, we'll do a basilica, just tear the leaflet and do a TAVI and TAVI in the future. Well, this may be a difficult procedure with some higher risk of strokes, but again, even with this, it's not guaranteed, because if we have the commissural pulse just in front of the corneostia, so you can tear it with basilica, but you just have it just in front of you, so it doesn't really help. And let's do some case scenarios here to discuss. First, TAVI in a rapid deployment valve, a Perceval. As you can see here, we can measure in the axial imaging all the dimensions, and especially the dimension from the left main to the opposite side is pretty large, 33 millimeters. So you don't expect to have a problem here, no matter what size of valve you're using. And here we've used the 26 millimeter sapien valve, the implantation here with rapid pacing with an excellent result and no risk for corneosteal obstruction. This is a very old sapien XT valve that was degenerated and stenosed that came recently for a TAVI in TAVI. You can see it's extremely small anatomy, 23 millimeter sapien XT valve. Fortunately, it was implanted lower. At that time, the acceptor was 50%, and this meant that now the TAVI in TAVI, it's much easier because the left main is higher from the valve. So the cage is not a problem and it's not going to obstruct. So this is the valve with a very good result and no problem in the left main. And here is a degenerated evolute valve that fortunately the patient had previous bypass and the perfusion of the corner is from the grafts, because as you can see here, the distance of the left main to the frame of the valve is extremely small, and there's no such problem in the right coronary. And you can appreciate it in these cuts how close is the left main to the valve, but fortunately there are pattern grafts here, so we don't really care about it. And here is a sapien within an evolute valve, and you can see what I told you earlier, that it has to go higher, because if you put it down here, then you leave the top of the leaflets that are supraannular moving, so you have to go higher. Coronary protection is a big thing today when we do more and more TAVI in TAVI. Here you can see a lab code number 21, and you can see, although we have a VTC of 5 millimeters, how smaller becomes the STJ just above that measurement of VTC. So it's not just one measurement, it's a combination of measurements we should consider before implanting the valve. So here we went with protection of the left main. This is a small 20 millimeter valve, and you can see immediately after, you can see the white line threatening to close that gap there that is now occupied by the stent. So we didn't want to risk withdrawing the stent and having a total occlusion of perfusion there. So we proceeded with inflating the stent, and this, as you can see, pushed the white line of the native leaflet lower and guaranteed very good perfusion. When we have small anatomy, look, the anatomy here is extremely small by any standard, very borderline to be accepted for any valve. Sinus of Valsalva, very small. And here again, we can see how we can use the very small 20 millimeter valve. This is a 16 millimeter balloon. So we can get the guarantee here that we have some perfusion when we have a diameter of 16 millimeters. This is a 20 millimeter valve, but much underinflated. So it's like an 18 valve. After the implantation, we see we have very good perfusion to the left main and some regurgitation, of course. So we feel safe to do a post-dilatation with a larger volume, expand 1 or 2 millimeter the valve more, and still have a good result because we've tested for the perfusion of the left main. This is a similar case that is also, as you can see, bicuspid with extremely small anatomy and heavy calcium everywhere. This is functional bicuspid with one rough. You can see it here. And again, when we do the simulation with a smaller core valve, we see that everything gets obstructed there, extremely small anatomy. So we go again with a 20, with a 16 millimeter balloon, and we feel confident there is some space around it. And then we get the 20 millimeter valve underinflated, 2 MLS. We implant the valve, we see that we are safe. Of course, we have some regurgitation and the valve is not fully expanded, but we now feel safe to go and do a post-inflation, expand the valve more, and still be safe with good coronary flow. And what about the heavy asymmetric calcium in bicuspid valve? This is the definition of asymmetric calcium that you can find it just in one leaflet in a true bicuspid valve, type 0. You can see it here. And here is certainly a problem because if you go with a self-expanding valve, it's going to be pushed and the ellipticity index will be extremely high. On the other hand, you don't know how a balloon expandable valve is going to behave. So we do the test with the balloon, the 16 millimeter balloon, and we see that it stays stable with good perfusion of the left main. And this is the 20 millimeter valve. And you can see after implantation of this valve, when the balloon deflates, the valve rotates, but it stays functional and working very well with no problem to the left main flow and with tiny regurgitation and with very good result. And I'll finish with an example of horizontal aorta here that it's sometimes difficult for the implantation. We have a lot of calcium, as you can see, a pillar of calcium in LVOT. And that's why when we have a lot of calcium, we don't want to inflate balloons in general. And here is the horizontal aorta. Here is an evolute valve that we prefer in all cases with extreme calcification. And we needed to do some post-dilatation. You remember that pillar of calcium there that created some paravalvular leak. This is a 25 millimeter balloon. And after that, you see a very good result. And finally, this is another horizontal case with a bicuspid, again, valve with 2 leaflets calcified, but the calcification is restricted on the leaflets. It's not going to the annulus very much. So we do the balloon here and we go for the 23 millimeter valve, which is an undersizing compared to the measurements we had earlier, with a very good result. And I think this is our last case. Again, extreme calcium, avoid to inflate balloons there, go with self-expanding valves. That's a general rule. And this is a case with extreme calcium. Usually these cases are also bicuspid. And you can see the extension of the calcium, the measurements, the calcium nodules there. We avoid to do aggressive ballooning there. And just a very small balloon, 20 millimeter balloon, although the smaller diameter was much higher, just to make sure that we just touch the leaflets, and then we come with an Evolute Pro 29 millimeters. And you can see how compressed this valve is before and after implantation. And you can see how it's distorted from this extreme calcium. And again, our post-dilatation is very conservative with a very small balloon, 22 millimeters. And you can see the recoil of the valve after we deflate the balloon, but it's still a little better, as you can see, compared to before the ballooning. And I think with this case, I would like to thank you.
Dr. Sparias, thank you very much for an excellent presentation. The cases were very interesting. So I cannot see any questions from the audience. So I would like just to make 2 remarks. Coronary access is one of the problems we have to address before expanding the TAVI indications to people of lower age, because we cannot put a TAVI valve in a 60, 65-year-old patient and tell him that probably we will have to repeat this procedure 2 or 3 times, because we have to have an access to the coronaries. But for me, I would like to ask you that there is a saying that you do what you know and what you do best. So do you think that for TAVI programs, the operators must know how to implant successfully and have extensive experience using 1 or 2 or maybe 3 different systems, because the technology for every valve is different? We have supraannular, intraannular valves. So in order to have a successful TAVI program, do you think that we must be familiar with all valves or just 1? Because having experience with 2 or 3 different valve systems, we may give our patients the best valve and the valve that suits their anatomy better. Thank you very much.
Thank you for this question. It's very important. I think the most important thing is the volume. The higher is the volume of a center and an operator, the better the outcomes for the patients. And we should always advocate the patient interests. So we should protect the volumes of the centers that are doing TAVI. I think this is the #1 significance. And then if we go to see what is happening today and what are the indications today, I think the conversation, the discussion has shifted from the high-risk patients to the patient age. So we're going to younger patients, 65 years old or above, and the game is completely different there. So we didn't discuss a lot about TAVI in the past when we're doing 80-year-old patients with aortic stenosis, but now if we start doing 70-year-olds or 65-year-olds, these are patients that they're going to need the TAVI and TAVI, and it would be very unfortunate if we do a TAVI at this age and after 10, 15 years down the road, they realize that they cannot do a TAVI in TAVI because of the first implant, and they will have to do surgery then. So that's why I think the big thing today, when we're moving to younger patients, is to pre-empty and pre-consider what is going to happen when these patients are going to need TAVI and TAVI in the future. So yes, for this reason, I think we need to have in a program a combination of valves to get the best outcomes.
Okay, thank you very much. So I'd like to pass the microphone to Dr. Voudris in order for him to present our next speaker. Thank you very much.
Thanks a lot. It's a great pleasure for me to present the last speaker of this scientific session, Professor Toutzouzas, who is going to present some very interesting tips that makes the TAVI procedure successful. Predilatation, post-dilatation, transit, pacing, and depth of implantation implications, and different approach in the various TAVI device. Kostas.
First of all, I would like to thank you, Mr. Chairman. I would like to ask Dr. Sparias, what's the time limit? Because I think we overpassed the session time. So how many minutes do I have?
Kostas, I think we have plenty of time because normally we'll have a break now up to 12 o'clock. But since we're online and we're not going to meet outside for coffee or snack, I think we have plenty of time up to 12 o'clock. Thank you.
I'll try to focus on pre-dilatation, which is our case here. So is it still necessary part of pre-dilatation? From the first slide, I would like to point out that there is, yes, we need pre-dilatation. This is my option. Although we have now in 2021 great data from several studies, as you're going to say, that we can obviate in some cases. However, this is not the rule, and we have to adapt to individualize every time our case. So what are the pros and the cons for the balloon pre-dilatation? The pros is that we need to have peri-procedural planning, the valve size assessment, radial counter forces reduction, this is very important. Theoretically, we can reduce the paravalvular leak and the prosthetic valve fitting. What are the cons? It's a more complex case, we need more time, we need more fluid, we have to do always rapid pacing. We need sometimes more contrast agent, although the amount is not so significant. However, we need to use sometimes more contrast in order to evaluate the size of the valve in some cases. We can produce conduction abnormalities during balloon pre-dilatation. Even with a wire, we can produce it. Imagine with the balloon valvuloplasty. And we can, of course, we produce hemodynamic instability, which we don't pay off. However, we need to consider in some cases it is dangerous, and I would like to focus as a tip and trick, which sometimes we pay for this for the patient. If the patient had already a myocardial infarction in its history, sometimes it's dangerous to have hemodynamic instability in such cases. And of course, some cases have shown that we have cerebrovascular accident. So there are some pros and cons, and we need to evaluate it. What are the data? Unfortunately, we have only 2 randomized trials and 1 semi-randomized trial, as you're going to see, in 2016, 2019, and 2020. Fortunately, we have also experience with Evolutar self-expanding valve. However, we do have also with balloon expandable valve, and we have some data with Accurate now, which is a new player in the self-expanding valves. So this is the history of all these studies that have showed up, the case of pre-dilatation, if we need it or not. And as you may see here, plenty of them are observational. The study population, it's around 100 to 200 cases. There are some cases of Abramovich with 500 cases approximately, and from Pagnesi and his colleagues with 700 cases. However, as you may see here, they are mixed up with all valves, so we don't have clear conclusion from one valve. And generally, we can say that the outcomes had similar rates. Of course, as you may see here in this column, there is no randomization. It's just an experience based on the experience of the operator, of the center, and the appreciation of the calcium and the anatomy from the CT, and previously only with echo. So there were similar rates, although it was non-randomized, and this is also some cases with observational studies with very low number of patients, except the analysis of the source 3 registry with 1,500 cases, no above 700 cases, only SAPIEN 3, and there were similar rates of outcomes, although we can discuss what it means outcomes in all these cases in these studies. However, we have to say that in all of these randomized cases, the outcomes differ. And they differ in terms of the primary endpoint, which was after the study design was evaluated. And in the most of the cases, there was mortality, there was PVL. However, there was no device success, which is obviously, this is what we care about. So there were just observational studies and also this, and favors no pre-balloon valve dilatation in those cases. And then we came up with randomized studies. Our study, 171 cases. We did it with Dr. Voudris, we're very proud of that. And also with Leclerc, they had 236 cases only with SAPIEN valve. The outcome was to evaluate in these studies the procedural success rate. Of course, we had secondary endpoints regarding the mortality, and as you're going to see in the next slides. Simultaneously, we started one of the accurate NEO studies, the DIRECT-2 study, and we have some also experience on that from other studies, from Kim and Pagnesi, with a large number of patients, 1,200 here and around 300 cases here. And they had a device success rate of 91%, which is unprecedented, and a matched cohorts in this study of 97%. Of course, they didn't use the VAC1 or VAC2 definition, as you're going to see in these cases. So we have a problem with definitions in all these studies. So the first study with the SAPIEN study was Leclerc, published last year in JACC Intervention. They used the VAC2 definition and the criteria that we used here for non-inferiority analysis, and they showed that the mean difference was, as predetermined, was not statistically significant between the two groups. Actually, the non-inferiority threshold of 7%, as was predefined, it was successfully found in this case, and they didn't show any difference. They randomly assigned 250 cases, and they came up with 115 cases in the pre-dilatation and 121 in the no pre-dilatation, without any significant difference in the primary endpoint of the device success. I would like to remind you what we mean by the VAC2 definition, that we have a prosthetic valve with no prosthesis patient mismatch, mean aortic valve gradient less than 20 millimeters of mercury, or peak velocity less than 3 meters per second, and no moderate or severe prosthetic valve regurgitation. The VAC2 definition, as we already know. Of course, since I think now we have the middle of April, we have the new criteria as was suggested by the Valve Academic Research Consortium with FARC3 criteria, which have not been, of course, until now have been used. So this was the criterion, and here you can see the with prior balloon dilatations and without pre-dilatations, and here you can see that there was non-inferiority of 0.02, no death in the pre-dilatation. There was one death in the without pre-dilatation. Moderate and severe AR 5%, moderate and severe AR 6%, suboptimal valve performance 1.7.8, patient and prosthesis mismatch 19 and 15%, no difference. And as you may see here, when we use the definitions, we have different numbers. As you may appreciate, no more 95 and 97 and 92%. We come to the reality, and we have a similar device success rate of 75% in the conventional TAV, and in the direct TAV, 80%. These are the numbers if we use the definitions of the success rate. This is an analysis that from the same group. And they measured the myocardial injury in pre-dilatation, post-dilatation, as defined by the increase of troponin. And as you may appreciate here, pre-dilatation, pre-procedural troponin levels, pre-dilatation, post-procedural increased, they have increased troponin. Direct, pre-direct, if we need procedural, and this less increase. So direct TAV, we can say that it's associated with less increase of troponin, and we can translate this as less myocardial injury. And this is again is shown here in the BAV group and the direct BAV group, no myocardial injury in the direct, 87%. If you do pre-dilatation, then the myocardial injury, it's around 28%, 27.9. So we have higher incidence of myocardial injury as defined by the increase of troponin. Now we come to our study. It's a multi-center study. We have shown a previous slide. I would like to remind you some details for as tips and tricks. We randomly assigned the 171 patient, And we came up with similar rates. You see that we had really experienced centers with very experienced operators, 0% mortality in both groups until 30 days. And I have to congratulate once more all the operators in Onation Center and in Israel and in National Navy Center. They did extremely good job, as you may see here. There was one case of stroke in the direct TAVI, and we had 27% of pacemaker in one group, 32% in the other group, with 5 and 3% incidence of major vascular complications. So you may see that we are really we had good results. 15% in the pre-dilatation group, we needed the post-dilatation, and in double percent post-dilatation in the direct group. So we may have similar results concerning the mortality. We may have similar results concerning the pacemaker implantation. Of course, I have to remind you that it was before the new techniques of evolutar placement. So now these percentages are lower. However, these are the pragmatic numbers that we had in this study. So we had to pay off to obviate the need for pre-dilatation with an double increased rate of post-dilatation. If we assess again, the device success rate by VARC1 was 88% in both groups. However, if we use the strict rules of VARC2 definitions, then you see that we have a similar rate of approximately 76 and 74% in both groups. Actually, we had 18 patients in each group with patient prosthesis mismatch. And you may appreciate here by the effective orifice area index, as we categorize the patients in insignificant, moderate, and severe PPM. By this definition, severe was less than 0.65, I have to remind you. I already told you about the VARC2 criteria. And again, you can appreciate in this slide, VARC1 definition, VARC2 definition without any differences. Subgroup analysis, however, according to pre-TAV aortic valve area, showed a trend toward better success rates in the pre-BAV group if we had less 0.6 area. So what does this mean? This means that if we have very significant, very calcified lesion, we have an index, the AVA, that may individualize the patient, that we may have a benefit with pre-dilatation in this patient. We cannot prove it, it's just an assumption in a very qualified and very experienced audience that I have to mention. All the other parameters were not different between these two groups. All the secondary endpoints that we used, pacemaker implantation, major vascular complications, bleeding, and acute kidney injury. As you may see here, the pre and the post aortic valve area, and the PVL we had in both groups, none, mild, and moderate, and you can appreciate that there was no difference between these two groups regarding the incidence of PVL. Of course, I have to remind you that we had a double rate of post-dilatation in both groups. And here are some examples of failure in these cases. You may appreciate that the valve has popped out from the aortic annulus, and the operators had to implant a second valve with a good result. This is a good result. However, if we use the VARC2 definition, then you may appreciate that the aortic valve area index is 0.65. So this is a failure. This is a patient prosthesis mismatch, although by echo, you have a good, successful, good implantation. And then we presented the results after 1 year. We didn't see any difference between the two groups at 1 year. This is the aortic valve area before, post-TAVI, and at 12 months. And this was published some months ago in the CCI journal. You can appreciate here the paravalvular regurgitation at all times. It's still unchanged during the 1 year period of follow-up. This is the cumulative survival according to all-cause mortality and according to the pacemaker implantation. Again, the long-run p-value was 0.24. And all the parameters, as you may see here, BAV, post-BAV, were not different between these two groups. So from the direct study, we showed clearly by a randomized fashion, by using the appropriate criteria, definitions, that we didn't have any difference between the two groups. So now we'll proceed to the third case of a direct 2 trial, trying to see what happens with the new neo-accurate valve compared to the other valves. This study still it's not going, it's ended. We had the final follow-up. We had two groups of direct 1 and direct 2 trial with 86 cases with accurate neo compared to the other two groups. We used the same primary endpoints. The primary endpoint was device success by VAC2 definition, and we had the similar secondary endpoints regarding these procedures. We had 5 hospitals in the direct 2 trial. The majority came from Poland and from Inter-Balkan Center in Thessaloniki and other cases. And you can see again, we had procedural mortality 0%, 30 mortality 1.1%, post-dilatation in 33%. I have to remind you that all cases with neo-accurate, they did pre-dilatation. So it's a very similar result with Evolutar, and this is very important. PVL 4.8 with a mean grade of 20, more than 20 in 1.1%, and very, very low new pacemaker implantation of 3.1 position. So where are we now? Direct TAVI is feasible and safe with all 2 cases that we know, and now we know more with neo-accurate, with pre-dilatation. Direct TAVI feasible and safe in selected case with accurate neo devices. More severe AS trends better with pre-BAV. Of course, we have several other questions regarding patient factors, device factors, anatomical factors, and I would like to focus on the bicuspid scenarios, and I would like to demonstrate you very quickly a case which was presented in CardioAct last November. There was a case with large valve area, as you may see here, 28.6 of square millimeters, a large valve with a mean diameter of 28.3 millimeters, large vessels, good sign of Valsalva, height and diameter. You may appreciate there was a bicuspid valve, difficult to treat. And we start up with an angiography. We used pre-dilatation, and you may appreciate again that the height of the opening, the functional opening of the valve is distal to the annulus. It's in the ascending aorta, as you may see here. We started up with the valve. The valve was not well positioned, as you evaluate here, and we had to do 3 or 4 implantations and recapsulation of the valve to go and implant the valve very high, as you may appreciate, and we had a good result. Of course, it was not the optimal result. We post-dilated with the valve, and you can see the recoil again. So we had to post-dilate 1, 2 or 3 times and to achieve a good result. So this is not an everyday clinical scenario, but we have to evaluate in which cases we have to do pre and post dilatation. I think I'm out of time, so I will skip the other. Slides, and I'll go to the conclusion. So pre-dilatation can be avoided without increasing the risk of procedure failure. No pre-dilatation strategy in self-expanding valves possibly increases the need of post-dilatation. New valves will need more data. We have some data, and in selected cases, pre-dilatation is required. Thank you very much.
Do you hear me?
Yes, we hear you.
Okay, congratulations, Dr. Tudras, for your excellent presentation, including your personal experience with without pre-dilatation. I would like, because the time is over, just a short question. Nowadays, moving to low-risk patients, do you think that it will be necessary in more cases to have post-dilatation to improve the paravalvular leak?
I'm sorry, I missed the first part of the question. In which cases?
Do you think that nowadays moving to low-risk patients will need more post-dilatations to improve paravalvular leak?
I think that when we are moving already to lower risk patients, and mainly the lower risk means lower age, we will treat more and more bicuspid valves. So 2 days ago, we did a case, 71 years old with bypass, low risk patient. We did pre-dilatation because we had to treat the bicuspid valve and post-dilatation. So yes, the answer is probably yes. And for this reason, and another reason, we have to achieve an optimal result in low-risk patients because they have different survival option. So I think possibly we have to do more and more post-dilatations.
Okay, I would like to thank all speakers and co-chairman to this very interesting scientific session. I think we have some minutes for a break and continue to the next session. Thanks a lot.
Thank you very much.
Thank you very much.
Thank you.
go. Good morning from Dracula. First, I would like to thank the organizers and congratulate Dr. Farias for organizing this excellent meeting. The title of the session is Having Special Anatomy with exceptional presenters, and we'll start with Dr. Setzer, and well-known with excellent cases, studies, implications for non-TAV cases. And bicuspid anatomy is the TAV in bicuspid anatomy, implications for planning and device selection. Can we hear the Dr. Setzer speak, please?
TAV in bicuspid anatomy, implications for planning and device selection. Here are my disclosure. Couple of key messages about TAV in bicuspid aortic valves. The first one is that bicuspid aortic anatomy is quite frequent in the general population and within TAV patients in particular. Patient selection has an impact on outcomes. We're going to see that afterwards. The clinical outcomes in more recent registries seems to be comparable between tricuspid and bicuspid aortic valve patients when we use second generation TAV devices. And at last, sizing is currently quite intuitive, but we know that this sizing correlates with good clinical outcomes. So the idea is to try to capture what we are doing today. Couple of thoughts about patient selection for TAV. We know that there are anatomical differences between tricuspid and bicuspid aortic valve patients, and two of them may have a major impact on patient selection, apart from the extent of coronary artery disease. First, the calcium distribution and the absence of presence of calcium at the level of the raphe has an impact on therapeutic selection between surgery and TAV for bicuspid aortic valve patients. And the aspect of the ascending aorta is also important. When we have a large aneurysm of the ascending aorta, this may direct the patient towards surgery. We need to all speak the same language. So that classification is the most popular. It's the Sievers classification, defining type 0 with no raphe, type 1 with a single raphe, and type 2 with two raphes. And this is important so as we all speak the same language. And when we put this into perspective with more contemporary TAV registries, we can clearly see that type 1 is the most frequent phenotype, particularly type 1 left to right in Western countries. And this has been confirmed in many registries as, for example, this low-risk, Evolute low-risk registry, once again, type 1 left to right being the most frequent. And we rarely encounter type 2 bicuspid aortic valve phenotype in Western countries. We may face different phenotypes in Asian population. We have that CT classification that is also very important to integrate in our daily practice, because it's going to help us understand what is the overall procedural risk of the patient. Based on the number of commissures, the absence or presence of a raphe, and the extent of calcification, we're going to define several phenotypes, CT phenotypes. And we know that, for example, the amount of calcium, a very asymmetric, eccentric orifice is going to have an impact on valve deployment, valve expansion, real risk of malposition, risk of regurgitation, or the risk of annular rupture or aortic root injury. So it's quite important to address that, assess that at baseline. And we have that registry, retrospective registry, that clearly demonstrated that the combination of extensive calcification at the level of the leaflets and at the level of the raphe is going to have a negative impact on the survival of the patient's midterm survival. So it's really important to understand, assess that at baseline. Couple of words on sizing for bicuspid aortic valves. There are several methodologies that have been proposed for sizing for bicuspid aortic valves, whether it be annular base sizing, mean perimeter derived or annular derived diameter of the annulus, or supraannular base sizing, whether it be the supraannular tracing of what could be the anticipated opening of the leaflets, or the commissure to commissure distance that is easier to achieve. We also have that balloon sizing that is more difficult to integrate because it really clearly depends on the size of the balloon, the orientation of the balloon within the anatomy, the interaction with the sinotubular junction with the sinus of Valsalva. So it's more difficult to put it into numbers as opposed to the CT assessment. Everything resides in that CT scroll technique. You go from the annulus and you move upwards, trying to understand what are the metrics of the annulus, what is the calcium distribution, what is the phenotype of the bicuspid, and you move from the annulus to upwards just to understand the configuration of the landing zone. And when we ran the Bavard registry, we proposed to use the commissure to commissure distance, a very easy way to assess that supraannular region 4 millimeters above the annulus. This is debatable, but this serves as a reference for a common discussion. And so we identified 3 types of configuration of the landing zone. Tubular, when the mean perimeter derived diameter of the annulus matches the commissure to commissure distance plus or less 10%. Flared, when the commissure to commissure distance is more than 10% greater than the mean perimeter derived on the diameter of the annulus. And to my opinion, what is the riskier configuration, the tapered configuration, with a commissure to commissure distance being smaller, more than 10%, than the mean perimeter derived of the diameter of the annulus. For the first two configuration, tubular and flared, everything can be based on the annulus, the minimal dimension. And when you consider the tapered configuration, it's more intuitive to use the supraannular dimension just to avoid to be too aggressive for the annulus. Because we have observed in the Bavard registry that there was a constant undersizing of the devices once expanding within bicuspid anatomies, about 10 to 15%. Another methodology that is very important to integrate, particularly if you plan to use a balloon expandable platform, is that circle method. You put, for example, in this situation, a 26 millimeter device in a patient with an annulus that is borderline, metrics that are borderlines between 2 valve sizes. And you can clearly understand here that a 26 millimeter device is potentially going to be too large for the patient. You use the same thing with a 23 millimeter device, and you see that potentially that 23 millimeter device is less risky for the patient. So it's really important to use that circle method when you plan to use a balloon expandable platform. If we want to put everything into metrics, when we size for bicuspid aortic valves, you can clearly understand that the amount of oversizing that is used for bicuspid aortic valves is smaller, is less than for tricuspid aortic valves, or most of the time 3 to 4% oversizing as compared to 10 to 15% oversizing when we use tricuspid, when we do TAVI in tricuspid aortic valves. So less oversizing. There is still oversizing, but less than for tricuspid aortic valves. This is still work in progress. This paper has been accepted for publication. If we achieve first to do a supraannular tracing 4 millimeters above the annulus, second to standardize it, what we can see is that the mean perimeter derived diameter that is obtained is going to match the mean perimeter derived diameter of the device after implantation, and this is based on post-CT scan, post-TAVI CT scans. So it may be helpful to understand what is going to be the maximal diameter of the device and to avoid excessive oversizing once again. So key messages for sizing. CT sizing is the gold standard for TAVI and bicuspid aortic valves. Annular base sizing is efficient in about 90% of the patients, so it's quite reassuring. Supraannular sizing is recommended to understand the landing zone configuration because we have to be cautious in tapered configuration and extremely calcified anatomies. The second method is really useful when you plan to use a balloon expandable platform. And most importantly, we have to avoid excessive oversizing. First, because there is constant under expansion of the stent frame, 10 to 15% in bicuspid anatomies, whatever type of device you use, and aggressive oversizing is going to lead to complications. So let's finish up with a couple of procedural consideration. The first is the working projection. In bicuspid aortic valves, we have to work in a kind of cusp overlap view. We have to find that two cusp view, work on the CT scan to find that two cusp view that is going to be appropriate to deploy the device. The aim is to achieve high implants, whether we use the radius-lucent line for balloon expandable platform, the SAPIEN 3, or the end of the stent frame, the inflow portion of the stent frame for self-expanding devices. The goal is to achieve high implants. What we've seen in Bivolute X with a self-expanding platform is that pre-dilatation has to be part of the procedure. Less pre-dilatation for balloon expandable platforms, but for self-expanding ones, this is recommended. Reposition the device to really achieve the perfect depth of implant. This is really achievable, and post-dilate if necessary, because what we've seen in Bavard is that circularity is achievable with new generation devices. Another important point is the risk of misalignment. We know that it's important for, it's really frequent with tricuspid aortic valves. It's the same for bicuspid aortic valves because we have different orientation and takeoff of coronary osteums. So we need to use the markers that we have in the catheters, particularly for self-expandable ones, to try to achieve a proper commissural alignment. For type 1 left to right, what is the most frequent bicuspid phenotype in Western countries? It's very simple. You use the same technique as in tricuspid aortic valves. The aim is to put one of the commissure in front of the raphe. So it's the same technique as for tricuspid aortic valves. It's more challenging when we are dealing with non-type 1 left-right, non-left-right connected bicuspid phenotypes. For example, the type 0 with a phenotype that connects the right and the none, or a type 1 that connects the right and the none, or the none and the left. It's more challenging because you can see, as for example, depicted here in that CT scan, that the risk of misorientation of the posts of the commissure is really, really important. So we need to work on the CT scan to understand what could be the appropriate rotation of the handle to achieve a proper commissural alignment in non-left to right bicuspid phenotypes. And for example, in that situation, we had to put the flush port of the Evolute platform at 6 to 9 o'clock. And at the end to end up with something that was not perfect, but more appropriate for this particular phenotype. For the other ones, you all know the techniques. Use the posts to properly align your catheter with the commissure. So let's summarize about techniques for TAVI in bicuspid aortic valves. The first one, two-cusp view, mandatory. The second one, pre-dilate for self-expandable platforms, using the minor diameter of the annulus at baseline. It may be useful also for balloon expandable platforms in extremely calcified anatomies. Commissural alignment has to be achieved, so we need to work on that, understand the configuration, the orientation of the coronary osteums, and try to achieve a proper commissural alignment. High implants are recommended, but remaining across the annulus, we don't anymore recommend a supra-annular deployment. It doesn't make sense, and because it's going to end up with more regurgitation, less stent frame expansion. So we need to put the devices across the annulus, not extremely deep, but across the annulus. The stent frame has to be assessed in two orthogonal views, and we need to post-dilate if necessary, starting with the minor axis of the annulus at baseline and ending up with a mean perimeter-derived diameter of the annulus as a reference for the balloon if necessary. So now it's time for the discussion, and I thank you very much for your attention.
Great. Outstanding talk. We have to see again in slow motion the video to understand all these tips, tricks, all these arguments that we have Dr. Tetze taught to us. Just to summarize, at the beginning, in Greece, there is contraindication to put the TAVI in bicuspid valve. Nevertheless, the data showing that The results for having bicuspid valve is excellent. In 90% of the cases, we can achieve optimal result with having bicuspid valves. We have to be careful in extremely tapered anatomy, in extremely calcified bicuspid valve, and nevertheless, the planning, sizing is more difficult than in tricuspid valve. But at the end of the day, the results are excellent. I don't know if any other one of the moderator wants to have a comment.
Okay, just a brief comment. Hello to everybody. Thanks for the invite. Just a brief comment. Like if you check the status of the reference papers all over in the last years, you will see that with the initial TAVI technology, we indeed had not so good results, and that was a problem. With newer devices, with newer technology, and of course with more profound understanding of a slightly different procedure of the bicuspid versus the tricuspid, the data show that we have equally good results with the tricuspid TAVIs. So I think this was a talk of the future.
And a comment from me, I think it's becoming more and more important bicuspid anatomy because we're moving to younger patients, and it's up to 50% of the younger patients who are moving now with TAVI that have bicuspid anatomy. So our results there have to be good. What we know so far is our results is good on mortality outcomes, but probably they're not as good in PVL, in bicuspid valves, compared to the tricuspid valves. So there's some more work to be done there. But what I learned from Didier's talk today, and he was very clear about when to use the annular dimensions and when to use the supraannular dimensions when we have the trapezoid shape in bicuspid anatomy, and also how to use the simultaneous autography with BAV for sizing, especially in balloon expandable valves. My personal impression in bicuspid valves is that the calcium that matters, not the bicuspid anatomy itself. I think if you have a bicuspid anatomy with just a low quantity of calcium, then this is not very different to a tricuspid TAVI. But when you have a bicuspid anatomy with a lot of calcium, either on a RAF, if it's type 1, or in one leaflet or the other leaflet, or the asymmetricity of calcium, or things also very important when we have BAV anatomy, then things become more challenging with TAVI procedures. So in my mind, it's the quantity of calcium that you have on a bicuspid valve and the symmetricity of calcium that make it easy or difficult. And finally, I think that's the only anatomy that I wonder if the ellipticity of a device will have any impact on future durability of the device, because clearly all the self-expanding valves in the true bicuspid anatomy, they have an ellipticity index that is quite high at the end of the procedure, and no matter how much post dilatation you do, you always have the recoil. But with the balloon expandable valve, you get an ellipticity index that is about 1.1, even in bicuspid anatomy. So I wonder if the long-term results of the self-expanding valves in bicuspid are good, and this is something we have to observe.
Great. Because of time, I think it's time to move to the next talk. Dr. Spanier, do you want to introduce the next speaker?
Dr. Latsios.
Okay. Yeah. Thank you. First of all, thanks to the organizing committee for inviting me to this today very interesting event. May I thank the whole of the organizing committee, interventional cardiologists like Kostas Spargias, as well as the surgeons, which reflects the interest of the whole of heart community regarding TAVI. So we'll go to a video recorded talk by Marco Barbanti from Catania, Sicily, who after the reaccess paper that went out in last November regarding reaccess, showed us some interesting findings. However, if not that so much, fulfilling. And this is a very, taking a pass from Kostas Spargias, this is a very interesting topic regarding younger patients, because if you put a TAVI to a 60, 65-year-old patient, you have to think what's going to happen 10 years after that, either programmed in a programmed PCI, or if he comes late at night during a STEMI, regarding coronary access after TAVI. Let's see the talk. Video, please.
Good morning. Thank you, the organization, for this kind invitation. My name is Marco Barbanti. I'm an interventional cardiology in Catania. Today, I was invited to talk about the coronary implantation. This is a very important issue that in the last few years has gained a lot of importance and a lot of attention from the clinical community. And I would like to start my presentation from presenting you a case. This was an 82-year-old gentleman with liver cirrhosis, diabetes mellitus, and severe renal insufficiency. This patient had quite intense clinical cardiac history with an acute coronary syndrome in 1998. For severe aortic stenosis, he underwent a TAVI with a core valve, 29 core valve, in June 2008. So this was actually one of our first cases, and the procedure was quite effective. This patient went absolutely good for a while, but in 2014, he came back with a shortness of breath with the NYHA class 3-4 and CCS2 angina. We diagnosed a severe transcatheter valve degeneration with a mean radius of 42. So these were the pre-procedural consideration back in 2014. So this patient was on high risk for surgery. No oral anticoagulation therapy was attempted because it was a clear degeneration and because the gradient, the transport gradient decreased progressively with time. We decided not to do a CT because at that time we thought that there were no issues with sizing, and the patient also had a renal failure. And we decided to implant the same platform size and type, so with the Evolut R29 at the same implantation depth. So this was the procedure back 2014. The procedure was absolutely uneventful, with implantation Evolut 29 inside the first one, and the result was absolutely good. I have to say that I was happy at that time, but this patient came back with a new coronary syndrome, and we tried to cannulate selectively the coronaries, and after, I can say, almost 1 hour, it was absolutely impossible to obtain a selective coronary angiography of both left main and RCA. So this patient went also a CT post, and you can see here there was kind of a barrier just in front of the left main, so indicating that the engagement of these coronaries was absolutely impossible. So fortunately, this patient had no major complication from his acute coronary syndrome, but this was a clue and the first sign that coronary access and the presence of the manifestation of coronary artery disease after TAVI can be an issue that should be tackled and should be taken in mind. Because we know that the significant coronary artery disease is present, is very frequent in TAVI patients, rising up to the 75% of our patients. And we know that it's not something steady, it's something dynamic. So in TAVI patients suffering from coronary artery disease, acute coronary syndrome might happen anytime. And it was demonstrated that it has poor prognosis. We know from literature that post-TAVI ACS incidence is about 4.7 up to 10%. But also ACS after TAVI can be also underestimated because not all patients are seen in TAVI centers. A point which is important is because the longer life expectancy, the lower risk in the younger patients, these patients had more likely to having coronary events after TAVI. So maintaining access to the coronaries is critical for patients' lifetime management. What the literature says today regarding acute coronary syndrome or presentation of acute coronary artery disease after TAVI. This is a very big registry from TVT. And out of more than 100,000 patients, of this 4.7% were admitted with diagnosis of acute coronary syndrome. We see here that the prognosis of these patients, it depends by the clinical presentation, with poorer prognosis in patients presenting with acute coronary syndrome, STEMI and non-STEMI, a little bit better prognosis in patients presenting with unstable angina. But not just the clinical presentation is important for the prognosis of these patients. Also, what type, if the complete or revascularization was performed or not, is an important driver for the prognosis. We can see here from this paper by Farouks that patients who underwent revascularization after TAVI presenting with this clinical presentation, so with the ACS, those who underwent revascularization had definitely better prognosis with those as compared with those who had no revascularization. And this is the most recent paper on STEMI after TAVI, showing that actually the door to balloon in case of STEMI after TAVI was definitely higher compared with the control group of patients not receiving TAVI, and the PCI failure rate was 4-fold higher in a TAVI patient as compared with no TAVI patient, with this very poor prognosis at 1 year, so 33%. So it means that acute coronary syndrome after TAVI is something that we should take in consideration, that for sure will increase in the future as long as we're going to expand our indication in younger patients. But of course, it's something that can have an impact on our prognosis. And of course, regarding the coronary access after TAVI, there are some issues that can impair this selective cannulation. And some of them are just anatomical, such as the dimensions of sinusoidal junction, the sinus height, the bulkiness of leaflets, the sinus of valsalva width, and the coronary height. But some of them are related to the prosthesis we implant, such as the valve implant depth, the commissural tablet orientation, the CD skirt height. So according to this, we can say that we have different TAVI platforms. And there are some issues that should be considered when assessing the prosthesis and its impact on a coronary access after TAVI. The first one is the short frame versus long frame. The second one is the open cells versus closed cells. And the third one is supraannular versus intraannular leaflets. So according to these characteristics, we might have a valve which can be more prone in having a more challenging cannulation of the coronaries after TAVI. And this is a meta-analysis showing, and actually the Medtronic core valve, so it was associated with a higher risk of having unsuccessful coronary cannulation as compared with the SAPIEN 3. So it means that short frame open cells, they predispose better to have a manageable coronary access. And this is the first prospective study investigating this particular issue. So among 300 patients in which the primary endpoint was the coronary cannulation after TAVI, the unsuccessful cannulation rate was 7.7%, but it was interesting to see that almost all cases were observed with the Evolut, with only one case with SAPIEN 3 and no cases with the accurate neo valve. So we concluded in this paper that there are some anatomical and some procedural factors, including the use of implantation of the use of Evolut valve and the implantation depth. So the higher the implantation, the higher the chance to have an impairment in coronary access, and the higher the oversizing of the sinus of Valsalva, the higher the chance to have an impairment of coronary access. All these variables taken together may predict with a significant high probability, high specificity, the cannulation failure of the TAVI. But another point that should be discussed is also the commissural alignment, that so far has been in TAVI has been random, and a lot of attention has been put in this issue. First of all, because the frequency of THP commissural misalignment, the impact of commissural misalignment along the long-term valve performance, particular durability, and also which is the focus of this presentation, repeat procedures such as PCI and also Redu-TAVI. And it's very important to talk about commissural alignment also because there is the possibility to solve or reduce this issue with some procedural experiments and better patient selection. Also, this is important because we can provide the manufacturers some important insights for improvements of the future and current THP platforms. But how frequent is it? This is a paper by Fuchs back 2018 showing that actually this is absolutely frequent. So severe commissural misalignment was reported with all type of device in almost 1/3 of patients. And this is a CT-based study by Ochai, published in JACC Intervention in 2020, showing that an unfavorable coronary access with Evolut valve, it was observed in 34 and 25% of patients, respectively, for left main RCA, and it was a little bit lower with SAPIEN valve, so with 15 and 8% for left coronary artery RCA. Once again, highlighting the fact that the type of valve we're implanting has an impact on implantation, on cannulation after TAVI. Tank showed that for the first time that actually we can do something for commissural misalignment, and particularly we can do something not with the SAPIEN 3 valve. We showed that we can orient the valve by crimping the valve in different positions, but we have no impact on the commissural misalignment, so overlap with the native, with the prosthetic commissure. But we can do something with Evolut, so by putting the flash port at 3 o'clock, so we may have a significant reduction of severe overlap between the two caps, the native, the prosthesis caps down from 76 to 20%, but also with the accurate neo valve, so we are able to orient the valve and then obtain a better commissural alignment. And finally, to conclude, is a very important to see the coronary implication of intra versus supraannular Redu-TAVI, because we always thought that TAVI is a reproducible procedure. This is absolutely sure, but this procedure has some implication. And one of them is that we are going to create a cylinder into the aortic root that might preclude any possible access to the coronaries in the future. So this is once again something that should be highlighted. And regarding this, what is important is the first valve we are going to implant. This is a paper by De Backer showing different THP and THP combination, studying how frequent could be the impossibility to obtain a coronary access. And we saw that when the first valve to be implanted is a core valve Evolut, it's very frequent to see at least 2 interfering factors with coronary cannulation after Redu-TAVI, as compared with SAPIEN as a first THP in case of THP in THP, which at least 2 interfering factors was observed in only 17% of patients. So it means that the first valve is very important, and when we are going to decide what kind of valve we are going to implant in our patients, today we have to also consider the possibility that this patient might benefit from a coronary angiography or might have high risk of acute coronary syndrome in the future. So going back to our patients, that I presented at the beginning of my presentation, I would change today some procedural presentation regarding the use of CT, the use of same platform, the same implantation depth. And I would change as it follows. I think CT today is mandatory to screen potential issues with the coronary reaccess. It's very important to tailor THV type and size implantation depth, and also a careful selection and commercialization of the first THV. So in consideration of this, to conclude, I would say that in case we have in our cath lab patients with preceding with a TAVI inside, there are some consideration that should be taken in mind. One is to have a low threshold for femoral access, so that could be easier to engage the coronaries. Use a JL/JR guide catheter, downsize the guide catheter by 0.5 centimeters, aim the frame of the waist of the valve and be coaxial. Don't be shy to use a guide extension catheters, and remove also the wire over a wire. And this is a flow chart that we presented in our intervention, and you're going to see in a few months where we suggest how to deal with these patients. So in conclusion, we can say that coronary artery disease is correlated with aging, is highly prevalent with the TAVI population. Lower risk in younger patients with longer life expectancy are likely to develop coronary events, especially with the progressive evolution of either existing or new lesion over time. Specific anatomical THV patient interacting factors as associated with more challenging or even impossible coronary cannulation after TAVI, and also design of the implanted THV matters. A THV with short stent and open cells are proven to maintain easy coronary access. And in a THV and THG context, the first cut is the deepest. Thank you for your attention.
Okay. Thanks for a very interesting talk. Covered a lot of issues, provided some tips, some tricks, some solutions regarding access, coronary access after TAVI. I stand to my initial comment that what Kostas Sparias said, the more we go to younger patients, the more we go to patients that have a larger, longer life expectancy ahead of them in the future, the more we're going to need to re-access and re-access their coronaries. And something that 10 or 15 years ago wasn't even to be talked about, what's going to happen in a high-risk patient of TAVI regarding the coronary. That was not an issue then. Now it is an issue, and it's becoming more of an issue. And the more tips and tricks we hear and the more experienced people talk about it, the more we all learn. You have any ideas, any further comments, any further tips for the audience?
Oh, I completely agree with you, George, that as we move to younger patients, thinking about future coronary access becomes more and more important. And of course, when we do a TAVI procedure, what we want is the immediate success. So if there is, a burning reason to use one particular valve to have a safe outcome and a good outcome, we're going to need it. We're going to use it because we need our patient to survive the procedure. But if we can use 2 or 3 different valve designs without any problem in the particular anatomy, then we should start thinking about future coronary access and integrate this factor in our decision process in the device selection. And I think we're going to move on, and we're delighted to have one of the pioneers of the field of TAVIs and transcatheter valves in general, Professor Simon Redwood, Professor of Interventional Cardiology, well known to all of us at St. Thomas Hospital. And thank you for being with us, Simon. And the talk will be about valve fracture when we do valve-in-valve procedures.
Thank you very much. Can I just check you can see my slides okay?
Absolutely, perfectly well.
Great. So thank you very much for the introduction. Yes, I'm an interventional cardiologist at St. Thomas's Hospital in London, and I'm going to talk to you about valve fracture. Here are my conflicts of interest. And I have to acknowledge Adnan Chatriwala, who provided a lot of these slides that I have adapted. Now, structural heart disease procedures have been associated with a lot of what I thought were initially crazy ideas. One of them is transcarotid TAVI. I was convinced that would increase the risk of stroke, but it doesn't seem to. Secondly, basilica, that's intentionally lacerating either the aortic leaflets either in front of the left coronary or the right coronary, and I was convinced this would cause severe aortic regurgitation and hemodynamic collapse, but it hasn't seemed to have done that. Lampoon, which is a similar procedure of lacerating the anterior mitral valve leaflet at the time of mitral valve implantation, that again seems to be safe. Transcaval TAVI, I always thought that was madness and would cause vascular complications, but it seems to be very safe and very easy to do. And finally, valve fracture, which again I thought would be very dangerous and cause annular rupture. So why are we talking about valve fracture? Well, if we look at the valve-in-valve paper from Danny DeVere and JAMA and the mortality after valve-in-valve interventions, you see here that if you present with stenosis of your valve, then your prognosis is very much worse. And presumably this is due to patient prosthesis mismatch. Similarly, if you use smaller valves, as opposed to larger valves, your mortality is higher. And again, this is almost certainly due to patient prosthesis mismatch. And if we look at the results of bioprosthetic valve fracture, this is one study of 66 patients. You can see on the left-hand side the mean gradient, on the right-hand side the effective orifice area. It's substantially reduced after valve-in-valve intervention, but it's also reduced more so after bioprosthetic valve fracture. And similarly, the effective orifice area is increased after valve-in-valve procedures and increased a lot more after valve fracture. It's important to know that most surgical valves can be cracked. There are a couple that can't be cracked but can be remodeled, one of those being the trifecta. The Medtronic Hancock valve and the Avalus valve, which I'll show in a second, are the two of the valves which cannot be fractured and cannot be remodeled. So here you see a table. On the left-hand side, the valves that can be fractured, the Biocor Epic, the Magna, the MitraFlow Mosaic, and the Neuro Perimount. In the middle are valves that can be remodeled, in other words, stretched, the Carpentier-Edwards valves, the Inspiris, the older Perimount, and the Trifecta. And on the right-hand side are the two valves that cannot be fractured or remodeled, the Avalus and the Hancock. And this is the sort of appearance you get on CT. You can see with the blue arrows where the fracture has occurred on these two valves. And here's the setup. First thing to say is it is 100% off-label and has not been approved by any of the valve manufacturers. What you need to do is have a 50 ml syringe with some dilute contrast connected to a three-way tap, which is also connected to an indiflator. And the first step is turn the three-way tap to the 50 ml syringe. You inject as much contrast as you can, then turn the three-way tap to the indiflator and wind up the indiflator to increase pressure. It does take time and it does take coordination in order to get the correct pressure. So it is a longer pacing run than we're used to when we're doing balloon aortic valvuloplasty. We tend to use either a true or an Atlas Gold balloon and choose a size which is 2 to 3 millimeters larger than the internal diameter of the implanted valve. So it's important to look at the valve-in-valve app, the aortic valve-in-valve app, and know the characteristics of the valve which has been implanted. So you should expect about a 3 to 4 millimeter gain in the internal diameter with fracture. And you should select a valve size based on the expected internal diameter following fracture. But you shouldn't oversize the valve that you're going to implant. So upsizing does not improve hemodynamics and you will end up with a constrained valve. So just for an example, if you have a 23 millimeter Magna, that has an internal diameter of 21 millimeters. Using it, for example, a 26 millimeter Sapien Ultra valve would not fully expand. So you should use a 23 millimeter Sapien Ultra and then a 22 or 23 millimeter high pressure inflation. Confirmation of fracture sometimes isn't present, but sometimes you will get a sudden drop in inflation pressure. You will occasionally hear an audible snap. You may see the balloon waste release, or you can just see visual confirmation of the fracture. One important caveat is that Medtronic have released an urgent field safety notice towards the end of last year that you shouldn't oversize when you're balloon fracturing an evolute valve or core valve. and you should go maximum of 2 millimeters larger than the constrained size of those valves. So for example, a 23 millimeter evolute R or Pro, you don't dilate more than 22 millimeters. And going up to the 34 millimeter, you wouldn't dilate more than 26 millimeters. So which patients should we fracture? Well, I think anybody with a small or intermediate surgical bioprosthesis, and by that I mean a true internal diameter of 21 millimeters or less. Any patients where you have a high residual gradient following your valve-in-valve procedure, and by that I define it as greater than 20 millimeters of mercury. And some people would argue that you should do this in all patients. I think that's probably overkill, but you should certainly consider it when you're performing valve-in-valve procedures. So what are the effects of valve-in-valve under expansion? You see this phenomenon known as pinwheeling, which is twisting of the leaflet-free edges resulting from excessive leaflet redundancy. On the left-hand side, you can see the valve during systole before valve fracture, where you see all this excessive tissue. And on the right-hand side, that excessive tissue is gone. And I'll show you an example of that in a minute. We do it because underexpanded valves don't last nearly as long and are associated with recurrent stenosis and degeneration. So here's a bench testing example of a patient that has a 21 millimeter mitral flow, that has a true internal diameter of 17 millimeters, and using a 23 millimeter true balloon. On the left-hand side, you see after implantation of the 23 millimeter SAPIEN 3, before valve fracture, there's quite excessive redundancy of the leaflets. In the middle, you see it if you perform your valve fracture before implanting your SAPIEN 3 valve. There is still some excessive redundancy, but less so. And on the right-hand side, if you perform your valve fracture after implanting the SAPIEN 3 valve, there's much less in the way of leaflet redundancy. And we see this with all the valves. In fact, I don't have Portico up here, but you see this with the SAPIEN 3, the Accurate Neo, and the Evolute R. So on the left-hand side of each of these three panels is no bioprosthetic valve fracture. In the middle is performing your bioprosthetic valve fracture prior to deploying your TAVI valve. And in the right-hand side is performing it after you've deployed your TAVI valve. And you'll see if you perform your valve fracture afterwards, you get a larger internal diameter. You can also calculate this pinwheeling index just to prove the point. And the pinwheeling index is the length of the leaflet from the valve frame to the coaptation center, divided by a straight line distance between the endpoints of the leaflet edges. And that's, minus, and then that's divided by the length ideal and multiplied by 100%. Don't worry too much about the calculation, but it's just to illustrate here that you see if you don't perform bioprosthetic valve fracture, you get quite a high pinwheeling index. That is reduced somewhat if you perform your valve fracture before your valve-in-valve intervention, but it is substantially less on the right-hand side if you perform your valve fracture after valve-in-valve intervention. And similarly with the effective orifice area, for the three valves highlighted here, with no bioprosthetic valve fracture, there's quite a small effective orifice area. That is somewhat improved if you perform your valve fracture prior to valve-in-valve intervention, but it's very much better if you perform your valve fracture after valve-in-valve intervention. So is it better to do it before or after? Well, there are pros and cons. If you perform your bioprosthetic valve fracture first, then you don't risk high pressure inflation of the new valve, but there is a risk of embolization or severe aortic regurgitation from damaging the prosthetic valve. If you perform your valve-in-valve intervention first and then do your bioprosthetic valve fracture, the pro is you can assess the results first, decide whether you need to perform fracture, and a high pressure inflation improves the optimal hemodynamics as I've just shown. But the risk, of course, is that you may damage the leaflets of the new valve. Alan had looked at the multivariate predictors of the final gradient, and you'll see at the bottom the timing of your balloon prosthetic valve fracture, in other words, fracture after your valve-in-valve intervention, is the strongest predictor of a low final gradient, and so that is preferred. I'm just going to show a couple of examples. This is an 86-year-old lady who has a pre-existing 21 millimeter perimount valve. From the valve in, valve out, that has a true internal diameter of 19 millimeters. And we've chosen a 22 millimeter barred true balloon. And I'll play this now, but if you concentrate on the top of the valve, you will see the fracture quite clearly. They're quite long pacing runs, long inflations in order to get the pressure up. But if you look very closely, you will see it pop open towards the end of this, this cine run. There, just there, it pops open. I'll just show that once more so that you can see it. And you don't often see this, but when you do, it's very reassuring. Now, this was an example where we performed the valve fracture prior to deploying our TAVI valve. And we did this because I was worried that it would damage the valve, but that's not our practice anymore. This resulted in acute aortic regurgitation and hemodynamic instability. So we very quickly deployed a 23 millimeter Sapien Ultra valve. You'll see it's a slow deployment, allowing me to reposition the valve. I'm just pushing it forward there. And then once I feel it's captured and in the right position, we perform a full inflation. And you'll see here, there's a very good result. It's a fully expanded valve, minimal aortic regurgitation. Here's an example where we performed our TAVI implantation first. This is also a perimount, 23 millimeter, so 21 millimeter internal diameter. We're using a 23 millimeter Sapien Ultra valve. Again, it's a slow deployment to allow us to get it coaxial and in the right position. And then we performed our valve fracture afterwards using a 24 millimeter Atlas Gold balloon. And again, you'll see here, it's quite a long pacing run. It's very useful to have an anesthetist in the room because these are long pacing runs and the patients don't really enjoy it. But the benefits are you get much better hemodynamic results and much better long-term results. In this case, you don't actually see the fracture. You see the valve expand, but you can't actually see it fracture. And again, a nicely expanded valve with no aortic regurgitation. It's important to know when not to fracture valves. Know which valves can and cannot be cracked. And I've mentioned earlier that the Hancock 2 and the Avalus are the two ones that cannot be cracked. You should have a CT, a comprehensive CT analysis, know what the valve to coronary distance is for both the left and right. If that's small or if the sinuses are small, consider a basilica procedure or coronary protection. Check the size of the sinotubular junction and the outflow tract and ensure that that anatomy can accommodate the balloon that you're going to use to perform the fracture. But do remember that smaller balloons can be used, but are less likely to achieve a good result. And for me, a contraindication to fracture is if the patient's had a prior root repair or replacement, because there's a much higher risk of root injury or rupture. One paper looked at complications in 74 cases. There were 7 complications, 2 cerebral emboli, so I think you should have a very low threshold for cerebral protection. 1 acute VSD. There were 3 cases of valve damage. 2 of those were severe aortic regurgitation of the TAVI valve, and 1 was severe aortic regurgitation of the bioprosthetic valve, similar to what I showed you earlier. And interesting, there was 1 failed anterior mitral valve leaflet, which I suspect was entrapment of the wire in the anterior mitral valve leaflet structure, and that was treated with a mitral clip. There are theoretical concerns, which I must say I haven't seen: annular rupture, coronary obstruction, conduction abnormalities, and valve migration. So in conclusion, small surgical prostheses are associated with patient prosthesis mismatch and a higher mortality. Valve fracture or remodeling is associated with lower gradients and a larger effective orifice area. And valve fracture or remodeling after valve and valve deployment seems to be associated with the best outcomes. And if you are going to do it, use a high pressure balloon 2 to 3 millimeters larger than the true internal diameter of the implanted prosthetic valve. And I find using an Atlas Gold balloon is preferable because you can go to much higher pressure. Thank you very much.
Thank you, Simon. That was a very comprehensive presentation of the fracture, where we stand today. I was wondering if we have pre-decided to go for fracture in one TAVI in TAVI, is it important the height of the valve? Usually we go very high when we are valve in valve with all valves, essentially, both SAPI and Evolut. But if we're going to fracture, is that so important? Because when we do post-dilatation, we may have some foreshortening of our frame, and if we're too high, it may actually jump above the valve. So I was wondering, is this a point we should pay attention so precisely as before when we're going to do fracture?
I think that's a very good point, and I think it's very rare for it to move. I've not seen it, and although you're quite right, theoretically it will shorten a little bit more. I think it's unlikely because the valve should be constrained within the bioprocessic valve, and is unlikely to move.
Perfect. And one more question for me. What about the calcium? I mean, if you have a calcified annulus and you see that you have extensive calcification surrounding your prosthetic valve there, would that deter you from going to fracture it? And how much of calcium is too much of calcium?
Sure. I mean, I think that's a good point, and I should have mentioned it. The simple answer is yes, it would deter me, and I'd be much more reluctant to fracture the valve. I think what I would do in that case is I would implant the valve and measure the hemodynamics carefully, have perhaps a transthoracic echo as well, and just check and make sure that you really have to do something about it. But thankfully, it's actually not that common, because usually if the surgeon has done his job well, he would have removed the previous aortic valve and the extensive calcification, and it doesn't seem to be an issue.
Right. And finally, anticoagulation. Do you treat these patients the usual way? Because usually when we do valve in valve, we need a course of anticoagulation or anticoagulant. So do you withhold this anticoagulation for the first few days after you fracture, just to prevent any intramuscular hemorrhages or aortic root hemorrhages from small tears?
I must say I don't. I've not seen late problems. I've seen one case of late rupture, which was several days later, where the patient presented with an aortic dissection. This was not in the setting of valve fracture. But usually if you're going to have an annular rupture or problem, it happens at the time of the procedure. So I must say we don't change our practice, and we will, if the patient has an indication for anticoagulation, we will start it usually the following day.
Great, thank you very much. I don't know if one of...
Can I just have a quick quick question? Okay.
Sure.
Prof. Redwood, hi, thanks very much for your experience. My name is George Lachios. I work in Hippocrates in Athens. Just a quick and practical question. You've talked about prolonged inflation, which is obvious in order to crack, because we used to do all our TAVIs under conscious sedation and not general anesthesia. When you mean long in terms of seconds, what estimate would you give? Like 30 seconds, 45-second inflation? And if these patients tolerate this prolonged inflation without...
No, that's a very good question. And certainly the first few ones we did, they were very long inflations. They were probably up to a minute. But once you get good at it, you can do it a lot quicker. And what is worth doing, I showed you the setup. It's very well worth practicing that outside the body several times. And you can get very quick at doing it. But it is clunky. You have to inject the syringe as quickly as possible, turn the tap, and screw as quickly as you can to try and get the pressure up. And if you haven't injected enough contrast with the 50 ml syringe, it will take a long time to get the pressure up to 15, 16 atmospheres. But after a while, once you practice it a few times, it can be very quick.
I think it also has to do with the balloon you're using. If you use the true balloon, and the reaction of the true balloon to inflation is much quicker. But if you use the Atlas balloon, this is a very stiff balloon, and it really takes longer. I haven't used the true balloon. We don't have it in Greece. If you have experience on true balloon.
We used to use the true balloon, and I've stopped using it because I just found the results weren't as good, and I found the success of fracturing it was less because the rated burst pressure is much less than the Atlas Gold. But I accept exactly what you say. It is much quicker to inflate, but you can't go up as high.
That's a very good information for us to know, because I think True Balloon is coming to Greece soon. And with this, I want to thank all the contributors in this session. And thank you for being with us. And I hope all of us will learn a few new things. That's the aim of this online meeting. And thank you for being with us. And we're moving
Thank you very much.
to the next session.
Colleagues, my name is Dimitrios Alexopoulos, and on behalf of my co-chairman, Dr. Thanos Pipilis, we will welcome you to this very interesting session on TAVI durability and thrombosis. I'm very honored to introduce the next speaker, who is Professor Ran Kornowski. Professor Kornowski is from Rabin Medical Center in Israel, but he is very well known for decades for his innovative work in all over the spectrum of interventional cardiology. And in this session, we will be very happy to hear his introduction regarding surgical and TAVI valve durability. What do we know and what is still missing? Professor Kornowski.
Thank you very much for the introduction and for the opportunity to speak at your valvular summit. The topic is dealing with a major clinical issue, which is the long-term durability of TAVR and SAVR. And I have no conflict to report on this topic. So this is the topic, and I would start with few introduction notes by saying that over 200 surgical aortic valve replacements and over 250,000 transcatheter aortic valve replacements are performed yearly worldwide. A strong trend has been noticed over the last 20 years towards a considerable increase in the use of aortic bioprosthesis relative to mechanical prosthesis. And bioprosthesis are known to be prone to structural valve degeneration or deterioration. The acronym is SVD over time. And a significant challenge when comparing the durability of different type of surgical bioprosthesis has been the lack of a standardized terminology for the definition of degeneration or dysfunctional valve. And as I'm going to show you soon, in earlier TAVR versus surgical randomized trials, at least up to 5 years of follow-up in patients at high or intermediate risk profile, including either the balloon expandable or the self-expandable valve, there was no indication for late clinical valve-related catch-up in terms of valve degeneration or valve failure with the new generation of TAVR valves. And this would be a major focus during the course of my talk. These are two examples taken from a JACC paper a few years ago of a bioprosthetic valve degeneration. What you see here on the left side is a porcine valve with bulky calcification nodules on the leaflets and the valve surface, leading to severe aortic stenosis. And on the right side is a bioprosthetic pericardial valve with excessive panus outgrowth and fibrotic tissue reaction, causing again valve stenosis. And the same patterns can be seen also in transcatheter valves, and it could be a mixture of valve stenosis, valve regurgitation, or both pathologies altogether. So if we look at the surgical literature, we see that over time, over the course of 10, 15, and even 20 years, a structural valve deterioration has been estimated up to 15% with a lot of variabilities. Some of the series would quote 5%, 7%, 10 or 15%. And also the incidence is progressively increased over time. What is also very striking, if you look at these two studies, these are two studies that looked at valve durability over 20 years. And you see here the 20 years freedom from valve failure has been 37% here and 67% in this one. So how can we bridge these two figures, which seems to be very, very different? And the answer is that whenever echocardiographic assessment was taken into account, obviously the rate of valve degeneration, of valve deterioration was much higher compared to a surgical cohort when only reintervention or redo surgery was the only endpoints that was taken into consideration. So it was very clear from this table that there is a lot of variability in terms of endpoint definition. And this is also from a very important study that was published 2 years ago in JAMA Cardiology. This is perhaps the largest analysis which encompassed 167 studies and 12 FDA reports, which include some 100,000 patients using 17 different valve types. The mean follow-up was up to 14 years, and some reports went up to 30 years, and 37% of patients remaining at risk at maximal follow-up. What you can see, again, the great amount of variability, which is, this is a 10 years actual freedom from structural valve deterioration. This is the mean age of the patient. And you see the overall, most of the dots are around 85%, 88%, but there are outliers. Outliers that means that higher rate would be seen with some valves, including patients that were treated or operated at younger age, and some of the reports would even quote much higher valve durability. So it was very clear that historically, most surgical studies have associated structural valve deterioration with the need for reoperation only, but did not provide any specific echo or Doppler-derived criteria or standardized clinical definition to uniformly outline structural valve deterioration rates. Given that reoperation does not necessarily imply structural valve deterioration and vice versa, one would expect a systematic underestimation of the true incidence of structural valve deterioration if it is solely defined on the basis of reoperation. This is especially true in elderly patients with structural valve deterioration who often are refused redo surgery because of their high or prohibitive surgical risk profile. So a systematic assessment of prosthetic valve morphology and function by echocardiography, Doppler assessment, and adjunctive imaging also, such as MSCT and cardiac MRI, may more accurately portray the real prevalence of structural valve deterioration. So keeping this in mind, this is very important to acknowledge that recently standardized definitions have been developed focusing on prosthesis centers and patient-centered outcome using serial echocardiography and longitudinal follow-up assessment to report valve durability accurately and accounting for the competing risks. This was the EA PCI, ESC, EA CTS documents, and more recently, the VARC-3 document that I would highlight in detail. So it started by the consensus document that was published at the European Heart Journal in 2017 by Capodanno and peers. And these are the 4 categories that were the foundation for the VARC-3. This is a bioprosthesis valve dysfunction category. On the left, you have the structural valve deterioration, which is including the intrinsic permanent change of the prosthetic valve, which is either calcification, leaflet fibrosis, tear or flail, leading to degeneration or hemodynamic dysfunction. We have the non-structural valve deterioration, which include any abnormality not intrinsic to the bioprosthetic valve itself. It could be intra or paraprosthetic regurgitation, prosthesis malpositioning, patient prosthetic mismatch, late embolization, leading to degeneration or dysfunction. And we have the issue of thrombosis or endocarditis. And also the definition would include echocardiographic assessment over the course of time with normal functioning of the valve, structural valve deterioration with moderate or severe hemodynamic dysfunction, suspected thrombosis that could be subclinical or clinical, and suspected or confirmed diagnosis of endocarditis. The next important document was a consensus document that was published by Danny Dvir and colleagues a year later in Circulation. And here there were the definition or the new definition of structural valve deterioration, which would include stage 0 when there is no significant change in the valve function, stage 1, which is morphological leaflet abnormality without significant hemodynamic changes, stage 2 SOR, which refers to stenosis or regurgitation, which is moderate stenosis or moderate regurgitation, or a mixture of both, which is RS, and stage 3, which is the severe stenosis or severe regurgitation. So these documents set up the stage for the VARC-3 definition, which are very important. This would become the common language and the common standard for all the studies that would be planned and conducted over the next few years. This is a scheme, and we have to dive into this document. So the type of bioprosthetic valve dysfunction was mentioned before in the Capodanno document. You see here the definition of structural valve deterioration. Again, extrinsic permanent change to the prosthetic valve, which include wear and tear, leaflet disruption, flail leaflet, leaflet fibrosis or calcification, strut fracture or deformation. We have the non-structural valve dysfunction, which is any abnormality not intrinsic to the prosthesis valve resulting in valve dysfunction. This could be paravalvular regurgitation, the patient prosthetic mismatch, or other causes. We have also the thrombosis and the endocarditis. The next tier would be the hemodynamics changes. Again, as was mentioned, stage 1, stage 2, and stage 3. I think it would be, again, very important to zoom into the stage 1, which is a morphological valve deterioration, intrinsic permanent changes to the prosthesis valve, which include leaflet tear, disruption, flay leaflet, leaflet fibrosis, or calcification without significant hemodynamic change. But stage 2 is also morphological valve deterioration and increase in the mean transvalvular gradient of at least 10 millimeter mercury, resulting in a mean gradient of at least 20 millimeter mercury, or new occurrence of increase of at least 1 grade of transvalvular aortic regurgitation, resulting in moderate transvalvular AR. And the stage 3 would be the severe hemodynamic valve deterioration, which is a morphological valve deterioration with increase in the mean transvalvular gradient of at least 20, leading to a mean gradient of at least 30, with severe increase of at least 2 grades, causing severe aortic regurgitation, and this would be defined as severe hemodynamic valve dysfunction. But this is not the end of the definition. We also have to look at the clinical consequences, which again stratified into stage 1, stage 2, and stage 3. Stage 1 is any bioprosthetic valve deterioration with clinically expressive criteria such as new onset symptoms, left ventricular dilatation or hypertrophy, dysfunction or pulmonary hypertension, or irreversible stage 3 hemodynamical valve deterioration. Stage 2 would be aortic valve reintervention, which could be either surgical or transcatheter reintervention in the valve, and stage 3 would be valve-related death. Using these criteria, the investigator of Partner 2 compared the 5 years incidence of structural valve deterioration using the valve 3 that was implied, that was used in order to define structural valve deterioration in failure among the patients that were included in the randomized Partner 2A trial. I would like to remind that these patients were at moderate or intermediate risk, and also the cohort of patients that was part of this study is using the SAPIEN 3 that was later on compared to the surgical arm of the randomized Partner 2A trial. And if we look at the 5-year results that were adjudicated using echocardiographic assessment and core laboratory, what we see here that after 5 years, the rate of structural valve deterioration using the SAPIEN XT was 9.5%. Using the SAPIEN 3, the new generation or the later generation of SAPIEN, it was only 3.9%. And the surgical arm, the structural valve deterioration was 3.5%. There was a significant difference in favor of surgery when compared to SAPIEN XT, but there was no significant difference in terms of the comparison between SAPIEN 3 and the surgical arm. We see in the same paper that was published last year in JACC that the definition of structural valve dysfunction or deterioration related or causing bioprosthetic valve failure was even lower. You see here, this is the BVF for the SAPIEN XT, which was 3.7%. For SAPIEN 3, it was 1.1%, and for the surgical arm, it was 0.8%. I would like to remind that the definition of bioprosthetic valve failure was either reintervention or death related to valve dysfunction or severe stage 3 structural valve deterioration related or causing hemodynamic valve dysfunction. If we look at the all-cause of bioprosthetic valve failure, which is the integration of bioprosthetic valve failure and non-structural valve dysfunction, the rate was 4.7% to Sapien XT, 2.6% for Sapien 3, and 1.3% for surgery, which was lower numerically, but no significant difference between Sapien 3 and surgery. A significant difference remained between Sapien XT and surgery. In terms of the matched cohort of hemodynamics, you see here in terms of the pre-evaluation of the mean gradient, which was around 45 millimeter mercury over a course of 1, 3, and 5 years. There was no significant change between TAVR and SAVR. And if we make the calculation of the rate of bioprosthetic valve deterioration or failure, rate per 100 exposure per year, you see here the TAVR would be 0.63. This is mainly the S3 analysis versus surgery. There was no significant difference. And also in terms of the rate of bioprosthetic valve failure, 0.63 for TAVR versus 0.37, no significant difference, numerically different, but no significant difference. But again, this was mainly the Sapien 3. If we look at the mode of deterioration, it is very interesting to note that among patients who underwent surgery, the dominant mode of deterioration was endocarditis. For Sapien XT, it was certainly structural valve deterioration. But for Sapien 3, it was mostly an issue with paravalvular aortic regurgitation that was the reason in few patients, although it was the reason for undergoing or redo or defining the case as structural valve deterioration or structural valve failure. If we look at partner 3, this is the low-risk patient. We have only 2 years follow-up, and we see that the rate per 100 exposure years for stage 2 or 3 hemodynamic valve deterioration was 1.45 for TAVR, 0.71 for surgery, not significantly different. And in terms of bioprosthetic valve failure, it was 0.41 for TAVR, 0.59 for surgery, no significant difference whatsoever. So the interim conclusion from the partner data is that there is no evidence of important clinical catch-up favoring surgery through 5 years follow-up with the Sapien 3 TAVR. This was not the case with Sapien XT. Using standardized definition and serial echo, there is also no evidence of increased structural valve deterioration or bioprosthetic valve failure associated with Sapien 3 TAVR compared to surgery, the 5 years intermediate risk and the 2 years low risk data. Nevertheless, late, more than 10 years or 10 years or more follow-up data is not available, and even mild midterm, up to 2 years follow-up in low-risk patients is very limited. So it will require at least another 5 years follow-up to have sufficient data to make meaningful interferences regarding long-term Sapien 3 durability, and this will be very important, especially when TAVR, the age of TAVR patient is becoming younger and younger. So we need these longer-term data about durability and structural valve deterioration and failure. What about CoreValve? We have by now the 5 years outcome of the CoreValve data among high-risk patients. You see the hemodynamics are very favorable for the valve up to 5 years. But what about the definition of structural valve deterioration or structural valve failure? What you see from this publication, from the CoreValve investigator group, let's look at severe hemodynamic structural valve deterioration after 5 years. So patient with a mean gradient of more than 40, 0.3%, very low for TAVR, 1.1% for the SAVR group. changes in mean gradient from discharge at 1 month, more than 20 millimeter mercury, increase very low for both groups, and severe central aortic regurgitation. This would not taken into account the paravalvular leak, so new from discharge, again, very, very low. If we look to the less stringent criteria of moderate hemodynamic deterioration, we see higher rate, but mainly for surgery, because in this study, a significant proportion of surgical patients had excessive or higher surgical, higher valvular or transvalvular gradients. So I would not take this number as an indicator for very high failure rate among the surgical group. I think these numbers are more indicative among the core valve patient. In Israel, we have conducted our own survey and study looking at 450 consecutive Israeli patients who underwent TAVR and survived at least 5 years. We had 184 of these patients, and we look at all these patients with repeat echo assessment and using the VARC 2 criteria for structural valve deterioration. We published this 2 years ago at American Journal of Cardiology. We found structural valve deterioration in 12.3%. Of these, 16, which is 8.9%, experienced structural valve deterioration, and only 3.3% experienced bioprosthetic valve failure. And also what we saw that bioprosthetic valve dysfunction occurred more frequently in patients with small valve, 23 millimeter or less, and high peak or mean transvalvular gradient at baseline. This table is taken from a paper that tried to synthesize the overall data that exists about the rate of structural valve deterioration. You see that the overall estimate has been 5 to 7% after 5 years, but using mostly third generation valve. And another paper published at Eurointervention by Capodano about 2 years ago, again, indicates structural valve deterioration of 1.3%. This is a low rate with the confidence interval that's shown here, and bioprosthetic valve failure of 3.7% in a period of follow-up period that range between 6 to 8%. We have also to remember that in case of non-infected and non-thrombotic bioprosthetic valve failure in TAVR, there is now the option of TAVR in TAVR. This is from Uri Landes and a group of investigators that showed that overall we can perform TAVR in TAVR very safely. The success rate is very high. The mortality at 1 month is only 1.4%, and the conclusion from this study that in patients with late valve dysfunction after TAVR, redo TAVR is associated with significant improvement in valve function and symptom and relatively low incidence of procedural complication and reassuring survival at 30 days and 1 year. And the results of TAVR in TAVR, this is another publication by Uri Landes that was appeared very recently in JACC, showed that the results of TAVR in TAVR are similar to those of TAVR in SAVR. The 1 year mortality rate or the survival rate is very similar, but the range of complication is somewhat different, with some differences depicted here that I would not go into detail for the sake of time. So we have also to remember that the option of performing surgery with TAVR explant is also available, but certainly associated with much higher risk. The 30 days mortality is almost 50%, and the 1 year mortality among explanted and redo surgical patients after TAVR failure is around 23, 25%. So this is still an option. Now, the key question, what would be the impact of age on aortic stenosis? what is the appropriate therapy sequences according to what we know nowadays and according to the limited durability data that exists up to 5 years, 7 years, but certainly not good data up to 10 or 15 years. So these are three scenarios. This is a patient of 80 plus years old, 65 years old, or 50 years old. A key factor in clinical decision-making is the ratio of life expectancy to the non-valve durability. So in a 65-year-old, the average dual life expectancy is around 20 years. So age is often used as a surrogate for life expectancy. Now, if we look at these two scenarios, on the left, we have a 65-year-old patient, and on the right, we have an 80-year-old patient. Both have to undergo aortic valve replacement due to severe aortic stenosis. On the red, you have the life expectancy graph for the patient who is 65. On the right, you have the life expectancy graph of the patient who is 80 years old. But you have here the life expectancy of the bioprosthetic valve, whether surgical valve or TAVR valve, which is here depicted in the yellow graph. So what would be the appropriate strategy in terms of valve replacement in these 65-year-old, taking into account at least 20 years of life expectancy, and the 80 years old here, the patient with a life expectancy of 7 and 8 years. So the sequencing is very, very challenging, and we don't have all the answer. I think that the clinical issue is the goals are to limit the number of open surgical procedures and respect the patient preferences. So the strategy could be a TAVR first strategy, which is very different. For a patient who is 80 or more, TAVR is for sure the best option. For a patient with 65, should it be TAVR first and then SAVR, or redo TAVR? And the patient who is 50 years old, should it be SAVR first or TAVR first and then SAVR and then TAVR? Also, we don't have all the answer right now, and we'll have to see over the next years. It will take 5 or 10 years for sure to get some of these answers. So in conclusions, ladies and gentlemen, valve durability remains an important clinical issue. While midterm 5 years follow-up studies demonstrate favorable outcome, the long-term durability of TAVR remains to be explored. Durability is particularly important in younger patients who are expected to outlive their TAVR prosthesis. TAVR valve deteriorate by similar mechanism as surgical bioprosthesis, and so far, up to 5 years, there is no evidence of important clinical advantage favoring surgical valve durability up to 5 years follow-up with SAPIEN 3 or the new generation of CoValve TAVRs. So I would like to thank you very much. I hope my lecture was clear, and I don't know if we have some time for questions. Thank you a lot.
Thank you very much, Professor Karnowski. It was a great lecture. You delineated all the problems that we have with the durability of the bioprosthetic valves and the dilemmas that we have. So I think it's quite clear that we do have strong data for the 5-year valve function, at least for the core valve and the SAPIEN valves, the older and more well-studied. I really enjoyed your final conclusion that we have to take very seriously into account the age of the patient when we decide what procedure we'll perform. And my minor question is, by having data only for SAPIEN and core valve, in your practice, is the absence of data regarding other valves like the accuracy, the portico, are factors that influence you and your selection? I mean, the lack of data on the durability of the newer valves, how it influences you in your practice?
Yeah, we don't have long-term data for the Accurate Neo, especially Accurate Neo 2, which was launched last year. We use it quite a lot nowadays. We don't use Portico, but it's very clear that every valve will have to go through a very rigorous assessment of long-term durability, such as are performed already very meticulously by the partner group, the core valve group. There would be no waivers for every valve to be followed at least for 5 years. And if the aim or the goal would be to offer these valves to younger patients at lower age, we need more than 5 years, for sure at least 10 years. So it's a process and it's a moving target, and we'll have to be patient about that.
And I think, as you clearly said in the first part of your talk, it is very important to use strict criteria and standard criteria to make any comparisons between several valves.
Yeah, VARC 3 now is the gold standard for everybody.
Okay, thank you very much indeed. Thank you.
Before we go on to the next speaker, can I ask also a question? Dr. Konowski, by the time the 10-year follow-up will be available, will it be clinically relevant? Because at that time, there will be new generation of TAVI valves. So how do we take that into consideration?
It's a great question, but we have to base our assessment on the available data. We cannot, if we're going to have good 10 years data for TAVR, I think it would be sufficient, because we are going to assume that the newer generation are at least as good as the older generation. If we're going to have problems with 10 years data, we'll have to rethink about what we do.
Okay, thank you very much.
Thank you again.
So we will move now to the next speaker. It's a pre-recorded presentation. It's from Professor Lars Sondergaard, who is from Denmark, and he will enlighten us on surgical and TAVI valve thrombosis. What do we know and what is still missing? The subclinical and the valve thrombosis is a very important thing, and we can take the discussion after also Dr. Danga's presentation, since Dr. Sondergaard will not be available.
Thank you for the invitation to give this talk on surgical and transcatheter heart valve thrombosis. What do we know and what is still missing? So first of all, we need to understand what we mean about valve thrombosis. And as I see it, there's two kinds. There's clinical valve thrombosis, where the patient have an elevated gradient across the valve prosthesis and often followed by symptoms. And for these patients, you need to treat it. Then we have what we call subclinical leaflet thrombosis, where the gradient is within the normal range and the patient have no symptoms. And I would say, for these patients, leave it. So let's start with an example of a patient with a clinical valve thrombosis. This was an 84-year-old female who had a history of leukemia and also diabetes. She had a TAVI procedure done 6 years ago using the first generation core valve prosthesis. At the time of the procedure, she was in sinus rhythm and therefore discharged on aspirin as the only antithrombotic therapy. She came back because of increasing symptoms during the last couple of months. She was now in function class 3 and she was in sinus rhythm. On the transthoracic echo, it was clear that she had an elevated gradient across the transcatheter heart valve, a max gradient of 61 and a mean gradient of 37 mm mercury. There was a mild central aortic regurgitation, the ejection fraction was normal, and there was only a mild mitral regurgitation. So in order to try to have a closer look at this valve prosthesis, she underwent a transesophageal echocardiography. And as you see, there's some thickening with inside the stent frame. You can see a turbulence outflow and also some kind of regurgitation. But again, it was difficult to actually understand what was causing these hemodynamic impairments. Therefore, we did an intracardiac echocardiography. And you can see this ICE probe is introduced from the femoral artery, is around the aortic arch, and the probe is sitting in the ascending aorta, looking inside the stent frame of this core valve prosthesis. And what was clear from this ICE procedure that there was a thrombus formation on one of the leaflets, and also one leaflet didn't move at all. And this was causing this high gradient and also some aortic regurgitation. So this patient is what we would call a clinical valve thrombosis with a high gradient and symptoms. There's been at least 2 reports in the literature about this clinical valve thrombosis. One finding that it occurred in around 0.6% of the patient undergoing TAVI, and the other one in 2.8% of the patients. Both studies find that it actually occurred at a mean of time of around 6 months after the procedure, but it could also start within the first couple of weeks after the procedure. And although some of these patients in the beginning underwent a revalving, it's now well known that this clinical valve thrombosis can be treated by putting the patient on oral anticoagulation, either with a vitamin K antagonist or with DOAC. And as you see here, this graph from Latif's paper, post-TAVI, the patient had a mean gradient of 10 millimeter mercury. Coming back with a valve thrombosis, the mean gradient was now around 40 millimeter mercury. And after about 1 month of anticoagulation, it was close to normal. So again, this is quite clear that these patients with clinical valve thrombosis need to be put on oral anticoagulation, and that's going to resolve the problem. The question is more, how long should you continue oral anticoagulation for these patients? And I would say it seems to be fair to give it maybe 3 months, then stop it, monitoring the patient very closely, and if it's going to reoccur, consider to put the patient on lifelong oral anticoagulation. So moving from clinical valve thrombosis to subclinical leaflet thrombosis, which is a completely different phenomenon. This was actually first discovered in the Portico IDE study in the US. FDA asked for a CT scan, not to look for the leaflets, but to look for any signs of stent fractures. And some of these sites applied these very advanced 4D CT scan on the patient, and this was actually the first patient where it was recognized. If you can look inside, you can see 2 of the leaflets look like as they are not moving. There was a lot of discussion in the beginning, is this an artifact or is it just a true finding? And we now know it's a true finding. These leaflets are not moving, and it's actually caused by a thin layer of thrombosis on the aortic sides of the leaflets. And again, despite you see here, 2 leaflets are not moving, the patient have almost a normal gradient across the valve and without any symptoms. In the beginning, it was considered that this was a finding only for the Portico valve, but we have seen now several studies showing that it can occur, or it does occur, in all kinds of bioprosthetic aortic valves, both transcatheter and surgical valves. And also we know that if the patient is committed on oral anticoagulation, again either vitamin K antagonist or DOAC, it's going to resolve. And this is what most sites in the beginning did when they found this phenomenon, starting oral anticoagulation for these patients. There's also been discussion what is actually causing it, and there can be several factors. I think one of the main factors for this phenomenon is that your stent frame is underexpanded. So as you see here at this graph on the right hand side, you see a nicely expanded stent frame. The leaflets have equal size, and that have a very low incidence of subclinical leaflet thrombosis. But if the stent frame is underexpanded or constrained, 1 or maybe 2 of the leaflets will not unfold completely, and that is going to increase the risk of subclinical leaflet thrombosis. And this also explains, at least partly, why this phenomenon is seen more frequently with the Portico valve, because in that valve you have the leaflets in an interannular position, whereas you with the evolute valve have the leaflets in a supraannular leaflet position. So if the leaflets are at a supraannular position, even though the stent frame is constrained at the annulus level, where the leaflets are positioned, the stent frame is often circular, and that's why you see a lower rate of subclinical leaflet thrombosis in these valves. And also this study very nice to show that if you do post-dilatation after valve implantation, the risk of having subclinical leaflet thrombosis is lower. Of course, because you have a less constrainment of your stent frame. And despite you have one, or in some of these cases, two leaflets not moving normal, the gradient for these valves are normal, or almost normal. You see here in this large study from LA and from Copenhagen that patients who have no subclinical leaflet thrombosis have a mean gradient of 10 mm mercury compared to 13 mm mercury for patients with subclinical leaflet thrombosis. So even though it's a few millimeter increased or elevated, it's still within the normal range. It's not something you're going to pick up on your transthoracic echo when the patient is coming back for follow-up. Also in the beginning, there was a lot of concern whether this finding would impact the outcome for the patient. Particularly, would it going to increase the patient's risk to have a stroke and a TIA? And again, as this registry study from LA and from Copenhagen, there was a signal that at least for the TIA seems to be more frequent in patients with subclinical leaflet thrombosis compared to patients with normal leaflet motion. But one important thing you have to consider here is that there was a temporal separation between the event, the TIA, and the time of the CT scan. And for some of these patients, there was more than 1 year between the TIA and the CT scan. And as I'm going to show you in a minute, this subclinical leaflet thrombosis is a dynamic phenomenon. So even though you find that the leaflets are not moving normal at the time of the CT scan, you have no idea what the status of that leaflet was 1 year earlier. And of course, this has also raised discussion, what is the best antithrombotic therapy after a TAVI procedure? We have seen the Galileo trial presented recently. It was a quite large-scale trial, around 1,500 patients randomized between a low dose of DOAC plus aspirin for 3 months, followed a low dose of DOAC lifetime, compared to what was conventional treatment that time, DAPT for 3 months, followed by aspirin for life. And before we come back to the finding of the main study, there was also a sub-study. And that sub-study was called Galileo 4D. And what it actually did was it took the patient at 3 months and they underwent a 4D CT scan to look for subclinical leaflet thrombosis. And as you can see here, patient who was on DOAC had a much lower rate of subclinical leaflet thrombosis compared to patient who was only on antiplatelet therapy. And this figure here shows patient with intention to treat, but if you look as treated, there was none of the patient who was actually on DOAC who had subclinical leaflet thrombosis at 3 months. So again, this could be an argument for putting these patients on oral anticoagulation. But going back to the main study, the main Galileo trial, we all know that the patient we treat today, these are elderly, comorbidity, frail patients, have a much higher bleeding risk. And as we saw in the Galileo main study, if the patient is on DOAC, there is an increased risk of mortality. So again, despite you have a lower rate of subclinical leaflet thrombosis on patient on DOAC, it's going to cause a higher rate of all-cause mortality. And again, remember, it seems that subclinical leaflet thrombosis have no clinical impact on the patient. The gradient is almost normal. There's no risk of thromboembolic events. Another argument for not putting these patients on oral anticoagulation is that the natural history of this phenomenon seems to be very dynamic. So what we did very early on in Copenhagen was that we took the patient and they underwent 2 CT scans with 3 months in between. And no matter what we found on the first CT scan, we did not change the antithrombotic therapy. And as you see in the green boxes, those 9 patients, the phenomenon actually resolved between the first and the second scan. On the other hand, in the red boxes, you see 13 patients where it actually progressed between the first and the second scan. So here again, it seems to be a dynamic phenomenon. It can resolve and it can progress spontaneously. And these findings we did here early on was actually confirmed in the 2 low-risk trials. So both in the partner 3 and the Evolut low risk, the patient underwent a CT scan at 30 days and at 1 year. And as you can see, both for the patient undergoing TAVI and the patient undergoing surgical aortic valve replacement, some of the patients had subclinical leaflet thrombosis at the first scan. And for these patients, you can see some of it resolved spontaneously without changing the antithrombotic therapy. And also for the patient who have no subclinical leaflet thrombosis at the first scan, some of these patients actually had that finding of phenomenon at the second scan at 1 year. So what is needed now to have a better understanding of this subclinical leaflet thrombosis? We need to understand the natural history and the potential impact of this phenomenon, and also whether the patient will actually benefit for a short term of DOAC early on to wait for the valve to be endothelialized and then just going to an aspirin. Is that going to change this occurrence of this phenomenon? So we're running now in Denmark this Notion 4 trial. Patient in sinus rhythm is going to be randomized between aspirin from day 1 or DOAC for the first 3 months, followed by aspirin as a monotherapy. Patient in atrial fibrillation will be randomized between DOAC from day 1 or only DOAC for 3 months and then followed undergoing a left atrial appendage closure and then aspirin. And what we're going to do is that we're going to do a 4D CT scan at 3 months, 1 year, 2 years, 3 years, 4 years, 5 years to look at this dynamic phenomenon and also whether it's going to cause any risk of thromboembolic events, because if the patient will face a thromboembolic event, a stroke, TIA, a systemic embolism, the patient will undergo an additional CT scan to look at the status of the CT scan, of the leaflets. So I think it's fair to conclude that for subclinical leaflet thrombosis, the consensus today is there's no indication for routinely CT scan to look for this phenomenon. And the clinical impact of subclinical leaflet thrombosis is unknown. And there's no indication to start oral anticoagulation in case of finding subclinical leaflet thrombosis. First of all, it's going to increase the risk of mortality, and also it may resolve spontaneously. So again, here just to conclude, for bioprosthetic valve thrombosis, divided into 2 groups: patient with clinical valve thrombosis, elevated graded and often symptoms, treated with oral anticoagulation and is going to resolve. Patient with subclinical leaflet thrombosis, that's almost a normal gradient, there's no symptoms, leave it and don't even look for it outside clinical studies. Thank you.
I think that was a very nice presentation. It's a pity we don't have Professor Zondergaard with us, but he explained very well the difference between the clinical and subclinical thrombosis, and it's an evolving field, and that fits nicely with the next speaker, Dr. Alexopoulos will present, because it's relevant to the thrombotic events after TAVI.
Okay, our next speaker is Professor George Dangas. The talk is pre-recorded, but Professor Dangas is with us, so we will have the opportunity at the end of his talk to discuss both the lectures.
Ευχαριστώ πολύ το Προεδρείο για την εισαγωγή. Χαιρετισμούς από τη Νέα Υόρκη. Ευελπιστούμε στην Αθήνα το 2022 και θερμά συγχαρητήρια για το συνεδριό σας μια ακόμα χρονιά. Το θέμα αυτό το οποίο θα πραγματευτούμε είναι ιδιαίτερα ενδιαφέρον. And let me change in English for our English faculty and panelists. We know that thromboembolic episodes after transcatheter heart valve, particularly aortic valve, are affected by the long-term risk of the patients as well as accentuated by the periprocedural period regarding the valve implantation techniques, also related with the technologies, and obviously with the periprocedural atrial fibrillation should it exist. The valve thrombosis is an interesting and attractive phenomenon. Nobody wants a thrombus in their valve. It's related to a complex interplay of surface, hemodynamic, and hemostatic factors. And let me be very clear. The fact that we studied in transcatheter heart valves, it doesn't mean it only exists in those. There is a lot of data, not as many though. Not as many studies are done in surgery in general, but you can see that the surgical bioprosthesis, they thrombose and they degenerate. And as you can see on the graph on the left, thrombosis precedes the evolution to degeneration. This is a time-related phenomenon, but is it the same? We don't know. Perhaps it is. Perhaps starts as a clot and then organizes and degenerates, or perhaps not. This is to be determined. More importantly, TAVI studies, as well as SAVR studies, as part of the large randomized trials. You can see here one of them, but there's another one almost identical, that didn't change medications and evaluated this phenomenon by 2 sequential CTAs at 30 days and at 1 year. This imaging finding, I should say, fluctuates over the time, regardless of what happens with the medical therapy. Patients who have it at 30 days, well, some of them have it at 1 year, and patients who don't have it at 30 days may develop it at 1 year. And by 1 year, both surgical and transcatheter prostheses have just about the same rates of clots. Microclots, I should say, around their valve. The relationship of these things with ischemic events in the brain or elsewhere, it's really not very well documented in the initial areas. It doesn't really concern us. The guidelines reflect the fact that we have a consensus documentation, not really based on large clinical trials because they really don't exist. So in general, we have a combination at a level 2, except in those who have an other indication for oral anticoagulation, or if of course we have a metallic heart valve, which is really not the subject of this talk. So everything else, as you see, is a class 2 indication. Let's go study now patients with a no underlying oral anticoagulation in order to systematize a little bit the talk, otherwise things can get very confusing. In an initial study of ours, we hinted that a very common practice of clopidogrel loading may not be as beneficial and in fact may be detrimental. And this is in association with the Dutch investigators and many other European investigators in the Bravo 3 trial. This is a sub-study that we showed that clopidogrel loading is related to more vascular complications in the procedure, during the procedure, 48 hours outcome over here that you see. Randomized trials in this population essentially compared dual antiplatelet therapy, and let me also be very clear, with clopidogrel loading pre-procedure, pretty much. I have here the largest study, the ARDE trial, just 200 patients. Imagine what the others are. The others are under 100. There are a few studies initially from Italy, Professor Russia, and others. Anyhow, the flavor the same. A lot of segregation of events early on, and later on, not much difference. And again, in my view, and in most people's view, this is probably related with loading than anything else. A larger of those trials now emerged a year ago, and this is from the Netherlands primarily, and investigated aspirin alone versus aspirin plus clopidogrel, again with a pre-procedure loading. Let's be very clear about that. It's not a post-TAVI randomization. All right, it's a pre-TAVI randomization. A follow-up at 1 year. And again, it's very clear. Anyone can see that there is some bleeding activity early on, obviously related to the procedure and whatever related events. And later on, not much difference in the bleeding all the way. The lines are very parallel. And in the end of the day, they end to have a 15% versus 25% in the clopidogrel and then associated preoperatively, and you see the difference. Interestingly, the ischemic events trend also similarly, and again, a lot of events early on, most of the events early on. Interestingly, this is a first trial that actually gave a treatment for 3 months, 90 days, so to speak, you can see on the x-axis, and then follow the patients up to 1 year and included a 1-year endpoint. And again, you can see that a very interesting phenomenon that the aspirin group specifically, there was an upward drift of events over time. Is it isolated? Well, maybe it is, but at the same time, that's the only study that did this. So is it a new thing that perhaps we don't see because we don't follow patients that much, or we follow them during the treatment periods at the ARTE trial, and if you follow them later on, maybe the absence of early on inhibition of platelets or other factors may end up producing some events later on. Or maybe it's a play of chance, we don't know, but it's definitely very interesting. In the Galileo trial, we investigated something further. We tried to use a low dose rivaroxaban at 10 milligrams once daily. 15 to 20 milligrams is the dose for the atrial fibrillation, let's remind everyone. So we use a low dose rivaroxaban for 3 months in combination with baby aspirin, followed up everybody for over a year, as you see here. After 90 days, the regimen was rivaroxaban alone. In the control group, there was dual antiplatelet therapy followed by aspirin alone. Unfortunately, these things did not pan out as originally planned or thought, really. Rivaroxaban had more events and more bleeding, particularly because there was a high mortality. And that's interesting. That's overall a non-cardiac mortality. Look at further, we started understanding how difficult maybe it is to conduct trials in this very high age group, and ultimately we showed that about 30% of the people, even more, over time they discontinue the study drug and they don't want to be part of the study. And as we'll see, this is a phenomenon that many other studies now are trying to find when they study these octogenarians plus patients. And interestingly, the larger mortality between the two groups occurred 3 or more months after such patients discontinued the study drug. I think that's fascinating. It's very interesting, shows us what we don't know about these populations, and shows us the way we need to go about conducting and following up these very older patients over time, as opposed to fantasizing maybe about outcomes and treatments that are derived in the 60s age group, such as in most atrial fibrillation or other anticoagulant trials. Regarding the CTA imaging of the valve, the Galileo had a very clear result. So we used a very clear, validated, reduced leaflet motion classification, grade 0 to 4. And no matter how many definitions we tried, and you can see more in the related NEJM paper of last year, we found that the low dose, even low dose of rivaroxaban, was able to suppress this phenomenon. On the other hand, again, let's clarify that this phenomenon was an imaging finding, but did not really correlate with any clinical outcome of any sort in the 1 year of the follow-up or so. So let's move on to trials in patients with an oral anticoagulation indication. And primarily, we talk about last year's results of the POP-TAVI second cohort, again from the Netherlands, patients or oral anticoagulation plus clopidogrel versus anticoagulation alone. Let me clarify and I think this has escaped many people, that in this study, the investigators treated everyone pre-procedure, and most of the procedures were conducted on uninterrupted oral anticoagulation, and obviously the respective group also received a clopidogrel loading pre-procedure. So there was a lot of pre-procedure activity. This is not a successful TAVI following up randomization upon discharge. It's clearly not. The results, a lot of bleeding up front. You can see bleeding rates immediately in the range of 10 and 20%, and a lot of bleeding later on in the addition of clopidogrel, in addition to oral anticoagulation. So in general, it looks like the clopidogrel does not that much. In fact, there also lower MACE without clopidogrel. At the same time, the generalizability of this study is also limited just by the fact that I explained to you before that unlike most of us and around the world, this study pre-treated with oral anticoagulants and oral clopidogrel. Most of the patients, most of us do not follow this practice, so it's not very clear what message we get, but doesn't look good for clopidogrel anyhow. Most recently, we have the Atlantis trial, which I chose to present last because it has a mixed population, included patients with as well stratum 1 versus patients without need for anticoagulation. So everyone was treated with the same active agent, the apixaban, full dose, and there were two control groups. The stratum 1 had vitamin K, warfarin, or similar drugs, and the other one had antiplatelets, single or dual, according to the doctors. We don't have that much details, and again, you see the breakdown of the groups here. Overall, their endpoint included the not only the clinical major adverse cardiac and cerebrovascular events, as you see up top, but also venous thromboembolism and PE, as well as the detection of valve clots by the CTA. So there was a mixed clinical and imaging endpoint with more events in the control groups and less events in apixaban. I shouldn't say events, I would say endpoints, because some of those are not events, they are imaging findings. If you restrict it to the events, the clinical events, somehow apixaban has more events, and 121 events, as you see in the blue line of the control group, and as you see below, this imbalance seems to be a little bit higher in the patients without the need of oral anticoagulation, whereas they're identical in the table. You can see that in the indication for oral anticoagulation, the events are dead even, 49 and 48 in both groups. When the secondary outcomes are outlined, you can see that most of the benefit implied earlier had to do with a valve clot by the CT and also the reduction in the venous thromboembolism and related events at the bottom of this table. When we go to a little bit more clear identification of the two groups, we can see that the need for oral anticoagulation had actually no difference between vitamin K and apixaban, no matter how you cut it. However, those who have no need for oral anticoagulation, it seems like we have a little bit of a repetition of the results we show before with the rivaroxaban in the Galileo trial, with a higher MACE driven by higher mortality, mostly driven by higher non-cardiac mortality, and that's a significant result. At the same time, this study continued to indicate that the findings, again, of Galileo, of the reduction of reduced leaflet motion is also important. And again, this is the methodology of the 4DCD sub-study of the Atlantis, just focusing 100% now on the CT findings. It is larger than Galileo, almost double. About 800 patients, nearly triple, I should say. We had 250 patients in Galileo. And again, you see that in the stratum 1, there was no difference whatsoever with the apixaban versus warfarin. and in the patients with no indication of oral anticoagulation, there were fewer thrombotic, I should say, events, clots identified, 9% versus 16%. That was the percentage. And again, you see different definitions further down. The stricter definition leads to 1 versus 9% of events, of imaging findings. Again, in this study, it verified that these imaging findings don't have much to do with subsequent myocardial infarction, death, stroke, or peripheral embolization, and you can see the related slide here. So again, we see that in a course of about a year, there is no immediate adverse outcome of these valve clots. Of course, all these studies and all this confusion may have something to do with the fact that there is a lot of individualized use of any agent or any combination by many hospitals and many medical centers in the world, and we can discuss that in the discussion period. And finally, one before my conclusion slide, I want to remind you that in European Society of Cardiology 2021, we want to present the final results of the 1,426 patients that we randomized into edoxaban versus warfarin, all in patients with a TAVI and a atrial fibrillation upon discharge after initiating this therapy after successful TAVI. In conclusion, we can see that the incidence of leaflet thrombosis post-TAVR is high, but its clinical indications not well understood. There's no immediate stroke or TIA risk, which everybody feared, but however, remains a question whether there is a significant contribution or not on the limited or shorter, I should say, valve durability. We'll see about that. The clopidogrel before TAVR, particularly the loading dose, has been associated with more bleeding and vascular complications without obvious benefits, and I think this is probably on the go, although there's no such mention in the updated guidelines. In patients without other indication for oral anticoagulation, the updated guidelines have a class 3 based on the rivaroxaban 10 milligrams, and I think most likely there may be an update after the apixaban trial that is also unidirectional. In patients with AFib and oral anticoagulation, the monotherapy seems to be better than the clopidogrel, albeit with a caveat that this was found in the patients who were initiated on both oral anticoagulation and clopidogrel before the procedure, a practice that's not widely applicable. And obviously, I think we continue to study this very, very interesting and important subject for further information and update of our guidelines. Thank you so much for your attention.
Thank you very much, Professor Dangas. Thank you, George. And I think you can hear us. Ευχαριστούμε εμείς, and the two lectures are open for discussion. May I ask you first, following your nice presentation and your original work that you presented, just to give us a simple rule for the patient without atrial fibrillation who undergoes a TAVI, just a single antiplatelet agent or dual antiplatelet for 3 months, but without pretreatment with clopidogrel?
Now, as you said, the last is the best option at this point. No pretreatment, no need for pretreatment with clopidogrel, but we give a 3 to 6 month Plavix treatment in combination with Jasper.
And for the atrial fibrillation patient, I think most agree that anticoagulation alone is enough. I mean, all the studies, while adding antiplatelet, created a problem with bleedings.
No, yeah. If they need anticoagulation, you go with monotherapy, unless the patient has a stent or something. So, which is about 20%, I think. 20% of people will have some stent or other vascular reason, significant vascular reason. Otherwise, just anticoagulation.
Thank you. Thanos, do you have a question?
No, that was the same question. I think that as clinical cardiologists would like to see things simpler, and things in this high-risk group goes that way. If they have atrial fibrillation, just knock. If they don't, perhaps single antiplatelet. That's very nice to be true if it holds on with the next studies. Do you think the following studies will make things more complicated or more easy for the management?
Well, I think this field is very confusing, and every study studies a certain angle, either a certain drug or a certain valve. It's difficult to have a simple answer. All I know that makes life easier already is if anybody is undergoing any kind of procedure, surgery, whatever, all of those treatments can be stopped immediately. They can undergo the procedure and they can be resumed afterwards. So we have this easy decision, which is not the same with a coronary stents and how soon after the stent is a surgery or something. Over here, we don't have that. If there is any of this, even a week after valve, they need whatever surgery, no problem. You can stop the anticoagulation or the antiplatelet or whatever you need to stop, and no problem resuming it a little later.
In the Galileo trial, you tried the 10 milligram of rivaroxaban. If you were to reorganize the trial, would you consider the 2.5 milligram dose like COMPASS?
Yes, in fact, I think it's definitely a good one. I think that the 2.5 would be the better one. I can tell you that the Galileo trial, if you can imagine, it was criticized for using too lower dose. At that point, we're facing the opposite criticism of why there would be no efficacy. It would do nothing at the valve level, because it's less than the 15 to 20 milligrams, which is the regular full anticoagulation dose. And that was the main reason for the sub-study, to actually demonstrate or prove that there would be efficacy even with this low dose at 10 milligram. Interestingly, how the clinical results came about. And of course, in that light, we're not so surprised how the non-anticoagulated part of Atlantis ended up as well.
George, if I may, what is your practice regarding subacute leaflet thrombosis? Are you searching actively for this in your patients, and accordingly you modify antithrombotic treatment, or you're waiting for clinical symptoms? Or...
No, we're not searching actively. We're searching inactively. We're inactive about that. Sometimes we see these elevated gradients, and in those, I order a CT. Most of the time, I have found that that's not a leaflet problem anyhow. Most of the time is related to the acceleration of the blood through the LVOT due to the severe LVH some patients have, and that leads to high velocity by the gradient, what we call a high peak instantaneous gradient without a lot of contribution of stenosis, really. But these cases, the CT clears them for a clot, and I don't even remember a true clot case identified, but so we're not very actively out for it.
So your suggestion would be just follow up with an echocardiogram, and if something goes wrong there, then you suggest the CT?
Yeah, I think if you have a jump of the gradient by over 10 by echo, by interval echo, I think you have to question that, and at least to a CT. Again, most of the time it will be due to the severe LVH and not due to the valve thrombosis, but I think makes everybody feel better about that.
Good.
George, there's a question. Yes. There's a question from Dr. Arabadzis. from the audience, from the faculty actually. What is your opinion on adding clopidogrel to an oral anticoagulant in patients with increased gradients post-procedure when a valve-in-valve procedure is done? So valve-in-valve, increased gradient, and would we go in these particular patients more aggressively?
Yeah, well, I think valve-in-valve patients, first of all, are sicker to begin with. So you're going to have risks for clotting anyhow. But in general, there is a tendency to have a lower threshold to anticoagulate those patients. I'm not sure that I share that, but I understand where it comes from. And I think that if there's a specific scenario by a specific valves with very restricted leaflet, or the leaflets very close to the coronary sign, to the coronary arteries, or the sinuses are in some configuration that's you know, a little restrictive or a little concerning, I would say, I would do it. But I don't want to say that I'm anticoagulating all valve-in-valve cases. I'm not. And I'm not adding clopidogrel either to any of them.
Okay, I think we can conclude at this point. I would like to thank all the speakers for their contribution, particularly George Dangas, who participated in the discussion as well in this early hour in New York. Kalimera, George.
Καλημέρα σας και συγχαρητήρια πάλι για το συνέδριο. Και οι τρεις είναι 2 μιλιόνα πολύ καλοί. Καλησπέρα, χαιρετώ και τον κύριο Πιπηλή επίσης. Γεια σας.
Γεια σου, Γιώργο.
Ευχαριστούμε, Γιώργο. Γεια σας.
name is Ioannis Iakovou. I'm very happy to welcome you to this excellent table. We have an exciting faculty with Ganesh Manoharan as the first speaker. He's going to present us data on TAVI durability and thrombosis, and he will elaborate on the if TAVI devices are all the same or there are any specific differences between them. So, Dr. Manoharan, thank you again for having the time and to join with us in this afternoon. Thank you very much, and we are all ears.
Super. Thank you very much for the invitation, first of all. And the topic itself is quite emotive, so I'm not going to be emotional about it. I'm just going to show you what data we have. And the title is TAVI durability and thrombosis, are all TAVI devices the same? This is an image that Raj Makar, I think, will be showing you later on. But essentially, and Lars Sondergaard did a lovely presentation about the difference between leaflet motion showing clinical signs versus an imaging feature. And it's really picked up in more detail in 4D CT. So I think it goes back to the definition. I think the first thing to remember is leaflet motion abnormality is not clinical valve thrombosis. And we now have valve 3, which definition is somewhat similar, but essentially it's valve thrombosis is a phenomena due to thrombosis that's interfering with flow across the bioprosthetic valve, either surgical or TAVI device, sufficiently enough for you to intervene. And based on these definitions, the clinical valve thrombosis is currently estimated about 0.61%. Now, remembering that this percentage was derived from really first generation technology and not the current generation technology, and also not using the techniques we currently employ deploying any of the valves we use. And importantly, you do need a very specialized acquisition using CT to look at this in more detail. A joint standard definition has been produced to define bioprosthetic valve dysfunction, and note that thrombosis is now included into this definition when the valve is failed. And again, the similarities between VARC and the joint statements are similar. If you have thrombus, that's fine, but it must impact on the functioning leaflet for it to be defined as a failed valve. Similar findings also been seen by other registries. The biggest one is the Portico ID, where it was first seen, where it's estimated nearly 40% of patients, approximately 30-day CT, have this phenomena. And again, when you join the Resolve registry and Savory registry, something similar, about 13 to 14% of patients demonstrate these subclinical leaflet thrombosis. But as Lars has shown, despite all of these phenomena, they do not seem to affect the valve gradient on echo. And it's been seen again in all type of valves and nearly up to 22% in this study. They have found that the transesophageal echo correlates with CT finding. Reduced incidence of leaflet motion also was seen with warfarin, but not with DAPT. So warfarin appears to be really the only treatment that you can use to either reduce it or remove it. Anticoagulation does resolve the leaflet motion defect, and there's been no increase in clinical events in the Portico ID trial, but there has been a little noise in terms of increase in TIA seen in pooled registry data. When you look at other registries, so in this case, a Savory registry, and a whole list of valves are given at the bottom, the numbers really is difficult to make any sense of what is and what isn't. You can see that in the TVA overall, 30.1% were seen to have halt, and in surgical valves, about 28.2%. Again, if you look at the type of generation devices used, most of the valves at the bottom here are now obsolete, or at least the techniques used are obsolete, apart from the SAPIEN 3 shown here. Again, when you look at leaflet motion that causes motion defect, again, the variation is quite wide. TAVI having 19%, surgical much lower at 3.1%. So there seems to be some noise now that the surgical technologies seem to have lower leaflet motion abnormality as compared to the TAVI device. And again, when you look at in more detail, different TAVI devices, there are different data sets. Portico and the self-expanding seems to have somewhat similar outcomes compared to the balloon expandable, at least in this technology, in this study. But then in more detail was looked at by John Jose back in 2017, where they followed up 642 patients in their center, and they looked at clinical valve thrombosis, and they found that about 2.8% of patients of the 640 had clinical valve thrombosis. And they also noted that it would be significantly more in the balloon expandable technologies. But despite that, there were no deaths related to the valve thrombosis. And in terms of numbers, it's about 4.6% of patients in the balloon expandable versus 0.98% thrombosis in the self-expanding. So there seems to be, in the real world, in a single center, a difference, a significant difference between balloon expandable versus self-expanding technology. But they do not seem to relate to worse outcome later on. And another study, a registry, this is exclusively in Japan, called the Ocean TAVI Registry, again looked at these features. I just want to show you this timeline. You can see that in Japan, the Edward Sapien was the first technology we used, and then nearly 3 years later, COVAF went into the region, and another 3 years after that, the newer generation Sapien 3 went into the region, and then approximately another about roughly the same time, or 6 months later, the Evolut R went to the technology. So you can see that the reason why I'm showing you this is to show that of all the registries that have been showing differences between one technology versus another technology, they never actually compared apple for apple or orange for apple. So the timing of these technologies going into the center were different. So the techniques used may be different. The type of patients looked at may be different as well. So just something to think about when you're looking at the data that's being presented. So in the Japanese target patients in the Ocean Registry, they looked at 485 patients who underwent 4D CT analysis. So these were not consecutive patients. These were just patients of the cohort who had 4D CT. Early leaflet thrombosis was seen in 9.8% of patients. The mean pressure gradient at discharge was slightly higher in patients with early leaflet thrombosis, 12.9 versus 11. Now, okay, that is statistically significant in terms of number, but 12.9 millimeters of mercury was 11 millimeters of mercury in terms of mean gradient. Does it relate to a clinical outcome? I don't think so. What they found was a predictor for early leaflet thrombosis was for the balloon expandable valve was low flow, low gradient, patient with severe PPM, and the use of a 29 valve. However, they could not find any predictors for self-expanding technology used, and you'll see in a minute why that's the case. The prevalence, however, for leaflet thrombosis was similar between the balloon expandable and self-expanding. When you dive a little bit deeper into their data set, this is what you'll find. The vast majority of patients who had 4D CT were the balloon expandable patients. So a lot more patients who had balloon expandable had 4D CT, and therefore a larger number was seen. Despite that, I think of the 50 patients who received, or 49 patients who received the Medtronic CoValve, only 4 had evidence of early leaflet thrombosis versus a much higher number for the balloon expandable. Despite all of this, there was still no difference with respect to death, stroke, or heart failure hospitalization between early, and there were also no between early leaflet thrombosis and no leaflet thrombosis. But they did find a difference, a significant difference between the first generation Edwards XT versus the Edwards Sapien 3. I'm not sure why they saw that. It's a difficult to work that one out. But do you remember that the S3 has a external skirt, whereas the XT did not? And then finally, there was no difference between the Sapien 3 versus the CoValve, despite being a numerically bigger number. So the data is variable. I think it goes back to what was looked at. More recently, though, the Partner 3 did a sub-study looking at this feature in particular for the patients who were randomized in Partner 3. In Partner 3, patients exclusively had Sapien 3 valves implanted. Patients underwent serial CTs at 30 days and 1 year post-TAVI or surgical AVR. All CTs were randomized or analyzed in a blinded collab, and the investigators also did not know the findings of the CT. So this is, I think, is probably the first time this phenomena has been looked at in the balloon expandable technology in a prospective clinical trial governed environment. And what they could find was that this is interesting. So at 30 days between surgery and TAVI, leaflet motion or leaflet thrombosis non-clinical was observed higher in the TAVI group, 13.3% versus surgery about 5%, which is significant. However, at 1 year, there was catch up by the surgical group and probably slowing down of the TAVI group, making the number roughly similar and not particularly significant. My thoughts are perhaps the reason why in the first 30 days, there was much lower halt in the surgical arm is because a lot of surgical patients post-op would have been given Clexane or some sort of low molecular weight heparin. And could this have reduced the effect seen in early? And then you get this catch up when these patients go home, that in the end of the day, at 1 year, there is no difference between TAVI patients with the balloon expandable versus surgical patients with surgical valves. The mean gradients again did not change very much in the first 30 days to 1 year. Leaflet motion, however, in the presence of absence of leaflet motion did show a subtle change in mean gradient from 13.3 to 11.4. Again, statistically significant, but clinically, I don't think a patient will see the difference. And again, at 1 year, there was a catch up and it all dissipates or dissolves. So the conclusion of part 3 was very clear. The incidence of halt and reduced leaflet motion are frequently present in bioprosthetic valves, which you've seen repeatedly in other studies. The incidence in the entire cohort was about 10% at 30 days and increased to about 24% at 1 year. When you compare balloon expandable TAVI versus surgical AVR, the prevalence of halt and reduced leaflet motion was significantly higher in the TAVI group at 30 days, but not at 1 year, which I've shown. And it suggests that the natural history of halt was dynamic and spontaneously resolved in over 50% of cases, and in the absence of anticoagulation. And new halt appeared in about 20% of patients at 1 year, but with no clinical sequelae. Valve hemodynamics in the halt group and reduced leaflet motion group had minimally increased gradients, but with no clinical significance. And then finally, there were no deaths or MIs in patients who underwent halt. So, and the pool rates of death, stroke, TI, thrombotic events were numerically high in patient halt, but not statistically significant. And why is this? So this is something that's come up more recently on trying to work out what's the difference between a supraannular technology, self-expanding versus an intraannular technology, in this case, the balloon expandable, and the concept of a neosinus triggering thrombus formation has been brought up. And but MIDA showed and published in Circulation showing that in the supraannular leaflets, there's a reduced neosinus flow stasis. So the flow stasis in this zone is significantly reduced in supraannular valves compared to balloon expandable or intraannular valves. And perhaps that reduced flow status predicts the thrombus formation and the size thrombus formed as well. And finally, if you look at in the similar group, looking at cohort 29 and SAPIEN 29, the underexpanded valves or oversized valve appears to have lower rates of sinus stasis, and also a valve deployed lower. So an intraannular valve deployed lower also appears to have a higher risk of neosinus stasis. So deploying the valve higher perhaps would reduce this risk, and sizing a valve appropriately again perhaps will reduce the risk. But if you look at numerically, the CoValve appears to have a much lower risk of stasis compared to a SAPIEN valve for size. And other features have also been looked at that could reduce this phenomena, under expansion of the valve impacting on the leaflet. That last is shown very nicely how the leaflets are distorted, and that then reduces its opening capability. Deploying the valve too low, creating these pockets where fluids can form and reduce flow dynamics. And then finally, implant depth. And then finally, I think also commercial alignment appears to potentially improve flow dynamics in that area, increase washout, and reduce the risk of thrombus formation. So some thoughts. Non-clinical leaflet thrombosis appears in reasonable number of cases post-TAVI, both in TAVI and AVR patients, perhaps slightly more than TAVI patients. How non-clinical leaflet thrombosis seems to disappear with time, but leaflet clinical thrombosis formation thankfully is rare and treatable when discovered. Leaflet thrombosis appears to occur more commonly with balloon expandable valves when compared to self-expanding, but seems to be similar to surgical AVR without significant increase in adverse events. This higher occurrence may be related to flow dynamics and interaction to the surrounding native anatomy, and perhaps optimizing deployment techniques, device iterations, and post-procedure care, like post-dilatation, like giving anticoagulant in patients you're worried about, may reduce further the prevalence of clinical and non-clinical leaflet thrombosis. But I think how to correlate thrombus formation in leaflets and what happens long-term, we don't have the data yet. Most of these data are following up only up to 1 year. So we do need much longer-term data to look at what the impact of patients with clinical or non-clinical leaflet thrombosis has on durability. With that, I will stop. Thank you very much.
Thank you, Ganesh. It was an excellent presentation and very informative as well. So before I let the other speakers talk and the faculty, so let me ask you a question. So if I understand correctly, so the best thing in order to avoid a leaflet thrombosis of a valve is to place a well-expanded, self-expanding valve, right?
Correct. I think like any technology, whether you're doing coronary stents or TAVI or whatever you do in your life, if you don't follow the IFU and don't do the job correctly, it will, I think, cause harm both short-term and long-term. So from what we've seen so far, at least with TAVI technology, it appears that deploying the device at about 3 millimeters subannular, that you get good seal, good expansion, and less amount of interaction between the old leaflets and the new leaflet seems to be the right thing to do. The other point I would like to raise as well, of all the data I've shown you, the most nuanced and most recent data really is from the SAPIEN 3 prospective follow-up trial data. Every other registry data I've shown really is on TAVI being deployed in the 2014 to 2015, 2016 time zone. And, you know, all of us who do TAVI, we've changed a lot on how we deployed TAVI 5 years ago, 6 years ago to what we do today, correct? So I think that is important as well when you look at this data and to understand what to do and what not to do.
Good. And a second question. So if you place a balloon expandable valve, are you more, let's say, aggressive in your, let's say, antiplatelet and antithrombotic therapy when you deal with this kind of patients? No?
I don't think so. I think it's very important to be not to overkill a CT phenomena versus what actually is happening clinically. Yeah. I think if you look at all the, and also, you know, George was on earlier on and he gave a very nice talk about the use of NOAC and TAVI patients. The risk of bleeding cannot be underestimated, I think, in our older patients. And there is now data to suggest that DAPT is not really required. You can go in monotherapy. We certainly in our unit, from the time that data trial was presented, have reduced to monotherapy. So far, touch wood, we have not seen a sudden rise in embolic events. But what we have seen is a drop in the amount of vascular complications or late hematomas and late bleeding in the vascular area. So that is a balance I think we need to take between treating an imaging phenomena versus a clinical phenomena.
Yes. Kostas.
Yeah, I think the big gamble here is whether we're going to be able to connect thrombosis with durability, as Professor Dangas discussed in the previous session, because that will make materialize the significance of thrombosis into a long-term clinical sequel. I think for the time being, since we cannot connect subclinical thrombosis with clinical events, we only act upon on significant gradient increases like we had earlier in the previous session. If we get a gradient rise of more than 10 millimeters of mercury in sequential echo for the mean gradient, then we should proceed with the CT scan to investigate. And if we find leaflet thrombosis, then we should treat. Otherwise, my understanding is that there's no reason to act up on this subclinical event. Do you agree, Ganesh?
I agree. I do think also that with time, once with the technology changing, with our implant techniques changing, we are deploying it higher. We are deploying it, trying to get more commercial alignment. This clinical and non-clinical leaflet thrombosis numbers are going to come down significantly. So then, when you come down significantly, trying to do a clinical trial when your overall clinical thrombosis is between 0.6% to 2.8%, you need like a large 10,000 patient PALMER trial almost to show any clinical relevance. And I'm not sure interventional cardiologists will be too enthused in running a trial like that. I don't think.
Yeah.
I don't think
as we discuss it now, we see just one aspect of TAVI, which is leaflet thrombosis, and the other aspect is TAVI and TAVI, and sometimes there are conflicting data on this too. So if we want to have less leaflet thrombosis, we go supraannular, and higher, we have flushing in the coronary sinuses. But we know that if we see TAVI from another aspect, the aspect of TAVI in TAVI, the higher we go, the higher the possibility that TAVI in TAVI is not going to be possible. So I think we have to have a general approach to this procedure and put a balance in the various aspects. So this is one aspect in the device selection, but we should always keep in mind, the other peripheral aspects.
Correct. Agreed.
May I ask you something, Dr. Manoharan? Perhaps if we had more sizes in every valve, not to have only 3 sizes from Edward, so as to have not to have a mismatch, valve mismatch, perhaps it would be better, so as not to have this thrombosis in sinuses.
That's a good hypothesis, and certainly when you look at, so Portico comes in 4 different sizes for the same diameter availability, whereas Medtronic comes in 3 and Sapien comes in 3. And if you look at the Portico valve, at least based on recent public presentation by Lars at at PCR on the Portico NG next generation device, the mean gradients of the Portico valves for all the valve sizes seen is similar to the CoValve supraannular valve. So that is an annular functioning self-expanding valve with 4 different sizes compared to a self-expanding valve, supraannular valve with 3 sizes. And I think the squeezing of the leaflets or over under expansion, or you look at the reverse way, trying to squeeze a very large one, a small anatomy, I think does impact on leaflet motion, and also then potentially at the later time may impact on thrombus formation. Now, the other side of the coin is where some people would argue that having any form of thrombus on the leaflet, it probably is part and parcel of normal healing of these foreign materials in a patient. Because remember, we are not sequentially doing CTs every month on every other patient.
Okay.
The timing of the CT is 1 month, and then anything between 130 days to 365 days. And perhaps if you have an image modality that doesn't cause any harm, and perhaps if you CT everybody every day for 365 days, maybe all the technologies, whether surgical or transcatheter that you put in the patient, will at some point develop a bit of thrombus and dissolve, right? And that's one of the difficulties of this area. And I think the only thing we can really hold on is the risk of clinical thrombosis, if not treated, causes harm. Therefore, doing at least a 30-day echo and perhaps a 1-year echo seems logical. And if you do find a change in gradient, make it a much more sooner echo. And then if there's still a change in gradient, then treat them. And it looks like at the moment, warfarin seems to be the better anticoagulant strategy than any of the other technologies available or techniques available.
What intrigues me here is that we've seen that the surgical bioprosthetic valves have the same leaflet thrombosis problem with our TAVI devices. And I wonder how can this happen when the native leaflets are removed, surgically excised by the surgeons? So I wonder if this excision of the surgical leaflets is not, you know, an advantage finally, at least in the field of thrombosis of the leaflets, because we see it in both TAVI and biprostatic valves. So the excision of the native leaflets, somebody can say it's not that important, right?
So this is why when in my conclusion I said that the new sinus phenomena may rather than definitely does, for the exact reason what you said, because the non-clinical leaflet thrombosis are also seen in surgical patients, where the so-called covering of the old leaflets, they're fully removed, right? And the surgical valves are actually implanted in the vast majority of patients, commercially aligned, and yet you see it. So I go back to my original statement. I think when you put a foreign body into a patient, they all will have some degree of thrombus formation. And what we are not seeing, I think, is that because we're not looking at it on all patients every other week, that's why we're not seeing them. That's why you see this percentage ranging between 9% to 45%. My gut feeling is that I think you'll see it in nearly 90% of patients if you are able to check it every day for the next 365 days. But thankfully, for all of these patients, the vast majority of them, it dissolves spontaneously. And in a minority of patients, it progresses on to something more sinister. And in those patients, and I think that's the area we need to look at. Who are those patients? There are signs that suggest that if you underexpand your valve, they are potentially at risk. There are signs that if you put a much bigger valve into a small area where the leaflets are already mangled, they may be at risk. Patients who are already got coagulopathies, and at a higher risk of thrombus formation are probably at risk. And other areas, patients that you and I know, bicuspid with horrendous calcification potentially could be at risk. Valve in valve could be at risk because we are squeezing big technology into small anatomies. And perhaps even horizontal anatomy where the flow dynamics are not normal in relation to your frame could also be patients who are at risk. So I think what would be nice, is for patients and technologies and companies to look at trials trying to pre-warn us who are the high-risk category patients. And then we can home into those patients and then treat them appropriately.
Great. So I think if there are no other points of discussion, we'll thank Ganesh for being with us live today. Nice to see you, and hopefully next year face to face.
That'll be, I think, like all of us, that would be the best thing ever to meet face to face. Once again, thank you for the invitation. Have a great meeting.
Thank you for being with us.
Okay, let's proceed to the next speaker. Unfortunately, it is pre-recorded. I think that we're going to proceed with the presentation of Dr. Tang from Mount Sinai. Okay.
Hello. It's my pleasure to present to you this topic, TAVR valve design and future coronary access for treating CAD. Here are my disclosures. Lifetime patient management post-TAVR is growing increasingly important because now TAVR is approved in patients across the entire surgical risk spectrum, age 65 or older, according to the most recent ACC/AHA guidelines. However, many of these patients may have progression of coronary disease, needing CAF or PCI. And of course, TAVR valve degeneration will require re-intervention, whether it's surgery or redo TAVR. CAD management after TAVR is the next pandemic because prevalence of CAD undergoing TAVR ranges in the literature 40 to 75%. And in fact, over 60% of patients with intermediate surgical risk have CAD. The success rate after TAVR in terms of coronary access vary amongst series and valve types. However, many interventional cardiologists not familiar with TAVR may find the process and the procedure difficult. So it's important to understand the key aspect of TAVR devices and aortic root anatomy to facilitate coronary reaccess, especially in urgent situations. Here are the reasons for potential difficult coronary access. If you have a bulky leaflet calcium facing the coronary artery, you might not be able to selectively engage the coronary artery as shown on the left side. Or if you have a valve-in-valve situation where you may have sinus sequestration with the stent frame of the TAVR valve and the surgical valve, it might be challenging to reaccess the coronary, especially in the low left main situation. And as we talked about before, the lack of device familiarity by interventional cardiologists who don't perform TAVR will make this potentially challenging. There's also variable aortic root anatomy. And of course, there are multiple barriers facing the coronary artery orifice, such as the native aortic valve leaflet, the transcatheter valve stent frame, and the transcatheter valve commissures due to lack of commissure alignment. In one of our initial papers, we shown that essentially the new commissure orientation to coronaries with a CT study are essentially random based on the previous TAVR valves. And therefore, understanding the anatomic relationship is key, including the aortic root and the TAVR device type. So shorter frame valves, such as balloon expandable or mechanically expandable valves, are more relevant in TAV or redo TAVR, unless the stent frame goes above the sinotubular junction. In taller stent frame valves, mostly self-expanding valve, you might have issue with coronary access and redo TAVR, particularly with supraannular devices. Here's a seminal paper we published a couple of years ago looking at both anatomical and device and procedural factors affecting coronary access. And some more recent papers looking at commissure orientation, as you see here, may in fact create interference with coronary access due to commissural misalignment. In this paper, looking at both self-expanding and balloon expandable valve, you can see that the incidence of one of the commissures facing a coronary artery is ranging from 8 to 10% in balloon expandable valve to 20% in self-expanding valve, thus potentially interfering the ability to perform coronary access. This is a paper on low-risk TAVR patients from the MedStar trial, and you can see that in this CT study, looking at the commissure alignment, if the commissure facing one of the coronaries, it may make not just coronary access potential unfavorable, but also TAVR and TAVR as well. You can see the incidence around 8.7% and 13.1%. You can also see this paper, coronary access after repeat TAVR itself. You can see that depending on the type of device and the location of the STJ relative to the device and the anatomy, the depth of implantation as well, the ability for coronary access with TAVR and TAVR can be challenging. This is a nice algorithm looking at if you have large sinotubular junction versus narrow sinotubular junction, and if you do TAVR first, TAVR and TAVR in terms of coronary access may be challenging in certain scenarios. And in fact, with narrow STJ, you might be better off with surgical valve replacement first, followed by TAVR to avoid coronary obstruction and facilitate coronary access. In one of our editorials in Eurointervention, we actually simplified the classification a little bit, basically depending on the height of the transcatheter valve, the first or the second one, but also importantly, commissure alignment of the first or second valve to determine ease of coronary access. And TAV in TAV is a bit different from TAV in SAV. After surgical valve replacement, we don't have any native leaflets left behind, and so commissure alignment is done 100% of the time and make a basilica procedure feasible. Whereas after TAVR, different devices, as you've seen, have different frame of leaflet profiles. Because there's lack of commissure alignment, basilica may not always be feasible. So we believe that commissure alignment may matter in future coronary access, but also aortic valve reintervention after TAVR. The reason is that in surgery, we do it every single time, all the time, to avoid coronary obstruction. And also you reduce the barrier to reaccess because you don't have a commissural post facing one of the coronaries. Now, there might be some early anecdotal evidence and presented evidence that it may impact durability based on the commissure orientation, such as gradients and also flow dynamics. And basilica and leaflet management strategy to reduce coronary obstruction really is not feasible if you have a commissural post facing one of the coronary arteries. Here's an example of the surgical valve where you put a balloon expandable or self-expanding valve. If you don't have commissure alignment with the transcatheter valve, even with basilica, you can see that the commissural post may actually face the split portion of the basilica procedure, still causing coronary obstruction with TAV in SAV. So you can imagine it could be similar in TAV in TAV as well. This Align TAVR paper we published last year looked at 3 different transcatheter valves and see whether we can intentionally align the commissures with the delivery systems. And essentially what we studied was over 800 patients looking at SAPIEN 3, Evolut, and ACURATE neo, and we tried to align the SAPIEN 3 with crimping the commissures at 3, 6, 9, and 12 orientation and deploy the valve in a standard manner. With Evolut, we try to do the delivery system at 3 o'clock flush port orientation instead of a 12 o'clock conventional manner. And the ACURATE neo, we look at basically the 3 commissure orientation, the track on floral before and after deployment. What we found with SAPIEN 3 is that despite crimping the valve commissure opposed at different clock face orientation, there's really no predictable way to align the commissures with the SAPIEN 3 system. With the Evolut system, the CTAP represents one of the commissure opposed, and the head marker on the delivery system is visible on fluoroscopy, as you can see here in terms of orientation. Also, the CTAP, which is the commissure, is mounted approximately 90 degrees off from the head marker, so there's a mathematical consistency in terms of deploying the valve and release. So you can see here, majority of the time when the valve is deployed, the head markers were located at the outer curve or center front. And when the valve is released, you can see majority of the time the CTAP, which is the commissure post, is located in the curve of the ascending aorta. However, if you look at the head marker position at the initial deployment, you can see that on the red bars, if the head markers were to get in the curve or center back, the incidence of severe coronary overlap is much worse than the green bars where the head markers located in the outer curve or center front. So because of that, we try to improve this by rotating the flush port to 3 o'clock away from the operator instead of conventionally 12 o'clock to try to get the head marker track along the outer curve of the aortic arch and ascending aorta as much as possible, such that when you deploy the valve, the head marker should be at the outer curve when you're doing a classic or LAO deployment view, or center front facing you at a cusp overlap view to optimize alignment. And the goal essentially is to try to land the CTAP in the inner curve of the ascending aorta as much as possible. Where is this flush port located? You can see it's the gray handle, and the way to do this is just insert it into the femoral artery away from you at the time of insertion. So here's a video showing the head marker tracking the outer curve of the descending aorta across the aortic arch to the ascending aorta and the root, such that when you deploy, you can see the head marker in the outer curve if you do a classic LAO view, or if you cusp overlap view, it should faces you directly. And so when you release the valve, you can see in the free cuscoplanar view, the CTAP should be facing the inside, the inner curve of the ascending aorta. And this patient had a post-CT stage confirming that the commissure are well aligned relative to the native commissure, making potentially coronary access easier. In fact, this patient had a coronary angiogram after the TAVR, and you can see that selective angiography is not a problem when you have commissure alignment. So thus far, we are over 350 consecutive cases done up to this past January, and you can see that the head marker orientation significantly improved to almost 95% now. And you can see also this ability to align the commissure reduces the severe coronary overlap now significantly, one of both coronaries, left main, right, or both coronaries, such that it would potentially make coronary access easier. Now, there are some limitations to this technique, such that it's a transfemoral approach only. We have not tried it in alternative access. Of course, iliofemoral tortuosity, calcification, and the anatomy may limit the ability to track the head marker to the outer curve in the descending aorta, especially with left femoral access. There are some newer techniques now to perhaps doing more patient-specific strategies. For example, in this case, report on commissure alignment with TAV and SAV. You can see that by the position of the head marker facing you directly, again, the cusp overlap view, you might be able to tweak the torque the catheter slightly to optimize the alignment during deployment. With the ACURATE neo valve, you can see that one of the commissure tabs, as long as it faces behind you or at the inner curve, when you deploy the valve, it should improve the commissure alignment. However, if you insert the flush port at 12 o'clock, as recommended by the manufacturer, essentially it's pretty random how it ends up. And this is showing that the severity of commissure overlapping the coronary is certainly much better when one of the tabs is facing the back or the inner curve during deployment. Now, there's some novel ways to optimize commercial alignment. One of them is patient-specific analysis. Essentially, you 3D print your CT anatomy and try to rotate the catheter and the bench model, test it, and then adopt it in the patient as you deploy the valve to optimize alignment, as shown in this accurate NEO example. There's also some ways now, perhaps with portico TAVR as well, to try to do this with the fluoroscopic marker. This is done on a bench model, and there's some early data going to be soon published in clinical model as well. However, there are valves that actually deploy requiring commercial alignment, as you saw here. The Yana valve and the J valve both require commercial alignment to actually deploy, and these may make coronary access certainly easier and maybe even redo TAVR in the future. So in summary, current TAVR devices are not designed to achieve commercial alignment to facilitate coronary access. However, doing so may make lifetime management of patients with AS or CAD potentially easier. The technical modifications improves absolute commercial alignment, but we have not found the case for SAPIEN 3. In terms of future directions, I would say CT-based and patient-specific analysis may improve commercial alignment with the current TAVR devices. In fact, I think we need prospective studies to perform coronary reaccess after TAVR to demonstrate feasibility and effectiveness of commercial alignment to facilitate this. And finally, I think device manufacturers really need to step up and design valves and delivery systems to consistently achieve commercial alignment so that we can manage lifetime journey of these patients better. Finally, I'd like to show you this TAVR Cafe app, which is available free on your mobile phone platform, whether it's Apple or Android. And you can, all also available on the website. And you can see this web-based platform available as well, looking at post-TAVR PCI and coronary angiography. And we have animations, anatomy, different catheters. This is designed and developed by Dr. Samin Sharma, Dr. Annapurna Kini, at Mount Sinai, my co-interventional cardiologist, and myself. And I hope that you will download it and utilize this tool, because for those of you who are not familiar with TAVR devices, we find this highly useful. I'd like to thank you very much for your attention.
Costa, I don't know. I think that we may proceed to the next presentation.
I
Do you
think
have any questions?
I think it was a master's talk about this issue, the issue of alignment of the TAVR device to the aortic root. And most of these slides are included in other presentations, have been included and will be included. So I think we should continue with the next presentation, which is from the very prominent colleague Raj Makar from CTSNet Los Angeles. He's gonna present us about TAVI in aortic regurgitation, and it is pre-recorded case presentation.
Hello everyone, I want to wish everyone good health around the world, and to all my friends in Greece, and thank you for the kind invitation. My task today is to talk to you about TAVR for pure aortic insufficiency. So I just thought I would start with this slide because it makes the point that aortic insufficiency is quite prevalent. If you look at patients, or in a population-based study rather, where above 65 years of age, aortic regurgitation is present between 1 to 2% of the population. So this translates into quite a few patients for this procedure. We also know, based on this study, that the survival after surgery is better when you intervene earlier, when patients have NYHA class 1 or 2 symptoms, rather than when the symptom class is class 3 or class 4. So it's not surprising. There are a lot of small series that talk about the use of TAVR in aortic regurgitation. And I'm going to review some of these data with you and then talk about a dedicated system for aortic regurgitation. but there are obvious challenges in the treatment of non-calcified aortic regurgitation. The primary issue is that of insufficient anchoring, and very often this is because of large annuli in addition to lack of calcium. And this may lead to embolization. Residual aortic regurgitation is not uncommon with the use of commercial devices, and often in an attempt to oversize, there are case reports of annular rupture as well. So in terms of anchoring mechanisms, the anchoring might occur in different places, whether it is the leaflets, the annulus, the aorta, and there are different devices which act in different ways. And for example, you've got the sapien valve and the lotus valve, for example. These were only effective at the annulus. Looking at the dedicated valves, the valves that work both on leaflets and on annulus, there are a few there. There is one of these, which is the Jenna valve, which is right now in clinical trials. So some of the earlier studies, smaller studies, and these are some of the earlier studies published with core valve that basically showed that this was feasible, that the second valve requirement was not trivial, in fact almost 20% of the times, with more than mild residual aortic regurgitation, also about 20% of the times. And then there is this series of about 20 patients, with the accurate valve, where the anchoring, just like the core valve, is both in the annulus as well as in the aorta. And essentially, the results were not bad. Though this is a small series, the device success rate was 90% and 30-day mortality rate was 0%. There were no significant complications. More than moderate aortic regurgitation occurred in 1 out of 20 patients. These are data from the STS ACC TVT registry. And once again, if you look at the results here, these are in-hospital and 30-day events, and compared to the overall, or compared to use for aortic stenosis, TAVR and aortic regurgitation was associated with higher device migration and embolization rates, higher rates of reinterventions, higher rate of conversion to surgery, and a 30-day mortality of 15.5%. So clearly, I think it is reasonable to say that actually these results are not only not as good as aortic stenosis, where you can see, for example, that the 30-day mortality rate was 4.3% compared to the overall 15.5% with aortic regurgitation. And also in the series, the mortality tends to be, in fact, if anything, more than the predicted STS at times. So here is yet another series that my young associate, Dr. Sunghan Yoon, put together. A total of 331 patients from 40 centers in this international registry, and the average age was 74 years with an STS score which was about 7. And if you look at the distribution of the devices here, once again, most of these procedures were done with the transfemoral access, and this also includes the early generation devices. This is an older study, so there were patients, even with the old Jenna valve, which was actually implanted using the transapical approach, in addition to some of the other first and second generation valves. And what was very clear here is that the outcomes, whether you look at second valve implantation or aortic regurgitation, or mortality, they were essentially lower with the newer generation devices, but nonetheless they were still high. So if you look at the 30-day mortality here, it was about 8%, even with the newer generation devices. So this wasn't considered to be, it's feasible, but wasn't considered to be really stellar outcomes. And if you look at the incidence of second valve implantation, once again, it was not trivial, anywhere from 9% to 26%. I just want to emphasize that the Jenna valve here was the old Jenna valve, not the transfemoral. This was the valve that was actually implanted using transapical approach, not transfemoral approach. What was also very clear is that mortality was lower in patients when they did not have residual aortic regurgitation. So I think it sort of re-emphasizes that treating aortic regurgitation was meaningful here, or is meaningful, if you can actually leave the patient with mild or less residual aortic regurgitation. So just like TAVR in aortic stenosis, residual aortic regurgitation is also a predictor of mortality at 1 year, even in patients who have aortic regurgitation. And once again, this is looking at the newer generation devices versus the early generation devices. The mortality was clearly lower when you're talking about the newer generation devices, which includes the Sapien 3, the Evolut, and and the Accurate valves. So I thought I would show you some case examples of what we've done in our lab, and here is a patient that we did quite a while ago. In fact, 86 years old, severe aortic regurgitation. You can see there is absolutely no calcium here. The perimeter is 74. And in this particular case, we decided to use a 29 millimeter Evolut. As I was trying to show you here, that we will often use 2 pigtail catheters to actually, understand the anatomical landmarks. So this is the result. After placing the Evolut valve. As you can see, there was not much aortic regurgitation. So, it was clearly a good outcome. Here is the echo. Now, I wanted to show this interesting case example. This is a patient that we did maybe almost 7 or 8 years ago. And essentially what this young man was placed on a heart transplant list because he'd undergone aortic valve repair, which had failed, also had a history of CABG, had bad kidneys. They were talking about doing both a heart and kidney transplant. Essentially, he was not thought to be a good surgical candidate for repeat surgery. You can see this is his baseline aortic angiogram and echo, severe aortic regurgitation. The EF was down here as is seen, and there's also severe mitral regurgitation. Here is the perimeter was 79. We did this procedure. We deployed the 31 millimeter Medtronic core valve at that time, and immediately after the procedure, he was fine. After the deployment, rather, there was no significant aortic regurgitation, but in a few minutes, as we waited, it was clear that the device had actually now descended down and there was severe aortic regurgitation. So what we did in this particular case was, and you can see how the MR is actually severe as well. So in this case, we deployed a Sapien XT valve because that was the valve that was available at that time. This is 8-9 years ago, as I mentioned, and you can see that there is no aortic regurgitation. So we've done a few cases with combination of self-expanding valves and balloon expandable valves. Essentially what you're doing is you're creating a landing zone for the balloon expandable valve, which prevents the balloon expandable valve by itself from sort of flipping and embolizing into the ventricle. And this technique has bailed out quite a few patients actually in our laboratory. And this is the final result. And you can see 3 months later, there is no aortic regurgitation. And not only that, the mitral regurgitation has actually also disappeared. So it is a very common thing, for aortic regurgitation and mitral regurgitation to coexist. And it makes sense to deal with the AR first, because often it may actually take care of the mitral regurgitation, at a later time point. So here are the pictures of MR, severe, before and then after valve in valve, it's actually gone. So I thought I would also show you a case example with a balloon expandable valve. And here is a patient, once again, an older gentleman with low EF, turned on by 2 surgeons, severe aortic regurgitation. no calcium, or maybe specks of calcium, you can say. The annulus here was large, 595. Okay, so we took a 29 millimeter sapien valve, and we actually put excess volume in there. So this is of course, you've got to be careful, make sure that you go up slow, you're stable, and pacing capture is not lost. I think even more so than aortic stenosis. And this is what the valve looks like because of the excess volume. You can see it is much more stretched out, and there is no aortic regurgitation. So this is the echo as well. I think it is important now so we've been using these devices off-label because there are clinical situations where there's nothing much else can be done. But I'm very excited about this device, the JenaValve device, which is a self-expanding valve, which is in clinical trials right now. And what makes the anchoring of this device very solid is not only does the anchoring occur at the level of the annulus here, but also these locators trap the leaflets between the valve frame and the locators themselves here. So essentially that provides a good sealing and also provides good anchoring. So this is what essentially are the basic steps here. You can see that you are releasing these locators and you are aligning them. You're putting them in individual commissures guided by echo or fluoro or combination of both, and then the valve is actually released. So I want to show you a case here. This is a patient. Once again, you can see the annulus is 549 here. There is no calcium. This is the aortic root angiography, and you can see the JenaValve catheter there. This is before releasing the anchors. Now we've released the anchors, and now we are taking selective injection into the cusps to see how these locators are sitting in the cusp. So once we are sure that these locators are well placed, we will go ahead and actually release the valve. These days now, when we release the valve, we will go ahead and actually do some rapid pacing at the time of the release. You don't need to do this earlier, of course, but just in the final step. So this is, you can see the different cusps and the locators. All right, and at this point, so multi-purpose catheter is what we normally use to go down in each of these cusps. Okay, so after being absolutely sure, this is the release of the valve, and you can see that it nicely sits and there is no residual leak here. So here is the echocardiogram. You can see that there is no aortic regurgitation and no significant PV leak as well. So what are the data? So at Cedars-Sinai, we did our 23rd case last week, and the data that I'm going to present here is a snapshot that was taken a couple of months ago, and these data were presented by Torsten at the American College of Cardiology. So the Align aortic regurgitation is the trial that I'm talking about, and this takes patients who are at somewhat higher risk for surgery, either determined by STS or by the heart team. The trial currently excludes bicuspid pathology. The average age of patients was 74. The STS was about 4 average, and other comorbidities are actually listed here. And if you look at the procedural characteristics, once again, almost 80% of the patients had general anesthesia. The device time was 26 minutes, and the size of the valves is also listed there. Most common size was a 27 millimeter valve. So these are the key data. Absence of procedural mortality, 97.1%. Single valve in proper anatomic location, 96% of the times. And if you look at some of the other issues, such as absence of moderate or severe prosthetic, very nice, 98.6%. And if you look at the rates of embolization, just one patient, CVA one patient, conversion to cardiac surgery, 1 patient. So these are, and this includes the earliest experience of the operators, and some of them had done only 1 case. So the all-cause mortality was 2.9%, and cardiovascular mortality was 1.4%. Essentially, if you look at the incidence of stroke, it was 2.9%. Other complications are listed there. So these are quite favorable, considering that these were high-risk patients, and this was the earliest experience of the operators. And if you look at the pacemaker implantation, early on, I think we had lessons. We learned lessons about how to size. I think we were oversizing quite a bit, and actually implanting the valve a little bit too deep. You can see how the pacemaker rates actually now have come down to what are about 17% in the last 50 cases. So equally impressive are the PV leak rates. If you look at, there's only 1 patient that had a moderate PV leak. And if you look at the valve areas, because of the way the valve is designed, the effective orifice area here was 2.7 centimeter. This is like really large areas and low gradients. And if you look at the NYHA functional class improvement at 30 days, it was also very impressive compared to baseline, where you can actually see that class 3, there's no patient with class 4, and class 3 was present only about 11 or 12% of the times. The other 88% of the times the patient were either in class 1 or class 2. So I think to summarize this, I would say that aortic regurgitation prevalence is significant. I think we probably underdiagnose it, and for sure we undertreat it. Outcomes are better in patients who are treated with aortic valve replacement earlier. At least that's what we learned from the surgical literature. Outcomes of TAVR by the off-label use of current commercial self-expanding and balloon expandable devices are less than ideal, and they are characterized by higher valve embolization, migration, additional valve implantation, and higher 30-day mortality. Though I have to say that these results are also getting better with time, but they are not perfect for sure. Treatment of pure aortic regurgitation affords different fixation mechanisms for proper positioning and sealing, unlike a stenotic aortic valve where calcium plays a very important role. Anatomic alignment and cusp fixation hold the highest promise for success, and JenaValve, I believe, is a dedicated system which has been designed for that. And in the preliminary results that I have presented to you, the results of dedicated JenaValve system are very promising, in my opinion, considering that this was the earliest experience of the operators in terms of reducing aortic regurgitation, in terms of having optimal hemodynamics, and in terms of low mortality and morbidity at 30 days. So I'm going to go ahead and end, and thank you for the kind invitation, and I hope to see you all in Greece next year. Thank you. Goodbye for now.
Great presentation. It seems that the fire for aortic regurgitation is relighted after some years interruptions of dedicated valve. The JenaValve is coming back stronger after the transformation from a transapical to a transfemoral device. So we're looking forward to that, because patients with aortic regurgitation are there, many of them inoperable, and will certainly benefit from a dedicated device to avoid all the complications of the devices we're using today that are designed for aortic stenosis. If we don't have any burning comment, gentlemen, you want to add something, or we go to the next table?
I think we better move to the next table. I think it was conclusive, this talk, and it was learningful as well.
Perfect. Thank you all very much, and thank you our speakers, Dr. Tang and Dr. Makar, and we move to the next table.
Okay, can we start now? All right. All right. Thank you very much, Dr. Sparias. Good afternoon, ladies and gentlemen. I would like to thank the organizing committee for giving me the opportunity to take part in this roundtable regarding the valve-in-valve and TAVI-in-TAVI techniques. Actually, this is one of the hottest topics in the cardiovascular science of our days. This scenario and the problematism around it resulted in the reduction of the age recommendation for biological valves down to 50 years at the latest American guidelines. The chair will be shared with two excellent interventional cardiologists, Dr. Toutoussas, Professor of Cardiology at the Athenian University, as well as Dr. Triandafilou, Consultant Interventional Cardiologist at Evangelismos Hospital. And now I'm very happy to call Dr. Kodali, who is a professor of medicine at the Columbia University, also an interventional cardiologist, who will share his thoughts about coronary protection in these challenging techniques, the TAVI in SARV as well as TAVI in TAVI. Dr. Kodali, you may proceed.
Thank you very much. Can you see my slides?
Yes, certainly.
Perfect. Thank you for the kind invitation. I'm sorry that we can't be there in person. It was wonderful the last time I was there, and I look forward to hopefully next year being able to join you. So I'm going to go over the topic here, my disclosures of coronary protection when you're doing TAVI in surgical valve or TAVI in TAVI failure. The reality is these events, coronary occlusions, when they occur, can be catastrophic, and the mortality is very high if you're not prepared to treat it. But the reality is, treating it is very difficult. It's really about preventing it and understanding, who's at risk and how do we avoid it, how to prevent it. And sometimes preventing it means not doing the case. But it's important to understand what is and why does a coronary obstruction occur after TAVI and SAVR. So this is from Danny DeVere. This is a bioprosthetic valve in a model. And when you put a TAVI in, you basically create a covered stent. These surgical leaflets of the prior valve are pushed up, and you see here the frame of the TAVI valve and the TAVI leaflets inside. So these leaflets are then pushed up near these coronary arteries. So it's just a mechanical obstruction, and there really has to be room. And there are several ways that this obstruction occurs. Sometimes there's just no room in the sinus, right? In a patient like this with an effaced sinus, there's just no room for these bioprosthetic leaflets to sit. And so there's not going to be any flow around. And so you're going to get an obstruction of the coronary artery. Or sometimes in patients, especially those with like a 19 or 21 millimeter surgical valve that are small females, they have short sinuses. And the surgical valve leaflets, which can be tall, 16, 17 millimeters frames, can reach up to the sinus, and you can sort of seal off the entire sinus at the STJ. And this last one is less likely, but the obstruction of the TAVI device can actually obstruct the valve as well. And here's a clinical example, of Edwards Paramount. You see this low-lying left main, but if you put a TAVI device in here, you're basically going to seal it. And that's what happened in this patient. It sort of created that covered stent, and there's no flow into the left main there. So there's a lot of variability, and it's not enough time to go through the different reasons, but basically the risks are really dependent on the type of prosthesis. Valves with externally mounted leaflets like the MitraFlow, the trifecta, have very high risk, because in these surgical valves with externally mounted leaflets, there's nothing to constrain the leaflets, and the leaflets can extend all the way to the coronary. The stentless is a little bit less, but the lowest risk for coronary obstruction are stented valves with internally mounted leaflets, which are often the most commonly used valves, such as the CE valves or the Medtronic valves. So when you're assessing the risk for coronary obstruction, you're basically, the easiest way, and I'll go through some examples in 3 Mencio, is to sort of put a virtual valve. Here's, this is from Danny DeVere and Philip Blanque in Vancouver. And basically, here's a surgical valve by these gray lines. You put a simulated TAVI device, and then you measure the distance from that simulated TAVI device to the coronary. Now, some of these, if it's centered, sometimes depending on the angle and horizontal aorta, the valve may deploy canted. And so there's a lot of variability, and sometimes it's hard to predict. In this same patient, if the valve is canted, the VTC might not be as good as it was before. But in narrow sinuses, is clearly going to be obstructive, and there's a bunch of anatomic features that predispose risk for coronary obstruction. And there's anatomic ones, such as we talked about with the low coronary takeoff, narrow STJ, a narrow sinus of Valsalva, patients with prior root repairs. But then there's also the valve itself. As I said, mitral flow and trifecta with the externally mounted leaflets are the highest risk. The lowest risk are porcine valves because the leaflet height is shorter. Patients with bulky degenerative valve disease are probably at higher risk. So there's a lot of different factors you have to consider. So when you're screening, there's different ways to do it. An aortogram in a patient like this there's no risk of coronary obstruction here. You put a TAVI device in, clearly there's enough room. But the real screening is done on CT, as I said, and you can measure the heights to the coronary arteries. But in reality, what we do is that a virtual valve, right? And this is an example of several CTs. You put this red circle represents the virtual valve. And as you put the virtual valve in, you come up to the coronary arteries and you measure the distance from the virtual valve to the coronary arteries. Here it's low at 2, here it's high at 9, here it's low at 2. Now, this is exaggerated. And so this is not correct. And that's one of the things. So the SAPIEN valve, if you put a SAPIEN or core valve inside, this is a surgical valve with internally mounted leaflets. So the SAPIEN valve is going to sit here. So this VTC is not measured correctly. It's going to be bigger. It's going to be 4 because the valve is likely not going to expand fully because that's going to be constrained by the surgical stent frame. But initial analysis presented from the VIVIT registry, VTC of 4, anything above that was relatively low risk for coronary obstruction. But as I said, there are these valves such as the 3F valve, the mitral flow, and the trifecta, where the leaflets are not constrained by the stented surgical frame. And so these leaflets can extend all the way out and they would be very high risk. So what do I do? In high-risk patients, I consider general anesthesia and TEE. I inject I consider BAV, although I don't like to do it in bioprosthetic valves, but sometimes I will to assess risk. And based on my pre- and interprocedural risk assessment, I either consider protective or preventive strategies. And protective is to wire and protect the left main with a stent, which we'll talk about, and preventive are the basilica. But what's key is after the procedure, you've got to verify normal flow in the coronary arteries. And whether it's a non-selective or selective angiogram, that's different. In a truly high-risk case, if the patient is not high risk for surgery, I don't do the case and I send the patient to surgery. You don't want to push the limits. And so just want to show a few case examples in the next 5-6 minutes. This is an 84-year-old woman who had a prior 21 Hancock valve who had her coronary arteries were although she was bypassed, there was not good flow from the grafts and they were still at risk and she had bioprosthetic valve failure. So this is an interesting case. So there's challenging left main anatomy. The left main was low. I think this is coming across funny. I apologize. The left main was low. And you see here the stent posts extend above the left main. It was very difficult to engage the left main. The grafts don't provide much flow to the circ. The lima is not that well defined. And even just sort of selective angiogram was difficult. And there was an osteal left main lesion. And so there's a lot of discussion. And the left main in this view doesn't look well, but we had Ivested. And so the issue is, this is a patient with left main disease, low left main, but also borderline left main disease that's not protected. So this is a Hancock, which is a porcine valve. And in a Hancock, porcine leaflets, generally, they're not going to come up to the frame. So it's lower risk for coronary obstruction because the leaflets are shorter and they're going to end around here. But the stent struts are tall. They're at 16 and they go above the coronary artery. That's why it's sort of difficult to sort of engage. And so in this patient, likely there's going to be enough room because the stented valve, the true ID is much smaller in this 29 Hancock. Whatever TAVR device, and we're going to use a core valve here, is not going to expand out. So it's likely not going to expand to the left main. But what was clear is based on the height of the coronary engagement afterwards was going to be difficult. And we were worried about the left main lesion, and trying to treat it after through a core valve was going to be difficult. And this was years ago, 5-6 years ago, before we were doing basilica. And so at that point, we decide to assess. So, and you see the core valve here, the porcine leaflets don't come to the top of the frame. The VTC was enough, but engagement was difficult and there was a left main lesion. So we elected to protect and likely fix the left main. But I'll show this as a case example because of how we generally always protect. So when you protect, we take a guide with side holes, a guide liner, wire the LAD, and we put a stent. Make sure you have an adequate ACT. If you're going to protect, I always place a stent, prior to valve deployment. It's hard to cross with a stent in an emergency. And if you're concerned enough, then go ahead and protect. I use a side hole guide to do aortograms during the TAVR. The reason being, I don't like a third axis for a pigtail. So my guide has side holes. I'm withdrawing the guide above. I'm not in the left main, and I can inject 6 for 10. And with the side holes, I get adequate angio if you do need it. I always use a guide liner for core valve, and I try to use supportive wires because the guide is pulled back, so there's a lot of wiggle room here. And so I use a guide liner, and what I do is when you use the guide liner, you want to make sure you're observing the interaction between the guide and the delivery system. When you're advancing the delivery system, you don't want the guide to be pushed in. So at deployment, I withdraw the guide back because I don't want it trapped and pushed into the left main. I keep the guide liner near where I need to be. In this case, we deployed the core valve most of the way, and we were going to stent the left main anyway because there was a LAD and a left main lesion. We pulled it back and did it. And you can do aortic. And the reason I use a side hole guide is in this case here, you can do aortograms and see what you need. When you're doing a core valve, always keep the guide liner down here, because if you don't want to deploy the stent or you have issues, the guide liner will preserve access. And that way you can just withdraw the guide liner. With a Sapien, I pull the guide liner and the guide back, and I don't keep it in there. So in this case, we deployed the stent. We then released the valve, and then we re-engaged the coronaries and post-dilated the stent, and the final result looked good. The mean gradient was still relatively high, 14 because of a small valve. Valve area is 1.2, but the patient did well. So the snorkel stent technique, as you talk about here, is good. It prevents acute occlusion resulting in shock. It's simple. You can do it with awake patients. But the cons are it may result in unnecessary stenting because occlusion is not always apparent. It may result in an under-deployed stent because you're crushed against the STJ. You need lifelong DAP. Coronary access can be difficult. Long-term results are unknown, and it doesn't prevent late events. So over the last several years, pioneered by a group at NIH and Adam Greenbaum and others, Danny DeVere, the Basilica approach was where you lacerate the leaflet was sort of created. The idea is go from the groin, perforate the leaflet in front of the coronary artery with a wire, snare it in the LV, create a loop, and then lacerate the leaflet. And the idea here is with leaflet laceration, you see here, you open up the cells and you get better flow. So case example here, 77-year-old woman with a 21 Paramount. We couldn't get a CTA because of renal failure, but distance on the non-con CT of about 3. What we see here is you have a snare in the LVOT from a separate guide catheter. Then using an AL3 with an Estado wire, we perforate the leaflet. We've done it using fluoroscopic NTE guidance here. This view here where two struts line up shows the coronary is on this side over here, the left coronary. The wire is snared in the LV, and then you create this loop and pull it back. And so you then denude a piece of the wire and you advance this kink in the wire, which you'll see coming up here in a second. You see it coming here. There's a kink here. And that kink is the wire has been scraped. And then, so that way when you apply electrocautery, it will go through and see here, we're doing applying electrocautery and we're pulling both guide catheters and lacerating the leaflet. The valve is then deployed, and you see here in this low left main flow is preserved. But it's not a perfect solution because we don't have commissural alignment with the TAVR device. Here, if you lacerate the leaflet and deploy the valve like this, that's ideal. But if you don't have commissural alignment and the commissures of the Sapien end up in front of the laceration, yes, you'll get flow around, but it's not ideal. So future delivery systems that allow for commissural alignment may allow for better optimal placement. Lastly, what about TAVI and TAVI? It's an increasing concern as TAVR patients are living longer and bioprosthetic valve failure becomes a concern. And there's additional concerns about obstruction from the frame. You see this core valve and core valve, there's a lot of metal and there's a long skirt because you have that neo skirt. The outer core valve leaflets create a long skirt. You put a Sapien, you get a shorter one. Sapien and Sapien again versus Sapien and core valve. This is an interesting analysis. And so showing, they looked at, if you create this neo skirt in a patient like this, you're going to have no flow because this is from here to here is an entire, essentially a covered stent. And so looking at that and other factors, they basically showed that if you do it at core valve first, there was a high risk of having impaired coronary access after a TAVI and TAVI, compared to if you did a Sapien first. And so these are early analysis, these are theoretical, but these are important concerns and help me dictate the first valve choice. So real quick, 1 minute, 76-year-old woman with a 23 millimeter S3 that failed at about 7 years. Sorry, I'm gonna go back one slide. Just pointed something. You see here, missing the slide with the CT analysis, I apologize. But the left coronary looked okay. The right, we were concerned and couldn't clear. There was this calcium at the STJ. We elected to protect the right, and there was an osteal lesion, and there was still reasonable flow after. So we did not deploy the stent. There was no AI. Mean grade was 13, DI 0.38, and the patient did well. This was the CT analysis before. This is why we were concerned, because the right coronary was here, and I think that's the reason we protected. Second example, 94 gentleman with a TAVR about 9 years ago, 23 Sapien, again, high risk for surgery. The left main, clearly you can access from above, so we weren't concerned. And so we elected to put a core valve in here and got a nice result. But we post-dilated because we didn't get good expansion of the core valve, 22 balloon, felt very comfortable because the coronaries came from above. Got a very nice result, mean gradient of 6, valve area 1.9, and trivial PVL. So basically, pre and procedural guidance are helpful to predict the risk of coronary occlusion. In patients at high risk, protection with the stent can avoid catastrophic complications. In emergency situations, the primary focus should be on hemodynamic support. So if you're not prepared, patient crashes, don't try to access the coronary, get them on ECMO, get them on support, and then try and revascularize. And techniques such as leaflet laceration with basilica may be a better approach to avoid coronary obstruction and preserve future coronary access. Thank you very much.
Dr. Kodari, thank you very much and congratulations for your excellent talk. It was really a very impressive presentation. These things are very difficult to be done surgically and openly, and we are still very impressed of how you can do it only with the imaging facilities, and we're very impressed, the surgeons. There are only one question I want to address to you. You said that there are very difficulties that you have according to the type of valves that have been implanted preoperatively, surgically. Does this only apply to the type of the valve or also to the size of the valve that has been previously implanted? And do you have any special difficulties with these new generation valves, the Perceval, the sutureless valves that mimic a lot the TAVI procedures? Thank you very much again.
Sure. Yeah, several thoughts on that. The type and size obviously do matter. The type of valve, with the type of where the leaflets are mounted make a difference. The size makes a difference though. If you have a huge sinus and there's a 23 valve, you're not going to obstruct. Most of the valves that we're using surgically now at our institution are the Inspiris from Edwards, which is sort of designed to expand. And because part of the challenge is these surgical frames, if you don't fracture, you don't get good expansion of the Sapien. The Inspiris is designed to expand. Right now, we are fracturing all of the surgical valves before we implant the TAVR, whether it's a Sapien or core valve, to get better expansion. The Perceval is interesting because there aren't really sutures. So the leak, if you missize a Perceval, I don't think a core valve works well. So we've done Sapiens inside of a Perceval because it doesn't have a lot of radial strength, and so you can expand it and oppose to it. You can't plug a leak in a Perceval. I tried that once because there was a leak and I tried to do a PVL with a plug, and all I did was I kept extending where the leak was because until the suture line. So I ended up putting 2-3 plugs without great result. So if you have a paravalve or a leak with the Perceval, I would also do a valve and valve. with the Edwards system, with the where you expand the stent skirt with the balloon, that's different. That you can plug, and that you can do a regular valve in valve.
All right. Thank you very much.
Thank you.
Thank you.
Take care. Thank you.
And we can go further now. And I would ask Professor Toutzouzas to introduce Dr. Velianou, please.
Thank you very much. We continue this very interesting roundtable. I would like to introduce you Dr. Velianou, who is an interventional cardiologist from McMaster University, Ontario, Canada, and he will addressing us the modes of failure of valves and sizing issues for TAVI in SAV and TAVI in TAVI. Thank you for your participation. We are looking forward to hear you.
Thank you very much, everyone, and it's a great honor to be here with you, and hopefully next year we'll be all together in Athens. I have no conflicts to present here, except for Edward, sorry, I am a proctor with him. Okay. So is the durability of a valve important? Well, it depends on the patient you ask. An elderly patient, durability of a TAVI valve is not that important. If they're 85 years old, most likely the valve will outlast them. And if not, we can always consider doing another valve in valve if they've been selected appropriately. A 75-year-old may care a bit more, of course, because their lifespan is going to be a bit longer. They have many more years, but still, TAVI valve should do them well for at least a decade. Now, the tricky part now is when it comes into the younger patients. And although we have data on low-risk patients, patients who are young, we really have to think about not just doing the valve, but also the repeatability of the valve. And if we feel that the patient is in good health and may live longer, then potentially we have to consider surgery for these patients. We know over the years, depending on what studies we've read and also what we've accomplished, initially, very extreme risk patients were treated, but as the evidence came out, lower and lower risk patients. But along with these lower risk patients, they're lower risk much due to their age. And because of that, the expectation is that this valve has to last longer. The life expectancy of these people who are having a TAVI valve is much longer. And this is a slide taken from Rodrigo Begur. And you can see that, again, we should be looking at what is the expectation of someone to live to make decisions on how we do valves. And again, someone who is younger, we have to be a bit more careful with the valve we decide to put in, whether it's surgical or a TAVI valve. And even a TAVI valve, is it repeatable? So very important to review those on CT. And we know that bioprosthetic valves, the Achilles heel of them is dysfunction. A normal bioprosthetic valve, be it a TAVI valve or a surgical valve, works very well initially, most of the times, but it can go through structural deterioration, whether it's calcification of leaflet, tearing of the leaflet, valve seam disruption, stent fracture. But it also depends on how it interacts with the patient. So again, the in vivo and in vitro are two different things. We know leaflet thrombosis, endocarditis, patient valve mismatch, and paravalvular leak can disrupt these valves, and they can definitely last less longer because of that. Here are evidence of different bioprosthetic valve failures. You can see whether it's pannus, thrombus, calcification, usually ending up in aortic stenosis, or aortic regurgitation caused by wear and tear, depending what type of valve, where they are, and also endocarditis, which unfortunately still can happen to a few patients. And here's another extreme calcification of a valve that has failed. And it's a wonder that we do these with the success rates that we have when you see this. It's very important that we speak the same language when these valves deteriorate. So structural valve deterioration, whether you go by Vivid or the European classifications, basically stage 1, 2, and 3, where they are affected. And many patients by 5 years or so will start having some degree of valve deterioration. But in most cases, this is not an issue. We've all seen patients last over 20 years
with bioprosthetic valves, and testament to the surgeons who've placed them in properly, sized them well, and again, the patient's looking after these valves. But definitely, as they go ahead and deteriorate, we have to keep a close eye on them to be ready to intervene. And along with structural valve deterioration, we have to look at the total bioprosthetic valve dysfunction, which is not just the valve itself, but again, endocarditis, thrombosis, and non-structural valve dysfunction. So again, this is important on our non-interventional colleagues, who are the ones who are carrying out surveillance on these patients to ensure that we know what is happening with these valves and to intervene when appropriate. So what's important with the valve deterioration? Well, when you ask physicians and industry endpoints and studies, often because of power implications, we look at valve deteriorating as opposed to hard endpoints when we're testing these valves. And there's a gradation for morphologic leaflet abnormalities, and we'll see that sometimes even when we do CTs for follow-up with HALT and things like that on the valves, to moderate hemodynamic dysfunction to severe hemodynamic dysfunction. By the time they hit severe hemodynamic dysfunction, usually they are affecting patients. But ultimately, the patient doesn't care about all these nomenclature. That what they care about, do they die? Do they have a reoperation? And are they symptomatic? So again, we have to ensure when we're speaking with our patients, they understand what's going on, and not to scare them needlessly when we see the valve deteriorating, but to prepare them. The bioprosthetic valve and TAVI durability. Well, there's a lot of studies, all registry studies carried out by surgical groups internationally, which show excellent results with bioprosthetic surgically placed valves. And but you start seeing by 5 to 10 years, there is some type of structural valve deterioration. And greater than 10 years, you will see it in 30 to 50% of patients. It does not mean the valve is not working. It does not mean that the patient is symptomatic, but definitely after 10 years, people have to have proper surveillance to ensure that things are caught. And when you look at overall results at a decade, and this is a single center study, you see that surgical prosthesis do very well, with almost 95% still working satisfactorily at a decade. And this is what we tell our patients when they get a bioprosthetic valve generally, and we can be assured that this is actually the case. We have been burnt in the past with certain valves because often valves are changed a bit or use the same process, but for whatever reason, they don't seem to last as long. But by and large, most bioprosthetic valves have done very well. Now, a TAVI valve, will it fail sooner? Well, many people say yes. TAVI valves, the leaflets are thinner. Again, that's the nature of them being prepared and crimped or placed inside a valve ready to go. The leaflets are subjected to higher stresses and strains. Again, crimping is required. There may be more paravalvular leakage, and the duration, when you actually look at in vitro, in vivo models, you see that they don't seem to work as well. But again, when the cycling tests that have been done, again, a decade should not be out of the question for a TAVI valve. But a lot of people believe that because a TAVI valve may have less patient prosthetic mismatch, that they may last longer, generally larger aortic valve areas, and the TAVI valves, again, are improving. We've also noticed with studies throughout the years, the more recent studies, that the surgeons are doing a better job by placing bigger valves in place using root enlargements and other techniques. So this may not even be a benefit in TAVI compared to surgical valves as surgeons become more comfortable doing this on a widespread scale. When you actually look at studies for TAVI valves, and again, the patients that were replacing TAVI valves a decade ago were sick patients with other comorbidities. So it's very hard to get long-term data. I still have a couple of patients that I follow that have had it for a decade, and the valve is working fine. But many of them placed a decade ago have since died because of these comorbidities. But at least at 6 to 8 years, you're seeing about 3.7% biosthetic valve failure, which is excellent. So again, the valves seem to be doing the job and seem to be prepared well. Only time will tell how they will do in the next 5 to 10 years. A lot of people will argue that there is a difference with self-expanding versus balloon expanded valves. Now, looking at the CHOICE study, when you see the numbers involved, you're talking about 21 patients in each study reviewing all this. So there doesn't seem to be much difference, although certain things may come out on top for a self-expanding valve and certain things may come up on top for a balloon expandable valve, but it's still too early. And unfortunately, unless these studies are done head to head, it's very difficult to compare them because often they're placed in different types of patients and also different expertise. There are centers that are more geared towards self-expanding valves, and there's other centers geared more to balloon expandable valves. So how do we select for interventions? Well, when you actually look at the TVT registry, STS registry, in the early days of TAVR, you could see that valve-in-valve and TAVI immediately during TAVI, or redo TAVI, were fairly equal. But as time goes ahead, you see that we've jumped to, in the US at least, over 4,500 patients having a TAVI in a bioprosthetic valve, and only about 208 having them in a TAVR valve. So technique is getting better, the valves are getting better, and you can see that, again, with even with the expansion of TAVI across the US, things have gone quite well from that point of view. So they only make up a small number, the TAVI and TAVI patients, so very difficult to take any conclusions from this. Again, this is seen by the redo TAVI. It's basically a registry of over 60,000 patients. And looking at the consecutive TAVI and TAVI population, which only comprised of 0.68% in total, half of them being the bailout procedures during the TAVI, and the other half occurring after. And then when you see some were done within a year, that may have been maybe improper sizing or some other type of failure. I've never really seen this less than a year. And others are greater than a year, and for a number of reasons, the normal things that go ahead with valves. But when you actually look at the numbers, very small numbers of redo TAVI and TAVI. So we don't have much information on this at this time. When you look at the gradients of TAVI and TAVI versus TAVI and SAVR, generally a bit better, at least in the registry, compared to other registries and studies. And again, the lower profile TAVI valve, it should be able to have a better result. Much of these other results may have happened before fracking era. Again, thinking of trying to get the best possible hemodynamic result is very important. And redo TAVI seems quite doable with excellent gradients. Now, when you look at outcomes of a registry led by John Webb, and a few people speaking at the Athens course are on this paper as well. When you look at valve-in-valve and transcatheter aortic valve replacement for degenerated bioprosthesis, again, this is a registry, excluded small SAVR valves. It was a SAPIEN XT valve, mean age 79. So these are relatively high-risk patients still. You see that the gradients are acceptable. Mean gradient of mean gradient of 16 afterwards. That means there were some patients who had gradients of over 20. And the valve area of 1.2, again at 3 years, it may be acceptable in some patients, but that means there's some patients that had valve areas that are much smaller. There's no doubt patient prosthetic mismatch is probably a problem. And again, during this registry, many patients probably did not have fracking and had other advanced techniques to try and improve things. And the one thing that you see the quality of life in C has improved, which is good. But when you look at 3-year follow-up, the mortality rate is quite high, all-cause death or cardiac death. About a third of the patients are not around. So was that because these patients were very high risk? Or is that because something inherently was bad about doing a TAVI in a bioprosthetic valve? And no one really knows that answer, quite frankly. The risk of stroke is not inconsequential, 6.2 over 3-year follow-up. So again, there may be some other issues. Again, is it the patient or is it the valve or the combination of both? And when you look at repeat aortic valve replacement, it's 2% very low. Looking at surgery, again, STS database and the STS score derived from that. So you're going to see this is a perfect, this is where the numbers are taken from, but the mortality rate at 30 days is about 4%. So for, again, an intermediate risk patient, this is what we've derived our definitions from, but surgery is quite acceptable in well-selected patients, and it shouldn't be discounted. And when you look at other registry and matched pair studies, this one from France, you see that when you compare, again, this is not an RCT, but when you compare patients between 1 and 2 years, there seems to be a crossover with MACE, and the surgical valves or the reduced surgery tends to do better. So again, this is not a randomized controlled trial, but this is something to consider. So young patients, should we be placing a TAVI in a bioprosthetic valve, or should we be considering a redo? I think that's every center has to decide on their expertise and has to decide on patient risks and patients' wishes. So why the equivocal results in a TAVI valve? Is this underexpansion of the TAVI valve itself, crowding? Is this initial patient prosthetic mismatch? Often we try to do a valve in valve in a patient who already had some sense of patient prosthetic mismatch. And when you put in another valve in there, it's only going to get worse. Is there a loss of natural flow or backwashing of leaflets? Again, are these leaflets being flushed from potential thrombus and potential reasons for deteriorating early? Higher incidence of valve thrombosis. Most centers do anticoagulate these patients, valve-in-valve patients with warfarin or other DOACs. But again, we don't have good evidence from RCT studies, at least anything size. And is it patient issues as well? Again, infection or some patients seem to deteriorate their valves sooner than others. So we may take chances, but we shouldn't with our patients. That's a picture of me on the island of Chios, enjoying myself, and hopefully I'll be able to do that later this year. And but we need to do better. And final thoughts on this: we need to select our patients appropriately. Young patients who are acceptable surgical candidates, I think we have to really consider surgery, especially if they haven't had bypasses. Most surgeons will tell you that this is a fairly straightforward surgery, well-selected patients. We need impeccable CT imaging. We have to look at the amount of calcium, LVOT calcium, the VTC, coronary protection, things like that, to decide, should we do a valve-in-valve or should we do redo surgery even? And there are some patients we look at and we say, listen, we cannot frac this patient. We're concerned about this patient. Other advanced techniques, which were discussed earlier, basilica, again, having those in the toolbox if required. Appropriate device selection, balloon expandable versus self-expanding, and some of these smaller valves, self-expanding may have better gradients. Balloon expandable, very appropriate in most though. However, when in our center, when we're doing a valve-in-valve, we do careful pressure hemodynamics with 2 pigtails. There is a phenomenon of pressure recovery, and sometimes on echo, things look a lot worse than they actually are. So we look at this. If we get a good result, then we leave it alone. But most patients, we do some type of modification or fracking, again, if it allows it, to get even better hemodynamics. I think in the long term, this would be better for the device that we put in. So again, very important. And in the end, if when you do frac, try to go to at least the previous ID. So if it's a 23 valve and the ID is 21, you really have to get to at least 21, even more if there's more room. But if you can leave it at least as it was before, or even better, often we often do that. We get better results than the initial surgical results in terms of patient prosthetic mismatch. But again, being too aggressive, we can cause problems. So we have to know when to stop when we do that. And again, considering SAVR, I think it's very important that we involve our surgical colleagues in this. They have a lot of experience, and for the right patient, definitely SAVR is the right thing to do. And again, I think we have to use everyone's expertise when we do this. Our CT imaging, interventional cardiologists, anesthetists, cardiac surgeons. I'm a big believer of taking the best from everyone and coming up with a solution with the right patient. So I'll stop right there, and I will let you
Thank you very much, Dr. Velianou. It was very comprehensive analysis of valve-in-valve and valve-in-salve. But I would like, considering this long-term data that we have from the French registry regarding the valve-in-valve, TAVI and SALV, which patients would you consider that we should not proceed with TAV for valve-in-valve? By definition, we should give them to the surgeons.
You know, personally, I worry about the younger patients that are very acceptable surgical risks. I think someone below 65, if they haven't had a bypass and otherwise just a one sternotomy, I think we should consider it, especially if they're healthy, because I think, you know, to get 20 years out of that valve, a valve-in-valve, is probably asking too much. So I really would consider it in those patients. Or if there's any other issue, patient prosthetic mismatch, crowding, which you really don't believe you're going to get a good hemodynamic result, or subsequent patient prosthetic mismatch, especially in larger people, I think we should be calculating the possibility of patient prosthetic mismatch. So these patients should be considered for surgery. And of course, if people have other issues, whether it's surgical disease now with coronary artery disease, which they didn't have before, or even, again, from our center, Dr. Whitlock just published in New England Journal atrial fibrillation and left atrial appendage occlusion. So they have atrial fibrillation plus some of these other issues. Maybe we should be considering this as well. But I think it's a gestalt. It's putting all the information together and deciding.
Just for the surgical valve, if it's if we have the leaflets outside the stent frame, would you consider it better candidate for surgeon or not?
Yes, but with the proviso, though, if we do proper CT assessment, we should be able to handle that. And again, using other advanced techniques, if their surgical risk is very high, other techniques such as basilica, then we should be considering that. And Danny will be speaking next, and he's one of the world's experts in this. But again, putting these all together and then deciding with the patient is the best way to go, I think.
Okay, thank you very much. Unless there is no other question, I'll give to Dr. Tredafilou the podium in order to introduce the next speaker. Thank you.
Good evening from me as well. It's my pleasure to introduce the next speaker, who has a major contribution to the field, Dr. Danny Dvir, who will speak about device selection considerations for TAVI in SAVR and TAVI in TAVI. A very interesting topic. Dr. Dvir.
Thank you so much. Do you hear me well?
Yes.
This is a great pleasure to present here, and I'll say the last two presentations were really superb and great introduction to my presentation. So I'll try to focus on the challenges and issues with the TAVI valve-in-valve procedures, both in surgical valves and in TAVR devices, and to discuss what are the considerations in device selection within these. Just briefly, it's clear that we have entered the tissue valve era. The previous speaker spoke about it, and this is clear to all. It's about 95% of devices that we use that are implanted in surgery, and all TAVR devices are bioprosthetic valves. And they are very different, right? They have different morphologies, different leaflets, different designs. They have one thing that they all share. They are all prone for structural valve degeneration. And since they are prone for structural valve degeneration, we will see some kind of pandemia of patients with failed bioprosthetic valves. I don't want to discuss again things that were discussed in the previous session, but it is clear that we will see more and more patients coming back with failed bioprosthetic valves, especially when patients live longer and we implant these valves in younger patients. Younger patients tend to have higher risk of structural valve degeneration, and they also live longer. And therefore, we will see many patients with bioprosthetic valves coming back. And it is clear to all of us that a TAVR in these patients is very appealing, because many of these patients are high risk for open heart surgery, either because they had surgery before, all of the surgically implanted valves, or when they had TAVR before. Many of these patients have many comorbidities. This is why they got TAVR at first place. And clearly, valve-in-valve is appealing. When we look at results of TAVI valve-in-valve, I must say that we have many challenges because this is a very heterogeneous group of procedures, many different surgical valves, many different bioprosthetic valves failing, TAVR or surgical valves, and between them there are many different combinations and many different valves implanted inside them, many different TAVR devices implanted. These are the most common valves across the years that were used for TAVI valve-in-valve, but there were so many before. So you can understand why it is very challenging to really understand what are the results of TAVR valve-in-valve procedures. But in general, we can say that many things are great, many things are better even than conventional TAVR, and other things are not as good. It is clear that aortic regurgitation, for instance, is much less common after TAVR valve-in-valve than in TAVR in native. We also have less conduction defects. We have less annular injury. There is some protection by the failed bioprosthetic valve that is sitting in the aortic root. It enables some protection. But we have issues. One of the issues, the main issues that we have is the fact that we do not have room. There is not a lot of space in the aortic root to enable expansion of the newly implanted device. And we saw it in the original publications of the Vivid Registry. This is almost a decade ago, published in JAMA. We saw that small surgical valves and stenotic surgical valves were associated with higher mortality. It's very difficult to replicate this data nowadays because not as many patients die 1 year after TAVI, but we still see the same trend. Small and stenotic surgical valves are not as good for TAVR valve-in-valve, although these patients feel well. In general, after TAVI valve-in-valve, this is data coming from the partner study, KCCQ score increasing more than 30 points. This is amazingly good. A 6-minute walk test, dramatic improvement. So patients do feel well, but we leave them with some kind of suboptimal hemodynamic result. Here is some data coming from the TVT registry showing the comparison between TAVR in native and TAVR valve-in-valve. I'll make it short. The results of TAVR valve-in-valve, when we look especially at the short-term outcomes, are even better than TAVR in native. Even after we match the population of TAVR in native that is a bit older than TAVR valve-in-valve. But we still see some issues with TAVR that are more specific for TAVR valve-in-valve. Malpositioning is not as common in the past, but we still have some malpositioning issues, especially when we talk about TAVR in specific failed bioprosthetic valves, like stented surgical valves, especially stented with isolated aortic regurgitation. Coronary obstruction was discussed by Sushil in a great presentation. I can say that coronary obstruction is still here. We thought that coronary obstruction will decrease over the years, but still 2 to 3% of valve-in-valve procedures, even in new registries and new cases in the last year or two, still cases with coronary obstruction. And when you have coronary obstruction, this is very, very bad, 50% mortality. And obviously, the Achilles heel of TAVR valve-in-valve, residual stenosis. Residual stenosis is a common bad issue of TAVR valve-in-valve. Here is a case that finished with mean gradient of 48 millimeter mercury. We do have a technical consideration, things that we can do in the cath lab to prevent residual stenosis. We'll discuss them. But clearly, residual stenosis is a major issue. It is relatively common. You can see that many of the dots here, y-axis is post-procedural mean gradients, have mean gradient above 20. We discussed in the previous presentation, mean gradient of about 16 in valve-in-valve procedures, but many cases have mean gradient above 20. Some cases finish with mean gradient above 40. We cannot accept a case that will finish with severe stenosis after valve-in-valve. Here you can see examples, graphs from the TVT registry. You can focus on, this is from balloon expandable valves implanted. This is from self-expanding valve implanted. The y-axis is mean gradient. You can see that if you use small devices, mainly in small surgical valves, you can see that many cases will finish with mean gradient above 20. And what are the risks? What are the parameters associated with PPM, prosthetic patient mismatch, after aortic valve-in-valve? We published it in many different papers, but clearly we can identify what are the cases at risk for residual stenosis. Basically, patients that started with significant stenosis, with small surgical valves, for some reason more in younger patients, and cases that didn't have BVF, didn't have a good preparation of the valve, and mainly stented valves and balloon expandable valves, especially balloon expandable valves are used in small surgical valves. Here you can see 5 examples of TAVR under expansion after aortic valve-in-valve causing significant stenosis. And we do have now bioprosthetic valve ring fracture that is amenable to prevent many of these issues. Unfortunately, it is associated with some safety considerations that could be discussed. When we talk about balloon expandable TAVR devices implanted during valve-in-valve, you can see in the y-axis, it's the mean gradient after the procedure, and the x-axis, it's the size of the device. It's clearly something that is related to the size of the original device that is failing, especially devices with true ID of 21 and below. Many of these have residual stenosis after the procedure. And if you want to select cases whether not to use a balloon expandable valve, to use another device, maybe that cutoff is a good one, true ID of 21 and below. One of the, maybe I'll skip this slide. One of the things to consider also is having severe prosthetic patient mismatch, PPM, of the device that is failing, PPM. PPM is not good for having a valve-in-valve procedure. We do these cases occasionally, not rarely, because there are many patients that finish the procedure with PPM, and we try to salvage them without having a redo operation, but they have higher mortality. It's clear. Severe PPM is not a good, these patients are not good candidates for valve-in-valve. They have higher mortality, both short and long term, and higher risk for residual stenosis, obviously. You see that also using sapiens inside patients with severe prosthetic patient mismatch is not a good advice. You would prefer to use something that has some supraannularity, obviously. And here is a list of correlates for residual stenosis after aortic valve-in-valve. These could be described as pre-procedural parameters, procedural parameters, and post-procedural parameters. There are many different reasons why a patient has significant stenosis after aortic valve-in-valve. It could also be post-procedural parameters like clinical thrombosis, like structural valve degeneration after implanting the valve, which we should not ignore. When we talk about technical consideration during valve-in-valve and relieving the risk for residual stenosis, we need to understand the implant depth phenomenon. Implanting the device high, having some supraannularity, will significantly decrease the risk of residual stenosis. And maybe I'll skip this slide. Here you can see examples of high implantation and low implantation. Basically, the low implantation is intra-annular position of the implanted leaflets. And you can see in diastole and in systole how different would the valve behave. It's clear that we must have some supraannularity, especially in small surgical valves, in order to preserve the valve function, to reduce the risk of stenosis, to prolong the durability of these devices. I must mention briefly the VIVA registry. Their study included only Evolute devices implanted for valve-in-valve procedures with many small surgical valves. Over 40% of these patients had surgical valves with IT below 20 millimeter. And basically, when you implant high, you can significantly reduce the risk of residual stenosis and maybe even improve patient survival over time and maybe reduce the risk for reoperation over time. I do not have the time to discuss that in full. Can we have some supraannularity with SAPIEN 3? Many people ask, and it is clear that we can. When SAPIEN 3 is implanted high, the risk for residual stenosis will decrease. So how should we implant these valves? Where should we position the central marker? Some operators like to use the top of the SAPIEN 3 to the top of the surgical valve method. Others use the central marker relationship to the bottom of the surgical valve. I'll make it very simple and clear. We saw that when you use the central marker as a marker for how to implant the valve, even also in valve, this is a better method. And also, you need to put the central marker very, very high. You need to put the bottom of the central marker at least 3, if not 6 millimeters above the bottom of the surgical valve in order to gain supraannularity. You face yourself with some risk of malpositioning, but this is the best way to reduce the risk of residual stenosis when you do SAPIEN 3 valve in valve. Briefly about BVF, bioprosthetic valve ring fracture. There are concerns with BVF, and clearly BVF is 2 different procedures. You can BVF or fracture the surgical valve before the valve in valve, and you can fracture the surgical valve after the valve in valve. And each of these approaches have specific limitations and considerations, but in general, BVF is a very effective method to reduce the risk for residual stenosis. However, it has some safety considerations. Clinical valve thrombosis after aortic valve in valve is also another concern that we have that is not discussed enough in scientific meetings, unfortunately. Clinical thrombosis, not only leaflet thickening. We see it in many of these cases. Some of these cases would be relieved with giving the patients anticoagulation. So it is possible that we may need to treat many of our patients after valve in valve for at least a short period of time with anticoagulation in order to prevent clinical valve thrombosis. Clinical valve thrombosis appears more commonly in specific surgical valves coming for valve in valve for some reason, in mosaics, in Hancocks. We don't know the reason why exactly. We have some theories. And when we talk about coronary obstruction, clearly this is I do not want to repeat Sushil's presentation. This is a bad complication associated with nearly 50% more early term mortality, more common with valve in valve procedures. We know now how to classify aortic roots. What are the cases at risk for coronary obstruction using VTC, VTSTJ? You can read about it in our different publications. VTC is a very, very accurate parameter to understand the risk for coronary obstruction. It's not the only parameter that can describe that risk, but it is a very helpful parameter to understand. We talked about stent protection to prevent coronary obstruction, and we talked about basilica technique, a transcatheter technique that enables by tearing the failed bioprosthetic valve leaflet prevents the risk for coronary obstruction. But now let me describe in one slide a new technique. It is shortcut. It is a new approach to prevent coronary obstruction. It's a dedicated device. I performed already 4 cases with 4 patients, 6 leaflets with that device. It enables a very quick and elegant basilica-like procedure without the challenges of going through the leaflet and wire electrification that we need to do. So a simple and easy to use basilica using shortcut. I can discuss that after the presentation. Other devices that that are used for valve in valve, like portico valve in valve, we do not have enough data to describe. We have a paper that we did matching between portico and core valve. We saw some cases with portico that had paravalvular leakage after valve in valve. It could be that these were operator-related issues in these cases. When we talk about accurate neo used for valve-in-valve procedures, there are also many things to discuss. But one thing that is important to understand is that the upper crown of the accurate neo, the position of the upper crown is very important. The upper crown must be above the post of the surgical valve. When the upper crown is below the top of the post of the surgical valve, the device does not expand well, and we saw many issues. Stentless surgical valves are treated in about 15% of valve-in-valve procedures. These cases are associated more with residual leakage and malpositioning, and also with coronary obstruction. More challenging procedures. Do not have the time to describe all of the challenges with these, but these are very interesting devices coming for procedures. We talked about briefly in the last presentation about Perceval. Perceval patients with Percevals coming more commonly now to valve-in-valve procedures. They are treated, it seems to be the optimal treatment of these would be with SAPIEN 3, and the results are actually quite good. Not a lot of residual stenosis and no coronary obstruction to date that I know of, at least in Perceval valve-in-valve. We talked also about TAV-in-TAV, having valve-in-valve in failed TAVR devices, and we described the redo TAVR registry. Basically, we see that residual stenosis is not as common with TAV-in-TAV as in TAV-in-SALV, but the risk for coronary obstruction is very concerning in TAV-in-TAV, especially when we talk about devices that have long leaflets that go above the STJ. So basically, before I finish, the clinical dilemma is clearly with patients that have relatively not so high risk for having reoperation, especially patients that had only one previous surgery and they are not very old. Many of these patients have intermediate-like risk for operation. Very few of them would have even low risk for redo SAVR. So what should we do with them? Should we send them to redo, or should we do valve-in-valve? My last slides are related to a recently published paper of Vivid Registry about long-term outcomes from TAVI in failed bioprosthetic valves, valve-in-valve procedures. This is the long-term survival that we saw, 38% in 8 years. We took only patients that had more than that were implanted more than 5 years before. When we compared the long-term survival of balloon and when we compared large and small bioprosthesis in these, we saw a higher mortality in small bioprosthetic valves coming for valve-in-valve. We saw higher mortality in unadjusted analysis in patients having small bioprosthesis implanted with a SAPIEN family of devices. And also when we looked up on a transfemoral access only, we saw a trend for higher mortality in small surgical valves treated with SAPIENs. This is unadjusted analysis. And these are the independent correlates for mortality after valve-in-valve, having a small valve, having an older age. These are significant parameters. And these are the correlates for re-intervention after valve-in-valve. Having balloon expandable valve, having malpositioning, having severe PPM of the failed valve, and younger age, these are the correlates for re-intervention. You can see higher intervention rate with balloon expandable valve in comparison to self-expandable valves in long-term evaluation after aortic valve-in-valve, and also higher rate for intervention in those with severe prosthetic patient mismatch. And you can read in our different publications on the different considerations in choosing the transcatheter heart valve features that are optimal for valve-in-valve. I do not have the time to describe that in full. Maybe I'll go to the essentials to remember from the presentation. This would be that the size of the original failed valve may influence long-term mortality, and we prefer large devices also in surgery and in TAVR in order to have more room later on to treat that device. But also the type of transcatheter heart valve may influence the need for intervention after aortic valve in valve. The supraannular THV position would be preferred in order to reduce the risk of residual stenosis and reduce the risk for intervention later on. It seems that operator decisions during the original tissue valve implantation and or during valve-in-valve procedure may influence meaningful clinical outcomes. Thank you very much for your attention.
We thank you, Dr. Dvir, for your excellent presentation, which covered all the in an excellent way the subject. I would like just to, without making any personal comment, I would like just to transfer the question from Dr. Arabadzis, which arrived for a specific scenario about if you think that small annulus less than 20 millimeters is better off treated for the first time by SAVR, implementing maybe aortic annulus enlargement, or if a TAVR because if a TAVR fails, then TAVI in annuli less than 23 millimeters might be a problem. What's your
So talking about a patient with severe AS of native valve that we see in CT small annulus, and we want to understand whether to send them to surgery or to TAVR in the original procedure. It's really related to the other comorbidities and considerations, and being good for TAVR, good femoral access, and my thought would be even after you have these considerations, it's still a borderline condition between TAVR and surgery. I would think about the next procedure. Would that TAVR be treated easily 10 years ahead when that TAVR fails? Like, are the sinuses also very, very small? Is the STJ very small? Because we would like to treat, obviously, these patients with very small annuli with a supraannular device, but would the supraannular device make them very challenging to treat later on when they fail? Would they need double basilica, for instance, in these cases? So you need to have and what is the expertise of your center with doing annular enlargement during surgery? If you have a center that is superb in doing annular enlargements, maybe these cases should go to open heart surgery. So it's a very complex question, but this is something that we think about every day.
Thank you for giving us a picture of the progress in the field and also the complexities that still remain to be resolved. And I pass to Dr. Dedelias for the final speaker.
Thank you very much. These are so excellent talks, very impressive presentations. There are so many questions to be answered. However, we're running out of time. Therefore, I would ask straightforward Dr. Markus Kassel, who is a consultant interventional cardiologist at the German Heart Center in Munich, to talk to us about the treatment of bicuspid valves with balloon expandable valves. Dr. Kassel, you may proceed. Thank you very much.
Here is Markus Kassel speaking from the University Hospital in Zurich, Switzerland. Thank you for your invitation. I want to speak about the main procedural steps in the treatment of bicuspid aortic valve using the balloon expandable SAPIEN 3 valve. I want to start with the Sievert classification. As you all know, Sievert made a distinction in between type 0 bicuspid valves with only 2 leaflets, type 1 with 3 leaflets and 1 raphe, and type 2 with 3 leaflets and 2 raphe. The most common type is Sievert type 1 with 88%, and most of them have a raphe in between left and right cusp. As we move in the future to more low-risk patients and younger patients, we will see more bicuspid valves, as 65% of patients are 60 years old or younger. The first challenge in the treatment of bicuspid valves is a precise CT sizing, especially in type 0 bicuspid valves who have only 2-inch points. A 3-dimensional alignment of the annulus plane is very difficult. An easy way is to bring the 2 inch points in one line and then rotate the transversal plane around this line, looking for an annulus plane with the smallest area. And this annulus plane with the smallest area is used then for the valve choice. Crossing of a bicuspid valve can be sometimes very difficult. Usually I take an L1 catheter and a normal straight wire. When I bring the straight wire towards the tip of the L1, it straightens the catheter and the tip goes more to the non-coronary cusp. And when I pull back the wire, the L1 has more a curve and then the tip goes more to the left coronary cusp. When I turn the catheter clockwise, it goes from non-coronary side towards left coronary side. When I turn the catheter counterclockwise, it goes from left coronary side to non-coronary side. In type 0 bicuspid valves, I start from the left cusp side and then I turn counterclockwise, and in small steps I look where the jet is, and there I usually can cross the valve, which is easier as in type 1 bicuspid valves. In type 1 bicuspid valves, I use the information from the CT because I know where the raphe is. And I start with the tip of the L1 at the single cusp, and then I go from the single cusp towards the cusp with the raphe. For example, when there is a raphe in between left and right cusp, I start from the non-coronary cusp, turn the catheter clockwise, and then on the way, I will cross the valve opening, and I can cross there. Here are 2 examples for valve crossing at a type 1 bicuspid valve. In a severe asymmetric calcified valve with a raphe in between right and left cusp. The arrow shows the valve opening at the root shot. I start in the non-coronary cusp with the L1 tip, and then I turn counterclockwise in small steps. I will find the opening in between non and the other 2 cusps. In B, there's a raphe in between right and non-coronary cusp shown here. In this situation, I start at the left coronary cusp. I turn then the catheter counterclockwise, and I will cross from the single cusp on the way to the cusp with the raphe. I will cross the valve opening and I can cross the valve here. Because CT sizing in bicuspid is more difficult, and also bicuspid valves are often very calcified. In most of my cases, I use in addition balloon sizing. I want to show you 2 examples of balloon sizing. The upper pictures show very asymmetric calcified type 1 bicuspid valve with a raphe in between right and left cusp and severe calcified non-coronary cusps. The mean annulus measurement was 30 millimeter. A 25 millimeter balloon was used for sizing, and you can see here the balloon was shifted because of the calcification at the non-coronary side completely to the left coronary cusp side. Because here is a high risk of annular injury at the left coronary cusp side, we decided to use a 29 valve with less filling volume, -2 milliliters. And in D, you can see the deployed SAPIEN 3 valve. the SAPIEN 3 is here also shifted towards the left coronary cusp side, we could achieve a good functional result, and we, in this case, we did not post-dilate the valve to avoid annulus complication. In the lower case, you see also a type 1 bicuspid valve with a raphe in between right and left cusp. Here the calcification is symmetric. The annulus size was measured with 24.4. We used a 23 balloon for sizing. The balloon here stays more in the middle. Because of the severe calcification, we underdeployed the valve also. You can see in picture I that the valve used not the complete space in the annulus. We decided then to post-dilate with nominal volume, and in the last picture you can see a good deployed SAPIEN valve and a good result. Here is our bicuspid valve treatment algorithm. I want to explain you the algorithm because of an example. So, for example, we measure an annulus of mean 23.5 millimeter. In this case, we would use a 23 millimeter balloon for sizing. As you see in this picture, there's a lot of calcification and the balloon shifts to one side, to the non-coronary cusp side. Here's now the question, which valve, SAPIEN 3 valve size is the better one, the 23 or the 26 millimeter valve? On the left side, you see the example of a 26 millimeter valve, because the valve will be mostly not complete deployed in this situation. You have to place the valve a bit higher because it's then also not complete foreshortened. And in this case, we would underfill the deployment balloon with -2 milliliter first and observe then how is the implantation result. When there is still space in the annulus, we would then post-dilate with nominal volume or perhaps even overstretch the valve. If we use on the right side a 23 millimeter valve, the 23 millimeter valve will be more foreshortened, so we have to place the valve a bit more towards the ventricle. Here we would start with nominal filling volume, and when there is still space after implantation in the annulus, we would post-dilate with 2 additional milliliters of volume. I want to show you a special balloon post-dilatation technique. So instead, placement of the balloon for post-dilatation centered in the valve, you can place the balloon towards the ventricle or towards the aorta. When you place the balloon more towards the ventricle, you make a dilatation of the SAPIEN 3 inflow, and this is very useful when you want to get to a better sealing of the valve, but when you want to avoid to give too much pressure on a very calcified annulus. Or you can place the balloon more towards the aorta. This is very useful when you treat very big annuluses and when you want to make sure that the valve is good anchored, or when you treat, for example, not severe calcified insufficient valves, you flare the outflow and you have then a much better anchoring of the SAPIEN valve. The last 2 pictures are examples for bicuspid treatments. Here, treatment of a type 0 bicuspid valve with a mean annulus diameter of 29 millimeter. Here's the implantation view. I used an AL1 and a normal straight wire for crossing. I started at the left coronary cusp side, turned counterclockwise. Then we did balloon sizing with a 25 millimeter balloon. The balloon is much smaller than the annulus, but it stays very in the center. We decided for 29 millimeter valve with 2 milliliter additional volumes. We aligned the valve frame when it was undeployed to make sure that it is coaxial. And here you see the implantation with 2 additional milliliters of volume. In all bicuspid valves, we try to place the valve high. Optimal is 90-10, because most valves, they have very long leaflets, and sometimes you can have valve overlap. And here a very good final functional result. Finally, an example of a type 1 bicuspid valve treatment. It was a raphe in between non and right cusp. The annulus mean diameter was 24.8. We decided for balloon sizing with a 23 millimeter balloon. The balloon looked big in the root, and we saw there was a lot of calcification in left cusp, but that did not occlude the left coronary artery. We decided here for a 26 millimeter valve with 2 milliliter less volume. As the valve is predicted under deployed, we placed it a bit higher. After deployment, the valve frame of the SAPIEN 3 was not complete deployed, and there was still space in the annulus. We decided for post-dilatation with a nominal volume, and could achieve then a very good final result. This is our last slide. Thank you for your attention.
Thank you very much, Dr. Kassel, for your presentation. And thank you all for being here and share your excellent experiences with us. Let's hope that next year this meeting will take part live here in Athens while the weather is excellent, as well as in Ontario, in Toronto, and other places of the planet, of the world. But now it's time to pass on to the next very interesting roundtable. And please, I would like to welcome you all and ask you to stay tuned. Thank you very much. Thank you.
Alexioton Torres.
Good afternoon. I'm Alex Dimas. On behalf of the moderators, Dr. Zacharoulis and Dr. Jace, I would like to welcome you to the next session entitled TAVI Complications, Management and Prevention. Avoidance of complications is fundamental in any interventional procedure, but acquires greater significance as TAVI is being applied to a wider and younger patient population. A distinguished group of speakers has been assembled to address the issues. I would like to ask Dr. Zaharoulis to introduce the first talk. Dr. Zaharoulis, please.
Good afternoon from me too. It's with a great deal of pleasure that I will present our next speaker. It's Dr. Felipe Barrault. He's the head of cardiology research and research chair in valvular heart disease at Laval University in Quebec. He's a very well-known cardiologist for his work in aortic stenosis and TAVI, and also he's a very capable, as I hear, rock climber. So he's going to help us ascend the mountain of data that have accumulated. Hello?
Yeah, can you hear me?
Yes, I do.
Okay, good. Can you see my slides?
Yes, we do. Yes, we do. And we are all ears. Please.
Okay, thank you very much. Thanks for having me. It's a great pleasure and honor to present at your meeting on this important topic, which is paravalvular leak. So I do have some disclosure before getting started. The most important one is that we are the core lab for the echo core lab for some of the major trials in the field of TAVR. So paravalvular leak or paravalvular regurgitation has been and is still, I mean, one of the Achilles heel of the TAVR. We know that it has improved dramatically in the past years, but it may still be an issue. And we know from the early trials, you know, Partner 1, the core valve pivotal trial, Partner 2, that when you have moderate or severe PVL, mortality increases by 2 or 3-fold. And this is systematic, you know, trial after trial. And with regard to mild PVL, well, it may vary depending on the studies. So you have some meta-analysis, especially this one that was published several years ago already. But you see that, again, when you have moderate or severe PVL after TAVR, it is associated with 2 to 3-fold increase in mortality. So this is an important impact. And the controversy or the uncertainty is more around mild PVL. You know, mild PVL, of course, is frequent following TAVI, even nowadays. And there are some studies suggesting that it might be associated with an impact on outcomes with a 1.226 increase in mortality, for example, in this meta-analysis. But this is not consistent from one study to the other. And this might be because the impact of PVL is not equivalent in all patients. In other words, a moderate PVL may be relatively well tolerated in some patients who already have transvalvular native AR. So this is what we showed, you know, in our institution several years ago. If you concentrate on the dark blue curve here, these are patients who had moderate PVL after TAVR, but they already had moderate AR of the native valve before TAVR. And so they are, let's say, acclimatized. They are preconditioned to AR. And so this is like chronic AR and has no impact on outcomes. However, if you have a new onset of moderate paravalvular AR, so in patients with severe AS who had no AR, were not prepared for volume overload, an acute moderate or severe paravalvular AR has a very important impact on outcomes. So one of the messages is that a moderate PVR may be relatively well tolerated in some patients, but on the other hand, vice versa, only a mild PVL may be harmful, potentially in patients with pure AS, severe concentric LV hypertrophy, advanced diastolic dysfunction. These patients, even a 20 ml regurgitation volume may have detrimental impact. So that's an important point to keep in mind. I would like to share with you a recent pooled analysis of the Partner 2 trial that we did. So we pulled together the TAVR arm of the Partner 2A, which is an intermediate risk trial, as you know. And we also put together the TAVR S3 registry. So we have all the TAVR with XT or S3. And what you see again here, when you have moderate or severe PVL, blue curve, mortality is multiplied by 2. This is all-cause death at 2 years. However, in this trial, with a quite large number of patients, on average, doesn't mean that it is always the case in the individual patient, but you have patients with mild PVL had similar outcomes, similar survival compared to non-trace, at least up to 2 years. And what we also found in this analysis, because, okay, we have an impact of PVL, of moderate PVL on outcomes and clinical outcomes, but is it a marker for other comorbidities or risk factors, or is it a true contributor to the heart failure and mortality? Well, we look at the impact on LV remodeling, and yes, when you have moderate or severe PVL, it is associated with dilation of the left ventricle during follow-up and the deterioration in LVEF, and this was associated with increased cause of all-cause mortality and heart failure rehospitalization. So the good news is that with the newer generation of transcatheter valve, the SAPIEN 3 in the SAPIEN family, the Evolut R or Evolut Pro in the core valve family, let's say, we have seen a dramatic decrease in the incidence and severity of PVL. Look at it with the SAPIEN 3. This is the data on the left with the SAPIEN and SAPIEN XT, and then with the SAPIEN 3, we've seen major reduction in the PVL. And these are the results, the echocardiographic results of the PARTNER 3 trial, where we used, of course, the SAPIEN 3. And this is maybe the first trial randomized trial, where there was no longer significant difference in the incidence of moderate or severe PVL between the TAVR and the SAVR arm. This was very low rates in both arms. We have a rate of moderate or severe PVL less than 1%, and not significantly different from SAVR. However, the incidence of mild PVL was still much more frequent following TAVR versus SAVR. The other thing that we saw in the PARTNER 3 trial is that the impact of PVL, well, if you look moderate or severe PVL, like the pink, let's say salmon color curve, was associated numerically with higher rate of moderate or severe PVL, but this was not statistically significant, essentially because there are so few patients, only 4 in this, fortunately, in this moderate or severe PVL. But we'll still have, of course, to continue to follow the patient and see, for example, if the mild PVL, which appears to be overlapped and even a bit lower than non-trace, will eventually increase in the future in terms of a rate of death, stroke, or rehospitalization. Here, this is the primary endpoint that I'm showing here for the PARTNER 3 trial. So now, maybe a matter of concern when we saw this is here, so I just saw PARTNER 3. Now we one step back, PARTNER 2A, intermediate risk trial, and this is the 5-year data that we reported 2 years ago in New England Journal of Medicine. And what you see is here first the curve for surgery. This is the primary endpoint of death or disabling stroke. And now you have the curve for TAVR. And you see that there is a crossing of the curves. So initially, the outcomes, the rate of the primary endpoint appears lower during the first 2 years compared to surgery. But around 2.5, 3 years, there is a kind of not only the two curves merge together, but seems to be a crossing. And when we did a landmark analysis, well, with a landmark analysis at 2 years, well, before, in the first 2 years, there was a trend for superiority of TAVR versus surgery. But after 2 years, TAVI become inferior to surgery with higher rate of the primary endpoint. And you may say, why? Well, maybe it's because PVL. Because remember, the PARTNER 2A was done with the second generation of SAPIEN, the SAPIEN XT, that has higher rate of PVL compared to the SAPIEN 3. And indeed, you see the mortality curves according to the severity of PVL in the TAVR XT arm of PARTNER 2A. And first, bad news, I would say, is that the patients with moderate or severe PVL, at 5 years, 65% had died. And the other bad news is that you look at the mild PVL and it looks very superimposed with the non-trace up to 2 to 3 years, and then after start to diverge. And at 5 years, it's not significant, but there is a trend, a strong trend for higher mortality in this mild versus non-trace PVL. So I think, you know, this is maybe a matter for concern that the mild PVL may have an impact in the longer term. The other thing that I would like to emphasize is that the moderate severe PVL in the PARTNER 2A trial, very few were treated or delayed reintervention, which is intriguing, maybe because the people were well less aware of the adverse impact of PVL. So with the new generation of transcatheter valve, we've been able to reduce the incidence of paravalvular leak. Nonetheless, there is still a substantial incidence of mild, and in some hostile anatomy, you may have a moderate severe PVL, even if you have, you know, the best valve, best technique, best sizing, and best positioning. So how do we manage paravalvular leak? First, during the TAVR procedure. This is an example of a self-expanding. So this is a core valve 29 millimeter that was implanted initially, and at the angio control, then after you see clearly that there is some leak. We look at TEE. At the time we had the TEE, and this was a patient done under general anesthesia, and we see a major leak, you know, anteriorly, and as well as some significant MR, as you may have seen. And so what we did, the first correction procedure that we may consider is, of course, the balloon post-dilation. This is the first line when you have a PVL, and balloon post-dilation is one of the methods we can use to reduce PVL. With the newer generation and all the things we've learned about sizing, etc., we do less and less post-dilation, but still. And indeed, there are several studies that are listed here that have shown that when you do balloon post-dilation, this is efficient to reduce the degree of paravalvular regurgitation and sometimes eliminate during the procedure. There is, of course, a price to pay, and balloon post-dilation has been associated with a 1.5 to 2.5 increase in the risk of cerebrovascular events, especially early, so within the next few days. Of course, this is not necessarily an independent association, because patients who undergo balloon post-dilation often have, you know, worse risk profile, more valvular and annulus calcification. So if you adjust for all these factors, the independent impact of balloon post-dilation is much less. But still, you know, when you do an additional procedure, you often have also an increase in the risk of detaching debris, etc., and cerebrovascular events. So following post-dilation in this patient, unfortunately, as you see both on angio and TEE, there was still some residual important, at least moderate, if not more, paravalvular leak. So the next step is to do then a valve-in-valve. So we use a SAPIEN 3 for this that we implanted within the core valve using a lower position so that the cuff or the skirt of the SAPIEN 3 will be just below the apical border of the stent of the core valve to be able to do the sealing, if you will, and this worked. Finally, there was some residual trace or mild PVL after this second corrective procedure. And this is a good opportunity for me to show maybe the potential utility of the closure time ADP, which is a blood biomarkers, which is in fact a marker for the multimerization of the von Willebrand factor. And that has been shown in this paper by Eric Van Bell in New England Journal of Medicine to be a good marker of residual PVL. So typically when you have severe AS, the CT-ADP will be high. If you have a successful TAVR with no residual PVL, you will have a correction of the CT-ADP, and the CT-ADP will fall below 180 seconds. However, if you have residual PVL, you see here, it remains high. So this tells you, this is a red flag. You know, if the CT-ADP that you can measure real time in the cath lab with this analyzer can tell you that there is some significant PVL. And this is the case I showed you, you know. at the beginning of the procedure high because of the CVAS. After initial deployment, it was very high still because of the important PVL. Then after the post-dilation, the first corrective procedure, there was some reduction, but still abnormally high. And then it's only after the valve-in-valve, when we corrected the PVL, that the CT-ADP fell below 182nd. And then at discharge was further reduced. The other method that you can use is the this invasive AR index when it is below 25%. For those who prefer more invasive method, it is a marker for moderate or severe PVL. So this is when you have, I think, when you have any degree of AR at the time of the procedure, shown on the transthoracic echo that we use more and more now under conscious sedation, or an AR index invasive less than 25%, or CT-ADP more than 182nd, I think we should not hesitate to have more profound sedation or go to GA and have a look up with TEE. If with TEE you have trace AR, you could say, okay, fine. If it's moderate or severe, definitely you need to do a corrective procedure. If it's mild, this is where risk-benefit ratio comes into play. You have to assess, the potential risk for example, for annulus rupture if you do a balloon postulation, if it's a patient with an unfavorable anatomy. So I will go fast on this other aspect, which is what to do after TAVR procedure. So this is an interesting case. This is a case TAVR with a SAPIEN 3, but this patient had a balloon postulation at the time of the initial procedure to correct the PVR. And now, as you see, this patient ends up with some central intraprostatic, maybe because with the balloon postulation, we did some over deployment of the valve. And this patient is not feeling well. It's still by echo that it is a moderate transvalvular AR, but it's not a good echogenic patient. So typically, what you have to do in this patient is use the tables that we provided in the VAC3 published, I think, 2 weeks ago, finally. You have this, I won't go into detail, but we propose a multi-view, multi-parameter integrative approach to grade PVL, or this is paravalvular and same for transvalvular AR. This algorithm works for both. And then it is important when you have uncertainty about the grading PTE, because paravalvular or transvalvular AR in prosthesis is difficult to assess. There are some challenges, and the guidelines, the AC guidelines, recommend if the AR is uncertain with transthoracic echo, don't hesitate to do a TEE or CMR. CMR is useful to measure and confirm the regurgitant fraction in this patient, as shown in previous studies. And we did a CMR in this patient because we're not sure, we had some transvalvular AR. We're not quite sure with our transthoracic echo. So we did a phase contrast CMR and found a regurgitant fraction of 36%, consistent with at least moderate AR. So we treated the patient with another valve-in-valve here, and AR was corrected. So when it's after the procedure, I think we should not hesitate to be aggressive. If you have, mild or indeterminate AR, or I said more than mild or indeterminate AR, or if you have mild AR with symptoms or LV dilation or dysfunction, don't hesitate to do a TEE or CMR for quantitation of AR severity. And if you think you have a moderate or severe, again, we should not hesitate to do corrective procedure, even if it's delayed corrective procedure. If it's mild, well, I think we can manage the patient with close follow-up. And if it's none or trace, well, we should follow. So in conclusion, moderate severe paravalvular leak is rare, now less than 3% with the newer generation of THVs, but still associated with increased risk of mortality. So yeah, it's rare, but if you have it, you will pay the price. You will have an impact on mortality. Mild PVL, on the other hand, is more common, still 10 to 30%, depending of the studies. Even with the new generation of transcatheter valve, it is well tolerated in the vast majority of patients, but may be detrimental in some vulnerable patients. So we should not underestimate the long-term effect of paravalvular leak, even mild paravalvular leak on outcomes, as we've seen, for example, with the PARTNER 2 5-year data. So we should not lower the guards. And remember that PVL is still one of the top killers, you know, following TAVR when it is significant. So we should do every effort to prevent PVL in the first place. Systematic screening is important, and corrective procedure if we see moderate or severe PVL. And this is maybe the most important message. We should have a low threshold for delayed reintervention in patients who are finally found to have moderate or severe paravalvular leak or transvalvular AR after the procedure. Thank you very much for your attention.
Thank you very much, Dr. P. Barreau. This was a wonderful presentation. Although we have we're under pressure from time, I just want to have one quick question with you, and that would be, how accurate do you find the echo to be in evaluating the mild paravalvular leak, and how often do you have to resolve in another modality, such as you said earlier, the CMR? And is there a good correlation between CMR and echo in the mild paravalvular leaks? Thank you.
So yeah, that's a question that is very important indeed. And well, fortunately, we don't see very rarely now severe AR, you know, after the procedure. So that's so you're right. I think that the gray zone is between the mild and the moderate. You know, that's where often, you know, sometimes with echo, it's clear that it's mild or trace. Then we don't have to worry. It's more when I have a mild to moderate. And that's why in VOC3, we propose a more granular scale where we have mild to moderate, moderate. And it's more when you have mild to moderate where I often use, you know, additional method. You know, my threshold to do a TE first is pretty low. And TE and TTE are complementary because TEE, you will better see the posterior jets, whereas with TTE, it's the opposite. You know, you see not as well the posterior jets. So I think the two may be highly complementary. And the most important take-home message is to first do echo right. So be sure to image in the different windows, you know, apical short, apical long, parasternal short, parasternal long, apical 3-5 chamber, you know, you need to have all the views and use several parameters. I think the mistake we did initially is to rely only on 1 or 2 parameters, especially the circumferential extent, you know, that is very popular. This is not the best parameter. So we have to look at it, but we need to look at other parameters. And if we do, then it correlates well with or relatively well with CMR. But if we only use the circumferential extent, then the correlation is not good.
All right, thank you very much. So, and with no further delay, now Dr. Jace has the mic, and he will present the next speaker. Thank you very much.
Good evening from my side. Good evening from my side. I would like to thank the organizing committee for the invitation. No further delay. I have the privilege to introduce the next speaker, is Dr. Musiama, and the topic of the presentation is complete heart block, bundle branch block, and need for new pacemaker, prevention and management after TAVI. Dr. Musiama, the schedule is quite tight. Please, in the next 10 minutes, we are open for your presentation.
Oh, yeah. Good afternoon, everyone. Hopefully you're seeing my screen.
Yes, we do. Thank you.
Okay, thank you. Good afternoon, everyone. Dear colleagues, I want to thank the organizing committee for the invitation. In my presentation, we will talk about conduction disturbances following transcatheter aortic valve replacement. Aortic valve replacement is an established therapeutic option for patients with severe aortic stenosis who are considered inoperable or have high risk for surgical aortic replacement. Given its favorable efficacy and long-term durability of bioprosthesis, the indication has been expanded in the intermediate surgical risk patient, which raises concerns, especially about conduction abnormalities often observed. As known, the incidence of conduction abnormalities, pacemaker implantation following transcatheter aortic valve replacement, varies depending on on valve type from 5 to 20%, whereas in surgical procedures is as low as about 6%. Of course, with increasing operator experience and new positioning techniques, there has been a lower rate of conduction disturbances, which have fallen in single-digit rates, irrespective of valve type. Of course, the reason for this effect is the proximity of the conduction system to the aortic annulus, and as we see in the far right panel of images, the left bundle branch is more exposed and therefore has a higher risk of damage by the deployed valve. Other factors that are related to conduction disturbances are valve type, which is associated not only with the incidence but also with the persistence of the AV block, the aortic annulus size, depth of implantation, and the need for post-dilatation. Regarding patient characteristic, the pre-procedural presence of right bundle branch and the QRS duration of greater than 120 milliseconds have been associated with high risk of conduction abnormalities in most of the studies, and the presence of first-degree atrioventricular block has also been implicated in a few studies. Few studies have examined the case of timing at the onset of the disturbances and about the timing of their recovery. Most of the cases of recovered AV block is in the acute AV block group, which is within the first 24 hours. From these patients, about 70% will recover also in the first day post procedure. In contrast, the recovery time varies widely in the group of the delayed conduction complete AV block. Are there any patient characteristics who alter these results? Once again, the right bundle branch and the delayed onset of the complete AV block predict the persistency of the disturbances, and this may be a useful criteria for patient risk stratification and decision making when we have to select which patient will undergo a pacemaker implantation. Most of the patients who get a pacemaker implanted, of course, they have it for a high-grade AV block, although there is also about 8% or so that are having a pacemaker implantation due to sinus node disease. But there are no anatomical features who predict the persistence of AV block, only the aforementioned factors such as the right bundle block, the higher mean aortic valve gradient, and the need for post-dilatation. So there is a need to adhere to the recommendation of extended waiting period of 7 days, especially in patients without prior right bundle branch block, and in those patients where post-dilatation was not used. Regarding the pacemaker dependency, this is a topic of that warrants attention, since this is a dynamic effect and may be missed in a follow-up examination of the patients if there is a paroxysmal AV block. New onset left bundle branch block has been reported in about 1/4 of patients after this procedure. Data on newer devices remain scarce. There has been many interest about the long-term effect of new and persistent left bundle branch block. Most studies have shown that it doesn't affect long-term mortality either if a pacemaker is implanted or not. Of course, there are reports for the opposite. But apart from the conduction disturbances, there has been this recent study, the MER study, which shows that in patients that continuous monitoring, rhythm monitoring, or reveal device was implanted after their development of left bundle branch block, most of the patients had the left bundle branch block in 1 year follow-up, about 20 to 30% recovered, and the lower percentage of them needed long-term pacing. But another interesting finding of this study was that not only the bradyarrhythmia burdened was in about one-fifth of the patients, but about the same percentage of patients also showed significant tachyarrhythmias, which is a very interesting finding. Apart from the mortality, the long-term mortality, this study has shown that the presence of left bundle of the LBBB affects the left ventricular function across all levels of all groups of left ventricular function, either low or normal. And this is a very interesting because it maybe has an effect in the long-term management of those patients. A left bundle branch block has been associated with left ventricular synchrony and either lack or improvement or an increase in the left ventricular ejection fraction, which raises a question about the potential use, of the use of cardiac synchronization therapy after TAVR in patients with new LBBB, decreased left ventricular function, and symptomatic heart failure.
Dr. Musiama, sorry to interrupt. We have 2 minutes left. So
Okay. Yes, I'll go a bit quicker. Not all of the patients that have received a pacemaker will need the pacing in the long term. As seen here, patients with a left bundle branch block, either with first degree AV block or not, they needed less than 1% ventricular pacing in the long term. When the follow-up period is extended to 2 years, we see that there is a difference in risk hospitalization, in morbidity due to heart failure and death due to heart failure. So these patients should be examined periodically to adjust the pacemaker settings and ensure maximum normal conduction to minimize risks of long-term pacing and associated left ventricular dysfunction. And in many patients, leadless pacemaker and permanent balancing may contribute to less morbidity in the future. So patients should be assessed pre-procedurally because many of these patients show pre-existing conduction disturbances or have procedural RBB. This may alter our decision about the valve type. After the procedure, they should be monitored electrocardiographically. And regarding the LBB, there are no specific guidelines, but what is one sure determinant is that these patients would not be early discharged and they will need a longer ECG monitoring. So I'm closing with this algorithm. An expert panel has derived this algorithm, which suggests that patients with complete heart block should be monitored for at least 24 to 48 hours in case the heart block recovers and they could avoid the pacemaker, or if the patient has LBBB, the course of action would be determined by the QRS duration and the presence of first degree AV block. So we've seen the effects of the presence of new onset LBBB and the permanent and the need for permanent pacemaker. What is of paramount importance to prevent this complication is the appropriate sizing of the valve and the optimal deployment, aiming at a more aortic position. And we should have in mind that patients may benefit from left bundle, his bundle or left bundle branch, his pacing or left bundle branch spacing, and maybe the leadless pacemakers also are a favorable option in patients that will need low ventricular pacing rates. In conclusion, conduction disturbances are still a concern following these procedures. This is a frequent and economically relevant complication. Main determinants of AV block are pre-existing RBBB and valve type. Pre-procedure pacing evaluation may affect valve choice. Pacing dependency may be reversible. New onset LVB is associated with high arrhythmia burden and increased risk of pacemaker implantation within the first 12 months. And new onset LVB may affect left ventricular function. Thank you for your attention.
Thank you so much for the presentation. Excellent one, clear messages. Apologize for the pressure. No time, so please proceed, Dr. Dimas, with the introduction of the next speaker. Thank you so much, Dr. Muskiama.
You're welcome.
Thank you. We're arriving now to the last talk of the session. Will be given by Dr. Kapadia, who is the chairman of cardiology at the Cleveland Clinic Foundation. It has been instrumental in the evolution of interventional cardiology, specifically structural heart disease, working tirelessly to make the procedure simpler and safer. Referring to safety, stroke is a fearsome complication which impacts both on mortality and quality of life. Unfortunately, we will not be able, for Dr. Kapadia will not be able to join us live today. Instead, we're going to listen to his pre-recorded presentation entitled Cerebral Embolism Prevention and Management in TAVI.
Hello, everybody. I'm Samir Kapadia. I'm from Cleveland Clinic, and I'm very excited to be part of this wonderful program. I wish I could be there, but anyway, I'm giving my talk from Cleveland in my office. So this is an exciting topic for me, the cerebral embolism prevention and management of TAVI. I've spent several years trying to solve this particular problem. No financial disclosure. We are doing a large clinical trial, as you probably know, which is called Protected Tower, and I'm also the national co-PI for the Sentinel study. So what I will do is I'll try to present a case, then just describe some data, and then review the stroke prevention with EPD data, and then very briefly talk about the Protected Tower design and goals. And I wish to do all this in 15 minutes. So this is the case. This is how we do it in Cleveland Clinic, that each patient that we treat with TAVR, we create this slide. And this is a slide where we have the clinical history, the echo criteria, the left heart cath, the access, and whatever problems that we are trying to encounter or face. This is our setup. This is a very big room, but it's very important that in the room we have a pump, we have the anesthesia NP, cardiothoracic surgeon and cardiologist available, echo technician available, and one nurse. Not many people, but all this equipment available at our disposal. No Swengans, no GA, no Artline. So what we do here is just get access in the groin with one catheter, put one per close, and then just get access in the same artery in the bottom. So we have 3 sheets in the same side, not on the other side. So no contralateral access, same access, one below. And then we use the Sentinel device. So this is the Sentinel device. This is live. So this is the emboli protection device that we use commonly. So this is the only available one in United States currently. So there is an O14 wire that we place. We typically use a whisper wire. And then the whisper wire, you can see it probably right here, which I'm showing you with the arrow. And there's no dye, nothing involved. It's just coming from the radial artery. We see the aortic calcification, or sometimes I put a small catheter, which like pigtail catheter or straight flush catheter, to show you where the ascending aorta is. Now we are deploying the proximal filter. Just uncover the proximal filter. As you see, we are just pulling that back and uncovering the proximal filter. So the proximal filter will cover the innominate artery and the right carotid artery. And then you pull this back and then slowly form a curve. When you form a curve, you make sure that you are not really against the inferior margin of the aorta, so that you don't scrape anything on the aorta. I sometimes even leave a little bit of piece of soft wire outside. And now you flex it, and once you flex it, you pass the carotid artery is there, So you will pass the flex it and pass the small wire there, as you see, and now you can pull back the distal filter so that it is engaged into the carotid artery, and then just push the filter out into the left carotid artery, as you will see in a second. So this is very simple, and this is the live form. So this is how long it takes, about a minute to put it. And then once it's done, we put this straight catheter underneath, and then we inflate the valve such that we put it at a 0. So this is what we have described in the other paper to say that we can now deploy the valve at 0 height, not using, this is a biplane room, so in the same patient, you can see the typical view that people use, but we use this such that the right and the left are overlapped. We published this particular paper. And then we assess the aortic regurgitation, again with a low aliasing velocity to make sure that we see the aortic regurgitation. We used a lot of different ways to identify that what is the pressure, how much AR is there. So we used the dicrotic notch as a function. So if it's more than half of the downslope, the dicrotic notch, then there is not much AR. Or if the AR index, or what we use is a TI AR index, this is the index that allows us to measure irrespective of the heart rate. And then of course we do an aortogram. So the aortogram is also very important to see even a little bit of AR that we see. And if we see this kind of AR, we would post dilate the valve to make sure that the valve is perfectly placed. And at the end of the procedure, we take the pacemaker and put it in the right atrium and stimulate the right atrium at 120 beats per minute. If we can conduct one-on-one at 120 beats, we discharge the patient the same day. So this is also very, very important. And at the end, we just take a picture from the inferior sheath, nothing from the, so the top sheath is out. We take a picture from the inferior sheath, and then if it looks good, we are good. If not, we can inflate a balloon there and remove these wires. What are the current data? So the current data are that the stroke rate is declining. There's no question about that. But the stroke rate is still about 2.5%. And if you look at the TVT data analysis, we published this in JAMA. This is the reference for the JAMA. There is a 2.5% stroke rate. And this is self-reported stroke rate. So most likely the stroke rate is slightly higher than that. If you look at the timing of stroke and 30 days, it is very clear that 68% of the stroke happened procedurally. Very important thing to keep in mind within 30 days. And if you look at different types of risk factors for the stroke, you can tell that they're all common things that you see in different parts of the patients, in the sense that there are a lot of different factors that are associated with stroke, but in an individual patient, it's impossible to predict that this is a low-risk stroke patient or this is a high-risk stroke patient, meaning that stroke remains unpredictable in patients. Even in the non-femoral TAVR, we still use the emboli protection device. So if we do it from the left subclavian, we put it from the right side. We try to use left subclavian more than the right so that we can have an emboli protection system. And this is very important. Stroke is not just associated with morbidity, but also associated with mortality. There is 12.7% mortality with stroke, and 30-day mortality is 16.7%. And most of these patients ultimately end up not going home and going to the extended care facility. So there is a huge penalty for having a stroke. And if you compare the stroke between TAVR and SAVR, you again see that the stroke is less with TAVR, but still it is not like a PCI stroke. So the stroke this is the partner trial results. So I don't want to say that the stroke is more with TAVR, stroke is less with TAVR, especially the major stroke is less with TAVR. But still, in my mind, it is not, the gold standard is not SAVR. Gold standard should be PCI. So what I conclude from this initial part is that the stroke is still an important factor in the outcome of patients with TAVR. How about if you review the data about the stroke with emboli protection? So this is the classic, the first study, the pivotal study that we did in the United States. where we randomized patients 123 to the control arm, where we had just TAVR, the test arm, and the safety arm. So this combined group was the patient that we followed with clinical assessment, and in the test arm of the patients we did the MRI. We did not do the MRI in the safety group. So what we found, first and foremost, is that 99% of the filters had something inside. And when we did the analysis, we found that although the device had a decrease in the new lesion volume formation by MRI, this was not statistically different. So remember that the new lesion volume in the primary endpoint of this trial was negative. Because the primary endpoint was negative, we could not conclude that strokes were prevented. However, if you look at the different ways of analysis, there was still a reduction in the mean lesion volume in the protected territories, but again, this was not statistically significant. There were 3 different trials with a very similar design, with similar kind of MRI analysis. So Clean TAVI, Mistral C, and Sentinel, and they were all randomized blinded studies. And so what we did is we combined the data of all these patients. And when we combine the data, we find statistical significance, because as you see, all the 3 trials showed benefit, but this was a multi-center trial. When we combined the data, there was a statistical significance in the protected territories. However, if you looked at all territories, there was no significant difference. This is again the low lesion volume in the protected territories. However, if you look at all territories, there was still not statistical significance even after combining the 3 trials. So should we use the Sentinel device or not? So the first part was that if you now look at clinical endpoints, very important. So compared to the control group, the Sentinel group has less events of stroke. As you can see, 5.6% versus 9.1%. Very, very high stroke rate. The reason why the stroke rate is so high is because all patients got MRI and then the neurologist examined them. So the small things were identified as stroke, and that's why the stroke rate is 9.1 versus 5.6, but still it was significantly different. And if you look at that was 30 days, but if you look at 72-hour stroke rate, that was 8.2 versus 3.0, and it's also just statistically significant. So again, the clinical events were less, and very importantly, we found material in 99% of filters, and more importantly, we did not have any harm. So with these 3-4 things together, we think that using the Sentinel device makes sense. There are a lot of single center studies, retrospective, looking at the outcomes, including Cleveland Clinic, so Cedars-Sinai, in Germany, everywhere there is a reduction in the stroke rates. However, the TVT analysis was just recently performed by Dr. Cohen, and large number of patients, 12,000 patients with EPD and no EPD, over 110,000 patients. And he did the analysis of these patients. Very importantly, the EPD utilization is still 28%, even in the last quarter of 2019. And the proportion of patients receiving EPD is only 13% in the United States. Instrument variable analysis is like doing a randomized trial in the sense that now you say that as if your instrument is EPD or not, so you are randomizing the patients by the statistical method to say that whether they had EPD or not, and there was no statistical significance. Even though the number was 1.39 versus 1.5, very, very little difference in the stroke rate, not statistical. However, if you do propensity matched analysis, so this is a different way of analyzing the same cohort, it was 1.3 versus 1.58, so p-value was 0.02. What it concludes is that there is a little bit of a difference. First of all, it's not very widely utilized, generally safe, and there was no significant difference in the reduction in 30-day stroke rate, and the number needed to treat would be large, so about 300 patients for a major stroke by this particular analysis. There are several limitations to this. This is self-reported stroke. This is, it is not clear how many people know how they're doing the EPDs. So these are all limitations, but the advantage is this is very, very large number of patients. The reflex study is another type of a device, the TriGuard device, and this TriGuard device is a deflector. And here you can see that the control versus TriGuard, if you compare them, it's a little complicated analysis that is the safety cohort and in the control group, and they had phase 1 and phase 2. And so if you compare in the efficacy cohort, the control versus device, there are 121 patients. And what we found in this, that if you look at the composite primary endpoint, there was, to be honest, there was no significant difference, but even the numbers look a little bit worse on the TriGuard side. But however, this was not statistically significantly different. If you looked at the stroke in the REFLECT-2 trial, the safety analysis of the stroke was also in the REFLECT-2 trial was done, and the stroke rate in the control versus TriGuard was also slightly higher. So again, suggesting that at least there was no easy treatment effect. Efficacy endpoints, again, you can see the 30-day stroke rate. This is a TriGuard, this is the pooled controls, again, slightly worse. So what we are doing now? So what we are doing now is we are doing a randomized trial, because now you need a randomized trial with clinical endpoints. So this is the protected TAVR trial, one-to-one randomization with a sentinel or no sentinel in commercially available patients, commercially doing TAVR in all patients. And the advantage here is that we are doing the very clear endpoint of periprocedural stroke, nothing else. So periprocedural stroke, 72 hours in patients with TAVR or no TAVR. So there are 100 centers in and outside of United States, 3,000 patient study, large patient study. We are already about 600-700 patients enrolled when I'm giving the talk, and all the patients are receiving TAVR are assessed by the neurologist, and the randomized trial is doing superbly well. And so here you can see 1,500 patients in each, neuro exam in all patients post-procedure, primary endpoint is 72 hours stroke discharge. And what we will do, very importantly, is that if they develop the stroke, then there is a little bit more in-depth analysis of the patients, and then we will study, interim analysis will be done to say how far we want to continue the trial. So I want to conclude that the stroke after TAVR remains to be a clinically relevant problem, irrespective of the valve type. It's not predictable. Some subgroups may be at a higher risk than others, especially the bicuspid group. More data are needed to prove the efficacy of EPD in stroke prevention. Sentinel is a safe device. Effectiveness in the large randomized trial needs to be proven. And so protected TAVR is currently enrolling. I did say 300 patients here, but already we are around 600 to 700 patients. So thank you again for your attention. And if there are any questions, I'm happy to attend to the questions. Thank you.
This concludes the current session. Many thanks to the speakers, and many thanks to the audience for their participation and attendance. Thank you very much.
Good afternoon, everybody. My co-moderators and I welcome you to this next exciting session titled Decision Process to TAVI or SAVR today. We have the great pleasure to have with us international renowned cardiac surgeons and an interventional cardiologist, and we are eager to listen to their talks and have a very interesting discussion after their presentations on a very hot topic. Without further delay, I will introduce you the first speaker, who is Dr. Gregory Patakos, who is a cardiac surgeon at the Second Department of Cardiac Surgery and an associate director of the Department of Transcatheter Heart Valves at Hygeia Hospital in Athens, Greece. Dr. Patakos, all ears.
Thank you very much, Professor Angouras, for your introduction. So I'm going to talk about the latest TAVI trials and guidelines. Please interrupt me if I run more than 7 or 8 minutes, because I think this is just a prelude to some of the amazing talks that are coming up next. But it's just to give some background as to how we got here. So it's been almost 2 years since the low risk indication for TAVI was approved. But how did we get here? Really, I think this is what we need to look at. And I don't need to belabor all the statistics, but we've had low risk trials from a long time ago. And in fact, Washington Hospital Center, which is close to my heart, I rotated there as a general surgery resident, performed the first low risk trial. The trial's in quotes, it was an IDE trial, and it used a historical comparison. And if you can see, they had a mean STS score of 1.8%. They had a 3% death, which is almost double, but it's not bad for a start. And even since then, they knew about Hall hypoattenuated leaflet thickening. But really, it's when we come to the Medtronic and the Edwards trials that the FDA really started to take notice to give the approval. I think this is what really moved things there. The Medtronic low-risk trial, and Dr. Reardon will tell us more. So I'm going to very quickly gloss over these trials. I'm not going to go in depth at all because I think they'll form the basis for the next talks. We see that the mean age was 74 years old, mean STS risk score was 1.9%. And we found that TAVI had less disabling stroke, bleeding, acute kidney injury, AFib, but more AI and more pacemakers. And TAVR had lower gradients and larger effective orifice areas. However, this doesn't look sexy when you put it on a graph and you look at death or disabling stroke, but with the help of some graphic designers zooming in, you can see that TAVR has the composite endpoint slightly lower numerically, at least in surgery. And then we look at the Edwards Partner 3 trial, and we see that 1,000 patients were randomized with 950 making it to an intervention, mean STS score of 1.9%. A little bit unfair in that 26% of the SAVRs had a concomitant procedure. And you can see that the surgeons are really starting to get on the ball with this. Minimally invasive, 24%, and 80% had a valve greater than 23 millimeters. I think that's very good. All of these trials, in order to get good outcomes, they were all transfemoral. And that's important because the guidelines are starting to take notice of this as well. And I think we're going to see transapical and transaortic move away even more than they already have. So you see that when we look at the composite endpoint and we add rehospitalization in there, surgery is way higher. However, if you look at the endpoints besides rehospitalization, there's no real difference between surgery and TAVI. The other interesting finding is that there were lower gradients and larger area in the SAVR group. Why is this? It's because a lot of the surgeons in the Partner 3 trial did aortic root enlargements. And there was more mild paravalvular leak in the TAVR group, and there are 6 subclinical valve thromboses, 5 with TAVR, 1 with SAVR. Now, I'm not going to go through all of the other trials that are coming up, but we're going to see that there's going to be a lot of trials that are going to inform the guidelines. The UNLOAD trial with moderate AS and CHF, the Evolved trial, which is coming up, the Dedicate trial, which is trying to do essentially the same thing. However, it's industry independent. It's going to see if we really, when we take the bias of industry away, whether we come up with the same results. And then the early TAVR trial, which should be ending soon, to look at patients that are asymptomatic. Let's go to the guidelines now in 2020. And I think we've all noticed that the AVR algorithm has become a lot more complicated with TAVI. So I'll take you through this just briefly, even though you already know it for our audience. So if your estimated risk for surgery is not prohibitive or high, and VKA anticoagulation is reasonable, then if you're under 50, you should probably get a mechanical AVR. Ross is still on there, the Ross procedure with a 2B indication. That's another thing that I think is on its way out for most patient groups. And then if you're 50 to 65, we can talk about a mechanical or a bioprosthetic valve surgically. If you're over 65, a bioprosthetic. And so once we've decided that we're going to do a biological valve, then the question is really, are we going to go SAVR or TAVI? Now, if you don't belong to the group symptomatic severe AS or asymptomatic severe AS with LPEF under 50, you're getting open surgery, not TAVI. And also, obviously, if you're not suitable for TAVI from an anatomical standpoint, you're going to get open surgery. However, when we look at this, they stratify it now into patient age groups, and we all saw this coming a long ways away. If you're under 65, you should have an open operation for your biological valve. If you're 65 to 80, both SAVR and TAVI are given equal recommendations. And if you're over 80, TF-TAVI wins. And you'll notice it says TF. This is transfemoral only. TAVI wins, and SAVR gets a 2A recommendation. However, another couple interesting things to note from the guidelines is that small or large aortic annulus favors surgery. Why is that? It's because of the aortic root enlargement we saw that was done in the PARTNER 3 trial. And then the other thing to note is that it's interesting because TAVI provides a larger EOA if the surgeon doesn't do an aortic root enlargement. Also noted in the guidelines is that long-term 20-year data on outcomes with surgical bioprosthetic valves are available. Robust data on transcatheter bioprosthetic valves extend only to 5 years. And also, as we said before, with the small aortic annulus or aorta, a surgical annulus enlarging procedure may be needed to allow placement of a larger prosthesis and avoid patient prosthesis mismatch. So bioprosthetic in a 50-year-old, I think I'm going to try and finish early so we can have some debate after our illustrious speakers speak. But at this age, only SAVR is recommended. What happens down the line? Are we really helping this patient live a full life? We need to plan all of their procedures and not just kick the can down the road, I think. And, I'd like to hear everybody's viewpoint on this. But I think we're going to be seeing this a lot more frequently. So patient at age 55 follows the guidelines. He gets a biological SAVR. At age 68, 13 years, not completely unreasonable. Although we might say he's a little bit on the earlier side for his surgical valve to have degenerated. At age 68, he gets a TAVI. And 7 years later, this is not unheard of for TAVI either, he's degenerated his valve. And now he's all yours to the surgeon with an aortic root full of hardware. So I'll conclude with that, saying that I think we always need to think multiple moves ahead, just as we do in chess. And I look forward to seeing everybody live and in person in Greece in 2022. Thank you.
Well,
thanks a lot. Yeah, you can hear you. Thanks a lot, Greg. I was a very nice overview, which gives a lot opens for lots of discussion. I think that we will leave all the debate and discussion for the end of the presentation. Is that what has been agreed before? And now it's my honor and pleasure to introduce to you Dr. Maka, who is a well-known surgeon, cardiothoracic surgeon, being in charge of all the different studies which has been performed, and the ones that have been instigated the change in the guidelines. And I'm very keen to listen to what he's going to say to us, and what is the major risk factor for him, and what is the major thing which make his mind to decide about TAVI or SAVR, the age or the patient's risk. And he prefers the age of the patient. So Dr. Maka, Professor Maka, the floor is yours, and we're very eager to listen to what you're going to tell us. Thanks a lot for joining us today.
Well, it's my pleasure, and I'm sorry that I am not there with you, but I look next year. And I'm in an area without great internet connection, so hopefully it holds throughout this presentation. Can you hear me okay?
We can hear you very, very well, as you're being close to us.
So I was asked to talk about why I tie my decision to patient age rather than risk. And I very much enjoyed Greg's talk and largely agree with everything that he said. So this is my conflict of interest disclosure. I have been involved in a number of trials in the structural heart disease space. So we've now been 33 years since the original idea of TAVI. And now in 2021, there are about 75,000 devices done a year in the United States. And there are 2 valves that are approved in the United States for commercial use currently. Greg alluded to the trials. This is a summary of the trials. Over 12 years, there have been 9 trials in the United States, including a total of almost 10,000 patients, of which over 8,000 were randomized, that have resulted in 10 New England Journal papers over the last 9 years. So it's a very robust evidence base upon which to make decisions. And this is the summary of all of those trials. And in all of those, TAVI was either equal to or superior to surgery, independent of risk. So this slide right here says risk doesn't matter anymore. You have to look at other factors. And that most important factor, I think, is going to be patient age for reasons that Greg mentioned near the end. We now have 2-year follow-up, both published within the last month or so in the Journal of the American College of Cardiology of the 2 randomized trials. This is the core valve trial, which Mike will talk about subsequently. And the results are holding out at 2 years, as they are in the PARTNER 3 trial. Again, we have results holding out at 2 years, although there seems to be some catch-up of surgery toward TAVR. So it'll be interesting to see what happens at 5 years and ultimately at 10 years. So this is currently the status of TAVI in the United States. There are a total of 763 sites performing TAVR in the United States. This is the number of procedures performed. There were 73,000 in 2019. There were 56,000 in the first quarter of 2020. That should be about equal to 2019, taking into account the effects of the pandemic. Most centers had their volumes off about 20%. This is the reason for the procedure based upon a heart team decision at the site. And as you can see, in green, the number of low risk is growing. As a matter of fact, the first 3-month data shows that low risk is now the major reason for a TAVR decision. And this is the median STS predicted risk score based upon the risk category determined by the site. So you can see that risk patients, their mean STS score is 6. Intermediate 4, and low risk, their STS score is 2. This is on the basis of age, and you can see that high risk patients, the median age is 81. In intermediate risk, it's 80, and low risk, it's now 75. And this is the outcomes. This is the mortality at in hospital in blue, 30-day in red, and 1 year in green. And we can see that the in-hospital mortality is now about 1%. The 30-day mortality is 2%, all comers, and the 1 year mortality is about 12%. So the results are actually very good, independent of risk group. So Greg mentioned the guidelines. These are the guidelines that were published in December. And this is the table that he showed that I think says it all. The recommendations in the guidelines are all based on age, not risk. So if you're over 80, TAVI is preferred. 65 to 80, both are equal options. If you're under 65, surgery is still the only class 1 recommendation. So again, the guidelines, the recommendations are based on age, not risk. So this is the way that I think about it now. The first decision to make is tissue versus mechanical. The second, if it's and mechanical is should be probably the primary option if you're less than 50 years old. If you're greater than 70 years old, it's tissue, and it's a shared decision making with the patient between 50 and 70. If a choice is a tissue valve, if you're under 65 years old, the choice is now leans towards TAVR, but not absolutely. If you're over 80, it's TAVR, and between 65 and 80, shared decision making. So we are seeing a shift in risk stratification from a shift toward who is high risk for surgery, but rather now who is high risk for TAVR. So looking at this, who is not today for TAVR and should stay with surgery? Well, there's anatomical risk, there's complication risk, and there's concomitant conditions. So patients that should stay with TAVR are younger patients for these reasons you see here, and I'll focus on valve durability for the rest of this talk. Poor candidates for TAVR based upon left ventricular outflow tract calcium, low-lying coronary arteries, and some bicuspid valves. Other patients that should receive TAVR are aortic regurgitation, endocarditis, complex concomitant coronary disease, rheumatic disease, multi-valve disease in low and intermediate risk patients, and then structural valve deterioration. So now the decision making is why age matters. Well, we're getting to the stage that the patients are now outliving their valves. In the high-risk trials in which patients were mainly in their 80s, in general, the valves outlasted the patient, so you didn't have to worry about the second or third procedure. But as you see at 87 years old, you only had to worry about the valve lasting 5 years. By the time you're 77, you have to worry about it lasting 10 years. And now at age 68, you have to worry about it lasting 15 years. And now at 62 years old, you have to worry about a valve lasting 20 years. So how do we put this together? Well, what do we know about durability of TAVI? So far, there's no signal of significant early structural valve deterioration. These are the three studies that have the farthest outlook at it. And you can see there are some results out 6, 7, and 8 years. But if you look at the number of patients at risk, it is extremely low in all of these patients, primarily because they're an elder population. In Vancouver, there's only 11 patients that are out 8 years, but still there's no major signal. But I think we have to think of a patient with a lifetime management of the disease right now. And here's a patient from John Webb that was treated in 2008 at age 68. And now you can see at age 78 getting his second SAPIEN 3 procedure. So we have a huge choice of bioprosthetic aortic valves now, both from a surgical standpoint, sutureless standpoint, and transcatheter valves. Which of these will fail early? I think we really don't have a good idea of the relative durability of each of these valves compared to each other. So we have to look at the lifelong management of the patient at the aortic stenosis, and as Greg adeptly alluded to, not just the first procedure. So again, here's the guidelines. There's good guidance as to what to do over 65 years old. The answer is transfemoral TAVR if the anatomy is suitable, and that's the patient preference. But what if you're younger than that? Well, we get into the nested Russian doll phenomenon here. If you're over 80, you only have to worry about the first implant for the most part. But if you go down to 65, you have to plan on 2 implants. By the time you get down in the 50s, now you're going to have to plan for 3 implants. And the choice is, what order you do these implants? What is the first and what is the second? The younger the patient, the higher the chance of 3 interventions. Each intervention will add additional unknown issues, and the higher cumulative risk of stroke mortality and need for anticoagulation with each procedure. So the scenarios are as follows. You could do TAVR first in the younger patient, and then the second procedure could be TAVR and TAVR, and the third would be now TAVR explant with 2 valves in place and SAVR. The second, you could do TAVR first, and your next operation could be TAVR explant and surgery, and then in patient in their 70s. And then the next would be TAVR and SAVR. Or you could start with SAVR. You have the patient at their youngest at that point, do TAVR and SAVR, and then do TAVR and TAVR and SAVR. So someplace in this scenario, by the time you get into younger patients and under 65 years old, you're facing 3 procedures. One of those is going to be surgery. And the question is, when do you want surgery done? In your 60s, your 70s, or your 80s? And do you want it to be a first-time operation or a redo operation? And redo SAVR with TAVR explant is not a simple, straightforward procedure. It does carry higher risk than the first-time operation. So in summary, the initial procedure should be made on the basis of age, not risk. The decision should be made on the basis of age, not only at the first procedure, but the age and risk at the time of the second and the third procedure. When the patient will live longer than the valve, the focus should be on the lifetime management of the patient with valvular heart disease. And in patients less than 60, it is likely that SAVR will be needed at some point in time. It's not a question of if, it's a question of when. So thank you for the opportunity of making this presentation, and I look forward to hearing the other presentations in this session.
Thank you very much, Professor Mack, for your fantastic talk, where you very well alluded the change in the paradigm shift from who is the candidate for TAVR, and now to talk about who is not the TAVI candidate. I think that's what I got out of it, and thank you very much. And now, please, the next chairman to introduce the third speaker, please.
Thank you very much, Lambros. Thank you very much. Dr. Mack really did a very nice job giving us the almost certainty that age is what matters. That made Dr. Reardon's talk very interesting, because now we're going to see almost the opposite, saying that the risk is what matters. So we're very eager to hear what he has to say about that. And I'm very happy to introduce the well-known Dr. Reardon to give us the talk about why risk is more specific than the age considering TAVI. Dr. Reardon.
Good day, and thank you for allowing me to join you today to talk about TAVR and why I tie my decision to patient risk rather than age in TAVR. Just following after Michael Mack, who tied his to age, this does put me in a difficult position, but we'll see if we can go through this. These are my conflicts of interest as they apply to TAVR. I've had the opportunity to be involved in a number of the TAVR trials. Likely my greatest conflict of interest is I am a cardiac surgeon. So what do we know about risk? Well, there have been a number of good randomized risk trials done in the U.S. If we look at the PARTNER 1B trial, which was the extreme risk trial for PARTNER, randomized between TAVR and best medical therapy, which can include BAVs, there's a 20% survival advantage in every year for the TAVR arm. If we move to core valve extreme risk, we could no longer randomize against medical therapy, but we used a performance goal. And if you notice the survival at 5 years in the TAVR arm, it's almost exactly what it was in the PARTNER trial. So extreme risk was approved in the U.S. Then we moved on to high risk. In both these trials, we're going to use a primary endpoint of all-cause mortality. PARTNER 1A, TAVR versus surgery, non-inferior over 5 years. If you look at the core valve high risk, TAVR versus surgery, superior for TAVR years 1 and 2 by 5 years, basically the same number. We then moved to intermediate risk, the PARTNER 2A trial and the CERTAVI trial. Both of these use a primary endpoint of all-cause mortality or disabling stroke, and these were non-inferior all the way up to 5 years now for the partner trial. The 5-year data for SURTAVI will be out in October, and I hope to have that for you by the end of the year or early next year. The one thing that was a little worrisome in the partner 2A trial, as you notice, the lines tend to cross about halfway through the trial, and TAVR now has a numerically higher number than surgery right when it started out lower. Both these trials will be followed for 10 years, so we will get 10-year data on both of them. We then move to low risk, and these trials are a little bit different compared to previous trials. If you move to low risk, there's going to be fewer events, so you either need to add patients, add time, or add events. Adding patients and time can potentially be expensive. The partner team, Dr. Mack led this with Marty Leon, chose to use all-cause mortality, all-stroke rehospitalization, all things very important to our patient, to have more events. And in the Evolute trial, Jeff Popman and I decided to stick with all-cause mortality or disabling stroke, thinking these were a little more solid. The primary endpoint, as I mentioned, was the 3-part and partner 3, all-cause mortality, all-stroke, or rehospitalization. The SAPIEN 3 valve was out when the trial started, so all investigators knew this valve. In the Evolute trial, what we did was add time by using a Bayesian analysis, which gives us an early look for a 2-year endpoint. And all 3 versions of the self-expanding valve were used. About 3/4 were the second-generation Evolute R, and 22.3% were the current Evolute Pro. Now, as a partner, you were required to have transfemoral. This was not true in Evolute, but still 99% were transfemoral. And for the partner trial, it easily met its endpoint and was superior for the TAVR arm. And for the Evolute trial, it easily met its non-inferiority endpoint for a 2-year Bayesian endpoint analysis. Now, if we took the Evolute trial and we made it a 3-part endpoint by adding hospitalization, it too would have been positive for TAVR. So these are both published in New England Journal, as were the other trials, and this created quite a stir, having these 2 trials showing concordant positive results for TAVR in a low-risk population. And low risk got approved in the U.S., so we do have approval for all risk levels. So the 2020 guidelines came out that were authored by Catherine Otto and Rick Nishimura. And if you look at those, it no longer talks about risk at all. There are now 3 real categories where you're trying to choose between surgery and TAVR in a patient in whom a bioprosthetic aortic valve is appropriate. The first category was a class 1, was if you're 65 years of age or less and you're going to have a 20-year life expectancy, surgery is still recommended. The other end of the spectrum, if you're 80 or more, or you're younger and have less than a 10-year life expectancy, and you're a good anatomic candidate for transfemoral TAVR, then TAVR would be recommended. And then there's this middle ground. So again, it looks like I'm in trouble since age is not mentioned, since risk is not mentioned at all. So in the U.S., what you see is this is what's happening in the world of aortic valve replacement. The blue horizontal line in the middle is isolated aortic valves in the U.S. The red horizontal line is all aortic valve procedures, isolated with CAV, with other valves, with ascending aneurysm, roots. And the black line ascending is TAVR. So you see in 2015 there were more TAVRs than isolated aortic valves. By 2019 there are more TAVRs than all aortic valve procedures put together, although these are still mainly people that have some sort of increased surgical risk. So I think what we have to ask ourselves is, what do we mean by risk if this is how we're going to choose our patients? Because I think this is an important question. So surgical risks tend to be physiologic risk. Are you on dialysis? Do you have bad lungs? Are you on home oxygen? Do you have liver failure? These risks all tend to be physiologic and not so much anatomic. As surgeons, we can handle almost any anatomy that you throw at us. TAVR risk tends to be anatomic risk. No good iliofemoral access or axillary access or carotid access. A lot of calcium below the valve. These are the things in TAVR that really make it more difficult to actually do a case. So when I look at a patient, I define risk as both of these things as I'm trying to choose between TAVR and SAVR. So we have to ask ourselves, let's just stick with the low risk, who was not tested? Well, who was excluded from these trials? We excluded bicuspid valves. We excluded significant coronary artery disease. We excluded unfavorable anatomy. We excluded all associated procedures other than coronary bypass or stenting in the Evolute trial. and we exclude all those appropriate for a mechanical valve. So this is a fairly large group. For bicuspid valves, we typically use the Sievers classification. This is built on a number of raphes, either none, 1, or 2. The most common is 1 with a left-right fusion. And although I was originally taught when I was a young surgeon, this was mainly a younger person's disease, it really goes up. Even in people in their 80s, about 20% can be bicuspid. But as we move down into the group in the 60s and 70s, the lower risk group, where we're starting to try to choose between TAVR and SAVR, but half these people can be bicuspid. Now, they weren't done in the trial. We do know some stuff about it. This is from Yoon and McCarr, who went out and looked at the bicuspid valves in the TVT registry and how they did. And they really divided these people up into little calcium, calcified raphe, or calcified opposite leaflet, or one that had a calcified raphe and a calcified opposite leaflet. And what they showed is if you had little calcification, you were on this bottom line. And when you got to 2 years, your survival was pretty good. Your mortality 5.9%. If you just had a calcified raphe or a calcified opposite leaflet, only one of those, 9.5 at 2 years. But if you had a calcified raphe and a calcified heavily opposite lesion, your mortality at 2 years was a quarter. So not all bicuspid valves are the same. And these are some of the things that we look at as risk for TAVR, because these things are very easily taken care of by your heart surgeon. Now, we did run a low-risk trial. John Forrest presented this. He was a PI with Basil Ravalli. I was the study chair. And we actually had very good results at 30 days for this group. The one-year data will be coming out, and it's still going to look good. But again, this is a small group and reasonably well selected. How about age less than 65, since 65 is the cutoff in our guidelines? Well, in the partner trial, only 7% were less than 65, and in Evolute, only 6% were less than 65, and in Evolute, only 1.3% were less than 60. I have people coming into my office every day in their 50s asking if they can have a TAVR, and I have to tell them we really have very little data on people like you. How about anatomy that was excluded? Well, annulus too big or too small was excluded. As a surgeon, I can handle both these. I can make your annulus bigger, I can make your annulus smaller. As I've already mentioned, bicuspid valves and excessive LVOT calcification. Always hard to define, but do we exclude people based on that? Well, in both of these trials, the patients were seen by a local heart team that was deemed to be an expert heart team, and they had to sign off that they met all the inclusion criteria and had no exclusion criteria in the trial, and that they had anatomy appropriate for either surgery or TAVR with the chosen valve. So one would think when it got to the national screening level, everybody would be accepted. But in the partner trial, 34% were screen failed at the national level. In the Evolute trial, 14.8% were screen failed. So these are clearly not all-comer trials. Now, why were they screen failed and what happened to them? We don't know, because once you're out of the trial, we no longer have access to your data. How about coronary disease? Well, if you look at the protocol, partner excluded a syntax over 32, and Evolute excluded a syntax over 22 from the trial. But the mean syntax in the Evolute low-risk trial in the arm deemed needing revascularization was only 7. You're not going to see a survival difference with this. So how about durability? There's a lot of ways we define this. Is from David Capodanno's work. And mainly we're talking about structural valve deterioration. Well, we do know some of this about TAVR. This is from Lars Sondergaard's NOTION study. Out to 8 years, these valves, even the first generation core valve used in this trial, is holding up really quite well. In fact, I've talked to Lars, and the data is getting out to 10 years, and it's still looking good. Here's 5-year durability for partner 1B, partner 1A, core valve extreme, core valve high risk, and of course NOTION at 5 years. So if you look at this, then you'd say, well, we have some pretty good durability data, but both the intermediate trials and the low risk trials will be followed out 10 years. And certainly I think that's going to help us a lot. We know as surgeons, our durability data has not been as good as we would like in the way we've recorded, because it was often defined on people getting reoperations. So when as a surgeon, when I'm thinking about what I'm going to put in a mechanical or a tissue valve, I look at the life table, which is the orange bars, versus the valve durability, which is, this is a pericardial valve, so the best durability we have. If you're 80, you're going to live about 10 years, and your surgical risk of losing this valve is about 4%. Pretty good for a tissue valve. 75, you live about 13 years, gets up to about 6%, still pretty good. Get down to 65, now you're going to live a little over 20 years, and you're getting up to about 18%. You may very likely need a second operation. And again, some of this data probably is overstated based on the surgical literature. And certainly when you get down to 60, where you're going to live 25 years, or 50, where you're going to live 35 or 38 years, if you get a tissue valve, whether it be surgical or TAVR, you're going to get probably at least one redo operation of some sort, and maybe even two in your lifetime. So lifetime management and risk becomes important. That the anatomy is suitable for transfemoral TAVR, and there's a low risk of TAVR failure. It also assumes a reasonable surgical procedural risk independent of age. Do they have post-op X-ray therapy? Are they a redo? Do they have lemografts crossing the midline? There are a number of things that go into this that are assumptions that aren't necessarily stated in the guidelines, but are important. What we find is there's this very large middle group, and it says if you're between 65 and 80, and you have symptomatic severe aortic stenosis, then we need to know, are you anatomically appropriate for a transfemoral TAVR, the risk of that, and the physiological risk of surgery. Either if you are appropriate for transfemoral, then either surgery or transfemoral is reasonable considered based on what the patients want to do. Now this, of course, assumes, so what do I conclude? Well, I conclude that age is a rough measure of remaining lifespan, and surgical risk is directly tied to your longevity. If you survive your surgical procedure and not correct your aortic stenosis, how long you live is based on your intrinsic underlying risk. And TAVR risk are tied to TAVR success, which is tied to longevity. So this is why I tie my decision to patient risk rather than age, although both play a very important part as we go through this. I want to thank you for allowing me to speak at your conference. I look forward to coming back in person in coming years as we hopefully all return to normal. Thank you very much.
So nice. We had Dr. Mike, Dr. Reardon giving us their opinion that age matters the most, and the second presentation that the risk is more important. And now Professor Michalis and Professor Angouras, we have to see that you were equally convinced, or if we have questions that we're going to proceed and talk about it. What do you think? We have two strong indications that age and risk matters a lot. So what we're going to lean towards what? Do we have questions from our participants or our speakers?
Why don't we have, if I may interject, Dr. Angouras and Dr. Michalis, you both heard these world-class speakers. You yourselves are in the academic world professors. What do you tell your patients? Professor Michalis?
Yeah, let me kick off. My feeling is that what we listened, it wasn't very much different from Professor Reardon, because what he suggested, that I think he's very right, that age because means more risk, and more risk means age, and that these two things they are not going. Although they are not overlapping, they are not going one on the top of the other. There's a lot of overlap between these two. And what also I made out of Professor Mack, and I think is very right, and I mentioned that after he finished his talk, that now we are not talking about who is the most suitable TAVI candidate, but we're talking about who is not a suitable TAVI candidate in order to offer him a surgical procedure. And I think this is a big paradigm shift. And also we have to admit that the majority of the patients with the aortic valve stenosis, they are old patients. If you take them, what I see in my everyday practice, almost of the majority of these patients are 80 or above 80. There are patients that are 75, but these are not by any means the big cohort of the patients that we're looking after, especially in Greece, where we don't have a lot of rheumatic heart fever, and so we're being left with bicuspid valves, which they present in a bit earlier age.
Professor, thank you very much, Professor Michalis. Professor Anguras, you know, as a cardiac surgeon, we heard two excellent talks by two excellent cardiac surgeons. We have another cardiac surgeon, Dr. Thirani, who's going to be speaking to us a little bit about his own choice. What do you think, Professor Anguras? Let's get your take. What do you tell your patients? What would you want for yourself?
Well, I think, thank you for these fantastic talks. They made me a little wiser. Thank you very much, both of you. They both have a point. You know, this is not a very clear-cut issue. Many physicians support the concept, including myself, that AIDS and expected survival should be the base of the discussion between the patient and the heart team. On the other hand, trials have been constructed based on surgical risk. So, you know, how data from these trials are interpreted and are incorporated in our decision making process and into guidelines. This is something that is debatable throughout the world today, both by cardiac surgeons and cardiologists. And as you all know, there's been a lot of controversy, and there's been this statement from the Latin American Association for Cardiac and Endovascular Surgery that's been published in the Annals of Thoracic Surgery and in the European Journal of Thoracic and Cardiovascular Surgery, I think a couple of months ago. Yeah. And they state that the age range used to support TAVI in the guidelines is well below the mean age of the low-risk trials, 73 in the partner 3 and 74 years at the evolved low risk. They consider that this is an important methodological flaw to recommend as class 1 recommendation any indication for TAVR or SAVR based on AIDS. They consider this to be devoid of scientific evidence. And I know a lot of cardiac surgeons that I've talked to, at least in Greece, that agree with that. And I will also argue that even if we had a significant number of 65-year-olds in these trials, maybe it's a little premature to give the highest class of recommendation in this age group, because we don't have enough data, as we well know, and you all said, for this age group, for these otherwise very healthy population with a very long survival in front of them. So as a matter of fact, we have some data from the older trials that show that there is a crossing of the, as you show, the crossing of the curves, which probably mean that the death and the disabled stroke, it's gonna favor SAVR down the road. So what the outcome will be in 10 or 15 years. For all these reasons, it's still a very confusing situation. So what do you think about that? Doctor,
I think that's a great point, Professor Anguras. Can we hear a couple of words from Dr. Mack and Dr. Reardon? Just a quick rebuttal. How do we get a class 1 recommendation for age 65 when the trials all have 80-year-olds in them? Dr. Mack or Dr. Reardon, either you'd like to start?
So I'll be glad to start, Greg. And I think, you know, as the point that Michael made is that, you know, less than 6 and less than 5% of the patients in the trials were under 65 years old. And that's why the guidelines made the recommendation that they did. Yet, again, as Michael said, patients come into the office constantly wanting TAVI. And it's our job to inform them of it's fine to get a procedure and go home the next day, but you do have to worry about 10 and 20 years down the line. And that's very difficult to convince patients that that's what you should be looking at. You know, in my heart of hearts, what I believe, if you're under 65 years old, you should have a surgical valve with the large valve possible to be implanted. If you can't place a 23 or larger valve in, then you are doing the patient a disservice. You also have to recognize that you're not talking about the same length of durability of the second or the third procedure. You know, we assume that surgery lasts 12 to 15 years the first time. We assume that maybe TAVI lasts 8 to 10 years the first time. The second procedure you can't assume lasts the same, and the third you can't assume lasts the same. So it's not like you're taking 10 times 10 times 10 and getting 30 years out of 3 procedures. So again, to me, this all comes down with durability. In the short term, TAVI looks better than surgery, just like PCI looks better than CABG in the short term. But it's what happens down the line that matters. And other than waiting to get the durability data, we aren't going to know that answer.
Thank you. Dr. Reardon, your thoughts?
First of all, I would never disagree with my friend Michael Mack, who I take as my mentor. I patterned my career after him, and I had wished I had age rather than risk. But you got to take what you're given. I think either of us have done either one of these. I do think that we're going to be dealing with surgeons of your generation, Greg, of some unique things. I've already done 16 surgical valves after TAVR valves taken out. Last Friday, I had a lady sent to me with a 21 trifecta that then had a 20 S3 put in her, and they sent her to me asking if I'd put in a second TAVR valve. I operated on her, took everything out and did a root enlargement, put a 23 pericardial valve in, and she has a mean gradient of 6. And I think as surgeons, we need to be able to push out and say, we can do these things. Because I get people sent all the time for valve and valve with a 19 valve in there and low coronaries, and just say, what, can't you put another TAVR valve in there? And say, no, they need the right operation in the first place. So again, it's a combination of age and risk, but I think sometimes it's not everybody understands what we as surgeons can do and should do. And we as surgeons need to do a better job of putting in appropriate valves. We haven't always done that.
Right. I think that's what you just said was a fantastic segue into the next speakers. I don't mean to steal the thunder from our moderators, but I think we should go on and introduce our next speakers. I see we have Dr. Kleiman on standby.
Okay, perfect. Yes, it's a perfect pass to the next talk. It's a great pleasure for me to introduce Professor Kleiman. He's a renowned interventional cardiologist. He's the Lois and Carl Davis Centennial Chair at the DeBakey Heart and Vascular Center, Professor of Cardiology at the Houston Methodist Hospital, Weill Cornell Medical College in Houston, Texas, USA. And he's gonna give us a talk titled, I'm a cardiologist who just retired at his early 70s, at my early 70s, and have an aortic stenosis. What therapy will I choose, a TAVR or a SAVR? And we're all ears, Professor Kleiman. Thank you for being here with us today.
Hi, I'm Neil Kleiman, and I'm going to share with you the assignment of choosing between TAVR or SAVR for a retired physician in his early 70s who has symptomatic aortic stenosis. By way of disclosure, I'm an investigator for a variety of TAVR manufacturers. I have not yet reached age 70, and retirement is not in my current plans. As you know, if someone has AS and is symptomatic, there are basically simple choices to make. For the purpose of this discussion, I'll stick to biologic surgical aortic valve replacement versus TAVR. Of course, if you choose medical therapy, there are other choices as well. So let's make some basic assumptions. I have few comorbidities. I'm in the low risk category. I have a tricuspid aortic valve, and I do not have anatomic contraindications to TAVR. So what do the guidelines tell you? Well, to simplify them, the EACTS guidelines published before the low-risk trials were presented indicated that at age less than 75, the data favored SAVR. For the ACC-AHA guidelines published after the low-risk trials, age less than 65, the recommendation was SAVR, 65 to 80, SAVR or TAVR, received a 1A classification, age greater than 80, TAVR. So let's start with the basics. If I'm 70 and live in the US, how much longer am I going to live? Well, the actuarial tables published in 2017 would say that my wife and kids will have to put up with me for another 14 years. Now, what if I've had a surgical aortic valve replacement? Well, there are a lot of studies in the literature. This is probably the largest. It's from the STS database cohort, 145,911 patients who underwent SAVR between 1991 and 2007. 88% of these had aortic stenosis, so there is a broad range of patients covered over a fairly extensive time period. But if one is between age 70 and 79, the median survival for isolated surgical AVR is about 9.2 years. And this figure keeps coming up in a variety of other publications. Now, what about factoring risk into it? Well, I would like you to focus on the green lines. These represent low-risk patients. And what you can see is that age 70 to 79, shown by the dotted green line, survival at 8 years is 62%. So this will probably end up being slightly better than the overall 9.2 years I mentioned. But it's important to note that age was really most important among patients in the low-risk cohort as opposed to intermediate or high risk. And there are also a variety of modeled studies that have been presented. And I'll show you this one that used a variety of statistical models to look at life expectancy with a biologic valve or mechanical valve and event-free life expectancy. So take a look. These numbers are going to be very similar to the ones you've seen. If I'm age 70, my life expectancy is almost 10 years. Event-free life expectancy is about 8 years. If I'm 75, obviously that decreases. And if one looks at the risk of structural valve deterioration, at age 70, it's about 18%. At age 75, it's slightly more than 10%. And I put this up because we'll come back to this model. So what about low-risk patients aged less than 70? We know that the clinical outcome of TAVR, at least in the short term, is pretty good. This shows propensity-matched study of patients in Germany between 2013 and 2014. Interestingly, although low-risk data weren't available at that time, only 27% of TAVR versus SAVR were selected due to patient wishes. So what about the randomized trials? I think everybody knows about Partner 3 and Evolut Low Risk. I've just summarized some key features here. In both studies, median age was about 73 to 74 years. STS risk, less than 2. About 2/3 of patients were male. 30-day outcomes largely favored TAVR. As far as death, stroke, acute kidney injury, or atrial fib were concerned, new pacemaker was more common among TAVR patients in both studies, so with the SAPIEN valve or with the core valve. And here are the primary endpoint events shown with Kaplan-Meier curves. For Partner 3, TAVR was superior to SAVR. For the core valve prosthesis, using a double endpoint rather than a triple endpoint, the design was non-inferiority, and in fact, non-inferiority was shown. When the events were re-adjudicated to include rehospitalization for heart failure, triple endpoint rather than the double endpoint was consistent with superiority for TAVR. So triple endpoint superior in both studies. Both studies achieved their goals. Now, what happens, for example, when you look at slightly longer term follow-up? So this is Partner 3. This is the one for which we have extended follow-up. It now reaches out to 2 years. And what you can see is for the triple endpoint, there's still an advantage for TAVR. But when one looks at death or disabling stroke, much of that advantage is lost. And at 2 years, the outcomes are very similar. if one looks at New York Heart Association class, the benefit for TAVR is somewhat diminished. But again, these data go out only to 2 years. So what are the limitations of the low-risk trials thus far? Primarily short follow-up, concerns about prosthesis durability, and periprosthetic issues, residual PVL, the need for pacemaker, and coronary access. There's also case selection. These patients were carefully screened. The exclusion rate is about 30% for partner and about 15% for Evolut. All these patients had tricuspid aortic valves. Most exclusions were for angular size and calcification. Now, as I said, there's a serious concern about valve durability. And to evaluate that valve durability, I'd refer you back to this 21-year-old paper, which looked at 70 series of biologic valves, 132,000 valve years, and tested several different statistical models to assess valve durability. One of the points made in this rather extensive paper is that at least 12 years of follow-up were needed to produce reliable estimates. So we don't have that yet. So let me show you what we do have in the interim. So I'd like to start with a study that was published last year in Circulation. This modeled survival based on projections for valve durability. These authors used a technique called discrete event simulation, which simulates life trajectory of individual hypothetical patients from a given starting point until an exit condition, death, or survival beyond a fixed horizon. So patients in this model accumulate elapsed time and they age. So this will, as I show you, incorporate the need for reoperation. The model based its estimates on data from Partner 3 and from the simulation of SAVR that I showed you a few slides earlier. So based on Partner 3, the median age was 73.6, plus or minus 6.4 years, SDS risk less than 4, perioperative mortality, 0.4% for TAVR, 1.1% for SAVR. So survival was based on age, likelihood of reoperation, the number of reoperations, which obviously varied between modeled patient, and the recognition that the mortality of reoperation increases as age increases. And these investigators used a ratio known as the event-time ratio, which is the time to reoperation for a TAVR valve divided by that for a surgical valve. Values varied between 0.1 and 1. So the longer the durability of a TAVR valve, the closer that value was to 1. And when one looked at this model, according to age, the event-time ratio made the greatest difference in mean survival for patients who are younger. So the older the patient, the lower their long-term survival would be, and the less difference that the ETR made. So if one looks at patients in age 70 years, shown in blue, and age 80 years, shown in purple, this is what you saw. For a 70-year-old patient, an ETR had to be less than 0.3, meaning the durability of a TAVR valve had to be less than 30% that of a SAVR valve in order for it to make a difference in life expectancy. At age 80, it had to be 20% that of a SAVR valve. So a SAVR valve had to last 5 times as long in an 80-year-old and 3 1/3 times as long in a 70-year-old for the difference in TAVR valve versus SAVR valve to make a difference. Now, we don't have 12-year follow-up, as I indicated earlier. But based on what we do know, do we see this? No, we don't. So we have reliable 5-year data from the randomized trials, Partner 1B, looking at mean gradient and effective orifice area. Partner 1A, mean gradient, core valve extreme risk, TAVR versus SAVR, core valve high risk, TAVR versus SAVR. We see better hemodynamics with the TAVR valves out to 5 years. And we don't see evidence, we don't see a signal that TAVR valves are starting to degenerate at this point. We now have 8-year data from the smaller NOTION trial of low-risk patients. And if one looks at structural valve deterioration, even out to 8 years, although the number of patients is small, TAVR still looks better than SAVR. What about outright bioprosthetic valve failure? Again, out to 8 years, again, the numbers are small. There does not appear to be a signal that TAVR valves are starting to deteriorate more rapidly than SAVR valves. What about some of the other issues? Paravalvular leak. We'll take a look at the low-risk TAVR trials. We'd like to say that paravalvular leak is disappearing and that it's not a problem. I don't believe that's true. If one looks at the frequency of mild or worse paravalvular regurgitation, it's nearly 30% in partner 3 and slightly more than 35% in the core valve trial. So it's still there. Now, is this important or not? We like to say that it's not, but if one looks at some of the data that include relatively long-term follow-up, it looks like it is. Here's the Gary registry from Germany, published a few years ago. Residual aortic regurgitation, mild to moderate or more, 1.5% adjusted hazard ratio, so a 50% greater risk of death in that registry. And when one looks at the high risk core valve trial, one sees a 1.45 hazard ratio, 45% greater risk if you have mild aortic regurgitation. So in short, I don't think the data convince us that this problem has disappeared yet. So what happens in a patient with a 9-year survival after TAVR? Is the ventricle going to see this or not? Is the ventricle going to start dilating at year 6? And by year 7, is that patient going to start experiencing congestive heart failure on the basis of aortic regurgitation? I don't know. We will see. What about pacemaker? Well, again, the data aren't so wonderful. Pacemaker implantation is increased in both valve types. Now, granted, we're making some modifications, so we see less of it. It's still there. Here's a meta-analysis on your left of all-cause mortality. Not much difference. Improvement in left ventricular ejection fraction. It seems that the dysynchrony induced by pacing may have an effect on ventricular remodeling. And if you look at your right, at adjusted survival based on need for pacemaker after TAVR, adjusted survival is not significantly different, but the curves are starting to splay by the time you get out to 4 years. And in fact, if you look at rehospitalization for heart failure, it seems to be increased among patients who required pacemaker after TAVR. So that's a concern. On the other hand, there are data concerning patient prosthesis mismatch and survival. So this is a paper we published from the core valve data 5 years ago, looking at patient prosthesis mismatch and 1-year survival for TAVR combined with SAVR. And the bottom line here is that if you had a patient prosthesis mismatch, survival was worse than if you didn't. Now let's take a closer look. Mike Deeb's data based on core valve data, the frequency of patient prosthesis mismatch, the difference between TAVR and SAVR based on annular perimeter. The larger the annular perimeter, the less the difference. For patients with smaller valves, smaller perimeters, the difference considerably favored TAVR versus SAVR. Take a look at severe, moderate or severe patient prosthesis mismatch. severe patient prosthesis mismatch. Small annular diameter, 30% for TAVR, 7.8%, rather 30% for SAVR, 7.8% for SAVR. Something to keep in mind, and when one looked at all-cause mortality out to 2 years, if patients had a large annulus or an intermediate-sized annulus, not much difference between TAVR and SAVR. For patients with small annuli, TAVR had a distinct advantage. What about bicuspid valve disease? Well, just to touch on this very quickly, these are Bill Roberts data, just to indicate that the fact that I may be in my 70s doesn't mean that it's guaranteed that I don't have a bicuspid valve. And in fact, among surgical specimens in patients aged 80 or above, bicuspid valves were observed in more than 20% of patients. So for a retired physician in his early 70s, it's still a possibility. What about the outcome of TAVR in patients with bicuspid valves? Here are data from the TVT registry published by Raj Bukhar, more than 2,600 matched pairs of bicuspid versus tricuspid valves. At 30 days, no difference in mortality. Stroke was more common. Moderate to severe PVL was more common. Was no different. And surgical conversion slightly more common, although the numbers are considerably less. At 1 year mortality, at 1 year, there was no difference in mortality. There was no difference in stroke. There was no difference in moderate to severe PVL. What's happening now? Well, if one looks at trends in TAVR versus SAVR in the US, what you can see based on some data we published from the National Inpatient Sample Database, over this 4-year period, 2012 to 2016, there's been a mild increase in the frequency of SAVR, and a more dramatic increase in the number of patients undergoing TAVR, although I would point out that the scales are different for the two modalities, but the relative increase is much greater for TAVR. And in the matched cohort, the critical clinical outcomes were very similar. What about types of bicuspid valve? This probably does make a difference. These are data from Drs. Yoon and Makar from the International Bicuspid Valve Registry. And if one looks at valve morphology, no calcified RFA and no excess leaflet calcification had the best prognosis, shown here. Calcified RFA or excess leaflet calcification had an intermediate prognosis. Calcified RFA and excess leaflet calcification had a 26% mortality at 2 years. So in conclusion, if I'm a retired physician in my early 70s, and I hope never to retire, but it may happen one day, if I have a bicuspid valve, large annulus, small sinuses of Valsalva, putting my coronaries at risk, lots of calcium, I'm going to choose SAVR based on what we know now. On the other hand, if I have a tricuspid valve or a smaller annulus, and I have large sinuses of Valsalva, I'm going to choose a TAVR, again, based on our current knowledge. Again, I'd like to point out that these data are preliminary. We do not have long-term follow-up, but I really hope we never can resolve this issue. I hope we can keep debating the issue forever. I discussed this 2 years ago in Athens in person. I'm discussing it now remotely. I hope I get to keep discussing it because the issue is never resolved. So again, thank you very much.
Thank you very much, Professor Kleeman. And now I think that we have to move on to see what Professor Thurani, who is a cardiac surgeon, again, with his main conflict of interest being that he's not 70 years old, and who is going to discuss with us how he would imagine himself being a cardiac surgeon and his early 70s and needing to change his valve. So let's see what he foresees for the future, Dr. Surani. Dr. Surani, please do.
Thank you so much. First of all, I'm privileged to be here. I'm going to share my screen with you so you can see this. Hopefully you can see this okay?
Yes, indeed.
So I wish I was there and not in my house in Atlanta, but here we are, and maybe one day we can come. And so these are my disclosures for the different companies. So first of all, I'm only 52, so I'm not 70s, but I am a cardiac surgeon. And maybe I'll be working till I'm 82. Quite honestly, this is my 5-year-old son and my 5-week-old son. And so maybe I'll be working till maybe in the 80s or 90s. Who knows? We'll find out, right?
You might have to.
I may have to. So since the TAVR inception, I'm not going to go, I've seen Neil's presentation, so I'm not going to go into the details of what he has done. He's done an unbelievable, great job in going through really the details of each aspect. And I'm not going to do that. I'm going to give a little bit faster presentation, and then maybe we'll have some discussion afterwards. As we all know, TAVR was a niche procedure. My first TAVR was in 2006 as a transapical and partner 1 study, and consequently now close to 3,000 TAVRs. So it's been a long time. In that same 15-year time period, I've done a lot of surgical valves also, so it's a good mix. And we've really evolved, as you've heard from the 3 previous talks, how we've evolved over time period. And TAVR's iterated into a reproducible, predictable procedure. This past Wednesday, I actually did 6 of them, and I was done by noon, 6 TAVRs by noon. One, and the very last case was a transcable. And so it's exploded into thousands of centers globally. Mike showed you some data from TBT registry and the over 700 sites that we have in the United States. Even though actually the bigger part of my practice is cardiac surgery and not transcatheter, this is what I deal with every Monday when I see the patients in clinic. They're like, I don't want to go to surgery. Help me figure out how not to do that. And I agree with Mike Reardon, Mike Mack, and Neil that patients are coming to ask for this. It's our responsibility to teach them and educate them on what is the right thing. But I will say at the end of the day, if TAVR and surgery are equivalent, if they are equivalent, not at 30 days, not even really at 1 year, but when we look at 2 to 5 years, I think that TAVR will become the accepted therapy. We have to have excellent procedural outcomes, good hemodynamic results, and durability, and all the previous 3 speakers have talked to you about that. Cost is also something that's important. I don't know how much that is in Greece as it is in the United States. For me personally, my talk was what would happen for me in my 70s. Cost would not be an issue because I would take care of whatever needs to be done. But that is a big issue for other people. We do have insurance companies in the United States who have not approved low-risk TAVR. So therefore, if they're in that insurance company, the Anthem insurance company, even though guidelines say it's okay in low-risk patients and FDA has approved it in low-risk patients, the Anthem insurance company will not pay for a TAVR patient who's low risk. And so there are issues that we're already dealing with in the United States on this. This is a paper that I published that actually showed surgical results. And this is the largest surgical report, 142,000 patients in the STS database. This morning I was working on, there is another updated paper that we have in over 240,000 patients on surgery. That's just being accepted to the annals and hopefully will be out in the next couple of months. So I can't show you the results of that. But if I do want to talk to you and concentrate on the lower STS patients, the STS less than 4, both Neil and I are considered low-risk patients. So we're both low 70s, cardiology and a surgeon. And what would you want? We would be a low-risk person. The STS score is actually very predictive. I know people say it's not, but it is. So the predicted STS score was 1.7. Guess what actual was? 1.7. The STS was very predictive in low-risk patients and what a surgeon in the United States, how he was going to or she were going to perform. That's very important. Look at the mean age, by the way, 65%, 65. Okay. So this, I think, is a good way to look at it, that the STS is a good predictor in surgical outcomes in hundreds of thousands of patients. This is just a slide of the paper that's going to be published. This is very unique data. Isolated AVR in the United States, surgical AVR, the median case per hospital is 20. So they're on an average hospital. There are 1,100 hospitals in the United States that do heart surgery. The median number of open AVRs is 20. The median number of AVR CABGs in the United States is 13, 1 per month for the institution, not for the surgeon, for the institution. Okay, so this is something important that we have to start to look at. And here you can see the annual volume. There's some centers and the number of hospitals. You can see most of the centers did in between 0 and 50. You see that? So in AVR CABG, you can see it's a little bit different. And here are the outcomes for that. And we broke it up by the number of surgeries done per institution. So there were 9,367 patients, and that hospital did either 1 to 25 AVRs per year. There were 54,000 patients who actually their operations were done in hospitals that did over 100 AVRs per year. This is just for isolated AVR. The STS predicted was 1.8. The actual was 3.5. Low volume hospitals doubled their mortality was double what it was predicted to be. In high volume hospitals, the predicted mortality was 1.8. The actual was 1.5. So they did slightly better than what the STS predicted. And this is kind of the follow-up to the original study that I showed you. This will be published hopefully over the next couple of months in the Annals of Thoracic Surgery. As Mike mentioned, I think as Mike Mack mentioned, we've done over 9,000 to 10,000 partner study patients now. This is just partner. Think about doubling this when you add the core valve. This is just what I've been involved with and have a little bit more data on. And what have we seen? I'm going to show you the different components. I know that people have criticized the composite endpoint for the trials. I'm going to show you the individual components so we can talk about that. And here, this is for the low-risk partner 3 study. You can see that mortality in blue for TAVR was 1, 2.5 for surgery. From year 1 to year 2, that gap closes. So it'll be very interesting as we do the next presentation, which most likely will be a 5-year study. Mike Mack and Marty Leon will need to decide on that. It'll be most likely to be a 5-year study in a year or so, year and a half or so. So let's see, is this going to stay at 2.4 and 3.2, or are the graphs going to cross? That, I think, will help us guide what happens next. You can see at 1 year, there's a delta of 1.5. That delta is cut in half at 2 years. Here's the same all-cause mortality for the core valve study. At 1 year, there wasn't that gap that you saw, that 1.5 delta. It was more or less close to right on top of each other and was not statistically significant. Let's talk about stroke for the low-risk trial. A lot of strokes early on for the surgery group. That led to that difference in a statistical advantage of TAVR. This is what happens over 2 years. TAVRs double their stroke rate from 1.2 to 2.4 from year 1 to year 2. Surgery at 3.3 does not elevate to 3. It doesn't double. If it were to have doubled, it would have been a 6.6% rate. It did not. You had your stroke early on. You weren't going to have a stroke after that, more or less. And the statistical advantage goes away at 2 years. And you can see the delta of 2.1 and the delta of 1.2. Now, mind you, I just want to point out, this is all-cause stroke. This is disabling stroke. So the numbers, don't look at the numbers necessarily, but you can see here also surgery have a higher stroke rate. This is the 1 year data. And let's see what happens from year 1 to year 2. Now, at the components, if you draw out the individual components, this is for the partner 3 study. You can see TAVR and surgery. This is 1 year, 1%, 2.5%. Then you see the stroke, 1.2%, 3.1%. And this is rehospitalization. Okay. So the surgery patients had an 11% rehospitalization in the first year. The TAVRs had 7.3. So if you add all of those up, this is what we're looking at, the primary endpoint, but I wanted to show you more importantly, the components of it. If you look at the same bar graph for core valve, you can see, the value didn't show up there, but it's, as you saw, 1 year slightly higher, just above 3. And then you can see here the disabling stroke was much higher. It was a 4 to 5-fold increase. And then here you can see the repeat hospitalization also higher. for surgery. So this is kind of where we stand for the best trials we have. All I'm going to mention about perivalvular leak, which I think is the big ones that are important, that is going down. And I know that Neil gave you some very good data on that, and so I'm going to just mention that component of it. As far as pacemakers go, here you can see for the SAPIEN 3, Partner 3 study, there was no difference, 5.4% at 1 year surgery versus TAVR, and that's non-significant at 1 year. And when you take it out to 2 years, it's 8.5 versus 6.3, not significant. Surgeons believe that their pacemaker rate are 0. They believe it's 1. It's not. It's in really good surgical hands. You see it's a 5.4% surgical pacemaker rate. Neil touched on this a little bit. I'm just going to say that here you can see that the difference are statistically significant, most likely clinically not significant, but this is at 2 years. Let's see what it is at 5 years. I think that'll be important. There's not a huge change for surgery, for TAVR, 11.2 to 11.8, and then for surgery, 12.8 to 13.6. They're basically going up 1 millimeter over 2 years from implant, and I'm okay with that as a surgeon, as a transcatheter person. I'm okay with that. If it's starting to creep up faster at year 2 to year 5, that becomes important to me, and that's really what I'm looking for. In valve hemodynamics, it is core valve is superior to the surgical to their surgery arm, and you can see that it's 9 versus 12.3. And if you look one slide past the other, you can see at 24 months that was 9. At 24 months for SAPIEN 3, it was 11.8, about a 2.8 millimeter gradient. For surgery here is 12.3, and on the previous slide for Partner 3 is 13.6, so about a 1 millimeter higher for surgery in the Partner 3 study. So, but overall, the ballpark is somewhere between 9 and 13 on the gradients, which I think is okay as long as they don't continue to go up. This is from the core valve. You can see that the mismatch is much lower in TAVR compared to surgery. Of course, Mike Reardon mentioned that how important it is for surgeons to do a good job. Why is this topic gaining momentum? Because Chris at 65 really cares about this. He cares about durability. The 75-year-old, he cares about durability, but in case of failure, he kind of wants to have a redo TAVI. And the 85-year-old, he doesn't really care about durability. He cares about better quality of life. So these are the barriers. For the sake of time, I'm not going to go right into that, but these are some of the barriers to overcome for TAVR. Quite honestly, there's understanding different patient populations, a better predictor model. We've talked very aggressively. I had a call yesterday for an hour about anatomic predictors, not clinical predictors. Durability, of course, the thrombosis, anticoagulation is still up in the air. Methods for TAVR-related complications are not still well defined, and you can see other aspects. There are some anatomical differences. Here's a patient that had a severe bicuspid valve. I think all of us would take this patient. You can see on the right and the left into surgery. And here you can see what this patient looks like. This patient ended up having an AVR ascending. And this is the valve that was resected. Of course, that would go to surgery, and that should always go to surgery. New surgery is better in these three categories. I put valve gradients with select surgeons, not with the 19 valves. Mild PVR, I think, is important. Neil mentioned that. Both valves have mild PVR in around the 20 to 25% rate, and new left bundle branch blocks. You can see surgery is equivalent to TAVR in this category. New pacemakers, I think, depending on the valve type for TAVR that you choose. And then right now, in short to 1 year to 2 year outcomes, TAVR is better here. This slide will change as we get 5-year data. So I personally have a trileaflet valve, Greg, and guys, I wanted to tell you that. So therefore, for me, it'll be a TAVR. And TAVR device and techniques will continue to improve. We have DICE simulations, which is helping us on a computational simulation modeling. I think I would prefer a less invasive therapy. The option for a valve for me, my 72, 73 will be a bailout. And early on, it'll be it's superior in many regards. So I think that I agree that TAVR first pathway for me in a trileaflet valve will become important. Thank you very much for your attention, and look forward to seeing you in person, but also for any questions.
Thank you very much, Mr. Dr. Thorani, and I'm sure that you will work till the age of 80, because not only because you will enjoy it, but because you will need to. Anyway, I think that that was. I didn't expect to listen to both the cardiologist and the surgeon. I think that the cardiologist was a bit more skeptical and was thinking a bit more about having a surgical valve than the surgeon. But in any case, what you have to understand is that it's not a competition between surgeons and cardiologists. That becomes now a bit of a joke, and I think that we have to stop thinking like that. We have real patients in front of us, and we have to think what is the most suitable, what is the best for the patient. And just to start again, I think that of what I can understand, for the elderly patient, TAVI is not a question. It's something that has to be offered, and we have to start thinking what we have to do with the younger patient, and when also we have to pay attention to the special characteristics of the patients. Comorbidities make them suitable for TAVI. Anatomic characteristics possibly make them for suitable for a surgical approach. And for the younger patient, we have to inform and discuss with the patient, and we have to understand both ourselves and the patient that one intervention is not going to be enough. He's going to have more than one interventions towards the journey of his or her life. I don't know if somebody wants to discuss or if there are any questions about that, if everybody agrees.
We have some time now, Professor Michalis. Let's have the other cardiac surgeon weigh in from the moderators, Dr. Patakos.
Gregory,
Patakos and Patakos here.
If you can give the senior also the word.
Yeah.
I think, first of all, Greg, I would like to say that it's not that often to have such a panel, so distinguished speakers, and each one convinced us for the merit of his cause. In other words, each one was talking and were convinced, oh, it's the risk. No, it's the age. So we saw all the aspects of the decision. So we're convinced that the decision is not easy. And it's not to favor cardiology or cardiac surgery. That's why we have the heart team, because on top of everything is the patient. And we have to do the best for the patient. We saw all the details. So we have to see the aortic valve, the calcification, the sinus of Valsalva, and make the right decision, not just superficially. Looking forward to have all our distinguished speakers next year. And I can add to my cause that I will be obliged to serve not as a scientific member of the effort, but to be in charge also to let them enjoy the Greek nature and waterfront activities. See what Greece, because Greece is not only Sabra and Tavor, it's also seeing the country and see the waterfront. So thank you very much, and looking forward to see you in person next year.
So Dr. Patakis, I want to say one thing. I want you to know this. Now, I'm not just saying this. My wife's #1 country to go to in the world is Greece. And so she has begged me to come there. So I have a double reason to come.
Tell her that she's invited next year. We'll take good care of all of you.
Well, as I said, I hope there's not a definitive answer to the question during our lifetime.
Exactly.
So we can keep debating this.
Dr. Kleiman already alluded to this, and we have another 2 or 3 minutes left, if that's okay with the moderators. I wanted to ask Dr. Kleiman a quick question, and Dr. Thorani perhaps, and if we can get some other members of the audience, Dr. Nikas, Dr. Abadziz. If there are people on board here with us that also want to ask questions, we'd love to have your questions since we have another 3-4 minutes. A real quick question, Dr. Kleiman brought up on the side chat that we were having here, a real good point. And that's what we know from the US, and that's a lot. There are a handful of high volume centers, and there are a lot, at least in the US where there's good data published, there are a lot of hospitals doing very low volume. And, I have colleagues I trained in the US, and I have a lot of colleagues who tell me about the smaller hospitals they work at. they don't see what the partner trial saw. They don't see what Dr. Thorani is doing at Piedmont, what he used to do at Emory, at Washington Hospital Center, at any of these places, or what Dr. Kleiman and Dr. Mack and Dr. Reardon are doing. I think, we have to say something about reproducibility. And I think that a lot of these procedures, as someone who also does transcatheter procedures in open surgery, a lot of the transcatheter stuff, we have to be honest, is more reproducible. It's more reproducible. And I hate to say this to our cardiologists, but I think that if you have a low volume cardiac surgery program, it's probably going to be eclipsed by your interventional cardiology program eventually.
Isn't that amazing, Greg? The data that I showed, when that gets published, I think that a lot of people will find that very interesting.
I mean, I think, Dr. Thorani, I'm on the editorial board of the Annals, and we see these manuscripts coming through looking at US data for a lot of things. I looked at something recently looking at US data for CABG. You'd be shocked at the average number of CABG procedures. It's supposed to be our most common procedure. A lot of hospitals are doing, surgeons are doing 10 CABGs per year, 20 CABGs per year. It's only the real high volume centers. And obviously we've studied this for mitral disease very well with the GAMI papers and the other STS database papers. But there's a lot of things that we're doing low volume. And I think we have to talk about, are we going to go where bariatric surgery went, where you have only centers of excellence doing some procedures?
Yeah, much as that makes sense to all of us, and granted, we all have a dog in the fight, so to speak. The big push in the US is still for decentralization, move away from centers of excellence. We had a paper in JACC Interventions about that for interventional cardiology a few months ago. But, I think at some point, this is going to come back to bite us in a big way.
If I may say something, Gregory, since we have a couple of minutes still to go, let me suggest another scenario to our speakers and see what they have to say. Let's say that their valves fail after 10 years. So also let's suppose that you are 65 and not 70, and you still have a TAVR or a SAVR done at the age of 65, and the valve fails after 12 years. So now you're 77 and you're low risk, you are not frail, you don't have comorbidities, and so you have at least another 10 years of life, probably more. Most of these years, Dr. Brown is going to work as a cardiac surgeon. So now I would guess that if you had a SAVR done, you would opt for a TAVR at this point of time, unless your surgical bioprosthesis was very small, was a 21 millimeter, which is a somewhat more difficult decision. But if you had a TAVR done at your 65 years of age, would you opt for a TAV in TAV at this point of time? Does this lot of hardware, your aortic root concern you at all? There's a lot of data regarding, a lot of difficult thrombosis and coronary access issues, and having this scenario in mind, would you change your initial decision at 65? Would you opt for a surgical bioprosthesis then? What would you say?
Go ahead, Neil. You want to go and I can follow?
Being 65 and assuming my risk is low and that, I've taken appropriate radiation precautions, and haven't, as an interventional cardiologist, got something bad in my bone marrow, I would opt for a SAVR at this point in life. I think if that's your question.
Yeah, that's it.
So I think that was a great question, Professor Ongaras. I think that's great. So I would say a couple things. I'm now not talking of, I looked at our system this past week. We've done 281 patients with a TAVR who had an age less than 65. I was shocked over that, right? Because I just joined the practice at 18 months ago. So we're going to look at those patients and see exactly what's happened to them over the last 5 years. But I would say for me personally, I now talk to everybody about not this procedure, but the next two procedures, assuming they're going to live till 90. Okay. Right. And I tell them, for me, I worry about coronaries. I'm choosing personally a self-expanding over a self-expanding. For that reason, I get a little worried about self-expanding coronaries, especially if the STJ is a little low and the root's not very big, because then your second valve will become THV, and THV will become problematic. So if I had a 20 or a 23 original TAVR valve, I would have repeat surgery. If I had a 26 or a 29 valve, I probably would consider a THV and THV at that point. I don't think a 23 or 20 TAVR valves will be very, very favorable for a THV and THV down the road, because I think we'll create that Russian doll effect, which I think is untenable. So if I'm 77 and I received a 29 valve, I think I can get another TAVR valve. But if I got a 23 valve, I don't want to be open back up. So
Yeah,
I'm thinking
I
in
would
that
agree with that.
regard. Does that help a little bit?
Yes, that makes sense. So your initial decision is going to depend a lot on your aortic annulus size as far as
It all depends on what the CT shows.
Right.
And if the CT showed me that I was going to get a 19 surgical valve, I would go get a TAVR, because I don't want, unless I went to a surgeon who was going to do a root replacement on me or put in a 23 with a root enlargement with a Nix procedure, which is commonly what I do. But so obviously we're different, right? Everybody on this panel would have a high-level surgeon. Most people aren't on a panel like we are and have the insight and the knowledge. They just go to the local surgeon.
Yeah, I think that's a very good point. And seeing as how we're just 2 minutes beyond time, I think we should wrap up and say thank you to everybody. I'll let Dr. Anguras and Dr. Michalis and Dr. Patakos Sr. Close up. Thank you very much on my part, at least. Good to have you here.
It's our honor. Thank you.
Thank you all.
Thank you, everybody. I have no more further comments. Thank you. It was a privilege to have you all on board and listen to your fantastic talks.
Great session. Come to Greece. We'll do it live.
Yeah, it'll be
That
fun.
was great.
Okay.
The privilege is ours. Thanks, guys.
Thanks very much.
Bye-bye.
Looking forward to see you.
Θα μου δώσετε ένα λεπτό.
Ναι, ναι. Dear colleagues, on behalf of co-chairman Dr. Pilatis and Dr. Sparias, welcome you to this very interesting session, and a session with cases. It's a great pleasure for me to present first speaker, which is Professor Skalidis. Professor Skalidis, we are very interested in your case and in each way you deal with it. Professor Skalidis.
Hello. Can you hear me and show the presentation?
Perfectly well, Manolis.
Thank you. Congratulations once again for this excellent meeting. Because of the time constriction, I'm going to present a post-dilatation in a constricted self-expanded valve in a 90-year-old woman with chronic obstructive pulmonary disease. We used the GFR, New York Heart Association 2 to 3 class, multiple syncopal episodes on effort, and obviously severe aortic stenosis, max pressure gradient 110 millimeters per mercury, and a Euro score of 6.7. From the CT analysis, nothing special except that the measurements are not safe. There are a lot of moving artifacts. Despite that, the perimeter of the annulus was 80 millimeters. A lot of calcium in the leaflets up to the base of the annulus, some calcification here, and a little bit of extension of the calcification below the non-coronary cusp. You can see here some calcification. The size, according to measurements, is going to be 29 millimeters, but since we were in doubt about the sizing and the measurements, we did pre-dilatation with a 20 millimeter balloon. The anatomy is quite small, and because of that, and almost complete sealing with 20 millimeter balloon, we decided to go with a 26 instead of 29 millimeter evolute R. Here is the position, a deep, somehow deeper position at the release. And despite that, from the left, it was quite good. From the right side, it is quite constricted, under-expanded, the valve you can see here. We decided to go with, again, we insisted to go with a 20 millimeter balloon.
Το ξέρω, ναι, και θα έγινε.
We inflate the balloon and there is a recoil, as you can see here, with the 20 millimeter balloon. So we have to go with a 22 millimeter balloon. And after that, according to the law, if there is 50 to 50 chance something to go wrong, then 95, 90, over 90%, it will go wrong. And here is after post-dilatation with 22 millimeter balloon, contrast in the left ventricle, in the right atrium, you can see here, and in the left ventricle, rapid deterioration, the patient collapsed. And we performed blind pericardiocentesis with autotransfusion, and somehow the patient was stabilized. And you can see here the point of rupture of the annular, subannular rupture. And it's obvious that we are in this 2D case. Is subannular rupture with communication with the left ventricular outflow tract to the right atrium. That is the iatrogenic Zerbod defect, in other words. And is quite common in this area, that is between the right and the non-coronary cusp in the membranous septum, and the membranous septum rupture is above the tricuspid valve, is in the right atrium of the point of communication. The predictors, because of the time, I'm not going to say more details, but about the therapy is repair or reconstruction, is surgery with aortic valve replacement. But in this lady, no one wants to operate on her. So we proceed, since the hole was exactly below the first valve, to put another valve 1 centimeter below the first, and hopefully we close the hole. We release the 26 millimeter again valve. There is an improvement, but still there is some communication with the right atrium. The patient was good, and after 10 minutes, there is no more leak, and the rupture was sealed with, and even in the orthography, there is a mild leak, but in this particular case, we accept the result. So, in conclusion, annular rupture is rare, but life-threatening complication, about 50% mortality at 30 days. Annular calcification in the landing zone of the valve is a key predictor. Aggressive post-dilatation is a bad thing. Sizing and planning, pre-procedural planning, is the best way to avoid annular rupture. We prefer self-expanded valve instead of balloon expander. Management, percardiocentesis, heparin reversal, surgery, and in some cases, like our case, the position of the second valve may solve the problem. Thank you for your attention.
Professor Skalidis, congratulations. First of all, you saved the patient. And a question, a very short question. Do you believe that the fact could be predictable?
Actually not. We were afraid of that, but in most cases, it's not predictable. There is no, you know, when you see, especially in the left ventricular outflow tract, calcium, a lot of calcium, especially more than 5 millimeters, calcium extended to the annulus, that the possibility for rupture is higher, but you try to undersize the balloons and the valve to avoid it, but you never know the result.
Okay.
Manolis, that was, if I can make a comment, that was a very interesting case. And it just confirms the fact that every time we have a lot of calcium, we're in trouble. So the more the calcium, the more the trouble. And I think that was extensive annular calcium everywhere. And we avoid to inflate balloons generally in these situations. We go with a self-expanding valve. Probably we should stick to the CT scan screening criteria for the sizing and not use the balloon valvuloplasty and simultaneous autography for self-expanding valves. This is a good dimension measuring tool for balloon expandable valves, but I don't think it's so good for the self-expanding valves. So how do we stick to the CT scan measurements? We should have used the 29 millimeter valves, but probably will have some more radial force, so less paravalvular leak after deployment, and probably the need for more aggressive balloon post-dilatation will be less. But then again, every time we see this calcium, we know we're in trouble. In our experience, is the number one trouble. So it's conceivable this what happened, and congratulations for your reaction, for the pericardicentesis, and for having you know, the ability to react so nicely with the second volume valve and tap this VSD communication.
We will
So,
have, but I don't know if we put from the beginning a 29 millimeter valve, the result was even worse. I don't know.
yeah, you're right, because there was a lot of compression on this 26 valve from these calciums. So you're right. So,
okay,
let's move on. Nectarius.
Okay.
Dr. Pilates.
Good evening to everybody. It's a pleasure to introduce Dr. Voudris, who is well known to all of us, who is the head of the Cath Lab at the National Cardiac Center, to present the second case. And I'm sure that's a very interesting case, and we're very eager to listen to him. Dr. Voudris.
Thanks a lot, dear Chairman. Thanks a lot, the organizing committee. That's my disclosure. I'm going very briefly to present two cases on the same topic. The first one is a lady, 80 years old, with severe symptomatic aortic stenosis, normal coronary arteries, logistic Euroscore 1, 19.4, severe aortic valve stenosis 0.8 centimeter square, being gradient 41, and the heart team proposed TAVI procedure. This is the measurement. The annulus has a diameter of 23.8 millimeter, and there is a functional bicuspid aortic valve with severe calcifications. This is the aortography before the procedure, and the pre-dilatation with a 20 millimeter balloon. And then we implanted a Medtronic Evolut R26 millimeter device. You can see clearly the opening of the valve very progressively. The valve is free from the delivery system. And the final step was to remove the pigtail catheter that we use for orthography during the procedure, and we remove also the valve. So we continue with an orthography to confirm the new position of the aortic device. And we use a laser catheter to move the valve in the ascending aortic near to the aortic arch. You can see the position of the valve after laser catheter, and very easily we advance the second Medtronic Evolut R26 millimeter device correctly in the correct position, progressively open the valve, Finally, we had a post-dilatation with 22 millimeter balloon with an excellent angiographic result. The second case is a male, 82 years old, with severe symptomatic aortic stenosis, several comorbidities, normal coronary arteries, logistic Euroscore 2, 5.81, aortic valve area 0.7 centimeter square, preserved LV function. These are the measurements. The aortic annulus is 25.6 millimeter. Severe calcifications. Aortography, as usually, pre-dilatation with a 24 millimeter balloon. And we decide to implant a Boston Accurate Neo 26 millimeter device. The valve is advanced very easily to the aortic root. We assess the position of the valve. The proximal part of this valve is open, and then we continue with the distal part of this valve, and you can see the cone, the nose of the catheter inside the left ventricle. We try to remove the cone through the aortic valve, and we move the valve in the ascending aorta. We have an arterography to see the position of the valve, and finally we decide to implant an Edwards sapien valve, 29 millimeter, through the Accurate Neo valve. This is the opening of the sapien valve. And this is the final angiographic result. No regurgitation, excellent hemodynamic. So, as messages, valve displacement may occur with all type of transcatheter aortic valves. Be ready to deal with this complication using your experience, and thank you for your attention.
Dr. Voudris, thank you very much for these very didactic cases. And you show us two of the most common causes of the valve displacement, which one is the entrapment of the catheter. So when you try to remove it, you take the valve with it. So the solution, probably the prevention, is to use a wire to try to remove the catheter with a wire. And the other cause is the removal of the cone of the valve, so take the valve with it. But you solve the problems very easily, I saw, and very effectively. Just to bear in mind that two other causes of the valve displacement is the conical LVOT. So the LVOT is very narrow, and the valve looks like a cone when it opens up. So that's another problem that we may face, and if we are not very careful, we may remove the valve and attempt to pull the cone out of the LV. And also the post-inflation, the post-dilatation of the valve. So we think that it's a very nice demonstration of how bad things can occur, and at the same time, how easily an experienced operator can solve the problems. Thank you very much.
I'd also like to thank Dr. Voudris for sharing these cases with us and all of you. I think this is how we're learning, by sharing cases like this and discussing them openly. And just a comment, I think the first case was a bicuspid valve,
functional bicuspid valve.
Yeah, with calcified raphe, and this could certainly predispose to this compression on the self-expanding valve and the popping up. But of course, the main reason, as you discussed, was the pigtail there. So I think, thank you very much. I think we can move on. Dr. Kafkas, I think
yes,
you may...
I apologize for a little bit change in the program. Next case will be presented by Dr. Zaharoulis. Dr. Zaharoulis.
Thank you very much. Let me share screen with you in a minute. Here we go. I would like to thank the organizing committee for the kind invitation and apologize for the inconvenience in the program. I will be presenting a case that we did a few months ago. This is actually a perceval valve that has gone rogue. This refers to an 84-year-old gentleman that presented to ER with pulmonary edema and has been complaining of severe dyspnea and exertion developing over the last 10 days rather fast. The physical exam is, as you see here, with a diastolic pressure rather low, a rapid heart rate. He is definitely desaturated and afebrile. The EKG is a rapid heart AF of around 110. The chest X-ray showed an increased cardiac index with bilateral effusions, and his past medical history contained of a perceval valve, medium size, implanted 3 months ago. He also has paroxysmal AF and COPD. These are the medications here on the bottom of the screen. So what we did a rapid echo at the ER, and one can appreciate that there is a significant AI with significant moderate MR and an LV dilatation. Here you can see in both images. The patient was admitted in the CCU, placed on diuretics, IV nitrates, and nasal O2. And approximately 3 or 4 hours later, he was stabilized. The lab work came back, nothing significant. There's no white blood cell elevation. Hematocrit is pretty good. The Chem 11 is pretty good, with the urea and creatinine maybe in the high normals. Normal liver function tests and CRP of less than 1. Then when we decided to see what's going on with this guy, we decided to do a TEE. And one can appreciate here that there is a space behind the valve. You can see the valve opening, the 3 leaflets here opening, the prosthetic valve opening, and there is a space here that you can also see there is some flow going through. So there is this question: what is this? Is this a PVL? Is this an abscess? Is this a fistula? What this could be? And is this the reason why the patient is destabilized? So the differential, as we were discussing about the patients, we thought we would have a prosthetic valve degeneration, but this is too soon. It's only 3 months after the implantation. Could this be endocarditis? Well, the patient has no fever, the CRP is low, and the white blood cell is low. Could that be subacute thrombosis? Well, no, because the INR is 3, and it's rather unlikely. Could that be a PVL with an aortic roots abscess and a fistula? But the AI is mostly transvalvular. So what are the other conditions? Anyway, we decided to proceed with TAVI, valve-in-valve TAVI, with a working diagnosis of a prematurely degenerated perceval prosthetic valve. But the CT imaging showed something different. As you can appreciate, the valve has moved from the position that it should have been placed in the original operation, and you can see that the lower part, the lower portion of the valve has actually left what would be the normal position for that, and it also has moved so high that there is definitely interplay with the coronary arteries. So this is the aortogram. You can see that there is a valve that definitely has gone wrong. It's out of place, and the reversion portion of the valve is barely hanging on the native leaflets. You can see here. And just to compare, this is what we should have, or what this is a more correct position of the valve. You can see that the inferior aspect of the valve is clearly under the annulus of the valve. So what we definitely have here is a valve that has gone north. So there are several issues to be considered in the case. First of all, if we try to do crossing of the valve, will the wire cross through the prosthetic valve in the ELV, or will it cross behind the valve, following a route through the valsalva sinuses into the ELV? Then should we perform a valvuloplasty to check the leaflet interaction with the coronaries, or this could destabilize the situation by breaking the valve loose? Furthermore, what would be the valve of choice in this case, and should we protect the coronary ostia or no? So we decided to proceed with the case anyway, and as you can see here, we managed to get the wire through the valve, and we checked that in different positions, and made sure that it's going through the valve, and then we decided to protect the left main for the main reason that the valve was already too high, and there was extreme possibility for leaflet interaction with the left main. Don't forget that the leaflets here in the perceval system, they actually reach rather high. So the valvuloplasty would be too risky, and it could cause dislodgement and migration. And then, on the other hand, we would not be sure if the STJ was narrow enough to contain the valve, if that valve decided to move from its position. So for this reason, we did not do a valvuloplasty. What kind of valve? Well, there are two options, self-expandable or balloon-expandable. We decided to proceed with a Sapien S3. This is the valve we have the most experience with. Plus, we had Dr. Sparias on the floor, so we're more confident with a Sapien valve. The pros in this choice were that it has a lower skirt that would minimize the danger of left main ostium occlusion. Rapid pacing also would minimize the possible interaction between the transcatheter valve, the prosthetic valve, and the native valve NLV. And on the contrast, a lower frame height compared to a self-expandable valve would possibly fail to contain or capture the perceval leaflets in an open position, thus having two valves in series. One, the transcatheter that we have implanted, and one, the one that was already working. So where to implant the valve on the other hand? We must not follow the perceval lower edge landmark, obviously, because this is not in place. So one would say, well, implant it low, because you must cover the native valve and treat the AI and the AS, but not too low, because then you would miss capturing the perceval leaflets in an open positions, and thus, as we said, we would follow a conundrum between the two sets of valves working in series. Then place it high. Well, high enough to capture the perceval leaflets in an open position, but not too high, because you will miss the native valve, and you would miss treating the AI and the AS. And then further, you would increase the danger of compromising the left main ostium. So we have to try finding the sweet spot. And this is what we did. This is exactly what we have, actually. This is a schematic. The valve has gone further north. And we had to implant this valve in a position that has to deal both situations, deal with the diseased native valve and also with the leaflets of the migrated valve that has been degenerated. We did a few attempts. And you can see here we have protected the left main. We did a few attempts and decided to release the valve here. The valve was deployed, and as you can appreciate, it is somewhere in between from what would you want to do when treating a degenerated perceval valve. It expanded nicely, and this is what we have. The valve looks good. There is some central AI, probably wire reduced, and the left main is in place. So we were pretty happy, and this is what we had as a final result. There's no AI, the left main in place, and the patient doing fine. These are our case collaborators. Dr. Sparias was kind enough to help us with this case, and these were the other physicians involved with us, Dr. Papas, Dr. Delias, and Dr. Knopoulos. Thank you very much for your attention.
Congratulations, Dr. Zaharoulis. As you know, valve-in-valve cases are a challenge, but your case was something with much more difficulties. A question, what was the main reason that you choose Sapien 3 valve and no another?
Well, as I said earlier, I mean, in this situations that you are dealing something that is out of usually out of the ordinary, I think you should go with what you have the most experience with. And we felt more confident with using a Sapien valve. I don't think that it would be wrong to use another valve. And there are, as you say, as you might have seen in the presentation, there are contrasts, and there are pros and cons for each decision. But I think that it was a good choice in the end because we had a good result.
Yes. Kostas, Nektarios?
Just
Yeah,
okay,
Nektarios,
Costa, go ahead.
Sorry,
Okay.
you go ahead first.
Okay, thanks. I think it's very important that you know the valve that you're dealing with. So it seems that you know very well what the perceval valve looks like, and that's why you are pretty sure when you choose the Sapien 3 valve to put in what you expect to find to see and to find. So I think that's very important, and you made a very nice choice using this valve for valve.
Right, and just a comment on why not using a self-expanding valve. I believe that the self-expanding valve will be caught within the perceval, and there will be a restriction of how much to expand. So it wouldn't have the radial force down at the annulus to anchor to the annulus. It will stay like half open because it will be restricted by the dimensions of the perceval. That was the main reason.
Thank you.
Okay.
Nektarios?
Go ahead and proceed with Dr. Latio's case, I think, is the next one. And we'll see how we can deal with the peripheral access problems. Okay. Dr. Latios?
Yes. Hello, good afternoon. Thanks to everybody for the invitation. Thanks to the organizing committee, which, like I said this morning, I'm happy to see that it comprises from interventional cardiologists and cardiac surgeons. I would like to take a pass from what Kostas Sparias said before regarding complications. And I might say a colleague of mine, acquaintance of mine, a cardiac anesthesiologist, asked me, are you crazy? Only you, interventional cardiologists, show your complications. I haven't seen any complications from the cardiac surgeons. And let's keep that in mind during the following slides, like 7-8 minute slides. So I'll try to convince you to show you some stuff that went wrong regarding peripheral access. And I'm happy to see more and more something that would not gather attention like 10 years ago when TAVI started. Now it gathers more and more attention regarding peripheral complications. So, like I like to say, TAVI is not one difficult procedure, it's two difficult procedures. It's one with its own complications and, learning curve. And usually, or what we like to show our patients and our staff, it goes like that. Occasionally, it can go, and it has gone like that. And that is not only an aesthetic problem, but first, it keeps being a problem. Like even if we go down to sheets, it keeps into sheet sizes, it keeps being a problem, like 10% vascular complications part 2, which are very strict criteria, 5% serious vascular complication, and that translates into worse 1-year mortality, doubles the 1-year mortality in the same sense like a PCI from a femoral artery worsens the mortality if you have a bleed or if you get a transfusion. So we have to take care of the vessels. Let's see how we did not, or what went like we didn't want to go in, like in this case. I'm showing you again a 90-year-old lady, which blah, blah, was scheduled for TAVI according to local Greek and hospital policy. And at that time, we had the 14 French self-expanding valve, and the procedure was thought to close good with 2 pre-positioned proglides, 2 sets of sutures. So, like we used to do, we had the complement in the sheath from the right radial artery to lessen the bleed. And as you see here, it's not only a matter of, it's not that case, but just showing some example, it's not like sometimes you don't have a second femoral artery, but also it lessens your bleeds in the same way that a femoral PCI, a radial PCI lessens your bleeds compared to a femoral PCI. And if you go down really, really deep to literature, you can see that 1/3 of the serious bleeds comes from this small 6 French sheath and not from the huge sheaths. Also, you can do all sorts of stuff on the radial, like using tools, using balloons, open the way for the 14, 16, 18 French sheath to go through. Let's go back to our case. So that was the initial CT, and that was an autography from the radial artery showing a good, straight, no calcium, with a normal bifurcation almost at the middle. So we punctured it. We put a 26 TAVI in with minor leak, and we were happy. And then we went out, we pulled the two pre-positioned sutures, but then we had that rather nasty bleed. So we thought, let's put over the wire that we kept in during the position, let's put an angiosyl in. And we had the experience, and it was a good tip at the time, and there was some serious literature behind that that decision. So we put an angiosyl that, and that didn't go as planned. And you can see at the right-hand side that the femoral artery got occluded. Which very quickly related into clinical complications after a few minutes. Obviously, the leg went pale, went white, went hurt because the patient was awake. So we called the vascular surgeon, which at this 90-year-old lady was very unkeen to go into doing something would be take the collagen plug out, or doing even that's what they do. They get prepared to do a fem bypass, even if they don't need to, which means open abdominal surgery. So what we've done, through the radial artery, we tried to recanalize this occlusion. However, a normal hydrophilic wire 0.35 would not cross, and then we took a guide, an MB guide, through the radial artery, took it all the way down to the iliac artery, and then with some sweat and some skill, managed to get a wire across somewhere, which when we ballooned this somewhere with a coronary balloon, we found out it was a superficial artery. And then, and that was the result of the SFA. And then we've decided through the same catheter to take a wire, coronary wire, down to the profunda and balloon that and get it over after some time with this result. So we managed to save this lady's leg, save her from surgery, save her without a nasty covered or non-covered stent across the inguinal ligament or where the bend of the knee would be. And then after a few days, discharged her home, and on follow-up, that was unremarkable. Closing, let me put, and that was invited to be accepted in this new journal, which is called Critical Limb Ischemia, which was the case at this case. Let me answer the question, why not convince the surgeon? Why not even begin this TAVI or all TAVIs with a surgeon? So that was the case 5 or 10 years ago, and it was an obvious statement, an obvious argument. When I can see it and I can suture it, it can get better than a ProStar, a ProGlide, a Manta, or whatever, or pressure. However, the vascular surgeons themselves proved with themselves to be better when they did not operate, or equally good or equally bad when they used tools and not surgery, either in registries or in randomized trials. I mean, using ProGlides versus using suture techniques and cut down and all that stuff, had the same serious MACE as if whatever technique you used. And that was our experience from 2 centers and ourselves. So closing, let me convey you some messages we've learned all these years the hard way. TAVI is 2 procedures, so you have to know what to do, even up in the aorta, like Achilles did splendid, B, down in the femoral arteries, like many of us have to deal with, and not like deal with complications, deal with stuff. You have to have the equipment, not only the skills, but you have to have the equipment. And not only cath labs have equipment for peripheral vascular interventions. Angiosyls can be nasty when you get complications, but we've managed to deal with this complication through the radial artery. And like in all cases in interventional cardiology, that was I was taught, we begin with the end in mind. And unfortunately, many times the hole in the leg or the hematoma in the leg is what the patient sees and keeps seeing and sees and tortures him and leads to increased complication. Thank you very much. I hope I'll meet Kostas Larissa really soon.
That was a cold-blooded treatment. You kept very well your temper, and you reacted very quickly, and you saved the leg of this patient without having to put a stent. That's very important. And obviously the problem was the angiosyl, the collagen of the angiosyl that was moved within the lumen That's my interpretation, my explanation for this complication.
Yes, there's been a lot of there's been also papers and analysis regarding this complication. So what happens? What people think they happen is the suture like tingles, makes a small triangle and lifts up the artery, and then some calcium doesn't let the collagen foot get opposed to the artery wall. So the collagen plug, instead of remaining outside of the artery, goes inside the artery and includes it. That's the nasty mechanism behind this specific complication of sutures and plugs.
Dr. Latchers, thank you for the very didactic case. My question to you is, next time you put two proglides and you don't seal the artery and you still have some bleeding, how would you proceed to close the artery? And what if you still think that you may use an angioseal? Do you take any precautions? Will you take any precautions?
That's an excellent question. And of course, we've changed our mind and our practice. What we used to do is put a third angioseal in, a third proglide in. That was the proglide time. And now for 1 year and some time, we've changed completely our practice from pre-suturing with sutures with proglides or prostars to the Manta device, which I believe it's equally, and also the references, the published research, the published.
Okay, maybe another precaution would be to put a wire, an 18 or 14 wire down to the SFA. So in case you close the artery and you have some problem, you still have some access downwards.
Yes, that's an excellent suggestion. That's what most people suggested and used to do routinely during the era of the 18 or the 22 French. We had so egoistic at that time, and from that time on with 14 and 16, meaning we had so low rate of complication that we believe the extra contrast and the extra fluoro time for us and for the patient, plus the extra time of an awake patient on the table, just to put in every patient a wire down.
That's for sure.
If we had beforehand this knowledge that this would have happened, we would have,
Okay. Okay. Thank you very much.
Thank you, George. It's a pleasure for me to present next speaker, who is Dr. Nikas from Ioannina. Dr. Nikas Dimitris.
Good evening to everyone. I wasn't prepared to do this presentation in English, but I'll do my best. So just let me know if you can see my slides. Is it okay? Can you see my slides?
Great.
Yes.
Okay. So this is hop on, hop off case with a very, very nasty and unstable valve. So I'll try to do and present it as better as possible. So it's a case of a 76 years old male patient with a prosthetic trifecta, 21 millimeters valve of 19 millimeters of inner diameter. The patient had a surgery done 16 years ago. So we decided to go severe stenosis, obviously, and we decided to go for an Evolut R 23 millimeters in diameter. Here you can see our analysis, as I always say, and Professor Michalis always mention and underlines that we do all the analysis all alone, so we can know the patient better and we can deal with all potential complications much more easier. So we measure the annulus, we measure the inner diameter in the valve, the real inner diameter in the biprosthetic valve. Access sites, not the best, not the worst. We decided to go with the two proglide technique, as George Latches shown previously. Nothing special for that. And we proceed with the case. So this is the axis. We chosen to use the right femoral axis as a primary axis and the left femoral axis as a secondary axis. No problem with that. Even though there is tortuosity and calcium, we had no significant problem. We crossed the valve with fast wire. However, we had the feeling that the catheter wasn't going easily into the left ventricle, and therefore we decided to choose the position of the valve, and we used a second wire, which was a Landrequist, which crossed the catheter more easily through the biprosthetic valve. So we're more confident that we crossed within the valve and not somewhere outside the valve, probably. We had much more difficulty to advance the valve because of the calcium and the small aorta size in the calcium. sited in this abdominal aorta. And when we tried to put the valve and cross the valve without pre-dilatation, I have to say, through the biprosthetic valve, this was unable to do so. And you can see here how much force the operator put into the valve in order to push it through the biprosthetic valve. This is an Evolut 23 valve. As we are impossible to cross, we changed position, we changed wire, we used the second body wire, which we tried also the second body wire, and again, that was unable to cross through. And then where the transesophageal echocardiography came in, we put the transesophageal echocardiography, and as you can see here in this image, the first wire was crossed somewhere outside the valve, not a place where there was seen previously a severe regurgitation, paravalvular regurgitation. However, the second wire was inside the valve, and in order to verify the position of the wire, to be sure that the wire was inside the valve, and to proceed with the pre-dilatation, we put the balloon here, as you can see in this image, to verify the exact position of the wire. Afterwards, we proceed with a pre-dilatation with the 18mm balloon, and then we start the procedure again. And in order to see how much difficulty we had to advance the valve through the abdominal aorta, here's a video of this. As you can see, the valve goes very, very stiffly. We have to twist it over 90 degrees in order to push it through the iliac artery and the abdominal aorta. As you can see how much force we have to push. The whole aorta is moving from side to side. Using the echo guidance, eventually we are trying to put the valve. And we did several attempts. This is the hop-on, hop-off valve, I may say. So this is our first attempt, unable to stabilize the valve. This is the second attempt. This is the third attempt. This is the fourth attempt. Again, there was no way that we could manage to anchor the valve in the annulus or the biprosthetic valve and make it stable there. This is our sixth attempt, the seventh attempt. And while we was watching this and trying to put the valve, as one can see, the valve here was moving. Eventually, this thing was happening all the time. When we were trying to open the valve was popping out. And at last, we use this technique. We open the valve slowly and we pull it back, and then we open it rapidly, very, very quickly. Here is a slow motion of the video. This is a very rapid opening of the valve in order to make the valve work and in order to stabilize it at the annulus and site of the biprosthetic valve. I have to repeat again that this is a slow motion video in order to understand how we put the valve, we pull the back to the valve, and then we rapidly open the valve. We post-dilate with a 20mm balloon, and we close the artery successfully without any problems. So as a key point here in this case, I always have to say that biprosthetic valve in our procedure are always tricky. There are many things that may go wrong. We had another case a couple of weeks ago in which we couldn't easily cross through the valve, and we always go around the valve around the post. That transesophageal echocardiography may be necessary to facilitate the procedural steps, and always meticulous pre-procedure planning are essential for the procedure success. Thank you very much.
Congratulations, Dr. Nikas. Your cases pictures that sometimes we have to use all tools that we have, and in this case, transesophageal echo was the solution, because we saw that the first wire was in the wrong place.
That's correct.
Yes, yes.
Actually, it was in the first was the feeling that the catheter wasn't moving inside the valve easily. So we had to push the catheter to go through the valve when we have to change wire with the lanterns. So that was a bad feeling. We thought that with this patient, we have to have much better feeling in order to cross the valve. Therefore, we changed the wire, and then we had the same problem, and then we verify with the transesophageal echo that the first wire was crossing somewhere outside the valve, which was not seen as a paravalvular regurgitation.
Yes, yes.
Dr. Nick, you had a lot of obstacles to overcome to come to a very successful procedure. And my question to you is, did you pace, were you pacing when you were opening the valve, or was the patient his own rhythm?
We did several attempts with rapid pacing. However, that was again unsuccessful. The case that we saw, we did with a moderate pacing, let's say 120, 140 beats per minute. And then, as you can see, we open the valve, we pull it back in order to anchor in the annulus, and then we rapidly opening in order to quickly release the radial force of the valve and stabilize it there.
Okay. Okay. Thank you very much.
Thank you. Thank you.
Thank you.
Nectarios.
Okay. So now we'll proceed with Dr. Georgiou and its case, which we are very eager to hear. Dr. Georgiou.
Good evening to everyone. Can you hear me?
Okay, yes, very good. Go ahead.
So I would like to thank the organizers for their kind invitation. It's always a pleasure to participate in this meeting. So my case is not an uncommon or a spectacular one, but it's still an interesting case because it is related with a subset of patients with bicuspid aortic valve, which is still a challenging subgroup of patients with a lot of uncertainties and unclear answers. It is related with a patient of an 82-year-old with severe chronic obstructive pulmonary disease. The patient had also coronary artery disease. He underwent a coronary intervention with a stent implantation 3 months ago. He had also carotid artery disease, but it was asymptomatic and was treated conservatively. And he suffered from critical aortic stenosis with an aortic valve area of 0.6. The rest ECG showed a right bundle branch block with a QRS duration of 122 and the left anterior hemi block, which has its significance. The ECG-gated multi-slice CT showed that the aortic valve was bicuspid with a lot of calcium in the central part of the valve. There was a dilatation of the ascending aorta of 46 millimeter. And interestingly, the position of the aortic valve was horizontal. There is an obvious horizontal orientation of the valve with a calcium from the left coronary cusp protruding within the LVOT. According to this classification, it was a type 1 bicuspid aortic valve with a raphe, non-calcified raphe between the non-coronary cusp and the left coronary cusp. We all know that the bicuspid aortic valve have some special interesting issues we have to take into consideration. The risk of paravalvular leak, the risk of rupture is high, as well as the risk of processes mismatch is also high. And it needs a special measures to take before we proceed to this intervention. This is our view we decided to work on. We decided to implant a Edwards valve, a sub-in 3 valve, in this particular case because of the horizontal orientation of the aortic valve. Now our institute we use both valves over the last 1 year. We use both Medtronic and Edwards valves in a ratio of 40 to 60. So 60 sub-in and 40 Medtronic valves. We also decided to redilate the valve to perform a balloon aortic valvuloplasty because it was a critical aortic stenosis, and our feeling was that it would be difficult to cross the valve with the device promptly. Our attempts to cross the valve with a wire lasted approximately 20 to 25 minutes. It was one of the most difficult cases to cross the valve. We have an experience of 400 cases right now, and it was one of the most difficult cases we faced. there was a lot of tortuosity of the ascending aorta and the aortic arch. And then with rapid pacing, we slowly inflated the valve. Fortunately, this video is not playing. Maybe I can show you here. Can you see this video now? Can you see the video of the implantation of the valve? No. Can you hear me?
Yes, yes, we can see it. Joe, perfectly
So it was
well.
a slow inflation with 200 beats per minute, high pacemaker rate in order to keep the valve in the position and avoid any pop-up of the valve. And this was our result. So it was although we tried to implant it 90 to 10, 90 in the aorta side and 10 in the left ventricle, I think it was a good implantation with minimal paravalvular leak. And this was confirmed by an ultrasound the day after the procedure. I don't feel well because all the previous cases were cases with complications. In my case, it's not related with a complication. Of course, we have complications in our hospital too, but I think it's still an interesting case because it's still, it's always a challenge to deal with our bicuspid aortic valve. Thank you for your attention.
Thank you,
Thank
Dr.
you, Joe.
Georgiou. That's an excellent case with an excellent result. And we always not to have any complications like in your case, and which was actually a difficult case, but you proceed and worked very well, and you had an excellent result. Any question from the audience, please?
Just did you use the nominal volume for the balloon inflating this valve?
It's a very good question. The area of the annulus was 702, which means that the 29 valve was a little bit, is not covered by this area. It's until, as far as I remember, it's up to 690, the area of the annulus. Normally, in other cases, we would use 2 ml more of contrast in this case, but as it was a bicuspid aortic valve, and the risk of annulus rupture was high, we decided to inflate it slowly and keep the normal volume of a 29 millimeter Sabian valve. So we didn't.
Yeah, this is exactly what I was thinking, that on one hand, the valve is undersized for this area, but on the other hand, it's bicuspid with a lot of calcium extending into the LVOT. So you'd like to actually undersize your valve in this anatomy. And I think this is the perfect case to show how choosing the right valve for the right patient characteristics and anatomy can get you out of difficult situations. So extreme unfolding of the aorta, extremely horizontal annulus, dilated ascending aorta, very long reach to go there, and bicuspid altogether. And by choosing the right device, I think you finished pretty quickly this procedure. And probably the most difficult part of this procedure was crossing the valve, right?
You're right.
With a wire.
20-25 minutes to cross the valve, which is something we knew that. We used Ambulance left 2 because the aorta was horizontal. We shifted to other catheters. We went back to the Ambulance left 2, and finally we succeeded to cross it after 25 minutes.
I have one question, Dr. Georgiou, because I saw that there was a lot of calcium going down to the LVOT, I think. Would you consider to undersize the balloon after when you inflate the valve by 2 or 3 ml, so you can see if that would seal the annulus, and if you had the paravalvular leak, to proceed with the normal volume of the balloon?
Yes, it will be a possibility to do that, but the area of the annulus was even above the size, the proposed by the company volume to be used. So it was a 700 millimeter square of annulus. 29 valve, which is the biggest valve in the family of Sapien valve, the Sapien 3 valve, is to be used until 690. So if we use 2 ml less than, then it will be obviously a valve which had a lot of paravalvular leak. Obviously, the calcium was there. It was still a life-threatening situation, but fortunately, it was external and it was not compressed by the valve, and there was no any even paravalvular leak at that area. That was confirmed by echo later on.
Okay.
Thank you, George. And now Dr. Pilates will become a presenter from panelist. Dr. Pilates is the head of interventional cardiology in Metropolitan General, and we're all ears to hear your interesting case, Nectaria.
Thank you, Kostas. Thank you so much for the invitation, and it's always very nice to be with all these colleagues around me. The TAVI case that we'll present quickly is a patient with a very low ejection fraction, aortic stenosis with low ejection fraction. This is a 70-year-old man with chronic kidney disease on hemodialysis for the last 2.5 years. And the main historical point is that he is not very active, physically active, and he has a mild dementia and depression. He was in a pretty good condition up to 6 months prior to the intervention, but during the last 6 months, he started having some shortness of breath, which progressively get worse and worse. And he went to his cardiologist, who diagnosed the aortic stenosis, long runs of paroxysmal atrial fibrillation, the gradual reduction of the ejection fraction within 6 months from 55 to 25 to 30%. The ECG showed normal sinus rhythm at the time of the examination with LVH with strain and the narrow QRS, no RBBB, and no other conduction abnormalities. The echo showed a low flow, low gradient aortic stenosis with valve area of 0.7, and the ejection fraction was very low. And the patient at the same time had a severe pulmonary hypertension. He was very severely symptomatic. He had a moderately elevated STS and Euro score around 4. And it's in the era of the COVID-19, it's worth mentioning that he was vaccinated ×2. So this is the echo that shows a very thick valve, aortic valve, barely moving, a very low ejection fraction. And now we come to the decision, is that aortic stenosis really severe? And is the low ejection fraction that fool us? One very easy way to answer this question is to calculate the flow rate. The flow rate, if it's more, and what's the flow rate? If it's more than 200 ml, then we are pretty sure that the calculations of the aortic valve area are pretty accurate. What's the flow rate? It's an easily derived measurement from the transthoracic echo, and this is a stroke volume divided by the LV ejection time. So if the stroke volume is very low, let's say 35 ml, but this stroke volume is ejected over a very short period of time, it's enough to open the valve and give us a safe measurements. But if the same low stroke volume is ejected through a longer period of time, may not be enough to open the valve. In that situation, we have to do a DSE, dobutamine stress echo. In our patient, the flow rate was low, below 200 ml. So we proceed with the dobutamine stress echo, where we found a low presence of low functional reserve with change of stroke volume less than 20%. That's why we had to calculate the projected aortic valve area according to this equation here, which we found to be 0.8 centimeters square, with the ejection fraction going from 25 to 35% with low dose dobutamine. So we confirmed the severity of the aortic stenosis in this patient, and who has a pretty good coronary arteries without any significant stenosis accounting for the low ejection fraction. Now we come to the decision, what do we have to do with this patient? This is a patient with a moderate life expectancy. It's not low, but he has end-stage renal disease, and he's not very old, but he's not a good candidate for a surgical aortic valve replacement because he would not cooperate very well after surgery for the very good recovery. So we proceed with the decision to go with a TAVI, because we think that that was a safer option for this specific patient with two procedural considerations. This patient has a very low ejection fraction, so we have to avoid paravalvular leak and the need of permanent pacemaker implantation, which can be detrimental if this happened to our patient. Also, would be very bad thing to have a LBBB after the new LBBB after the implantation of the valve. So we have to very meticulously plan and execute the TAVI procedure to avoid all those complications. This is a CT angio sizing of the valve. It's a big annulus, 29 millimeter in mean diameter. It's pretty circular. The LVOT is also big and not very oval. We had good, we have a big anatomy with big sinus of Valsalva, high takeoff of the coronary arteries, and moderate calcification of the aortic valve. So in this situation, two valves would fit, the Sapien 29 and the Evolute Pro 34 millimeter. Because the Sapien has a low rate of conduction abnormalities and pacemaker implantation, we decide to proceed with the Sapien 29 valve. Through the right femoral artery, which was less tortuous than the left one, without a significant calcification. So this is the aortogram. The gradient, as we saw before, it's a low flow, low gradient, low ejection fraction aortic stenosis, very low gradient at the beginning. We thought that it was a good idea to pre-dilate. Actually, it was very difficult to cross the valve as the previous case. And because of that, we thought that it was a good idea to have a pre-dilatation of the valve and see how well would they seal the valve, this 25 millimeter balloon. And actually, we see that we have a good sealing of the valve. And that's why we thought that was a good idea also to proceed with the inflation of the valve of the Sapien 29 with 4 millimeter less, 4 ml less contrast in the balloon, and try to see if that would seal the annulus without having the risk of pacemaker implantation. So we proceed with position of the valve, which actually is a little low. But we see that the sealing was not very good. We have a mild to moderate paravalvular leak. That's why we post-dilatate with a -1 ml in the same balloon. And after that, we see that expansion is better, a little better than before, with mild paravalvular leak. Actually, it was some of that was due to the wire. When we got the wire out and we checked with the echo, there was a trivial AR and with EKG without any conduction abnormalities. with little gradient, a good sealing of the femoral artery. In the short term, the patient did very well with excellent hemodynamics, no orthopnea or PND, which he had before, and the microvascular circulation returned to the normal, and he continued hemodialysis. He went home 4 days later without any conduction abnormalities. Unfortunately, the patient was infected with COVID-19. He was hospitalized for 1 month, and he died 1 month later from COVID complications. So my conclusion is that the low flow, low gradient, low ejection fraction aortic stenosis is a diagnostic dilemma. The flow rate is a simple and easy first screening test for differential diagnosis of severe from pseudo-severe aortic stenosis. Calcium score can help if it's more than 2,000 units for men and 1,200 units for the women, which indicates severe AS. And the TAV is a safer short-term solution, especially in high surgical risk patients, but we have to be very careful and meticulously plan and execute the procedure to avoid the paravalvular leak and the pacemaker implantation. And just bear in mind that SAVR is a better guarantee for longevity in younger patients. Thank you very much.
Thank you, Nectaria. That was a very interesting case with a very good immediate result, but unfortunate end for the patient for another reason. Any comments from all the colleagues that are around?
Yes, Kostas, I think that many times we have problems with the diagnosis between severe aortic stenosis and cardiomyopathy. And it's a problem.
Yeah, that's a situation where we definitely need to check the calcium on the CT scan. And this is one of the, let's say, surrogates for the aortic stenosis, and rely on very good echocardiography to really say that this is a paradox aortic valve stenosis. And with this, I think we should move to the next presentation from Dr. Hamilos from Iraklio. And Michalis, sorry for the mix-up in the order of the presentations. It was your turn earlier, so we are looking forward to your interesting case.
Thank you, Kostas. No problem. Of course, I want to congratulate you and the rest of the organizers for the very high-level meeting, as always. And I'm going to present my case, which is not a complication case, which has the most interesting cases in TAVI, but it's a case that maybe helps to prevent some complications. So it's a 82 years old female with diabetic and the pacemaker who has a severe symptomatic aortic valve stenosis. She has a severe renal impairment, and has a pacemaker rhythm in her ECG. Normal coronaries in the coronary angiogram, and a pretty high risk in Euroscore and STS score, high risk patient. From the CT evaluation before the intervention, we can appreciate that the most important thing was that the left coronary ostium was really very low, 6.5 millimeters from the aortic root, and the perimeter was 22, and the sinus of Valsalva dimensions was quite okay, almost 30 millimeter, which make us a bit more comfortable to go on and choose a valve in order to implant it. The right coronary ostium was okay, but the left, as you can appreciate, was really, really low. Moreover, the legs were really extremely tortuous and very, very calcified, as you can appreciate. And we chose the right femoral artery to go on. And as a valve, we chose to put accurate Neo 2 valve. It was a very low rate of coronary obstruction, and has a favorable, let's say, design in order to have access to the coronaries especially in cases that are really low, as in our case. So from the aortogram, you can appreciate that the left coronary artery is normal, is huge in diameter, a very short left main, really low. So we decided beforehand to put a catheter and the wire there and the stent to protect the left main from a possible obstruction, because the valve should be deployed very close to the left coronary ostium. We did the balloon valvuloplasty with a 20 millimeter balloon beforehand with a contrast injection, and you can appreciate that the left coronary cusp goes almost all the way in front of the left main. So then we decided to put also a stent there, and we start the deployment of the valve. The deployment went quite okay, and then after the valve is released, we see that there is still flow in the left coronary ostium. The final result of the deployment is okay, with very mild leak, regurgitation, very mild regurgitation, and very low gradient, transvalvular gradient. But the question is now what to do with this coronary ostium. Yet you can appreciate from this aortogram that there is a lot of material coming from the left coronary cusp in front of the left main. You will also appreciate the selective engagement and the angiography of the left coronary ostium. We took really several projections, and we were maybe not able to decide what to do, because as you know, in some cases, maybe you have a patient patent left main, but when you remove the wire, because of the left coronary cusp, which is there, the natural left coronary cusp, you may have an obstruction, and this is catastrophic. So coronary occlusion due to TAVI has a quite low incidence, but when it happens, has a very high mortality. It's more common from previous registries with balloon expandable valves. And the predictive factors, which are not 100% predictive in all cases, is of course coronary osteohate, especially when less than 8 millimeters. The sinus of vascular width when it's less than 28 millimeters. Presence of very calcific nodules in the coronary cusps, and the short virtual transcatheter valve to coronary ostium, especially when it's less than 4 millimeters. And of course, valve in valve is a predictive factor for coronary occlusion. Of course, there are two techniques mainly to overcome this very bad condition. One is chimney stenting, which is easier to perform than the other one, but it's not always successful, and it doesn't have a very good outcome, because it has a 4 to 5% thrombosis or restenosis in 1 year follow-up. And the other one is the basilica technique, which I have to say I'm not common with. I don't know who's performing this, but it looks to me that it's quite a difficult intervention. That it's necessary, of course, to do in some cases when you have valve-in-valve cases, but it's not always effective, because it depends on the laceration of the native valve leaflet. So one other option that we decided to use in our case is to put an IVUS, intravascular ultrasound. There is a very small series of patients coming from the Verona group, from Flavio Rubicchini, 8 patients that they evaluated with IVUS, the left main or the right coronary artery ostia, in order to decide if they need a stent or not. And you can appreciate on the right side that in one case, it's the coronary ostium is really compressed by the stent itself or by the leaflet. And in the other case, the coronary ostium is really free of any material. So they suggest to do it in some cases. So we decided to do it in our case in order to maybe help us to decide what to do. Of course, the method has a lot of limitations. It's not established, and nobody really knows what to do, because there are not established criteria what to do when you have some images in the ostium with the left main. So you can appreciate in these IVUS images that it's a huge left main with almost 7 millimeter diameter, and you can appreciate in the fourth frame maybe this is the structure of the valve cells, and in the other two last frames it's probably material coming from the leaflets. So we felt quite okay with those images. We didn't see any significant, let's say, obstruction or potential to obstruct the left main with those images. And believe me, the 60 frame was the worst one that we could isolate from our IVUS. So we decided to leave it like it is. And we had some trouble with the closure because we had some dissection, but finally with some balloon expansion and two proglides, we were really able to close it safely. The rest of hospitalization was uncomplicated. And to finish my presentation, I would take some take-home messages. Acute coronary obstruction post-TAVI is of course uncommon, but when it happens, it's a catastrophic event. Careful CT evaluation and appropriate device selection can avoid this complication in most of the cases. I would also add that this is something that we'll see more and more because we go to valve-in-valve more and more, and this is a case for valve-in-valve in most cases. And in some cases, maybe, of course, we need much more data. IVUS guided decision to stent or not gel coronary ostia is a useful additional tool in such ambiguous cases. Thank you very much.
Thank you, Michalis. Interesting case, new use for IVUS. I would say you did very well that you didn't stent this left main. And you knew from before starting the procedure that the possibility to need a stent for this left main was close to zero because the diameter of the sinus of valsalva just in front of the left main was 31 millimeters, and I can't think of any accurate neo valve that has that diameter. So I would be pretty confident from the beginning that there will be no need for protection, and I wouldn't even use the wiring and the stenting in this case. Any comments from the colleagues around? Okay, no comments. So
okay.
Thank you, Michalis.
Just to add, yeah, okay.
Sorry.
Just a very short comment. You're absolutely right. The possibility to close this left main was really low, but it was, I think, a quite interesting demonstration of sometimes how can we use those tools to decide, because it's not always easy, as in this case, to decide what to do or not.
Absolutely, absolutely. Thank you very much for your contribution, and we're moving forward to Dr. Arabatzis from Interbalkan Surgery in Thessaloniki, and we're all waiting to hear your interesting, to present your interesting case, Akis.
Thank you very much, Kostas, and congratulations with this excellent event. So as TAVR expands to lower risk patients with longer life expectancy, there is a greater likelihood that transcatheter heart valves may fail. Currently, we create a new cohort of patients that will require future treatment. Treatment considerations include positioning and THV device choice, expansion of the new THV, and access to coronaries. We have limited available data. I'm presenting it here from 37 high-volume centers that the incidence of redo TAVR is 0.33%, and of those, 34% are within 1 year, and 66% are beyond 1 year. So our patient is a 76-year-old female. She had undergone the Sampiet implantation 8 years ago in Germany at 23 millimeters. Her main issue is morbid obesity with a BMI of 41, 42. She has several admissions for subacute pulmonary edema. She has a very high NT-proBNP. She has suffered some paroxysmal atrial fibrillations. Her coronaries are without stenosis, and she has familiar heterozygous anemia. So as you can appreciate, she has a moderate good LV function, and she has a peak gradient of 65, max velocity of 4 meters per second, and the valve area is 0.7 centimeters. You can clearly see now in the CT scan that the main problem of this patient is the short coronary ostia, especially the left main. It is 9.7 millimeters from the aortic root, and the right coronary artery is 13 millimeters. If we take a look at the cross-sectional images, we can see that the previous implanted valve has a circular configuration, and we can see that the maximal diameter inside the valve is 19 millimeters in a 23 millimeter valve. And if we see here this projection on the right top panel, you can see that the left main stem is 3.9 millimeters distance from the valve. That confers in a very high risk of acute coronary occlusion during the procedure. When we discussed which type of valve we're going to use, both self-expandable and balloon expandable were indicated. So the valve of Evolutar was a 23 millimeter valve. You can see now in the virtual projection that there is a very increased risk of coronary occlusion. And on the top left side in the moving image, you can appreciate the patient that we are going to treat. The left main is just above the previous implanted valve, and she has a short sinus height and a narrow STJ. So that is mainly prohibitive to implant an Evolut R valve. So we decided to place an S3 valve, and I have to say that we have to be very precise with the positioning of the valve. You can see that if we implant an S3 valve in a sapien valve, we have to be the crimped valve, the top part has to be 3 millimeters above the previous implanted valve at the outflow part. And if we implant an S3 in S3, then we have to be in line with the outflow of the previous implanted valve. So the procedural plan, as always, is with conscious sedation, bifemoral and radial access, femoral vein for pacing. We are going to have a steady situ for left main protection. We are going to implant an S3 23 millimeter valves. We are going to evaluate the left main post-valve implantation. Of course, close with block right, we can see that the femorals and iliacs are very good arteries. So these are the first projections. Always we check if we have in a proper place the wire with orthogonal views. You can see in the moving image now the positioning of the valve. As I told you before, we have to be 3 millimeters above the previous implanted valve. Rapid pacing, you see the inflation of the valve, deflation, and stop pacing. And you can see that we have a very nice result. The PVL was not that much. It was because the pigtail catheter was a little bit low. So afterwards, we check the left main, and you can appreciate that there is a sort of haziness at the ostium of the left main. So we decided to implant the stent. We post-dilated, and this is the final result after post-dilatation. So the patient had an uneventful course, just a 3-day hospitalization, and we had a mean gradient of 21 with a mild PVL leak, as we can see. Although during the measurements in the cath lab, we had a gradient, a peak-to-peak gradient of 17, 18 millimeters. So 1 month post-procedure, the patient comes back with dyspnea on exertion, and we see at the echo global hypokinesia of the apical segments and a lot of the segments of the left ventricle, and ejection fraction of 27. And we were very concerned that maybe was something happened with the stent, but the patient since 20 days was in AFib, so she had a low ejection fraction from tachymyocardiopathy. We cardioversion this patient, and 1 month post-cardioversion, she had a recovery of the ejection fraction and a Vmax of 2.9 meters per second and a mean peak gradient of 18. So let's see what happened in the past 4 months, because this patient was treated on January 21. As I told you, she had an uneventful course. 10 days post-procedure, she had an acute abdomen due to umbilical hernia tightening. She underwent emergent surgery during the night under 15 milligrams of rivaroxaban and 17.5 milligrams of clopidogrel. We had that low ejection fraction due to atrial fibrillation that was treated successfully with cardioversion. And 2 weeks later, just 20 days ago, she presented with excessive fatigue, nearly fainted, and we had an hemoglobin of 3 grams. I haven't seen in my life lower hemoglobin, and the endoscopy findings were duodenum diverticulum. Now the patient is well, and she is in New York Heart Association class 1. Her pro-BNP has reduced a lot. She has no dyspnea. She is mainly asymptomatic, and she only takes 40 milligrams of furosemide, and now currently she is under low molecular weight heparin. So to conclude, RE2-THV is safe and feasible. These patients have a lot of comorbidities and can suffer various clinical syndromes. Optimal technical strategy is unknown. We have to consider the impact to coronary access and THV function and durability, and the long-term consequences of RE2-TAVR are unknown. On behalf of the 3rd Cardiology Department, thank you very much for your attention.
Dr. Abadis, thank you very much. That's an amazing medical journey of the patient.
Exactly.
You follow her very, very well and very successfully. One quick technical question. When you opened the valve, did you feel any friction on the stent which was in the left main when you tried to position it in the right position?
No, we didn't feel any friction, and we had. I have to tell you that we took a lot of projections to decide whether if we are going to implant the stent, and we were pretty easy to deliver also the quantum balloon for post-dilatation. I even took back a little bit the stent and forwarded to take the proper position. We didn't have any problems.
So it was mainly the material from the leaflet, I guess, that would partially obstructing the left main and not the struts of the valve, right?
Right.
Okay. Thank you very much. If you don't have any other question from the panel, I would like to proceed with Dr. Dardas. Petro, welcome to this session. It's very nice to see you and to hear from you. And I know that you always have very interesting cases to present and solve. So,
thank you very much, Nectarios. And from this place, I would like to congratulate the organizing committee and Kostas Sparias because of this amazing meeting. I honestly watched most of the structural sessions in EuroPCR, and I consider that this meeting was at least equally the same level of quality. So congratulations, Kostas, for the meeting. Now, we've seen a lot about coronary protection over the last couple of cases, and I'm going to present you, these are my disclosures, I'm going to present you a system that we have developed in protection of the coronary system when we're putting stentless valves. Now, this is a case of 85 years old female. She had a bicuspid aortic valve in 2011, and she developed endocarditis in the aortic and mitral valve. She had an AVR with a Freedom Solo stentless bioprosthesis 21 millimeter and an MV repair with an annulus physio 28 millimeter at the same time. Now, she presented to us with progressively worse heart failure, and the transthoracic and triesophageal echocardiogram showed impairment of the LV function, ejection fraction about 35%, mild to moderate mitral regurgitation, and severe aortic valve. The valve, the prosthesis was severely stenosed with a max gradient of 94 and mean gradient of 47. And you can see the heavily calcified hypokinetic leaflets of the stentless bioprosthesis. And you can appreciate on the 3D and also the AV gradient. The coronary angiogram, the arteries were normal, but the left coronary system was quite low lying. And on the CT, it was about 9 millimeter from the annulus, whereas the right coronary artery was higher, was 12.6. And analyzing the CT further, what we saw that the VTLC was 5.5 to the left, but the left coronary artery was lying exactly at the level of the left aortic prosthetic leaflet. So in considering the risk factors for coronary obstruction involving valve procedures, we thought that it was a low-lying coronary ostia and a homograft stentless valve. So we thought that this lady was at least moderate risk for left coronary obstruction. I forgot to say that the sinus of Valsalva diameter was 28 millimeter. So we decided to go for a TAVI with an Evolut Pro 26 millimeter and to protect the coronaries. Now, what we have developed, we developed a system of protecting the coronaries whenever we're in doubt. We put 2 femoral sheaths from the same side. We put PCI wire in the LAD, a guide catheter, which is outside the left main and quite high, and an extension catheter, which we engage in the ostium of the left main, and an undeployed stent in the left anterior descending artery. And I'm going to show you exactly what we've done. This is the guide catheter, the extension catheter sitting just at the ostium of the left main, and the stent in the proximal LAD. So we went on with the TAVI procedure. We had to deploy the TAVI valve 3 times. And all these times, the whole system of coronary protection remained very stable. Eventually, we managed to engage the Evolut valve with a very good result. And you can see that the Gaizilla catheter moves very freely in and out of the coronary ostium. That means that we can actually do whatever we want. And first of all, we'll do an injection through the extension catheter. We move the extension catheter just outside the ostium of the left main. So we do an injection. And then we can put an IVUS if we have doubt, as Dr. Hamilos explained earlier in his case. Or we can put the stent at the ostium. And by doing this, by having this Gaizilla catheter moving freely, we can do all the steps of an ordinary PCI without having any problem with our guide cath. So we saw that the left main was unobstructed, and we withdrew first the stent inside the Gaizilla, and then after that we removed the Gaizilla and the wire without any problem. And this was the final result. So just in summarizing the whole system, we place the guide cath stable outside the TAVI frame, away from the left main. We place the extension catheter at the ostium of the left main, and this moves freely backwards and forwards. And then we can inject through the Gaizilla to the left main, and we can put a stent or put an IVUS if we had doubt, and we can assess the final result and withdraw the extension catheter without any problem. And we apply this system to all the cases that were in doubt of coronary obstruction. I'll show you another case we did a month earlier, again with a stentless Zorin Solo 23 millimeter valve. The patient had edema to the LAD, and the bioprosthesis had severe stenosis. The ostium of the left main was too low. And I can briefly show you the same system, the guide cath outside, the guidezilla inside the left main, the stent and the guide wire. And you can see here that the whole system doesn't move during the deployment of the valve. And the guidezilla presents a full free movement without obstruction of the movement from the frame of the evolute valve. And we had to post-dilate the valve in this case. And you can see that during the post-dilatation, the guidezilla, the whole system remains stable. And then we re-injected. We were sure that there was no obstruction, and we removed everything without any difficulty. And you can see here removal. Okay, so in conclusion, the stentless by prosthesis and low-lying coronary arteries increase the risk of coronary obstruction. We need to, of course, to do the CT scanning and measure everything. We advise coronary protection whenever we're in doubt. And in our case, we describe a system of safe protection of the coronary system. Thank you.
Thank you, Petros. I think this demonstration is exactly the suggestion of Cecile Kodali in his presentation earlier. He recommended to use guide extension catheter when you want to protect and you are deploying a self-expanding valve like the evolute valve. And he also recommended using regular guide catheter, but with side holes, to avoid using a pigtail when you protect, when you deploy a sapien valve, which is a very good suggestion. You avoid an additional arterial puncture, I think, but you cannot use one with side holes when you have an extension guide, like in this case. And I think, my friends, we have to move forward because we have another 5 presentations.
Yes, Kostas.
And we'll go to 10 o'clock or more. So, Nikos, please.
Yes. Next speaker is Dr. Karagounis. Dr. Karagounis, I wonder, is there a simple case valve in valve?
Yes, it's a similar valve, similar presentation.
Okay. Dr. Karagounis.
Yes, can you see me?
Yes, we hear you.
Okay. Essentially,
in 6 minutes, if it's
yes,
possible.
essentially is the presentation to reinforce what Dr. Darda said. We have a lot of...
Labros, you want to do the share screen first? Because we only see you. We don't see your presentation.
We don't see your presentation.
I'm sorry. I thought I did it. How about now? Can you see?
No, not yet.
Well, I press all the right buttons.
Okay, something is coming now. Perfect, success.
Okay, so it's a similar case, valve in valve, and we're going to see a lot of those cases because the last few decades, the surgeons put a lot by prosthesis. Our case is a 68-year-old lady who had rather abrupt onset of dyspnea. 2011 had a trifecta 23 millimeters because of aortic stenosis. 2019 breast cancer, treated with chemotherapy and radiation. And now she was in the midst of workup of possible metastatic workup. The labs were significant for hemolysis, and the surgical team considered her as an increased intraoperative risk because of bleeding due to chest radiation. The echo findings were significant for enlarged LV and LA, reduced ejection fraction, severe biprosthetic valve degeneration, primarily insufficiency,